which expresses itself as the age progresses. And the mechanical damage is not so much, but the damage done at the molecular and endocrine level by endometriosis is so much. Even stage 1 endometriosis can cause infertility, and these are very difficult to treat. These are very stubborn and very tricky patients to treat. Plus, whatever metabolic diseases expressed by that age, those also have a bearing on the fertility. Because if that lady has diabetes or hypertension, the vasculopathy or the neurovasculopathy which sets in, that will damage even the uterine and the endometrial vasculature. That again can lead to infertility. Now pregnancy per se. Higher incidence of chromosomal abnormalities. As we all know, as the age progresses, the chromosomal damage is seen. The telomeres, they get fragmented. The epigenes, the mitochondrial genes, they are affected. And for that matter, हे नुसतं maternalशी related नाही आहे. It is not gender specific. Even in males, the genetic quality of the gametes, it goes on being damaged. It will reduce as the male also ages. The genetic problems will be more in an aged male, which will be reflected in the offspring. So you have higher incidence of chromosomal abnormalities and pregnancy loss because of that. So I just said the chronic metabolic problems, namely diabetes, hypertension, obesity, these are problems which you see normally. The Indian scenario is even worse. Why do I say that? आम्ही आमच्या क्लिनिकल प्रॅक्टिसमध्ये बघतो, आपल्याकडे तो मेनोपॉजचं जे एज आहे इज अराउंड पेरी 38 पेरी 40. जेव्हा क्लिनिकमध्ये आपण पाहतो त्यावेळी त्या फिमेल्समध्ये मेनोपॉजल चेंजेस इन द वजायनल एपिथेलियम, इन द यूट्रस, युट्राइन साइज ह्या लवकर दिसतात. 37, 38 ह्या कारणासाठी. बिकॉज ॲज अ रेस वी आर डिफरंट. ॲज अ रेस वी आर डिफरंट. हे कार्डियक सर्जन्स नेहमी सांगतात, आपल्या कोरोनरीजचा डायमीटर हा पलीकडच्या लोकांपेक्षा थोडा छोटा असतो. सो इफ द एज ऑफ मेनोपॉज इज लेस इन आवर पॉप्युलेशन, इन आवर रेस, that means the expression of the metabolic disorders, they will not be very late, they also will be earlier. And pregnancy being a stressful condition, the problems which are dormant till then, they express in the pregnancy. त्यामुळे तुम्हाला ते gestational diabetes दिसणार, hypertension लवकर दिसणार, PIH, preeclampsia त्यांच्यामध्ये दिसणार. That's why I said that Indian scenario is different. Unfortunately, we don't have statistics as to how we are different as far as the menopause, or the metabolic changes, or the vascular changes, neurological changes. आपल्यामध्ये कधी सुरू होतात त्यांच्या कंपॅरिझनमध्ये. This is a nice actually area to be studied. Because of those metabolic problems, the cardiovascular and cerebrovascular episodes, those accidents, those will be seen earlier. And as I said, pregnancy is a stressful condition. त्यामुळे लेटर एजमध्ये जर त्या लेडीला PIH बसला तर तिच्या केसमध्ये वॅस्क्युलर ॲक्सिडेंट्सची पॉसिबिलिटी इतरांपेक्षा जास्त राहणार. सो यू हॅव टू विल बी रेडी फॉर दॅट. The fetus, as we said, higher incidence of anomalies. All this adds up, and there is a growth restriction, what is commonly known as IUGR. This is common in these patients. Sudden intrauterine fetal demise, death will be seen because of all these causes which we just enumerated. प्रिमॅच्युअर डिलिव्हरीज, नॅचरल किंवा यूट्रोजेनिक. त्यामुळे हे डोळ्यात तेल घालून हे फिटसेस बघावे लागतात. द मोमेंट यू फाइंड दॅट समथिंग इज रॉंग, यू प्लॅन अ डिलिव्हरी. कॉमन सीन दिसतो. एक 34-35 वीक्सला आपण हे सेक्शन केलं. 1.4 kg अ बेबी. ते NICU 15 दिवस, 1 महिना. NICUs even costlier than adult ICUs. तो परवाचा जो आपण पुण्यातल्या सुप्रसिद्ध हॉस्पिटलचा जो मध्ये किस्सा झाला, त्यावेळी त्या डॉक्टरनी फक्त 10 लाख रुपये सांगितले होते 2 बेबीजचे NICU साठी. आणि नंतरच्या त्या प्रोग्रेसमध्ये ही बातमी छोटी आली, पण मुख्यमंत्र्यांनी त्या 2 बेबीसाठी 25 लाख गव्हर्नमेंटचे सँक्शन केले, कारण ते पॉलिटिकली कनेक्टेड होतं म्हणून. 25 lakhs. So the costs are high, very high costs for these babies. आणि पुढे जाऊन काय होतं, this baby right from conception has faced a very hostile environment in utero. The environment became so hostile that the survival was at stake, so you have removed it. You don't expect this baby to come out and be a very healthy child. It takes, they have a stormy neonatal period, infant period, and evidence has shown that these children in their middle age, they are more prone to infertility, diabetes, hypertension, metabolic disorders त्यांच्यामध्ये लवकर सुरू होतात. तर हा इश्यू बराच पुढे जातो. तो कशामुळे झाले, का पोचलोय आपण इथे? स्प्रेड ऑफ एज्युकेशनचा एक असा पण साईड इफेक्ट झाला. Everybody now desires for a good education, good career, financial independence, anxiety from there. मग हळूहळू ते मॅरेजचं एज पुढं गेलं. 16, 17, 18. आमची जनरेशन पर्यंत ते साधारण 25, त्यामुळे ते आमची पिढी त्या कांदापोहे ह्याच्यातली शेवटची बहुतेक पिढी. त्यानंतर ते कांदापोहे इव्हेंट व्हायचं पण प्रमाण कमी झालं. माझ्याकडे मुली येतात, वय वर्ष 20, 21, 22. काय करतेस का? नीटची तयारी. तर इमॅजिन दिस गर्ल, ही आता नीटची तयारी करते, 21 वर्षाची झाली तरी. तर 1-2 वर्षात ती शिरणार. तिथून पुढे 10 वर्ष पकडायची. बाय द टाइम शी फिनिशेस ॲक्च्युली द एज्युकेशन. कारण MBBSला कोणी थांबत नाही, पोस्ट ग्रॅज्युएशन करणार, फेलोशिप करणार. सो बाय द टाइम दे फिनिश, होतं काय की वय वर्ष 13, 15, 18, बाय द टाइम दे कम टू 30, 32, दे हॅव फॉर्म देअर ओन पर्सनॅलिटीज, देअर ओन स्टाईल ऑफ लिव्हिंग, दे हॅव देअर ओन सेट ऑफ प्रिन्सिपल्स. काही मुली जॉब्स बी सुरू करतात, इंजिनिअरिंगच्या वगैरे मी पाहिलेल्या आहे. स्वतःचे फ्लॅट्स घेतात EMIनी. त्यामुळे दे हॅव सच अ गुड लाईफ इंडिव्हिज्युअली. दे हॅव देअर ओन टाइम टेबल्स. आणि मॅरेज म्हणलं की आता हे कुठं लोडणं आतमध्ये घ्या, अशी जवळजवळ ॲटिट्यूड होते. सेकंडली, द फिजिकल इंटिमसी जी त्याची जी गरज होती, दॅट इज ऑल्सो स्लोली वेनिंग ऑफ. बिकॉज नाव आता सिच्युएशनशिप्स, रिलेशनशिप्स, म्हणजे सगळ्या वेगळ्या टाईपच्या त्या रिलेशनशिप्स, या भानगडीमध्ये फिजिकॅलिटी हॅज नॉट रिमेन्ड ऑड थिंग नाव. इट इज व्हेरी कॉमन नाव. त्यामुळे दे डोंट फाइंड द नीड टू मॅरी समबडी. म्हणून तो रिलक्टन्स. झालं लग्न, so many of them, they don't want to have children. They have their fear. Again, ही रिस्पॉन्सिबिलिटी कुठे घ्या, हा एक आहे. त्यामुळे चीन तिथं पोचले, जपान तिथं पोचले, आपण हळूहळू तिथंच जाणार आहोत. वी आर नॉट फार. तर म्हणजे कॉन्सिक्वेन्सेस जे होत आहेत, the number of children will reduce, the quality of these children will be compromised. आपण नेहमी म्हणतो की आपल्या नंतरच्या पिढीला जसं होतं आपल्याला मिळालं हे प्लॅनेट तसं तरी हँडओव्हर करता आलं पाहिजे. ही चर्चा ज्यावेळी होते त्यावेळी ती वातावरण, पर्यावरण ह्या विषयीची होती. म्हणजे तुम्ही नासधूस करू नका, आहे तसं तरी द्या पुढच्या पिढीला. मग ही पण जबाबदारी राहते की चांगली जनरेशनच पुढे कंटिन्यू झाली पाहिजे, ही रिस्पॉन्सिबिलिटी पण राहते. माइंड यू, वी आर स्पीकिंग ऑफ अ व्हेरी एलिट क्लास. The people who are involved in this advanced maternal age, these are meritorious peoples. These couples are very high placed. हे IT सॉफ्टवेअर मधली घरी माणसं आहेत, जो DINK किंवा डिंक म्हणून म्हणतात त्याच्याबद्दल, डबल इन्कम नो किड्स, for various reasons. They don't want to have children. They don't want those responsibilities. मग होणार काय? हा जो जेनेटिक पूल आहे ऑफ दिस व्हेरी एलिट अँड एज्युकेटेड पीपल, यू आर नॉट प्रॉपगेटिंग इट इन अ व्हेरी गुड वे असं म्हणू नये. पण एक मग ठराविक जो क्लास आहे विच इज लोअर इन द लॅडर, इन मेरिट, इन इंटेलिजंट क्वेश्चन्स, इन द सोशल क्लास, तिथून हे प्रोडक्शन चालू आहे, त्याला अडचण काही नाही आहे. बट स्लोली वन सोशल क्लास इज बीइंग अफेक्टेड. आणि एवढ्या उशिरा ते सुरू झाल्यानंतर दिस बेबी बिकम्स सो प्रेशस, कारण सेकंड चान्स ते घेणार नाहीत. दिस इज द ओनली वे. मग ते प्रेशर त्या फॅमिलीवरती येतं, ते पेशंटवरती येतं, ट्रीटिंग डॉक्टरवरती येतं. त्यामुळे जवळजवळ त्या डॉक्टरचा, त्या पिडियाट्रिशियनचा गळा धरल्यासारखंच तो सगळा, म्हणजे ते सगळा तो जर्नी जातो. आपल्या शास्त्रांमध्ये ही ऋणं सांगितलेली आहेत. आईवडिलांचं ऋण, समाजाचं ऋण, शिक्षकांचं ऋण, आणि हे जरा विसरलं जातं की डेट ऑफ द ॲन्सेस्टर्स. सनातन धर्मामध्ये सांगितलेल्या गोष्टी. पितरांचं ऋण काय आहे की पितरांचं ऋण का तुम्हाला फेडावं लागतं? कारण पित्र होती म्हणून तुम्ही इथं पोहोचला. त्यामुळे त्या ऋणातनं जर मुक्त व्हायचं तर योग्य वेळी विवाह करून, योग्य वेळी त्या गृहस्थाश्रमामध्ये प्रवेश करून एक हेल्दी पुढची जनरेशन तयार करणं, दिस इज अ डेट. ही जबाबदारी आहे, हे ऐच्छिक नाही आहे. आणि तिथं जरा गफलत झाली आहे ह्या जनरेशनची. दे थिंक इट इज अ चॉईस, आमची मर्जी. This we can find anywhere. The management of these patients, there has to be a very good pre-pregnancy counseling. हा एरिया जरा आपल्याकडे डार्क राहतो किंवा फार विचार केला जात नाही की whether a thorough workup is done and assist that girl or lady so that she achieves physical and mental fitness. कारण fit to undergo pregnancy ही कन्सेप्ट आपल्याकडे विशेष रुजलेली नाही. प्री कन्सेप्शनल काउन्सिलिंग, बिकॉज दॅट गोज इन अ व्हेरी लॉंग वे इन प्रोड्युसिंग अ हेल्दी बेबी. कारण तुम्ही सगळं घेऊन डायरेक्टली प्रेग्नन्सीमध्येच जर आला तर इट बिकम्स अ व्हेरी डिफिकल्ट सिच्युएशन. अर्ली रजिस्ट्रेशन्स, इन्व्हेस्टिगेशन्स, NT स्कॅन, अनोमली स्कॅन, सिरियल फॉलोअप, डबल ट्रिपल मार्कर टेस्ट, कोरियन विलस बायोप्सी, ॲम्निओसेंटेसिस, NIPT, आणि मग ज्यांना सस्पेक्टेड PIH त्याच्यामध्ये तुम्ही लो डोस ॲस्पिरिन देता. मेटाबॉलिक प्रॉब्लेम्स असले तर क्लोज मॉनिटरिंग ऑफ दॅट हायपरटेन्शन, that blood sugar, starting insulin very early, managing the glucoses. Fetal being वरती फार लक्ष ठेवावं लागतं. You have to closely watch them, as I said. They land in intrauterine growth restrictions, demesis. You have to be very careful, and optimizing the delivery. This has to be in a good institute where all the facilities are there, a high dependency unit, because this mother is not normal. तिलाही लागू शकतं, ICU बॅकअप लागू शकतो, त्या बेबीला ICU बॅकअप लागू शकतो. सो द इन्स्टिट्यूट हॅज टू बी a really good one with all the infrastructure and the correct personnels who are managing this. हे जी सोशल मॅनेजमेंट, प्रिव्हेंटिव्ह अप्रोच काय करू शकतो आपण ह्याच्यामध्ये, तो अवेअरनेस स्प्रेड करणं ही एकच गोष्ट आहे, सिंपल नाही आहे. तो अवेअरनेस स्प्रेड करणं ही एकच गोष्ट आहे, सिंपल नाही आहे. हे व्याख्यान घेतलं तसं सोसायटीमध्ये हे स्प्रेड करणं, फॅमिलीपासनं, सोसायटीपासनं, की ह्या अडचणी आहेत, पुढे निर्माण होऊ शकतात. ॲड्रेसिंग द इन्सिक्युरिटीज, थोडं काउन्सिलिंग लागणार. ह्या मुलींना, त्या मुलांना, त्या लग्नाविषयी भीती, त्या डिलिव्हरीविषयी भीती, ती बाळं पुढे हँडल करायच्या विषयी सपोर्ट सिस्टम लागेल, की यू गो अहेड, वी आर देअर. कारण ही आई सेंटरला, द मदर ॲट द सेंटर हॅज टू बी द पॉलिसी. एक प्रेग्नंट मुलगी असते, ऑफिसमध्ये असते, बऱ्याचशा बाकीच्या त्या कोर वर्कर्सचा ॲटिट्यूड कसा राहतो, या तर रजेवर जाणार, ही कमी काम करणार, त्याचं तिचं बर्डन आपल्यावर येणार, याच्यात बदल करावा लागेल. यू हॅव टू लुक ॲट हर. शी हॅज टेकन अ रिस्क टू कंटिन्यू mankind and is ready to produce a child which is going to run your society, your country. त्यामुळे she is taking a risk in that, so you have to be supportive there. त्यामुळे ती त्या मातृत्वाचा सन्मान करता आला पाहिजे, ती केंद्रस्थानीच पाहिजे. इट इज नॉट अ व्हेरी सिम्पल सोल्युशन, आपल्याकडे नाही आहे त्याचं, पण काही गोष्टी सुचतात. म्हणजे की त्या करिअरची भीती, करिअर करायचंय. ते एक मध्ये मुद्दा असा आला होता की म्हणजे तुला मिळाली ॲडमिशन MBBSला, झालं तुझं MBBS, वय किती आता तुझं, 23-24, टेक अ ब्रेक. तुला पोस्ट ग्रॅज्युएशनला ॲडमिशन मिळाली, थांबतो. यू स्टार्ट अ फॅमिली, तुझी ती ॲडमिशन कुठं नाही जाणार. वी अश्युअर यू दॅट ॲडमिशन विल रिमेन. 3 वर्ष तुला ब्रेक, परत येतो, ते पोस्ट ग्रॅज्युएशन सुरू कर. सोसायटीला तो विचार करावा लागणार, ॲडमिनिस्ट्रेटिव्ह लेवलला तो विचार करावा लागणार. बिकॉज 20 to 30 इज द गोल्डन एज, याच्याबद्दल काही शंका नाही. आणि नंतर ते जे म्हणजे सगळी जी मी जंत्री वाचली, नंतरचा जो कॉस्ट आहे, त्या मदरला सांभाळण्याचा, त्या NICU, त्या बेबीला लाईफ लॉंग सांभाळण्याचा, त्यांची दुखणी सांभाळण्याचा, तो जो कॉस्ट आहे, तुम्ही त्या आईला त्या गोल्डन एजमध्ये जर सांभाळलं तर दॅट विल बी मच लेस देन व्हॉट इट विल बी लेटर. फूड फॉर थॉट ह्या गोष्टीसाठीच म्हणून हा विषय निवडलेला. बोलण्यासारखं भरपूर आहे. थँक्यू अगेन फॉर गिविंग मी दिस अपॉर्च्युनिटी. संयोजकांचे आभार. थँक्यू.
थँक्यू सर फॉर दिस इन्फॉर्मेटिव्ह टॉक. तुम्ही नेहमीच एक आदर्श प्रॅक्टिस कशी असावी त्याचं एक जिवंत उदाहरण आहे. आपल्या एरियातल्या हजारो महिलांचं आरोग्य सांभाळायची जबाबदारी अतिशय कठीण परिस्थितीतून सरांनी सांभाळली आणि ज्या आदर्शावर सरांनी प्रॅक्टिस केली, ज्या तत्वांनी केली, त्या तत्वांवरच पुढे आम्ही वाटचाल करण्याचा आम्ही सर्व प्रयत्न करू. आणि आता हा सोशल प्रॉब्लेम म्हणजे असा आहे की आपल्याला या एरियामध्ये 15 वर्षाची प्रेग्नन्सी पण डील करायची आणि 35 वर्षाची पण डील करायची. इतका फास्ट सिनारिओ बदलतोय. तर आता आपल्याला सगळ्यांना ते नॉलेज अपडेट करावं लागेल आणि सरांच्या ज्ञानाचा आपण सर्वांनी त्याचा वेळोवेळी आपल्याला मार्गदर्शन होते. थँक्यू.
झालं का? येऊ का खाली? माईक बी कशाला लागतो तुला? नको रे, माईक कशाला लागतोय?
May I request our chairpersons, Dr. Avinash Panbode sir, to felicitate Dr. Deshmukh sir.
Hello, hello.
Now the legs.
Good morning, everyone. Respected Dias. Myself, Dr. Saurabh, and I'm going to introduce you to new field of surgery, general surgery, that is bariatric surgery. It means a small stomach and big future. Small stomach, big future. It means if we have a small stomach and then we'll have a better and bright future. So, how it is related? Let's dive into bariatric surgery. So, obesity is a modern epidemic, which is a no longer lifestyle issue. It's a chronic relapsing metabolic disease. So, globally, around more than 1 billion people affected by obesity. And there, in India, there is a rapid surge in younger population, and it is linked to over 200 comorbidities like hypertension, diabetes mellitus, and cardiovascular diseases. So, what is pathophysiology behind obesity? Obesity is not a simply excess calorie intake, so it is driven by a complex interplay of hormonal imbalance, gut-brain axis alterations, insulin resistance, and excess fat accumulation causes a chronic inflammation by which it releases cytokines that leads to altered normal metabolism like lipid metabolism and insulin metabolism basically. So, we manage obesity by our dietary habits, exercise, pharmacotherapy like GLP-1 analogs, but long-term success rate of this medical management remains low. So, surgery comes into play. So, why bariatric surgery? Bariatric surgery, on the other hand, offers
Hello.
a sustained weight loss, significant metabolic improvement, and long-term disease remission. It's no longer cosmetic, it's a therapeutic and life-saving. So what are the principles of bariatric surgery? The two basic principles of bariatric surgery is of food or intake restriction and nutrient malabsorption. It works on these two basic principles. So what are the indications of bariatric surgery? There are different guidelines internationally and for Indian populations, but let's consider international guidelines. So patients having a BMI equal to or more than 40 without any comorbidity, so that is a straightforward indication. Then BMI equal to or more than 35 with any comorbidities like diabetes mellitus, hypertension, any cardiovascular accident, or BMI equal to 30 with uncontrolled diabetes mellitus. So these are the international guidelines. Indian guidelines are slightly less, that is BMI more than or equal to 25 with uncontrolled diabetes mellitus, because Indian population tends to develop these comorbidities at earlier weight. So these are the common surgical procedures performed. These are performed by laparoscopic as well as open techniques. Previously they were performed by open technique, but recently the minimal access surgery plays important role. So these are the different types of bariatric surgeries. So each procedure has its own indications, advantages and patient selection criteria. Will not go into details, but there are three main surgeries performed by bariatric surgeons like sleeve gastrectomy, Roux-en-Y gastric bypass and mini gastric bypass. So in sleeve gastrectomy, we cut a major portion of the stomach and will remove it, and there remains only a small pouch that will distend earlier by a less food intake, and we feel satiety earlier. So there is a less food intake. And another is Roux-en-Y gastric bypass, where we bypass the entire stomach, and we will anastomosis the jejunum to uh, upper stomach or lower esophagus, so that the food intake directly comes from go from esophagus to jejunum, and will bypass the stomach. So the absorption of the nutrients become hampers. So there will be a less fat absorption, so the patient loses weight. So how bariatric surgery work? It modulates the hormone signals, increase satiety, improvement in insulin sensitivity, and changes in gut microbiome. That's why it is called as a metabolic surgery. So these are the comparative studies between different types of procedures. So RYGB offers more weight loss. So what are the clinical outcome? Beyond weight loss, the bariatric surgery leads to reduced cardiovascular risk, improved lipid profile. It, it gives you better quality of life and reduced overall mortality. So like any other surgery, the bariatric procedures have risk, but because of modern laparoscopic techniques, the complication rate is very low. The routine complications like anastomosis, leak site, then bleeding from the staple line, but that are very less. So overall complications are very low. With proper patient selection and expertise, it is safe and effective procedures. So we there is a typical example from our practice: a patient with BMI 42 and uncontrolled diabetes. Within 1 year, the BMI reduced from 42 to 28 and HbA1c reduced from 9 to 5.8. So it highlights the transformative potential of bariatric surgery. So recently, bariatric surgeries are performed by robotic techniques and endoscopic techniques that makes surgery safer and more accessible. So this is a take-home message that obesity is a metabolic disease. It's no more lifestyle failure. It offers durable, life-changing results, and most importantly, it's not about reducing weight. It's about restoring metabolic health. Thank you. Just 1 minute. I am happy to announce we have started Chavan Multi-Speciality Hospital, giving care for basically for general and laparoscopic surgery and GI endoscopy, and another is maternity. So let's have a short tour of our hospital. So we'll move it by 1.5x due to time limit. Music म्युझिक आहे त्याला ॲक्च्युली याला ऑडिओ याला नाही जोडलं जवळ घेऊ का there is some problem. Just started 2 months back, but not yet inaugurated. Around 30 bedded hospital. Yes. This is the operation theater complex. There are 2 operation theaters. So this is modular OT. It's laminar airflow. Thank you.
Thank you.
Thank you so much.
Thank you very much, Saurav. Thank you, Dr. Saurav, for your excellent talk on pediatric surgery. And we all wish you best for your new startup. Thank you. Thank you very much.
I request Dr. Sagar Ghoshi to please edit Saurabh Chavan, Dr. Saurabh Chavan.
ठीक आहे हे आता दुसऱ्याला दिलं का presentation? Now may I request Dr. Ram Prasad Dharangutti sir for next presentation. Dr. Ram Prasad Dharangutti is an orthopedic surgeon with experience of 13 years in orthopedic field. He has completed his MBBS from D.Y. Patil Medical College, Pimpri, Pune in 2009. He has completed his DOT from D.Y. Patil Medical College, Nehru, Mumbai in 2015. He has worked as registrar in neurosurgery and orthopedics in BJ Wadia Pediatric Hospital for Children, Parel, Mumbai in 2016 and completed fellowship in pediatric orthopedics from BJ Wadia Hospital for Children, Mumbai. He is also trained and certified in doing robotic knee care. He is currently working as consultant in Department of Orthopedic Surgery and Trauma Care at Vishwaraj Hospital, Loni, Kalur, Pune, with specialization in pediatric orthopedic surgery and joint replacement surgery. And his topic is osteoporosis management, useful for day-to-day practice, both for general practitioners and consultants too. Please, sir.
Yes, thank you. Good morning to respected seniors and hello to all the colleagues, and thank you Indapur IMA for allowing me to share my thoughts.
Hello.
I think I'm audible loud and clear. Yeah. So today's topic is osteoporosis and its management. ह्या टॉपिकचं क्रेडिट आय थिंक मी मगर सरांना देईल की सरांनी मला म्हटलं की एक सर्वसमावेशक विषयावर बोलला तर सर्वांना त्याचा हेल्प होईल. आणि ऑस्टिओपोरोसिस पेक्षा सर्वसमावेशक कोणता टॉपिक होऊ शकतो मला माहिती नाही, सो आय थॉट ऑफ स्पीकिंग ऑन दिस. ऑब्वियसली वी नो डायबिटीज एज द सायलेंट किलर, but actually osteoporosis is the silent killer, and hopefully I'll be able to prove it to you at the end of this lecture. Okay, slide. Yeah. आता कुठल्याही ठिकाणी इंडियामध्ये ऑर्थोपेडिशियनकडे गेलं तर एक गोष्टीची खात्री आहे की बाबा आपल्याला कॅल्शियम आणि व्हिटॅमिन डी ची गोळी मात्र मिळणार. बाकी काही गोष्टीची खात्री असेल नसेल, पण ह्या गोष्टीची मात्र 100% खात्री आहे की कॅल्शियम आणि व्हिटॅमिन डी मिळणार गोळी. So why are they compelled to prescribe calcium and vitamin D? So let's try and figure this out. Okay. आपल्याला कॅल्शियम म्हटलं की पहिल्यांदा वाटतं की अरे फक्त बोन्स आहेत. ओके. सो ऍक्च्युअली इट्स नॉट द केस. ऑब्वियसली इट इज द calcium, bones are the reservoir for calcium, okay, but it's also important for nervous system function. It is the presynaptic release is first started by calcium intake, and calcium also acts as second messenger for many of the cell signaling and gene expression. Skeletal muscle contraction and relaxation मध्ये पण कॅल्शियमचा रोल आहे. Actin myosin complex बनवण्यामध्ये कॅल्शियमचा रोल आहे. Also it is important in heart muscle functioning, okay, and calcium is important in activating many of the clotting factors. Okay, so here you can see the same slide. So calcium is a very tightly managed ship in the bone. The blood levels are maintained between 9 and 11 mg per dl. Okay, if it is less than 8.5 we call it hypocalcemia. तर त्याच्यामध्ये काय होतं, मसल स्पाझम होतात, पॅरास्थीशिया होतं, हायपररिफ्लेक्सिया, प्रोलॉंग क्यूटी इंटरवल, आणि सिव्हिअर केसेसमध्ये हार्ट फेल्युअर लाईक सिम्पटम्स आणि लॅरिंगोस्पाझम पण होऊ शकतो. ओके, सेम इफ इट इज मोर दॅन 11 mg per dl इट इज कॉल्ड हायपरकॅल्सिमिया. त्याच्यामध्ये नेफ्रोलिथियासिस, पॉलियुरिया, पॉलिडिप्सिया, कॉन्स्टिपेशन अँड अदर सिम्पटम्स, कार्डिओवॅस्क्युलरमध्ये शॉर्ट क्यूटी इंटरवल, अरिथमिया अँड इवन हायपरटेन्शन. ओके, सो कॅल्शियममध्ये यू गॉट टू नो की फक्त बोन्ससाठी नाही, तर देर आर सो मेनी थिंग्स which are being modulated and dependent on calcium. So whenever you need calcium, body is going to take that calcium away from the bones and put it in the bloodstream, because you need your heart to function, you need your skeletal muscles to function, and you need your synapses to fire properly. And if you do not have adequate calcium, how would you get it? So bones are essentially the reservoir for that. Okay, so let's come to the topic, osteoporosis. Okay, it literally means porous bones. Okay, as simple as that. Harder ठेसो झालेले आहेत. Okay, and how do you define it? When you do a DEXA scan, T-score less than -2.5. Okay, that is how you define osteoporosis. The normal honeycomb structure of the bone is weakened. The causes are primary, and the types are primary and secondary. Primary kadi postmenopausal and senile, age related, and secondary madhe hyperparathyroidism, chronic kidney disease, prolonged steroid usage. Okay, so as I said, calcium is being used by the body for many purposes. तर ते ह्याच्यामध्ये बोन्स मध्ये दोन टाइप्सच्या सेल्स आहेत, ऑस्टिओब्लास्ट आणि ऑस्टिओक्लास्ट. सो ऑस्टिओब्लास्ट जे आहेत, they are bone forming, away the calcium from the bone and put it in the blood. Okay, so there is a constant balance between the two, okay, at any given point in time, and when this balance is disturbed, that is when you get it. So most common scenario what you get in our practice is elderly female, peri or postmenopausal, and they have osteoporosis. Then what is the reason? Estrogen has a bone protective effect, and when that estrogen drops, the osteoblastic activity reduces, and which leads to in turn increase in osteoclastic activity. म्हणजे बोन जे आहे ते रिझॉल्व व्हायला चालू होतं. That is the reason why you get porotic bones. Like I said, there are two types of osteoblasts, cells, osteoblasts and osteoclast. तर ह्याच्यात symptoms काय आहेत? Okay, so initially it starts as a vague bone pain. Okay, dull aches, कुठं थोडंसं कंबर दुखते, थोडंसं हिप दुखतंय, थोडंसं काफ दुखतंय, and असं आपण अंगावर काढत राहतो. Maybe 1 year, 2 year, 5 years, 10 years down the line, you do not realize that this is silently causing structural failure of the bone, okay? And now the bones are prone to easy fractures. A small fall will lead to a fracture in maybe distal radius, or a minor trauma, a fall from stairs will cause severe fractures, or comminuted fractures, or multiple fractures. It also causes cascading effect by pain. When the pain increases, you tend to reduce your mobility, and that reduced mobility in turn causes more osteoporosis and further weakening of the muscle, and that increases the pain, and so on and so forth goes the cycle. एकदम झटकात आपण खाली बसतो and you get vertebral fractures, किंवा गाडीमध्ये जोरात जुने आपण किस्से ऐकायचो की बस जोरात हादरली आणि पाठीत एकदम हे झालं आणि एक्सरे केला तर L1 फ्रॅक्चर झालं, D12 फ्रॅक्चर झालं. So that causes kyphosis and mechanical changes to the gait that further causes degeneration and osteoporosis and knee pain, maybe osteoarthritis of knee, okay? And very classical scenario that you will get, that perimenopausal or postmenopausal female, 60, 65, and she goes to the washroom and she slips and falls on the hip, mainly on the lateral side on the trochanter, and she will get a complex intertrochanteric fracture, comminuted one, okay? This is a classical scenario. So why it is a silent killer? So all those hip fractures have mortality rate of anywhere around 10 to 20% in first year after that fracture, no matter what treatment you do. And 5-year survival rate after a hip fracture is just 50%, okay? It's a shocking figure. म्हणजे 5 वर्षानंतर almost half of them will die with some other or the other cause. There are many papers which suggest that, okay? So जर एवढा सिरियस असेल तर आपल्याला काय करायचं, ओके? नुसतं हाडं ठेचू आहेत, घ्या कॅल्शियम, okay, असं नाही आहे, okay? Let's figure out what is to be done. Obviously we'll do serum calcium. Most likely it is going to come normal. So the question is always this: डॉक्टर तुम्ही म्हणताय माझे कॅल्शियम कमी आहे आणि टेस्ट केली ती तर नॉर्मल आली, मग नेमकं कोणाचं चुकतंय, लॅबचं चुकतंय की तुमचं चुकतंय? So we'll figure out what is. So blood levels, as I said, they are being maintained very tightly by the body. The calcium is taken away from the bones and not from in the blood stream, okay? So we also have to do vitamin D, ALP and PTH levels. The gold standard test for osteoporosis is DEXA, okay? This is the non-invasive test, dual energy X-ray absorptiometry, okay? This is the gold standard test for this, okay? And sometimes we have to do X-rays for stress fractures, proximal tibia, and any vertebral wedging, we'll do LS spine X-rays, okay? Treatment, now let's come to the treatment. Mainly, again, जसं म्हटलं, calcium, vitamin D, and K2, okay? I'll talk about K2 maybe just a little later. And there are lifestyle modifications, okay? We'll go each slide by slide. So for next, calcium what are the sources, okay? Mainly all the green leafy vegetables, okay? Cheese, paneer, okay? The daily requirement is around 1000 to 1200 milligrams in divided doses, okay? And also vitamin D. So let's talk about calcium first. So there are many forms of calcium. If the dietary intake is not good, we have to supplement it with some form of medication. So which medicines would you prefer? There are 2-3 salts which are available. The mainly commonly used is calcium carbonate. The elemental calcium in the calcium carbonate is around 40%. It is readily available. It is cheaper. But the problem is the absorption is also food dependent, okay? So you have to take these tablets with food. It also causes more of GI upset and bloating and constipation. But the advantage is that is the more elemental calcium is available in calcium carbonate, and the cost is cheap. So what is the newer option? Calcium citrate. So in calcium citrate, the elemental calcium is around 21%. म्हणजे 1000 milligrams जर तुम्ही डोस दिला तर त्याच्यात elemental calcium 210 milligram असेल, okay? So if the requirement is 500, you have to increase the dose, okay? That way. So citrate चा काय advantage आहे की it can be taken up any time of the day. Food intake शी त्याचा काही संबंध नाही आहे, okay? And it has excellent bioavailability आणि कॅल्शियम जास्त घेतल्यानंतर nephrologist will say आपलं renal stones वाढतात, but calcium carbonate मध्ये त्याची chances थोडेसे जास्त आहेत, but citrate आणि citrate मध्ये हे कमी आहेत, okay, or equal आहेत for that matter. Also, one other molecule which is available is citrate maleate. It is commonly used in fortifying the juices and everything, okay. This has elemental calcium of around 21 to 26%, okay. This also can be taken up any time of the day, but this is a little more expensive, okay. So these were the other ones are calcium gluconate, which is mainly used in intravenous therapy. Then let's come to vitamin D, okay. The vitamin D mainly is synthesized in the body by UV light, okay, and also we give oral intake, and it undergoes two hydroxylations first in the liver and in the kidneys. आता vitamin D साठी आपण सजेस्ट करतो की उन्हात जाऊन उभे राहा किंवा ऊन खा, तर त्याच्यामध्ये काय नेमकं आहे तर UVB light is more important, ज्याची wavelength is around 290 to 320 nanometer. That when do you get that UV light? Okay, that is the question, and how much exposure is needed? So in India, we have plenty of sun exposure, okay? So it's not like Europe or some other countries. So recommended would be during the summers, anywhere between 8 to 10 a.m. in the morning, approximately 5 to 10 minutes, 2 to 3 times in a week. That is more than enough. In winter times, obviously, the sun is at an inclination. That is why the recommended time will be 11 to 1, okay? So obviously the 10 to 15 minutes, that depends on the skin color as well. If somebody is lighter of a lighter color skin, and he will need less time. And if somebody is of a darker tone, he will need more time. And obviously this also depends on what amount of clothes are you wearing. पूर्ण कपडे घालून फक्त चेहरा आणि संपूर्ण साडी बिनून येऊन नुसतं हात उघडा आहे तर त्याच्यामध्ये obviously time जास्त लागेल. If little bit of hands and legs are exposed, कमी time लागेल, okay. So what vitamin D does? हे तर आपल्याला तयार झालं. What vitamin D does? It increases the calcium absorption from the stomach and intestines and puts it in the blood. It reduces excretion of calcium from kidneys, okay, and that way it stimulates osteoblasts to put that calcium inside the bone. मी जसं vitamin K2 मगाशी म्हणालो होतो. So now the vitamin D is putting that calcium in the blood. What about it needs to be put back in the bones, right? So vitamin K2 helps you doing the same. Rather than just circulating in the blood, vitamin K2 helps in putting that calcium inside the bones by increasing the osteoblastic activity. हे तर कॉमनली आपलं कॅल्शियम विटामिन डी झालं. त्याच्या पुढे काय? सो bisphosphonates is the primary line of treatment for osteoporosis. Once you have made the diagnosis that it is an osteoporosis by bone mineral density scan, then you have to give them bisphosphonates, okay. ह्याच्यामध्ये दोन प्रकारचे येतात, oral and IV, okay. How do they work? They have very strong affinity for hydroxyapatite. So they जातात आणि bone मध्ये they go into hydroxyapatite crystals, okay. They have a strong affinity towards. Then osteoclasts, the bone eating cells, they come and they bind with these bisphosphonates and they starts breaking it down, and that is how it causes apoptosis, म्हणजे त्याची cell death होते. Osteoclast cell death व्हायला लागते आणि that is how it increases the osteoblastic activity, म्हणजे osteoclast ची activity कमी करते, okay. So options are alendronate, resedronate, okay. तर alendronate हे commonly used drug है. It is around 70 milligram that we give weekly dose, okay. And how do we take this? The absorption is to completely depend on the stomach, okay. So it has to be given on the empty stomach, preferably in the morning, and you have to have around 25 to 30 minutes of stomach empty time, okay. No eating anything after having that tablet, and you have to sit upright. Why? Because it causes esophagitis. The very common side effect of alendronate and all the bisphosphonate is esophagitis. That's why lying down, गोळी घेतल्यानंतर झोपायचं नाही. म्हणजे सकाळी उठले गोळी खाल्ल्या अर्धा तास झोपून जाऊ नाही. You have to sit upright, okay. Resedronate Okay, another drug 35 milligram weekly किंवा 150 milligram monthly. Okay, ibandronate is also another drug, 150 milligram orally देऊ शकतो किंवा this is available also in IV. So what about those patients who have GI symptoms, gastric acid peptic disease असेल किंवा other esophagitis असेल? So for those we prefer zoledronic acid. Okay, this comes as an IV infusion. 5 milligram once in a year is enough. Okay, so this once in a year infusion is more than enough. Okay, so and also it works for people with GI problems. Side effects ह्याचे काय आहेत? Okay, hypocalcemia, very rare cases osteonecrosis of jaw and atypical femoral fracture. Okay, and there's something called as drug holiday. I'll discuss it later. So once you start taking bisphosphonates, around 1.5 to 2 years, you'll see reduction in vertebral fractures by around 50% to non-vertebral fractures are anywhere around 50 to 70%. That is how effective they are. Okay, so contraindications kya hai? Anyone with a kidney disease, we cannot give bisphosphonates. Okay, for a longer duration time. This can be given safely. Oral ones can be given safely for 5 years, and IV zoledronic acid can be given for 3 years. Okay, and after that you have to give it a break, and then you can start on some other drug. So what other drug is available? Teriparatide. मगाशी जसं बोलत होतो पॅराथायरॉइड हॉर्मोन आणि पॅराथायरॉइड ग्लँड ही ऑस्टिओब्लास्ट आणि ऑस्टिओक्लास्ट हे दोघांनाही स्टिम्युलेट करत असते. बट इन अ शॉर्ट ड्युरेशन initially it mainly stimulates the osteoblasts more than the osteoclasts. That is the principle that we use to in giving teriparatide. त्याला anabolic effect असं म्हणतात. तर 20 micrograms subcutaneous every day आपण देतो. Okay, so this increases osteoblastic activity and promotes new bone formation. This cannot be given more than 24 months because after that osteoclastic activity also is being stimulated by PTH, and that is why only for 24 months you can give this. Contraindications include Paget disease असेल, ALP कुठल्या कारणास्तव रेज असेल, skeletal malignancy असेल किंवा pre-existing hypercalcemia असेल. Obviously complications of this include hypercalcemia and hypercalciuria. न्यूअर आता हे टेरिपॅराटाइड बद्दल ऐकलं की एव्हरी डे सबक्युटेनियस इंजेक्शन द्यायचं फॉर 24 months. तर पेशेंट्स म्हणणार अरे डॉक्टर साहब कुछ तो उपाय करो, कुछ तो डिस्काउंट दो, ये तो बहुत ज़्यादा हो गया. So now doctors have come up with some other drug. Okay, denosumab. This one is also a subcutaneous injection. You can give this once in 6 months. So daily varun direct once in 6 months. Okay, so what is this? It's a monoclonal antibody. So what it does is it again inhibits osteoclast. Okay, म्हणजे bone resorption जे आहे ते कमी करून देतं, and that is why the balance is maintained and osteoblastic activity वाढवते. Okay, this also reduces hip fractures by around 70%. Hip fractures by around 40% and vertebral fractures by 70%. This also can cause hypocalcemia, back pain and muscle pain. But the wonderful thing about this drug, it's a monoclonal antibody and it is not related to kidney. That's why even in kidney failure patients, this drug can be used. And for that matter, most of the patients who are on dialysis or some kidney intervention, they are recommended to get this denosumab injection to prevent that osteoporosis. Okay, once you start giving it, maybe you can give it for 3 years, and after you stop, obviously the balance was restored with this, but again once you take that away, the effect of inhibiting osteoclast is reduced. So that's why you need to supplement that with bisphosphonates. Once you stop denosumab, you have to switch back to bisphosphonates. जसं मी म्हटलं की mainly patients will be perimenopausal or postmenopausal women. In them we also can consider hormone replacement therapy. You can consult your gynec and then recommend them hormone replacement therapy. It's mainly estrogen and progesterone combination therapy. And obviously it has its own complications, side effects such as venous thrombosis, increased risk of breast cancer and endometrial cancer. So if you don't want these, the other drug which is available is raloxifene. Okay, that is also can be given, which does not have any of the above complications. So आता हे सगळे drugs दिले, the choice of drugs I'll tell you. Also, that does not mean that you don't, one subcute injection once in 6 months or one IV injection once in a year of zoledronic and सगळं एकदम टकाटक झालं, आजीबाई एकदम बेडवरती होत्या आणि लगेच तुरु तुरु धावायला लागल्या. इंजेक्शन काही होत नसतं. Obviously, you have to do exercises. So strength training has been proven to increase the bone mineral density and muscle health. Okay, it improves muscle health by quite a bit. And we rely mostly on walking or whatever home exercises that we do. That is not the right thing. Core strengthening exercises that help you correct the posture and reduce the pain. Okay, that's how it works. And you have to change your posture while sitting and standing. That's how you will reduce that pain. And obviously, lesser, जर हे काही जमत नसेल तर at least walking करा, काहीतरी cycling करा, ते आहेच. Okay, routine checkups definitely to see, monitor the bone health. Okay, so I hope I was able to answer that question. की orthopedicians कडे गेलं की vitamin D आणि calcium का मिळणार आहे? कारण जर आपण त्याला कॅल्शियम किंवा हे सप्लिमेंट नाही केलं तर नक्कीच बाकीच्या इम्पॉर्टंट व्हायटल फंक्शन्स करता कॅल्शियम विल बी टेकन अवे बाय द बोन्स, taken away from the bones, and that lead to osteoporosis and weakening. So this is the take home message. Porous bones need more than calcium and vitamin D. म्हणजे osteoporosis मध्ये फक्त calcium, vitamin D नाही, दुसरे अजून drugs आहेत. You have to break that vicious cycle of bony pain, आणि bony pain होतं, muscle pain होतं, that causes reduction in the activity that in turn causes more bone pain, and so on and so forth. That vicious cycle continues. Primary treatment is bisphosphonates and bisphosphonates. All you have to consider them. That is the main line of treatment. The other, in severe cases, teriparatide, subcute injections every day for 2 years. If not, patient wants discount, you give denosumab, 6 monthly, 1 dose, okay? And in certain cases, hormone replacement therapy. Once you start, again, I'll tell you about the drug holiday. Once you start on one of the drugs, for example, bisphosphonates, if you give it for them for 5 years, then you have to switch back to maybe a denosumab. Then if you give that denosumab for 3 years, then you have to switch back again to bisphosphonates. If you consider teriparatide, you cannot give more than 24 months. So that is 2 years. Okay? That's it. Thank you. Any questions?
Thank you very much, sir.
Thank you, Ram Prasad, for a very excellent talk. Seemingly very simple topic of osteoporosis for as a short note for 3 to 4 marks, but it bears a huge significance. You have given various causes, how to investigate the osteoporosis, and what are the different treatment modalities, right from the diet to the calcium to the D3, hormonal replacement therapy like estrogen and raloxifene. So very nice account. Thank you again for giving such a nice lecture. I request
Thank you.
Dr. Sudhir Tambele sir to felicitate Ram Prasad.
Now, now may I request to felicitate our chairpersons. May I request Dr. Shivaji Rao Khabale sir to felicitate Dr. Panbude sir.
Now may I request Dr. Arjun Narote sir to felicitate Dr. Sagar Doshi sir. Oh sir, now the chairpersons for the next session are Dr. Shedke sir and Dr. Mrs. Chandansha madam. May I request to chair the session for the next two lectures? Dr. Shedke sir and Mrs. Chandansha madam. So next lecture is by Dr. Ranjit Pawar. Next lecture is by Dr. Ranjit Pawar. He's a cardiothoracic surgeon. He's done MCH from AFMC Pune, MS General Surgery from GMC Nagpur, MBBS from GMC Kolhapur. He's a bronze medalist in MHS Nashik Super Specialty Examination in 2016. His current appointments are working CVTS surgeon in Vishwaraj Hospital, Loni Karbor, consultant assistant professor in CVTS and in D.Y. Patil Medical College and Research Center, Pimpri. He has an experience of over 10 years of in both adult and pediatric cardiac surgery. He is a postgraduate teacher for super specialization MCH degree in CVTS. His areas of interest are coronary artery surgery, valvular heart diseases, aortic surgery, minimal invasive cardiac surgery, pediatric cardiac surgery, and lung surgery.
Good morning, senior doctors, my colleagues, and all others. Thank you very much for inviting me here for a short topic. Actually, my topic is a bit different for the general physicians, but still I will give a simplified overview of when to refer to a cardiac surgeon and with a minimal invasive cardiac surgery as a choice for these procedures. Already my introduction has been given. I am working currently at the Vishwaraj Hospital, Loni Karbor, Pune, and also assistant professor at D.Y. Patil Medical College, Pimpri, Pune. So to introduce, cardiac system is one of the complex and demanding area of medicine, and heart disease has been one of the most leading cause of the death and recurrent hospital admissions worldwide, and more so in India. While as a cardiac surgeon, we have to collaborate with broader specialties like general medicine, cardiologist, cardiac anesthetist, and pediatricians to assess these patients suffering from the cardiac ailments, assess their risks, decide treatment plan, and guide this patient for the further treatment, and prepare them for the definitive procedure. So it's always a heart team which decides about the management of the patients. The heart team basically consists of a cardiologist, cardiac surgeon, and cardiac anesthetist. The role of the cardiac surgeon extends beyond the surgery itself. He has to cater for the patient in the post-operative period, do the follow-ups, monitor his recovery, wound healing, and also the rehabilitation of these patients, and also keep the patient for the lifelong follow-up for their treatments. So when a patient is required to go to a cardiac surgeon, most common being when the conservative treatment fails to produce the desired effects and the symptom worsens, even in presence of the optimal management, the patient may need to go for a cardiac surgery. And other common indication, there are certain conditions which require direct referral to cardiac surgeon on the first diagnosis itself. So basically these patients, the common presentations are the persistent chest pain which worsens or exertion and does not subside at the rest or with medications, which can indicate advanced coronary artery disease or valvular disease and may need referral. Progressive shortness of breath, symptoms of a heart failure requiring recurrent admissions like recurrent edema, decreased exercise tolerance, and rapid fatigue. Certain arrhythmias which can lead to fainting can signify underlying structural heart disease and require further evaluation for a by cardiologist and cardiac surgeon. And palpitation, tightness of chest are these can also suggest a valvular heart disease. The conditions which require referral to the cardiac surgeon on diagnosis itself, there are certain conditions like aortic dissection, symptomatic aortic aneurysms, complications, mechanical complications of myocardial infarction like post-MI ventricular septal rupture or pre-wall rupture, contained rupture and papillary muscle rupture causing acute MR. Complex congenital heart diseases like tetralogy of Fallot, transposition of great arteries, TAPVCs are the conditions which require a direct referral and diagnosis to a cardiac surgeon. Then trauma with vascular injuries and cardiac injuries should be managed by a cardiac surgeon, and mediastinal masses which mostly needs a surgical excision. So there are various complex guidelines for the elective referrals. These are provided by the American Heart Association, European Heart Association, which recommend the various levels of the recommendations and grades of recommendations. These are quite complex guidelines, like significant left main disease with a high complex coronary artery disease, CABG is preferred over PCI, with reduced ejection fractions, or diabetic patient with complex congenital heart diseases. There are various complicated guidelines which are present over the worldwide, but to simplify these guidelines, elective referral is done in cases of valvular heart diseases, symptomatic valvular heart diseases with severe lesions like severe aortic stenosis, aortic regurgitation or mitral stenosis, mitral regurgitation, asymptomatic patients but with severe lesions, and when there is decrease in left ventricular ejection fraction or increasing left ventricular dimensions need surgical evaluation. Coronary artery disease with a refractory angina to medicines and I am not amenable to PCI needs a cardiac surgical evaluation. Recurrent hospital admissions and decompensated heart failure need evaluation for further treatment options like ventricular assist devices, and may be candidate for heart transplant also. Certain cardiac congenital lesions when they are at risk of developing pulmonary hypertension or causing symptomatic recurrent hospital admissions are indication. The point to be noted here is the referral should occur before the end organ damage or severe symptom onset, so that the early diagnosis can benefit by increasing the chances of effective treatment and reduce the risk of complications. The treatment modalities which can be offered in the modern cardiac surgery as open heart surgery, which has been time tested through a median sternotomy. With the last few years, there has been a invent of minimally invasive cardiac surgical techniques, which include by which we through a small incision we can provide the same effective treatment surgical options for the lesions. Then there are hybrid therapies which combines the traditional cardiac surgery plus the percutaneous techniques, endovascular procedures, and newer advent has been the robotic technologies. The choice of method depends on the type of the disease, patient health status, and the diagnostic test. So obviously the picture is self-explanatory, the sternotomy versus minimally invasive cardiac surgery. Given a choice, patient generally prefers to go not to go under surgery, and if the surgery is a must as a smaller incision, they will better choose the option. So what is a minimally invasive cardiac surgery? Cardiac surgery which is performed through a small incision without any complete division of the sternum is considered as a minimally invasive cardiac surgery. The approaches can be multiple, like a mini thoracotomy, where we do a small incision on the either right or left side of the chest to reach the heart and do the surgery. Mini sternotomy involves a part of the sternum, only the upper or the lower. The 2 or 3 interspaces are divided and the rest of the sternum is left intact. Then there is a transaxillary approach where the incision is hidden behind the axillary folds and totally not visible on the normally. The robotic assisted surgery, endoscopic surgery are the developmental techniques, and TAVI, a percutaneous technique where a new wall is introduced percutaneously through the peripheral veins and replace aortic wall, can be done by both a cardiologist and a cardiac surgeon. So the advantages of mix, comparing a mix versus the traditional surgery. The sternotomy incision usually is about 8 to 10 inches in length, while the mix incision is just 2 to 4 inches with significantly less pain, smaller hospital stay, and a minimal blood loss. The major benefit of the mix is the faster recovery. The recovery period for the mix is usually 2 to 4 weeks, while it takes 2 to 3 months for a traditional cardiac sternotomy surgery to recover. The key procedures which can be done through a minimally invasive approach are mitral valve replacement, aortic valve replacement, coronary artery bypass surgeries, ASD and cardiac tumors can be excised through minimally invasive surgery. So these are some of the photos, images I will be showing where we are doing a minimally invasive bypass surgeries. The first one is a minimally invasive bypass surgery done through a left-sided thoracotomy, where an incision of length of about 8 to 10 centimeters, that is around 3 or 4 inches. We can do a multiple bypasses, 2 or 3 bypasses to the heart without even stopping the heart. Minimally invasive mitral valve surgery is done through the right thoracotomy approach. Incision below the nipple level of a length of 4 to 5 centimeter is usually done, and valve is replaced or repaired through that. The benefit is that this incision is very smaller size. In females, even if the incision is hidden behind the breast, so there is no visible scar also, and it has a cosmetic appearance benefit also. Mixed aortic surgery is usually done through a partial sternotomy, hemisternotomy. Incision is even smaller than the length of a pen, generally usually 5 centimeters. And in congenital diseases like ASDs and selected VSD cases, we can repair them through a transaxillary approach. A small incision which is even not visible, you cannot recognize even the child has undergone surgery unless you lift the hand and see the incision hidden in the axilla. So who can benefit from a minimally invasive cardiac surgery? The working professional who need to go back to work in 2 to 4 weeks, who has a high demand, they can be candidate. Senior citizens who has a brittle bones and more risk of trauma or infection, and can lead to faster recovery and faster rehabilitation. Diabetic patients, again there is no division of the bones, so there is reduced risk of infection, serious infections, chest infections. And cosmetic demand can be a reason for a surgery. So certainly there are some contraindications to mix when we need to go for open cardiac surgery. These include complex multivessel diseases, emergency cases where the patient is hemodynamically unstable. The sternotomy has been a standard approach and a time-tested method to provide early access to the heart. Severe calcifications with a calcification of aorta and peripheral vascular diseases where we cannot establish bypass through the peripheral route needs to go for a standard surgery. Severe obesity can be a contraindication to give access to the heart, and complex congenital heart diseases may need open methods. Severe lung diseases, there is the minimally invasive cardiac surgery requires a single lung ventilation and with a collapse of one lung, and the lung disease patient can be a contraindication for this. There is also a role for the general physicians and the practitioners to take in the care of these post minimally invasive cardiac surgery patients. The patients, as they discharge early, they need a regular checkup to monitor their blood pressure, stress, and all wound healing. Also, their rehabilitation has to be monitored in the home setting. The valvular heart disease patient who have undergone valve replacement need to monitor their anticoagulation levels, and warfarin dosage adjustment can be done by a general physician. So this is a small video. So this is a standard sternotomy approach where we are exposing the heart through the cutting the hole of the bone, which gives a better exposure but takes time to heal. And a small incision surgery has its cosmetic benefits, providing the same efficacy of the surgical level. And the scar is not, you can see in pictures that the scar is even not visible, and patient is back to work within 1 month. In females, there is no visible scars, cosmetic appeal, and psychologically that is also beneficial for these patients. Again, a pediatric case with a incision of size of 3 centimeter in the axilla. So to conclude, we should think of a mix when a cardiac surgery is required for this patient. With selected cases like mitral aortic valve disease and coronary artery disease, mix can be a first choice for them. Early referral gives a better outcomes for this patient, and early recovery to the faster return to the normal life. Thank you.
Any questions from audience?
Good afternoon all. Excellent and very precise and elaborative lecture on mix. Now I want to ask you one question. We are going for TAVI, and you are going for minimal invasive aortic wall replacement. So how do you weigh both of these procedures? Which should be done when, which should be done when?
So the indications for the TAVI are now developing. It's like last 10-15 years, TAVI has been emerging procedure for the high risk cases, like the patient who are not candidate for a surgical aortic wall replacement, with patients with kidney failure or severe calcific disease, who are at high risk of stroke and post-surgical complication, wound in management complications. They are good candidates for TAVI, but the indications for TAVI are expanding now in the low risk patients also. So, but the longevity of the wall has to be taken care of. Like TAVI is a bioprosthetic wall replacement, so it is better suitable for the old age patients. And low risk with a patient going for mechanical wall can be a good considered for surgical AVR.
Yeah. Surgical risk also has been decreased very significantly because of minimal invasive.
Yeah.
Tower is low risk, but wall and the age of the patient should be taken into consideration.
Choice of wall, yes.
Next question is, you are a part of heart transplant team in DY Patil. What kind of patients you prefer for heart transplant or something?
The transplant patients are usually the heart failure patients who are requiring recurrent hospital admissions, like severe low ejection fraction, and they are decompensated with the recurrent need for hospitalization and grade 3 or grade 4 NYHA symptoms. They are the candidates for the heart transplants.
What is the success rate at present for the heart transplant?
For heart transplant, success rate is nearly about 5-year survival is around 80% and 10-year survival is about 50%.
Excellent, excellent.
Thank you.
May I request Dr. Sherke sir to felicitate. Dr. Power sir. Now may I request Dr. Ingule sir for next presentation. Sir is CVTS HOD at Vishwaraj Hospital. And topic is IV US guided PCI.
एकदम खाली एंजियोजी रन होते खाली हे रन होते कनेक्ट करें Good afternoon all. I am Dr. Ingole, HOD Cardiac Sciences, Vishwaraj Hospital. No long introduction needed because most of the friends are sitting in the audience and Indapur has been a favorite place. To give an example, when morning 5 o'clock I was getting ready, my wife was surprised. Why he is going at 5 o'clock and he is happy also? When husband is happy, wife feels strange, something panic. Where are you going? She asked me. I said, I'm going for lecture in Indapur. She asked second question, then why you are wearing pink shirt? I said, these are my friends. I am always happy to go Indapur, and Indapur has been always respected because this city respects knowledge. So I always happy to come here. Now, 3 years back when I was giving the lecture in the same hall, I had given lecture on heart failure. That time I had discussed something called as dapagliflozin as well as Ernie. Now, whenever prescription comes from the Indapur physicians or general practitioners for a heart failure patient, I see a prescription of dapagliflozin or Ernie. Likewise, you have adapted many times a practice according to upcoming knowledge or upcoming inventions. Today we are going to discuss similar kind of invention which is going to be very common in cardiology is IVUS, that means intravascular ultrasonography. You people only will write after some years go and do angioplasty with the guidance of IVUS. So it is we should know why do we need IVUS so frequently to do angioplasty. Angioplasty was discovered in 1958, it is way long back. Now it's time to go ahead, find new things and get a precise thing to go for the angioplasty. So as I said, we had discovered angioplasty previously in 1958. After that many various things came for the cardiac imaging. Cardiac imaging in total, we do TE, means transechocardiography, CT coronary angiography, optical tomography that is called as OCT, IVUS is intravascular ultrasonography. That means we go inside the vessel, do sonography inside the coronary arteries. We do cardiac MRIs, we do PET scan for the viability of the heart, we do routine angiography. So these are the modalities we do imaging for the cardiology. Angioplasty is different thing, imaging is different thing. We need it to image to do better angioplasty. What is IVUS? It's a detection device which goes inside the vessel and detects what is the pathology, what is the block, what is the length of the block. Why do we need IVUS? Because what you see is not always what is there inside the vessel. Whatever we are seeing angiographically is from the outside, we don't see inside the vessel. So for that we require IVUS. What is the difference between angiography and IVUS? Angiography is a planar imaging, while intravascular ultrasound is inside the imaging which is tomographically obtained. Angiography we take, every shoot is taken periodically, while IVUS will take the catheter pull back, it causes continuous real imaging. IVUS in angiography gives a shadow, we are seeing shadow of the vessel from outside, we are not going inside, while IVUS is going in directly inside the lumen and visualizing the wall. Angiography rarely defines the plaque, means what is inside that block rarely is defined by the angiography, while IVUS gives what is inside that plaque. Is there calcification, is there clot, what is soft block, what is hard block, everything is defined by the IVUS. Then quantifying vessel as well as precise diameter and area of the vessel is given by the IVUS. How does this IVUS? It's an ultrasound which is normal ultrasound which works from the like a bat. Echolocation, it gives sound waves and then recollects the sound waves. Similar way IVUS acts. This is the catheter of IVUS, which is first we put into the distal end of the artery and then it comes slowly back from the artery toward the proximal end. It generates ultrasound waves and then recollects through the transducer and we can find out the vessel structure accordingly. This is the लाइटला काय करते them as a ultrasonography. It emits the ultrasonic waves and collected by the transducer in the ultrasound and it gives the vessel morphology inside the vessel. This is the exact machine what we have in our cath lab. It's a Avigo Boston Scientific machine, is one of the best available in world. It's a AI generated. Yesterday there was one question, how we can help, AI can help us. Now this machine, once you just put in the catheter, gives all readings automatically. How much percent is the obstruction, what is the length of the block, what is inside the block. Is there clot, is there any calcium, or is there hard plaque or soft plaque? Everything is generated, AI generated, and gives information that makes easier to take decisions according to the plaque. This is how IVUS works. This catheter goes inside the vessel. It transmits the ultrasonic waves, and this kind of vessel picture it gives. Clearly it shows intima, media, as well as adventitia, and if there is any blockages, that can clearly show to us. This is a vessel lumen, which can be seen as a red. Then this is intima, vessel intima. This gives a media, the gap between intima and adventitia, and the adventitia border, it is shown like this. And if there is a plaque, this can be seen as a yellow on the monitor. So this is a normal IVUS where we can see 3 layers of artery, coronary artery it is showing, intima, media, and adventitia. If there is a block, which will be shown in yellow quite clearly. Now calcium calcification in coronary, is this the same calcium which is present in the blood? No, blood calcium levels are different, and coronary calcification is a different thing. Coronary calcification is a very important thing because it's like a hard rock sitting in the coronaries. It years and years it accumulates and becomes very hard structure or firm structure, and it's like a hard rock. So PTC is the cornerstone of the coronary artery disease. Calcified coronary regions remains a challenge for the PCI because outside artery is very soft, inside that plaque or calcium is very hard. How to remove that? That becomes a very much challenge. Proper calcium management is very key procedure to success, because if you don't remove that calcium, your stent is going to be underexpanded. Its long-term results are not going to be good. So overall, if you see, there is a 30% prevalence of calcium in the PCI. Any angioplasty, out of 100, 30% will have calcium. Majority of calcium is left untreated because it is not diagnosed many times. It is around 88% it is not diagnosed or left untreated. If the calcium, if there is a rock sitting under your stent, it is not going to expand properly, and if it is not expanded properly, restenosis chances are definitely going to be high. So for optimal result or long-term result, calcium must be treated initially, then stenting should be done. Regarding calcium, how does IVUS helps in detection of calcium? If we take a 440 patients they had taken for a trial, 40% only calcium was seen angiographically, 82% was seen by IVUS, and OCT has shown by 76%. In 21% of the IVUS, angiography did not show any calcium. So this much of amount calcium IVUS can show and it's visible, so it is very much recommended. If you suspect a calcified lesion, go for an IVUS and then go for the angioplasty. What other things IVUS helps? IVUS guides in the quantification of the vessel, that vessel measurement. It gives the diameter of the vessel, which is from minimal to maximal, which it gives the cross-sectional area of the vessel, which gives the appropriate sizing of the stent. Stent sizing, it helps in lesion length, diameter of the vessel. If we know the diameter of the vessel, we know how much size stent needs to be put and how much pressure should be deployed while putting stent. Adequate vessel preparation, that means we know whether if there is a large plaque burden and we don't want to oversize or undersize the stent, adequately we want to put the stent, that is the adequate vessel preparation is needed. Once angioplasty is done, once stent is put, we reassess the stent deployment by IVUS. It gives the PCI, post-stenting what information does it give? It gives if the stent is malopposed, whether it is under-expanded or malopposed, or whether there is a geographic miss. Geographic means lesion is still pending, stent is finished before the lesion. Under-expansion means it is not touching the vessel wall properly. If there is edge dissection, if there is a dissection of the vessel, it can show. Thrombus formation, if it is present, while doing angioplasty, there is a thrombus, we can identify by IVUS. If there is a tissue prolapse inside the stent, all these things we can identify by IVUS. So when should we use IVUS? Any diagnostic uncertainty, instant restenosis, left main angioplasties, and other complex lesions, we should go for the IVUS. As we discussed pre-stent workflow, what does it give? It gives the lesion length, defines the landing zones, where are the good landing zones, bad landing zones, access the plaque morphology, measure the vessel size. Once we have done the angioplasty, it gives the idea about geographic miss, is there any edge dissection, is stent is malapposed, and whether the stent is adequately expanded. So this is the example of post-stenting IOS, which gives a expanded, that white dots, those white dots are actually stent. You can see the lining of the stent is there. It is well expanded and well opposed to the vessel. Minimal area is achieved very nicely, and there is no edge dissection. If these all criteria is met, you are good to leave the angioplasty. Now we'll go with our few angioplasties. This was the gentleman which was 40 years old. He had a recurrent chest pain. ECG was having changes. Mid segment it is showing. This area is showing block is there. And the block was almost borderline block, around 70%. Now whether to stent it or not to stent it was the question. So when we went ahead, did the IVUS study. Now if you see in the IVUS, the wall area gets minimal and then again goes back to the normal. In plaque, or if there is a block, it doesn't goes back to the normal. It comes to the minimal size and then goes back to the normal. This is typical sign of muscle bridge. That means when heart contracts, the coronary has intramyocardial course. When heart contracts, the coronary gets clamped, and then once heart is opened, then artery gets normal. So it doesn't need any angioplasty or stenting. The gentleman was sent on the medication and he's doing very well from long time. This is a second case which was very complex. It's a chronic total occlusion case. I and Dr. Surya Prakash Rao from Hyderabad, one of the leading intervention cardiologists who had come to Vishwaraj, we were doing this. We did the case for almost 2 to 3 hours. The sizes we had chosen around 2 stents was 2.5 and 3.5 sizes were taken. We did angioplasty, flow was achieved, and then we thought we'll do a post-stenting just to see how is the stent and what is there. To our surprise, if we see here, these struts are hanging. Stent struts are inside the vessel. These are not opposed, not to the vessel wall. That means stent is under expanded. If we had left this patient like this, he might have come back after 6 months or 1 year with the recurrent stent. Our 2.5 hours of all work would have been gone in vain. So we took a 4 millimeter balloon, again post dilated, did a post stenting IVUS again, and everything was good. Gentleman is doing very well. This was recently done on 17/7. This is a third case. Now in this case, there are a lot of things which we see. This is the left main. Now left main is the start of the coronary. This area is showing some block. This area is showing some block. And distal area is also showing some block. Now whether to stent with all three, and the gentleman is 34 years, very young man. 3 stent for this young man would have been a disaster. Now we decided to go for the IVUS. We did his IVUS. Now if you can see readings of IVUS, his left main ostial and left main, this part is quite okay. We don't need to touch this part. This proximal part was having lesions. That was significant. Distal part was okay according to IVUS. So we just put 1 stent to him. He's doing very well. Left main part, if we do angioplasty in 34 years, his future prognosis becomes very difficult for him. On medications, he will do very well. So what was the tightest lesion? That only we could achieve with the 1 single stent by the IVUS. So IVUS is very important in decision making. Where should we do the IVUS? What are the complex angioplasty? Any of this angioplasty, we should do IVUS. Calcified lesion, ostial lesions, left main angioplasty, CTOs, bifurcation, long lesions, or instant restart. Is it backed by the trials? These are so many n number of trials which is done for the IVOS, and it has shown definitely improvement in the outcome. On basis of this trial, IVOS has given the class 1A indication by American College of Cardiology. We are underutilizing IVOS in our country. It is a class 1A indication for the IVOS for these complex angioplasties. Few trials which are landmark trials, ADAPT DS trial, 2 year it was done, large 3,300 patients. It shows clearly 53% of decrease in the stent thrombosis. Recurrent MI was 38% reduced. Then MACE was reduced by 30%. It's a significant decrease which can be seen. Another trial post PCI means once you do stenting and then optimize by IVOS whether there is stent is okay or not, around 6,300 patients, and it is showing clearly which was optimized with the IVOS, giving very positive results. Now long lesions, IVOS XPL trial was long lesions. If it is more than 20 millimeters of lesion, you should go for the IVOS. It is showing definitely positive result with the IVOS guidance. Other aspects of IVOS which we should be mentioned, if we go for any national or an international conference to present, and if you don't have IVOS images, they don't generally accept nowadays that you are angioplasty or anything for presentation, because IVOS is mandatory in these conferences nowadays. Medical legal aspect you should know. One cardiologist is saying this is 70% stenosis. Other cardiologist is saying, because that's a subjective matter, it is saying 80% stenosis. It's all subjective. But if you have a IVOS which is giving you numbers, then you can confidently or medical legally you are quite safe. Third thing is patient, if you show angiogram, he is very difficult to understand. But if you show the IVOS and if he understands the number, that plaque burden or percentage of obstruction, he will easily understand. So depending on all, American College of Cardiology has given the guidelines. All cath labs should have imaging capability. Preferred one is the IVOS. Intravascular imaging is essential for any complex lesions. Education will get us to there. And if one technology out of IVOS or OCT or other imaging, IVOS is the best proven by trial. Thank you very much for your patience.
Thank you very much, Dr. Ingole sir. Thank you. I would like to summarize Dr. Sherke sir.
Hello. Yes. Thank you, sir, delivering nice lecture, and you explained us new topic in a simple and lucid language. Thank you, sir.
Thank you. I hope there is no question.
Thank you, sir.
Thank you.
I like to felicitate Dr. Suraj Ingole sir. Dr. Chandrasekhar madam will felicitate Dr. Suraj Ingole sir.
And our next faculty is Dr. Ganesh Badge sir. His DNB Pediatrics, fellowships in pediatric intensive care, fellowship in pediatric emergency medicine, current position, PICU in charge, Sahyadri Hospital, Hadapsar, Pune. Experience, over 12 years of experience in pediatric intensive care, formerly associated with Columbia ASIA Hospital, Pune. Formerly associated with DMH Pune. Care competencies, PLS, Pediatric Advanced Life Support, Pediatric Mechanical Ventilation, Bedside Ultrasound and Functional Echocardiography, PICU Procedure and Organ Support, Areas of Interest, Pediatric Infections, Asthma Management, Academic Contributions, PG teacher for DCH and DNB students for the past 6 years. And topic is approach to sick child.
Good morning, all of you. First of all, I want to thank organizer for giving me this opportunity. I am Dr. Ganesh Badge, working presently in the Sahyadri Hospital, Hadapsar, Pune. Today, I am going to discuss a very basic and important topic, approach to a sick child. Why this topic is very important? There is a difference between pediatric cardiac arrest and adult cardiac arrest. Most of the time, pediatric cardiac arrest is not occur suddenly. It is most of the time due to the secondary to hypotensive shock or respiratory failure due to hypoxia, right? So, objective of this talk is to evaluate the early recognition of sick child, identify the severity of insufficiency and classify it, intervene as per urgency, and every time reassess, that is EII till stabilize. Severity of insufficiency, most of the time respiratory insufficiency is there. So we should identify whether it is a respiratory distress or respiratory failure, and we should classify why this is respiratory distress is due to upper area obstruction, lower area obstruction, lung parenchymal disease or disorder of control of breathing. If circulatory insufficiency is there, we should able to identify that it is a compensatory shock or hypotensive shock, and we should classify whether it is due to the hypovolemic shock, distributive shock, cardiogenic or obstructive shock, right? आपल्याकडे जेव्हा ER OPD मध्ये पेशंट येतो त्यावेळी आपण नेहमी सिक चाइल्ड आयडेंटिफाय करतो, पण वी शुड आयडेंटिफाय तो डिटोरेट होऊ शकतो का हे आपण आयडेंटिफाय करायला पाहिजे. सो फर्स्ट इंटरव्हेन्शन इज व्हेरी इम्पॉर्टंट. पुढे जाण्याच्या आधी काही केस डिस्कस करू आपण. 3 years female child, fever and cups since 2 days, rapid breathing since 1 day. At presentation, had a respiratory rate 56 per minute, recession and SpO2 86% in room air. What is abnormal here? Yes, saturation is low, tachypnea is there, right? So mostly it is a respiratory failure. 10-year-old male child, fever and vomiting since 2 days, seizure, altered sensorium since 1 day. At presentation, respiratory is 36 per minute, rapid breathing, secretions, SpO2 in room air is 86%. Abnormality is low SpO2, right? Third case, 6-year male child, pain in abdomen and vomiting since 2 hours, drooping of eyelid and weakness in all 4 limbs since 1 hour. At presentation, respiratory rate is 16 per minute, shallow breathing, secretion, ptosis and quadriparesis. SpO2 in room air is 86%. Obviously, saturation is low. So, what is the similarity in 3 cases? All the 3 cases has respiratory failure, right? So, what is the difference between 3 cases? Yes. So, etiology is different. In first case, fever, cough, cold. So, most of the time it is a lung parenchymal disease like pneumonia. Second case, seizure altered sensorium means it is a cortical lesion like meningoencephalitis. Third case, peripheral neuropathy. Either it is due to the neuroparalytic snake envenomation. But all the 3 cases have respiratory failure. So, concept is stabilization of respiratory, circulatory and neurological insufficiency first in sick child irrespective of definitive etiology. So, stabilization first, diagnosis later, right? जेव्हाही आपल्याकडे पेशंट येतो इमर्जन्सीमध्ये किंवा ओपीडी मध्ये एक 20 सेकंड टू 10 सेकंड आपण ऑब्झर्व करायला पाहिजे विदाउट टच हँड्स ऑफ एक्झामिनेशन, राईट? त्याला आपण काय म्हणतो, पेडियाट्रिक असेसमेंट ट्रायंगल. सो 3 कॉम्पोनंट आहेत पेडियाट्रिक असेसमेंट ट्रायंगलचे: अपीअरन्स, ब्रीदिंग अँड कलर. अपीअरन्स बिलॉंग्स टू कॉन्शियसनेस, ब्रेन. Breathing is for respiratory system and color is for circulatory system. This is pediatric assessment triangle. So, appearance, the mnemonic is tickles. How is the tone of the patient? Each patient is interactive. बाळ खूप रडतंय, but it is consolable cry or inconsolable cry. That is important. Look and gaze, interaction आहे का बेबीची, and speech for his age. All the abnormality points towards the central nervous system or consciousness. Second is breathing. आपण breathing observe करू शकतो. Whether patient is breathing or not, that is most important, right? Then fast breathing or slow breathing, which is bad? Bradypnea is more. Bradypnea has more worse prognosis, or bradypnea is more bad than the tachypnea, right? Sound during respiration, like wheezing, stridor, gurgling sounds. Use of accessory muscles, sternocleidoid muscles, subcostal muscle, intercostal muscles. This suggests work of breathing. So, all the abnormalities going towards the respiratory dysfunction. Third is color. Pale color is due to maybe anemia or due to that many cases in the trauma, blood loss. Bruises, ecchymosis, pitch is due to the platelet dysfunction. Mottling of dusky color, blue color, cyanosis, evidence of active bleeding. All these suggest toward the circulatory dysfunction. So, pediatric assessment triangle, appearance, breathing and color. Once we observe the patient for 10 to 20 seconds, we should able to identify what is the immediate concern, right? So, if patient is unresponsive, not breathing and no pulse, what will we do? Anyone? This is pediatric cardiac arrest. So we should start immediately CPR, right? If unresponsive patient, not breathing, only gasping, pulse is good, so we should start rescue breathing. While giving rescue breathing, we should observe the heart rate and perfusion. If heart rate is less than 60, poor perfusion, again start the CPR. If patient is responsive, breathing is there, pulse is good volume, yes, we have time, we should go for the primary assessment. So just we have discussed this table. So primary assessment is a pentagon. In pediatrics, we airway, breathing, circulation, disability, and exposure. This is the pentagon. So crying child, airway is open, right? Many of the time airway is maintainable. Maintainable means what? आपल्याला त्यावेळी त्याला हेड टिलची चिन लिफ्ट पोझिशन द्यायची गरज पडते बऱ्याच वेळा. सिक्रेशन असतात ते सक्शन करायची गरज पडते किंवा सर्वायकल स्पाइन इंजुरीच्या वेळी आपण जॉ थ्रस्ट मॅन्युअर करतो एअरवे ओपन अँड मेंटेनेबल ठेवण्यासाठी, राईट. दिस इज मेंटेनेबल विथ सम मॅन्युअर. अँड नॉन मेंटेनेबल एअरवे, अनकॉन्शियस पेशंट, GCS लेस दॅन 6 year, we require advanced airway management, that is intubation. Breathing, primary assessment pentagon is airway, breathing, circulation, disability, and exposure. In breathing, what will you see? The respiratory rate. According to ARI classification, up to 2 months, respiratory rate normal is up to 60. 2 months to 1 year, it is 50. 1 to 5 year, it is 40, and more than 40 is always abnormal. Work of breathing, just we have seen the accessory muscle working, right? Chest wall movements. In trauma, empyema, airway, there is one side chest movement is less as well as air entry is less, and always look for the pulse oximetry, SpO2. According to pulse, normal saturation on the room air is more than 94%, right? So we should target the saturation around 94%. Cyanosis usually seen when oxygen saturation falls below 85%. So once we diagnose that problem is the respiratory, that insufficiency is a respiratory, so we should able to classify whether it is a respiratory distress or respiratory failure. And in simple on clinical examination, we can differentiate even before ABG. If airway is not maintainable, there is marked tachypnea or bradypnea, air entry is reduced, patient is unresponsive, sinus, this is the case of respiratory failure, and this require immediate intervention. So next is circulation. Circulation, heart rate and rhythm. कुठलाही पेशंट इमर्जन्सी मध्ये किंवा आला तर आपण काय करायला पाहिजे, हार्ट आपण नेहमी SpO2 प्रोब लावतो, हार्ट रेट बघतो, पण रिदम 12 ADCG लावत नाही आणि रिदम बघत नाही. त्याच्यामुळे आपण मिस करू शकतो टॅकिआरिथमियाज एज वेल एज ब्रॅडिआरिथमियाज, राईट. हार्ट रेट मोर दॅन 220 इन इन्फंट, 180 इन द चिल्ड्रन इज ऑलवेज ॲबनॉर्मल, राईट. पल्सेस बघतो आपण, सेंट्रल अँड पेरिफेरल पल्सेस फॉर व्हॉल्यूम. आपण चिल्ड्रन मध्ये ब्रॅकियल, फिमोरल हे सेंट्रल पल्सेस बघतो, रेडियल आणि डॉर्सॅलिस पेडिस हे असतात ते पेरिफेरल पल्सेस असतात. कॅपिलरी रिफिल टाइम. कॅपिलरी रिफिल टाइम म्हणजे काय, आपण नेल बेडच्या तिथे प्रेस करतो आणि रिफिलिंग टाइम बघतो, ऑलवेज लेस दॅन 3 सेकंड. हे खूप महत्वाचं आहे. इट्स लाईक अ CRP इन CBC, राईट. स्किन कलर अँड टेम्परेचर, कोल्ड एक्स्ट्रीमिटीज होतात जेव्हा SVR वाढतो. ब्लड प्रेशर, ब्लड प्रेशर फॉल झाल्यानंतर शॉक असतो का, नाही. पुअर परफ्युजन म्हणजे टॅकिकार्डिया इज द फर्स्ट साइन. टॅकिकार्डिया, पुअर पल्सेस, कॅपिलरी रिफिल टाइम इज प्रोलॉंग, कोल्ड एक्स्ट्रीमिटीज, डिक्रीज युरिन आउटपुट अँड नॉर्मल ब्लड प्रेशर, राईट. त्याला आपण काय म्हणतो, कॉम्पन्सेटेड शॉक. वन्स ब्लड प्रेशर इज फॉल, इट इज अ हायपोटेन्सिव्ह शॉक, राईट. So we should intervene at the level of compensatory shock to avoid hypotensive shock. So just we'll see some videos. So capillary refilling time कशी बघतो आपण? तोलिम at the level of heart rate घ्यायचं, at the level of heart, nail bedच्या तिथे pinch करायचं आणि बघायचं. तर normally it is less than 3 seconds. आवाज येत नाही बहुतेक. इथे काय आहे? फास्ट ब्रीदिंग आहे, वर्क ऑफ ब्रीदिंग वाढलेली आहे. आवाज येत नाही याच्यात, पण नॉइजी ब्रीदिंग आहे. इट इज अ स्ट्रायडर. सो इट इज अ रेस्पिरेटरी डिस्ट्रेस विथ अपर एअर ऑब्स्ट्रक्शन. यामध्ये काय दिसते आपल्याला? लिथार्जिक बेबी आहे, टॅकिपनिया आहे, आवाज येत नाही त्याच्यात, ग्रंट आहे. सो इट इज अ रेस्पिरेटरी फेल्युअर इवन ऑन क्लिनिकल एक्झामिनेशन. हा व्हिडिओ इतका चांगला नाही आहे, पण हा पेशंट आलेला तेव्हा त्याचा हार्ट रेट मोर दॅन 220 होता. ECG वर नॅरो QRS absent P waves होत्या. तो on ECG it is a SVT. We have given adenosine with push technique, 3-way cannula लावून, and it's reversal झालं SVT. So rhythm आता जे बघितलं आपण 12 lead ECG लावायला पाहिजे. That is very important. The next is airway, breathing, circulation and disability. Disabilities belongs to the cortical function or CNS. दोन स्केल आहेत. One is AVPU scale and other is GCS scale. GCS थोडं कॉम्प्लेक्स आहे. चिल्ड्रन मध्ये आपण मॉडिफाईड GCS यूज करतो वर्बल स्कोरिंग साठी. AVPU त्याच्या प्रमाणात खूप सोपं आहे. A belongs to alertness. V is for response to the verbal stimuli. P response to painful stimuli. U is unresponsive. So unresponsive patient, approximately GCS is around 6 to 8. And always look for the pupils, size of the pupils, whether it is reactive to the light or not, right? So it will give the clue around the brainstem assessment. Always examine the patient, expose the patient. Look for the bleeding, injury, swelling, distension, deformity and rashes. So once we done our initial impression, that is appearance, breathing and color, after that any immediate intervention required or not, we should decide that. And then after primary assessment. Primary assessment is airway, breathing, circulation, disability and exposure. Also we can check the blood glucose always. Once we identified that as a respiratory system, insufficiency is a respiratory system, we should able to severity, classify the severity, whether it is distress or failure. Then we should identify upper airway obstruction, lower airway obstruction, lung parenchyma or disorder of control breathing. In similar way for the circulatory, compensated shock or hypotensive shock. And then we should able to classify cause, whether it is hypovolemic shock, distributive shock, cardiogenic shock or obstructive shock, right? So first intervention is very important. So upper air obstruction in children, most commonly it is a laryngotracheobronchitis. Airway first intervention is humidified oxygen, nebulization of budesonide and steroid. If foreign body is the near infant, what we'll do? Back slap and chest thrust. In adult we'll do Helmich maneuver. Lower airway obstruction, most common is asthma and bronchiolitis, where we give beta-2 agonist, steroids, and for the lung parenchymal disease or pneumonia, oxygen, blood culture followed by antibiotics. For the circulatory system, if we know that it is a hypovolemic shock, IV assess and crystalloidy. For the distributive shock like septic shock, blood culture, antibiotics and vasopressor drugs. In the cardiogenic shock, we use early inotropes. In the obstructive shock, intervention important is needle thoracentesis. But in all the cases, though it is a circulatory emergencies, we should start first step with the oxygen. So after once our primary assessment is done, we should go for the focus history and focus examination. The focus history is sample history, that is sign and symptoms, allergies, medication received, past medical history, last meal taken, event that brought child to the ER. We all do diagnostic tests routinely, but we should not wait for the result of the diagnostic test for the intervention. Right, diagnosis later, first stabilization and intervention. So how should apply this approach? We see one case, 3-month-old baby brought with the history of upper respiratory tract infection, poor feeding, breathing difficulty, previously well child. So here, pat triangle, child is irritable, pale and tachypneic. Tachypneic means it is an involvement of respiration. Pale child, circulatory system, right? So both respiratory and circulatory system is involved. So first intervention here is start with the oxygen, right? Second, airway assessment, saturation is 92%, subcostal retraction is there, SpO2 is 89%. So respiratory failure. So we should advance CPAP or high flow. In cardiac system involvement, it's tachycardia, 190 heart rate with with bilateral crepe. CRT is more than 4 seconds and BP is 80/50. So it is a compensated shock. For 3-month child, blood pressure is okay, but it is a tachycardia, prolonged CRT, right? So here we go for the ABG, right? And planning for the fluid bolus. But on the sample history, there is no history of loss of fluid, no diarrhea, no vomiting. So fluid bolus should be given very cautiously, around 5 to 10 ml per kg only. On secondary examination or focus examination, there is hepatomegaly, gallop rhythm, Krebs. So most likely it is a cardiogenic shock. So fluid bolus is stopped, we should start inotropes here and do the investigation like chest X-ray and ECG, right? So here we send cardiac marker, 2D echo is done and diagnosed as a viral myocarditis, started IVIG, child is stabilized, right? So teamwork is very important. In our ICU, pediatric ICU is almost 10 bedded with all advanced facilities with ventilator, NIV, bedside ultrasound and echo. We have all the subspecialties for help of us like nephrologist, infectious disease specialist, pulmonologist, hepatologist, cardiologist and endocrinologist. Thank you. Thank you very much.
Thank you, Dr. Ganesh Badge sir, for an excellent talk. I request chairpersons to please summarize the session.
Hello. Hello. Sir, you have explained day-to-day topic, that is approach to sick child in a simple and clear language. Thank you, sir.
Thank you.
I request Chairperson Chandan Shiv Madam and Suhas Shelke sir to felicitate our faculty, Dr. Ganesh Badge sir. I request Dr. Gandhi sir to felicitate the chairpersons. Sir, please. I request Dr. Khade Madam and Shubhada Madam to please take over the mic.
Hello, check. Yes. Okay, it is. Good morning. Now let us start the next learning process. I will invite Dr. Ashish Kumar Banpurkar sir. He is consultant pediatric and fetal cardiologist in Vishwaraj Hospital, Pune. His qualification is MBBS from Yavatmal, MD from GS Medical College, Mumbai, and DNB in pediatric cardiology from New Delhi, Fortis Escorts Heart Institute. He served as a consultant in Sri Satya Sai Sanjivani Hospital, Mumbai. The area of interest is pediatric arrhythmias, heart failure, and neonatal cardiac interventions. His achievements is many more: 10 national and international indexed publication, and life member of IAP and PSSI. Now the stage is yours, sir. I invite to chair the session Dr. Dr. Anuja Doshi ma'am and Dr. Kalpana Panbude ma'am.
Hello. Thank you, IMA Indapur and Vishwaraj Hospital for giving this opportunity. So I'll be discussing some pediatric cardiac case scenarios. Yes, and so to start with, basically we divide these pediatric cardiac symptoms in two categories, acyanotic and cyanotic categories. So basically these acyanotic patients, like this kid showing these tachypnea, there is poor weight gain, increased respiratory activity, and definitely they do have this diaphoresis, prolonged feeding time. So these are the usual symptoms in the acyanotic, and though cyanotic patients have these cyanosis definitely, and clubbing, and some patients do have the cyanotic spells. So these are the usual symptoms in with respect to the congenital cardiac defects, and what we are seeing here. So definitely they do require the consultation with the pediatric cardiologist. So I'll be discussing few cardiac cases. I'll start with the unusual case. So this is the 13-year-old female. Mother was very worried about the complaint of hoarseness of voice since last 4 to 5 months. She was not worried about the fever for 4 to 5 months, but she was more worried, maybe she is female, that's why. So the past history was significant. She underwent balloon aortic valvotomy at neonatal age. She lost to follow-up, but since last 4-5 months she has hoarseness of voice. That is a major complaint. Every time she was asking about this hoarseness. So I'll not go into detail of this echo report, but definitely with respect to, this is the aortic wall. We can see 2 leaflets, and there is huge vegetation on one of the leaflet. So there are 2 vegetations over here. I'll just point out. So these are the vegetations over this leaflet, left-sided leaflets. So significant, and there are only 2 leaflets instead of tricuspid aortic wall. This is the bicuspid aortic wall. And with respect to this echo report, there was significant aortic regurgitation, and definitely this kid do require some surgical intervention later on with respect to the dysfunction of the wall. So there are many issues with respect to this kid. Hypertension on clinical evaluation, and as such hoarseness of voice. With respect to that infective focus will require prolonged antibiotics, and definitely later on this aortic and mitral wall repair. So the patient was admitted, and with respect to the prolonged antibiotics, almost 1.5 months, at least 6 weeks of hospital stay is required. So we evaluated in detail this kid. As I mentioned, there was significant coarctation, and so with respect to these issues, I could find that resolving this coarctation can sort out my two issues, that is hypertension and hoarseness. So why this kid do have the hoarseness of voice? It is because there was significant post-stenotic dilatation, and that post-stenotic dilatation, and this is the left atrium that is compressing the left recurrent laryngeal nerve. So that compression of this left recurrent laryngeal nerve on direct laryngoscopy also showing this, there is a paralysis of the vocal cord, and I could definitely was confirmed. I didn't do the MRI also for that hoarseness and palsy of the vocal cord, and we were planning for this ballooning for initial for this coarctation, and that could resolve my hypertension and hoarseness of voice, but yes, patient was infected. So we need to treat for that infection. We started on antibiotics, but fever was persisting. We went ahead and we did the PET scan, particularly to look for any abscess, like paravalvular or base abscess, but there was no significant abscess, so we were sure that we are targeting the particular that infective endocarditis thing. And after around 7 to 10 days, because hypertension was not responding to the drug therapy, so we went ahead and we do this balloon aortic valvotomy. So we can see here in the first image, there was significant narrowing at this level, and there is significant post-stenotic dilatation. Again, there was challenge doing this balloon valvotomy. Both the femoral arteries could not be cannulated. So I did this through the axillary route. So this after this ballooning, we can see in the third image, this coarctation is completely opened up. Later on, this dilatation also resolved, and that hoarseness of voice also resolved over the period. And we continued this antibiotic, but there was also challenge. This was a chubby child, so IV access was the major issue. So we put up the peak line and received the antibiotics for almost 6 weeks. After afebrile state, this kid underwent the aortic wall repair. Just a minute. So this was the pre-operative aortic wall, we can see here, and this is the post-operative aortic wall, how well co-opting we can see here, and this is the color interrogation of the same aortic wall. So this was the case, complete teamwork and patience, and hope for the patient that it can be cured definitely. So we'll come to the second case. Again, that is relatively a complex scenario, not a routine scenario. This is a day 1 old, weighing 2.3 kg, poor activity, dull, sinus saturating are almost 40%. So this was the case of TOF with pulmonary atresia. So in this situation, our purpose is to maintain the pulmonary circulation. Initial days, it was a BT shunt used to be the source for the pulmonary circulation. But nowadays, transcatheter approach can be done. We can do the ductal stenting and secure the pulmonary blood flow. So we secured this pulmonary blood flow and medically managed. I'll show this angiographic image where this is the arch of aorta here. So this is the arch of aorta, and from this arch, from the undersurface, we can see some ductus is coming out, and it is supplying the pulmonary circulation. We went ahead and we put this stent in this ductus to maintain the patency and the pulmonary circulation. We did it through the trans-carotid approach. So we did the, we secured the carotid artery under USG guidance, and we did this ductal stenting through the trans-carotid approach. But yes, what later on, so this, we followed up this kid for almost 1.5 years, and at the age of 1.5 years, this kid underwent the corrective surgery. Following 3 to 4 cases are almost similar, but I just want to show the similarity and the importance of some drug therapy in these kids and the important findings. So this is the case 3. This is the 21-day-old on the respiratory support since birth, was diagnosed as the large VSD and large PDA. There was a significant family history because the similar male child with the previous child had the similar cardiac illness, that is large VSD and large PDA. The kid was planned for surgical, but before admission, the 2 days prior to admission, patient was collapsed and could not be survived. So family was really keen with respect to this kid, and once the patient was diagnosed with large PDA and large VSD, now continuous respiratory support, patient referred to us. So our initial plan was to target the ductus. At 21 days, doing the open heart surgery is really an issue. So we went ahead and we targeted the ductus, which initially medically stabilized, tried the pharmacological closure for the ductus, and it worked even after 3 weeks. Usually it works in initial 2 weeks, but our pharmacological closure in this patient worked, and this ductus narrowed down, not completely closed, but that definitely helped us. So our next target was to gain some weight for this kid. So this was the kid was not tolerating the oral feed also. So we went ahead with RT feeding. This was almost for 4 weeks. The patient was in front of our hospital. He rented a room. He was there for almost 4 weeks just for the sake of weight gain and early stabilization. After initial weight gain around 2.5 kg, at 3 months, this kid underwent complete VSD closure, and this was the follow-up. Just 2 days prior, I received this video from the parents. Annaprashan pan zala ite vattay. So this is the situation. So we initially stabilized the patient, and we underwent the surgical closure. So again, so this is the another similar scenario, but little bit different, but similar scenario. Just want to focus that the small kids can also undergo the surgical closure. So this is the 3-month-old child require 3 admission, every time ventilatory support. So this time also he was on ventilator, really catatonic. So it was really difficult for, they were not taking anywhere because of the clinical status. So our team and hospital also supported particularly for this case for early stabilization. We stabilized almost for 2 weeks initially, and then after 2 weeks, this patient underwent a surgical closure. This is the initial image, and this is the follow-up video. I'll just show this video just after 2 weeks of the surgical closure. So this was at the time of discharge, and after 2 weeks, this is the VSD closure. So these kids have normal lifespan. If we detect this cardiac defect at particular early diagnosis and early treatment, can give the full lifespan. So detection is really must in such scenario. So whenever there is, as I mentioned in my first slide, the symptoms, whenever these symptoms are there, definitely you should consult your pediatrician and then pediatric cardiologist. So I'll come to the next case. So yeah. So this is also particularly for the practicing pediatrician and the neonatologist. So whenever there is a distress, we can see here. So whenever there is a distress, particularly in a CSD patient, our first intention is to start on oxygen and try to stabilize. So these 2 images are just almost 3 to 4 hours apart. We can see there is significant distress, but that distress is little bit decreased over here. The only thing change is we have removed the oxygen. So oxygen does not always help the kid. It sometimes it may deteriorate the clinical scenarios, particularly in CSDs and shunt lesions. So I just stopped the oxygen rather than starting, and just started on diuretics, that initial stabilization. So particularly in stage these shunt lesions, oxygen is not always helpful. So this is the particularly theory. Sometimes in periphery, if it is not possible to always arrange the ventilatory support, so in such scenario, this bubble CPAP can be helpful. It will not cost you much, but it will give the PEEP rather than giving the oxygen, and definitely it will support the, as I shown here, it will open up the airways and decrease the resistance, but it will not decrease the pulmonary vascular resistance, and it will not deteriorate the clinical situation. So again, I'll come to the one of the scenario. So cardiogenic shock, so cardioversion. So it is a really, we do not commonly see the cardioversion, at least in pediatric ICUs, but this is the scenario where in neonate we are doing the cardioversion, and we are reverting it to the sinus rhythm. So yes, cardioversion is feasible and possible in neonates whenever required. So if we do not do that, they may land up into situation like NEC, and they may require the exploratory laparotomy and ongoing ICU stay. So this was the 15-day-old referred with respiratory distress. Initial heart rate was 360, feeble pulses. We directly went ahead and did this cardioversion, and it worked well. Stabilized and discharged. Now is in our follow-up. Yeah. Again, so all these scenarios, they do have the tachycardia. Again, this is the scenario. I'll just explain. So patient was all right. It was almost 8 o'clock. Doctor was just outside the hospital, was walking or whatever doing, and sister called him. Sir, suddenly काहीतरी झालं, बाळाचं saturation एकदम कमी होता है, tachycardia एकदम 190 पर्यंत झालंय. So he, and completely white झालंय बाळ. So it was a really pale child. So nowadays focus is really important, in particularly in NICUs and PICUs. So doctor suddenly immediately whatever initial after initial resuscitation, intubation and all, he did the focus, and he called me, sir, something is unusual in heart. So there is possibility of tamponade. So I just went, keeping my family behind, and at 11 o'clock in the night, we are doing the pericardial tapping in the 1.5 kg old kid, and you can imagine we have removed just 1.5 ml from its pericardium, and that is more than enough for that kid. So after that, patient was stabilized, and last week only this kid was discharged. So particularly whenever there is sudden tachycardia, sudden color change, you may think of situation like pericardiocentesis. You can see here, there is fluid is coming out of this needle, and we have just look at the amount of volume of the fluid coming from the pericardium is almost 1 or 2 ml. So that is enough to cause the tamponade, and sudden tamponade definitely a life-threatening event. Yes. Coming to tachycardias, going in detail, this was a 33-weeker. She has fetal SVT. It was in hydrops. There was significant fluid across the pericardium. Ventricular rate was almost 270. Initially, we started on digoxin sotalol, but there was no response. We changed to flecainide. After 48 hours, there was no significant response. So we went ahead and did this fetal intramuscular digoxin. With this fetal intramuscular digoxin, the fetal rate came to 170, and over the period we followed up, and the patient was later on delivered at almost 37 weeks. We could have delivered at 33 weeks also, because the weight was almost 2 kg, but managing hydrops kid in neonatal ICU is really difficult rather than managing it in the womb. So that was our plan, and it worked well. Baby is almost all right right now. Again, I just want to mention a really underreported thing, that is a neonatal, and infant cardiomyopathies. So we sometimes mention it as sudden SUDS, like there is no cause for the death, but it may be the neonatal or infant cardiomyopathy. These are the recent reports, various reports and genetically proven cardiomyopathies. So yes, this exists, and these patients usually present as significant tachycardia, significant tachypnea, and all these three patients are in follow-up. Now they are like almost 3 to 4 months follow-up, and they are doing good. One of the patient has a pH of 6.8 at the presentation, but yes, they are doing good now. Again, to the end, I'll just show the one of the case. This was our recent case. Though this patient was not having any symptoms at present, but we were very sure that this patient will later on develop the pulmonary hypertension. That is a really bad thing to happen in any individual, and possibly the pulmonary AV malformation. So we, this was also fetal diagnosis. We followed up this kid till 1.5 years, and recently we have discharged this patient from Vishwaraj Hospital after the portosystemic, that is Abernathy device closure, and patient is all right and doing good. So sometimes we need to intervene electively, though the patient is asymptomatic. Here we have checked the portal pressures before and after closing the opening of the this portosystemic shunt. So we can see here. So this is the portal vein coming into the sinus. There was a communication between the portal vein and the so this was the communication between portal vein and the IVC. We have closed this, and that's how the portal circulation will develop later on. We'll do the CT scan later on to define that. And yes, here we are showing that this is the portosystemic shunt, and we have occluded. We have taken pressure. We have confirmed that the portal pressure after occlusions are not more than 20. So if it is more than 20, that will be really difficult and may cause the gut ischemia. So we are after confirmation. So these are the few cases that we have done at Vishwaraj, most of the cases at Vishwaraj Hospital, and many of them with the minimal costing. So these are various cases, and just to show that how we do these routine cases like PDA device closures. These are the ASD device closures. Some myths and facts, particularly for the practicing who are taking care of the kids. So breastfeeding is not contraindicated in patient with CSD. You can give safely this breastfeed. Even very complex procedure can be done with the complex CSDs can be tackled with the intervention procedures. Heart procedure is possible in neonates also. वजन कमी आहे म्हणून सर्जरी नाही करायचं हा मुद्दा आता राहिलेला नाही. 10 किलो पर्यंत वाढ पाहायची, 15 किलो पर्यंत वाढ पाहायची, आता हा मुद्दा नाही आहे. आपण लहान वयात पण I have shown the various cases like weighing 2.5 kg, weighing 2.3 kg, and we have done the surgical closure also at Vishwaraj. So yeah, weight is not the thing, and definitely these kids, until you open the shirt, you will not make out the difference between the kid who is normal and kid who underwent the surgical closure. So they do have the normal life. Thank you. So with respect to this, I just want to give the message that heart rate is a really important indicator of hemodynamic status, particularly in neonates and infants, that gives the cardiac output, supports the cardiac output. So whenever there is a tachycardia, just click whether it is a cardiac thing. And in particularly in shunt lesions, there should be a judicious use of oxygen, because it may deteriorate rather than helping your kid. Thank you. Thank you very much.
Thank you, Dr. Ashish Kumar, sir. Thank you for the insightful presentation. The way you highlighted the cases, the challenges faced, and the management approach was really enlightening for us. Thank you.
Excellent presentation. Spectrum of cases, as usual. Now, few things for the knowledge of us. How much is the minimal weight and minimum days child you have treated?
So for the open heart surgeries?
Both.
Yeah, So there is no minimal age particularly for interventions, because nowadays we are doing this intervention in fetal life also. So sometimes whenever there is a situation like hypoplastic heart with significant involvement of aortic valve, so various centers in our country, they are doing the fetal aortic valvotomy. So particularly with respect to this surgical scenario, we wait for almost 3 months because the pulmonary vasculature settles in, and that gives the confidence that we can tackle in the ICUs, and that will give the good result. But yes, some scenarios are really complex. We need to go ahead at early neonatal age when it is a complex situation.
Second thing, you given a DC shock to death. Some
Yeah.
rhythm, what was the rhythm or anything?
So it was a 260 to, I have mentioned almost 360 heart rate. Definitely in a neonate with a 360 heart rate has to be more or less blindly has to be SVT, and we need to avoid this. It was lasting for almost 12 hours, traveled from Nagar, and it was there at home, then they went to particular hospital, then they transport to us. So with a heart rate of 260, there will be minimum left ventricular volume, so EDV will be really less, and cardiac output really, and I have seen, so I'll just discuss one more case I have not discussed, so this is the opportunity. So this kid, that patient had a fetal SVT, we delivered, it was 36, 37 weeks, we delivered, after delivery also that SVT continued, so we started on beta blocker. I assured the family and the neonatologist that the tachycardia will settle in almost after 42 or almost after 1 or 2 days. That tachycardia settled in, but later on this kid developed NEC. So this is a period of hypovolemia that can develop NEC. Even kidney can be involved in some scenarios. So whenever possible, we have to tackle as early as possible. So this period, so we go ahead and so in that kid with NEC, and we have to give the beta blocker. So we were not like willing to go ahead giving the IV. So we did give the rectal Inderal, and that worked well for that almost 2 weeks, and later on we changed to GSA.
Now, from general practitioner point of view, when they should call you in the numbers?
So definitely I have shown that first slide. I'll show it again. So this is this. So whenever there is a poor weight gain, whenever there is increased respiratory activity, definitely murmur you will call me, but subtle signs are poor weight gain, diaphoresis, increased respiratory activity, recurrent LRTI, prolonged feeding time, particularly infants. These are the signs. Later on, and cyanosis clubbing that are quite obvious, so that will indicate. Thank you.
Now, moving to next lecture, I will call upon on stage Dr. Sanesh Garde sir. He is MBBS and diploma in tuberculosis and chest diseases. He is consultant chest physician and head of the department in Vishwaraj Hospital. He has a 12 years experience of bronchoscopy and interventional pulmonologist. Now I request to you, sir, grace us with your knowledge.
First of all, I would like to thank IMA Indapur and Vishwaraj Hospital for allowing me, for giving an opportunity, for giving or sharing my experience with you. My lecture initial topic was like basic of bronchoscopy, but as everyone knows what is bronchoscopy, so I just twisted the topic, that practical basics of bronchoscopy. So What is bronchoscopy? Bronchoscopy is nothing but a type of endoscopy which helps us to visualize the tracheobronchial tree. There are two types of bronchoscope, as you can see, the flexible bronchoscope and the rigid bronchoscope. Initially, in the early days, the first bronchoscope which was introduced or which was used was rigid bronchoscope. That we will see in next slide, history. So why bronchoscopy matters? Because it gives a direct visualization of the tracheobronchial tree, as well as that yields to a higher diagnostic yield. It will also give bridges between the radiology and pathology. Means it gives us the, like if you see anything on a scan, like a pneumonia or something, but we don't know the type of pneumonia. Sometimes similar microorganism present, different microorganism present the similar images on the CT scan. Hence, it is necessary for the diagnosis, and sputum does not give that much of good quality. So, for that we need to do a bronchoscopy, and if we send it to pathology lab, that overall gives total diagnosis. That is it. That's why it is called it is a bridge between a radiology and pathology. So, where it is essential? It is essential in ICU. It is essential for diagnosis of malignancy, that is oncology, and also in the infectious diseases to get an organism in the rare diseases. So this is a evolution. The first bronchoscope was, I said earlier, that it was a rigid bronchoscope. It was introduced by Gustav Killian. He was a laryngoscopic, and it was actually not a bronchoscope. It was a gastroscope, a rigid gastroscope, which was used for removing a foreign body, that was pork bone, from the lungs. Then the evolution came. It changed to fiber optic evolution. That was done in 1960, and the current era, we have video bronchoscope, we have EBUS and navigational bronchoscope, and in the future we are going to have a robotic bronchoscopy as well. So types, we have a practical comparison, flexible and rigid. Flexible, it can be done on the OPD basis or a bedside in the ICU. You can admit or you can discharge the patient immediately, unless and until you do any therapeutic procedure, like you have done the, you have taken for the hemoptysis, you have given the glue or something like that. For that, you need to keep a patient, or you have taken a biopsy of the patient, and chances of bleeding are high in that patient. For that patient, either you have to do a 24 hours admission or daycare admission. And rigid, you have to use general anesthesia, hence it is done in OT. So that is, flexible bronchoscope can be done in local or under minor sedation if the patient is very anxious. And rigid, you have to use general anesthesia. Airway control, there is limited airway control in the flexible bronchoscope. While in the rigid, you have the excellent, because the rigid bronchoscope also has a port where we can connect an ventilator. Use mostly, flexible bronchoscope is used for diagnostic, and rigid for therapeutic, like tumor debulking, stenting, or it can for foreign body removal. But flexible, most of the times it is used for diagnostic. Sometimes it can be used for therapeutic as well, like in the conditions like hemoptysis, you say. With the help of that, you can give either instill adrenaline or cold lavage, or you can also instill a glue. So when should you call a bronchoscopy? Bronchoscopic, mostly 90 to 95% indications are like you have to do a bronchoscopy. Some 5% you can do or you can avoid. It depends upon the pulmonologist experience as well as the physician experience. So when hemoptysis. So first is hemoptysis. So in hemoptysis, it can be both. It can help us to diagnose the case, as well as in the same setting we can use a therapeutic we can do it. That is, we can treat the patient as well in the same setting. Or we have suspected the malignancy for the biopsy, non-resolving pneumonia, like I said, many organisms can show a similar feature on the CT scan. So getting an organism is very essential. Or you can say immunocompromised host infection. This is very important. You have to do a bronchoscopy in this type of patient because they are immunocompromised, and if you don't get an organism, then chances of spreading an infection is very high. Then if CT showing any endobronchial lesion for the biopsy, persistent lobar collapse, then if you need a microbiology diagnosis beyond sputum, tracheal stent placement, these are the, you can use this rigid as well as flexible bronchoscopy in tracheal stent placement, tumor debulking, stenosis, stridor, or a foreign body removal. So these are some of the cases where you have to go ahead with bronchoscopy as early as possible. That is diagnostic value for VAP, ventilator associated pneumonia. In that cases, most of the organisms are MDR, so it is very necessary to get the microorganism. In cases of severe community acquired pneumonia and hospital acquired pneumonia, ILD, or for the intrathoracic tumors, because they to differentiate whether they are compressing the bronchi or not. Then therapeutic values, most of these are in ICU, like atelectasis due to mucus plug, or benign or malignant central airway tumor, inhaled foreign bodies. This is this is used for this rigid bronchoscope. Then massive hemoptysis, and supportive for endotracheal intubation in difficult airways, photodynamic therapy, or position of double lumen ETT, especially for the thoracoscopic patient, or when you have a risky intubation like Malampatti score 3 or 4 patient, and where you extubate, chances of patient getting, if the patient becomes goes into the respiratory failure, then it is difficult to intubate in that situation. So bronchoscopy help in that situation. So contraindications. Only 2 or 3 are absolute contraindication, all are relative otherwise, like uncorrected hypoxemia, like a patient on a ventilator, or NIV requiring FiO2 of 80, 90, 100 with high PEEP. It is difficult to do bronchoscopy unless and until bronchoscopy is going to relieve his hypoxemia. Then only we need to take that risk. Or life-threatening arrhythmias, risk of again arrhythmias increases, or recent MI. Relative is like, for the relative, we can correct it and we can do it if it is necessary to do an bronchoscopy. Like if INR is more than 1.42, you can give the FFPs and do it. Platelet are less than 50,000, you can just use the platelet and give it, do it. Severe COPD exacerbation, you treat a patient, make them stabilize, and then you can do it in that also. So pre-procedure. Imaging reviewed personally, that is seeing an scan is very important for before doing a bronchoscopy. You cannot just directly, if the patient is having like a chronic cough and you directly do a bronchoscopy, is not. And most of the time CT is better than the X-ray because CT gives us detailed findings. Then indication should be clearly defined. Coagulation optimized, like if more INR is there, you have to give FFPs, and then oxygen, with the help of oxygen you can do it, or with the help of HFNC. Consent is very important. 6-hour fasting is also important. Many a times patients are anxious, they don't allow, then you need a sedation. For sedation and all, or if you want to do a, with a block, transtracheal block, 3 hours NBM is enough, 3 to 4 hours. Procedure, how you do it, the procedure. Drugs, what can be used. Previously, we used to give transtracheal block many a times, but nowadays mild sedation is become a norm. Like you can use midazolam, 1 mg, 2 mg, or fentanyl, or propofol. And monitoring is also important, for example, oxygen, ECG, blood pressure monitoring. Stepwise procedure, a patient should be in the supine position. It is easy to do a bronchoscopy in supine position. You can do nasal or oral, depending on patient condition. If the patient is like is having nasal problem, distortion or fracture, then you can do it orally. What we see vocal cords, trachea, bronchi, you know. And for each and every bronchoscopy, first we need to see the inspect the tracheobronchial tree on both the side. Just don't see the CT. We don't see the CT and go and take a ball from that region only. We inspect all the tracheobronchial tree and then we take a sample, because many times we expect something else and we get a very surprises inside. I will show you the cases, 2 or 3 cases later on. So, golden rule, look first and sample later. Sample technique, like we take a ball if we are suspecting an infection, or for the differential leukocyte count in ILD. For malignancy, we take a biopsy, TBNA for if we have a nodes, and brush biopsy for cytology. So this is an advanced technique, endobronchial ultrasound guided biopsy. It is not easily available everywhere. I think in Pune also we have only 2 to 3 centers where it can be done. It is useful for mediastinal lymph node and lung cancer staging. The use of or the advanced IBUS has reduced the need for mediastinoscopy, which was a little bit an invasive procedure. So in ICU also, very important bronchoscopy, mucus plug removal for ventilator associated pneumonia diagnosis and airway inspection. It can be a life-saving in acute collapse. Patient in the ICU on a ventilator, suddenly his FiO2 requirement increases. You see a X-ray showing a collapse, like right lung collapse or left lung collapse. Then unless and until you do a bronchoscopy, the patient is not going to improve. In that situation, we have to take a risk, even though if patient is requiring high FiO2. So what are the complications? Common and serious. Common are like hypoxia, which we can correct it with oxygen. Bleeding, we use adrenaline, cold lavage, or you can also use the tranexamic acid. For cough, we nebulize the patient. For pneumothorax, if it is mild, we don't do anything. If it is major, we need to put an ICD. For respiratory failure, similar oxygen, NIV, or if patient is still having respiratory failure, we go with the intubation and arrhythmias. So clinical thing, always you have to see the CT scan. You need to take a good history of the patient. You have to compare the CT scan with the patient symptoms. We should not use bronchoscopy when sputum is sufficient, that is sputum is giving an organism, then no need to do a bronchoscopy. BAL, we have to interpret carefully. Early use in ICU improves outcomes. Yeah, it's very important, because we have seen the cases in which even though there were small patches on the X-rays, we have done the bronchoscopy and it has shown a lot of improvement in the patients. So future direction, it is robotic bronchoscopy, AI guided navigation and advanced therapeutics. So let's go with the summary. Bronchoscopy is very safe, versatile and high-yield procedure, but you don't have to overuse it. It is very critical for modern internal medicine, and when you are used for the proper patient, the outcome is very good. So I will share some of the cases which we did in Vishwaraj. This was a 20-year female post-LACS, and she started complaining of breathlessness on post-op day 1. It was referred to us, and we did an X-ray. So we were confused whether it is a dense consolidation or effusion. We did a USG showing mild effusion. Then we went ahead with a bronchoscopy. The problem with the patient was that whenever we used to do supine, give supine position, patient was becoming more breathless, and we were not able to sustain her saturation as well. And the relatives were not ready for anything like HFNC or intubation. So what we did, normally we do bronchoscopy in supine position. In this patient, we did in 45 degree. And in this, we didn't examine the patient because the situation was different. Immediately, we have done this bronchoscopy within 2 minutes. In that also, she desaturated to nearly 50. But once we removed the mucus plug, her saturation improved. This is the pre-bronchoscopy, and this is the post-bronchoscopy. So this is the second case, 85 years female, known case of diabetic, hypertension, hypothyroid, admitted to outside hospital with complaint of abdominal pain, distension, breathlessness since 2 days. She was maintaining on O2 with nasal prawn, 4 to 6 liter, having hypotension and tachycardia. Patient came to Vishwaraj for CT scan, abdomen. We did an CT scan, and while shifting in the ambulance, immediately after taking ambulance, I think it was near to Vishwaraj only, patient suddenly went into brady arrest. We brought the ambulance back, we did a CPR, we intubated the patient, and we admitted in Vishwaraj. Report came to be cholecystitis. She underwent cholecystectomy. Then after post-op day 2, she was extubated and she was conscious, well, no hypoxia, minimum requirement of FiO2. She was altogether better. After extubation, in 10 minutes, again she had desaturated and again had arrest. Again required CPR for I think 3 to 5 minutes, and again we re-intubated. I will show you the CT scan of this patient. So airway was okay, but only here, this near the carina, the trachea was like collapsed. It was showing stenosis. So, but we were not sure whether it was stenosis or not. Even the radiologist didn't report it. So we decided to go ahead with the bronchoscopy. So what we did is, we weaned the patient. We took her on pressure support mode, so she was breathing normally. Then we went in with the bronchoscope. We saw the distal area, and by just pulling out the tube with the bronchoscope as well, we brought it to the vocal cords and saw the movement. And it was surprising that both the walls were collapsing, like it was a tracheomalacia. So it was diagnosed as a tracheomalacia. So we have given the option to the relatives, whether we had 2 options to put an tracheostomy or T-tube and discharge the patient, or the other option is to put a stent. The relatives didn't wanted the invasive procedure, so it would not look good, they said. So we went ahead with a stent, tracheal stent, and we did a stent. So this is a X-ray. We put a small tube, like 6 number tube, and then later on we extubated the patient. I was there in the ICU for nearly half an hour to 45 minutes to see the progress, and we were very happy that she was breathing normally, very comfortably. But we lost the follow-up of the patient. The patient didn't come for the follow-up. I think it is 2 years back. This is the next case, a 16-year male, post a case of OPP, treated, required intubation 2 months back, now came with a stridor. Same thing for him as well. Whenever he used to sleep, he was complaining of dyspnea. So we did an bronchoscopy, found to be having a tracheal stenosis. Then we dilated it and we put the stent. You can see here the stent. This is the stent. Okay, we had put the stent. We kept the stent for about 3 months, and then we removed the stent. His stridor was gone. He is now better. So these were the 2-3 interesting cases we had done. Even there was one case, autoimmune disease with complaining of blood in sputum. So we were confused whether it is an infectious or it is something else like diffuse axonal injury. Diffuse alveolar hemorrhage. So we did a bronchoscopy and we found that the blood or the sputum, reddish sputum was reddish secretions were coming from all the lobes. So we sent it for differential leukocyte count. BAL was sent for differential leukocyte count, and we found out that there were many RBCs. Hence we diagnosed it with diffuse alveolar hemorrhage. We given the pulse therapy to her with methylpred 1 gram OD for 3 days, and she improved later on. Her hemoptysis stopped, X-ray improved, oxygen requirement also improved. So bronchoscopy is very important procedure for the early diagnosis. All the indications are like 90-95% indications. You have to go ahead with the bronchoscopy. Only few indications are like that in early pneumonia whether we should do bronchoscopy or not. It is actually depends on the physician, pulmonologist and the relatives. You can if you go early, you can get a microaneurysm early. Unnecessary other antibiotics we can stop, as well as antibiotic, it helps to for the antibiotic resistance as well, to reduce the antibiotic resistance. So whenever in doubt, you can go ahead with the bronchoscopy. Thank you.
Thank you, sir, for that insightful presentation. Your clear approach and the clinical perspective has really enhanced our knowledge on bronchoscopy. Thank you, sir.
Excellent presentation. I want 2 to 3 questions to be asked. This tracheal stenting, how many days you can keep inside? And is there any foreign body reaction or new growth? It becomes a nidus for it.
See, what we are using is silicone stent. So chances of foreign body reactions are very less. You know, we can keep it for 3 to 4 months. It's like 12 to 18 weeks we can keep it, and after that we can remove it, because till then for the purpose for which we have put should be resolved. But if we remove the stent and you can see the trachea is collapsing or the purpose is not solved, then we have to keep it again for some days.
Go ahead for the restenting, or you keep it for longer time?
No, we keep it for longer time.
Second thing, foreign body removal from the bronchoscopy. Do you do with a snare or something else? How do you do it?
Depends. First, we do with a snare only, or we have a biopsy needle. We try with that. If it is easily done, that is good. If it is not done easily, then we use a rigid bronchoscope.
One slide just for fun. You had mentioned that absolute contraindication is recent MI, arrhythmia. We are there to support you. That should be a relative contraindication, I think so.
See, in bronchoscopy, each and every is a relative contraindication, because it depends on how necessary or how important is bronchoscopy for the patient. And if FiO2 requirement is 100, and if the lung is collapsed, that doesn't mean that you don't do the bronchoscopy in such patient. You have to do it.
Thank you. Thank you.
Now we will invite our next speaker, Dr. Santosh Khuba. Sir is here. Yeah. He is consultant hematologist, hemat-oncologist, bone marrow transplant physician. He did his MBBS from BJMC Pune and MD Medicine from GMC Bhavnagar, DM from the KEM Hospital, Mumbai, and fellowship in bone marrow transplant and cellular therapy, Dinanath Mangeshwar Hospital, Pune. His area of interest, especially in malignant hematology and bone marrow transplant. He is speaker at many places in Latur, Mastakon, Solapur, and many more places. Paper presentations mainly on the safety and efficacy of nilotinib in adult, single center experience. His paper is famous, Hematological Manifestations in Newly Diagnosed HIV Patients, GPI Conference 2018, and a study of clinical profile of patients having macrocytic anemia in correlation with serum vitamin B12 level. Many papers are there, sir. Now, I request you to share your knowledge with us, sir. Thank you.
Good afternoon to all. Many thanks to all the Indacon management committee who invited me here for a lecture. Today's our lecture is on the hematology, just not about the blood transfusion. It is beyond the blood transfusion. What is presentation actually I am going to give is a just outline I am going to present here. Why this topic is important to present as a beyond the blood transfusion, why it is necessary. 4 cases I will present: thiamine responsive megaloblastic anemia, sickle cell anemia, splenic marginal zone lymphoma, and Evans syndrome. After that, I will give a take-home message, what actually should be done. Why this topic? Because there are the 146 lakhs of blood units every year we are collecting. Last year in the India in 2024 and 25, the data is showing that 146 lakh of blood units what we have collected, those are 8 becoming deficient. They are not available to the patient everywhere in the India. What is the risk in the blood transfusion? Any type of acute blood transfusion reaction is a 0.2 to 10% in each transfusion. In the even tertiary care centers, the risk of fatal blood transfusion reaction is 8.5%. So this data I took from the National Institutes of Health, which was presented in the 2025. The first case, this is a 11-month female child, which was a resident of Solapur district. He is a kid of non-consensus marriage, requiring recurrent blood transfusion from 6 months of age and every month. The comorbidity along with this blood transfusion requirement, there is a newly diagnosed hyperglycemia. There was no familial transfusion disorder and no organomegaly. The CBC was showing HB was 6.8 gram, TLC was 10,000, platelets were 2.8 lakh, but MCV was 114 with a random blood sugar level was 350. Here if we see this kid which was requiring transfusion since last 6 months of his age, the kid having a MCV is 114. It is not possible at all with the thal major. Initially when we took a history, we thought it may be the thalassemia major. But if you look for the CBC, we can just rule out the thal major. The bone marrow aspiration was done outside somewhere else. It was showing the erythroid hyperplasia and megaloblastic change, but all 3 cell lines are preserved at all. That means bone marrow is functioning normally. We thought there is no marrow failure. The cause of anemia, if we look, is there marrow failure? No, not at all, because bone marrow is normal. Is it a immune in origin? Not at all, because serum LDH is normal. Is it a hemolytic in nature? No, because DCT is negative and retic counts were absolutely normal. So what will be the cause for the anemia? It is a nutritional anemia. Then what will be the cause for nutritional anemia? The first will be the most common, which we see in the routine daily practice, is that inadequate dietary intake. As per history given by the mother is feeding the 11-month kid, which is adequate in nature, and I think she is giving the justice to the kid, because she is only sufferer for the recurrent blood transfusion and hospitalization. The second possibility is a malabsorption. We just ruled out with the mother's adequate history and in the mental peace situation where she is giving the adequate food to the kid. So there is adequate dietary intake. The second possibility is whether it is a malabsorption. If at all there is a malabsorption syndromes, we should have some symptoms of the malabsorption syndrome like dyspepsia, abdominal symptoms, but these were also absolutely absent. Then what will be the third possibility, and which was less likely for any anemia? So defective cell utilization is one possibility where we can see such type of anemia. We did a serum iron study, we did a B12, we did a serum red cell folate levels which were absolutely normal. We have two things for the defective cell utilization suspiciousness. One is that there is anemia which was a megaloblastic type, and second thing, the newly diagnosed diabetes which itself points towards something which is abnormal in this case. So what will be the answer for this? Marrow is normal, there is no autoimmunity, there is no hemolysis, then we should have some alternative diagnosis for this kid. That's why we have gone, rather than wasting time with other functional investigations, we went for the clinical exam because there is a high suspiciousness of being a type 1 diabetes and the megaloblastic type of anemia. So this clinical exam itself have pointed that there is a mutation in the SLC19A2 gene which is responsible for the thiamine responsive megaloblastic anemia. What we did, we just did the high dose thiamine to the patient, that is a 300 milligram OD, symptomatic management with the blood transfusion and blood sugar level control over a period of 3 to 6 months after starting the treatment. We examined for the ocular, sensory neural deafness and cardiac disorders which were absolutely normal. If we see the thiamine responsive megaloblastic anemia, it behaves like a vitamin B12 deficiency only, but along with there are the manifestations like uncontrolled blood sugars, there are the ocular involvement and the sensory neural deafness along with the cardiac involvement are the possibility. What was the outcome with the treatment of this disorder? Is just there was no blood transfusion after treating for 3 months. The blood sugar levels were controlled without medications. The third possibility that the patient is absolutely normal nowadays. She is not requiring transfusion. She is not requiring any medicine for the diabetes. The obviously patient's parents are really happy. The fourth most is a healthy baby is our aim. This is possible with a teamwork from general practitioner to the ENT surgeon. Everyone contributed their knowledge and expertise for the management of this case. The second case, what we treated is a 5-year-old female, baby of secondary consanguineous marriage from the Solapur. She having anemic symptoms and growth retardation, requiring blood transfusion every month since her age of 2 years. On examination, she had a pallor, icterus, splenomegaly and hemolytic phases. The HPLC was showing the HB sickle window is a 71.8% and the HBF is a 16.1%. This is a graph of the HPLC which is pointing towards a sickle cell anemia. This is the HPLC interpretation. If we see where this case fits is in the sickle cell anemia. How I treated for this case? I just given a transfusion initially at the age of 4.5 years. When she presented to me, that time HB was only 5 gram. Then we started on the syrup hydroxyurea, that is 20 milligram per kg OD. The transfusion free since last 6 months. She is not requiring transfusion at all. The outcome of this treatment and the diagnosis was a weight gain was there to the patient because she is taking adequate food. She is playful. There was no blood transfusion at all. Baby is healthy, and now the parents are also happy because they have to leave their job and they have to go every month for the blood transfusion to the hospital. Definitely this has changed the scenario and the patient's parents are too happy right now. The case 3, 66-year-old female who is from the Solapur, teacher by occupation, but husband was also the bank manager in the SBI, but they don't have kids. Symptomatic for last 3 years, abdominal distension was there which was gradually onset in and progressive over a period of last 3 years. There were base symptoms since 3 years. There was a fatigability severe enough. The only two people are living in the house. One is a retired bank manager from the SBI, and the person who is taking care of both of them is a wife who is ill right now, and she having too severe fatigability since last 6 months that she cannot perform her routine household activity. She started requiring recurrent blood transfusion. That is a 6-point PCV transfusion over the last 3 months. On examination, there was the only significant finding that severe pallor was there, and on abdominal examination, gross splenomegaly was there. So the investigation, what we did the CBC with PS. The basic investigation, what is exactly there in the CBC is a HB 6 gram, WBC is 6,000, platelets were the 80,000, and the peripheral smear was showing the normocytic anemia, no atypical cells on smear, and borderline thrombocytopenia. We did a bone marrow because she was requiring too high PCV transfusions over a period of last 3 months. The bone marrow was showing the hypercellular marrow with suspicious involvement by the lymphoproliferative disorder. Being a lymphoproliferative disorder, we have gone for the whole body PET, whether there is an involvement in any other area, whether there is any lymph node or the organ involvement is there apart from the blood. There was absolute low grade FDG uptake in the spleen, which was slightly enlarged in the whole body PET. We did an immunohistochemistry, which was on the bone marrow biopsy block, where we got this CD5, CD10 negative B cell non-Hodgkin's lymphoma, and Ki67, which we can see here, is a just negative. That means we can say it is a low grade non-Hodgkin's lymphoma and specifically confined to the splenic area only. The most likely diagnosis for this case is a splenic marginal zone lymphoma. So what we did in the management, we just give a chemotherapy including the bendamustine plus rituximab for 6 cycles with adequate dose and the supportive care over a period of these 6 cycles. What is the outcome? There was no blood transfusion, no abdominal distension. Whatever spleen was there, it has regressed completely. The household activity, which there were no kids, and in the family they were living only 2 family members, and she was only person who is taking of the whole family. Now she is able to do all the household activity, including the cooking for both of them. Now the most happiest person in the world is her husband. The case for the similar case, 23-year-old female, resident of Dharashiv, married, having 1 children, and she was symptomatic since last 1 month. Dyspnea at rest, swelling over the bilateral lower limb, abdominal pain and distension since last 3 days before admission. The last menstrual bleeding was a 13 days back of abdominal distension. Treated at a local hospital for 3 days with a 2 PCV transfusion and referred because the HB was a 3.5, and after giving the 2 PCV transfusion also, the HB became the 2.5. So on examination, the pallor was there, icterus was there, mild splenomegaly was there, respiratory rate was a 25 per minute, and the SpO2 was around the 89 to 90. With the O2, she was maintaining around 99%. There was a tender abdomen. She was not allowing even to touch her abdomen because there was a so intense pain in the abdomen. So what we did a CBC, HB was showing 2.2 gram on admission, TLC was a 5,000 with a predominant neutrophils around 70%, platelet were only 5,000. The peripheral smear was showing the normo to macrocytic anemia, there was a mild agglutination, NRBCs were present, polychromasia was there, that itself will indicate there is an ongoing hemolysis in the body. There were not atypical cells, that means there was no underlying leukemia or lymphoma, and the platelets were reduced markedly on the smear. The LFT was showing the indirect hyperbilirubinemia. The good sign is RFT was normal. We did a further investigation based upon the peripheral smears finding, which was showing the hemolysis. Just to rule out being a 3rd decade female and young female, so we thought it may be the autoimmune origin. We did a DCT, which was showing the strong positivity, and the LDH was slightly on higher side. Retic count is a 15%, is too high for this normal female. The EVG abdomen we did, which was a polycystic ovary, cystic hemorrhage in the right ovary, and it was causing the ovarian torsion, and there was a around 750 ml of the hemoperitoneum in the abdomen. This hemoperitoneum was a mid-cycle ovulation rupture in the ovary, has caused the rupture in the membrane of the ovary and causing the severe bleed. In the normal person, when the platelets are normal, when the PT-APDT coagulation cascade is absolutely normal, in that case if you see this ruptured ovary for the ovulation will heal on its own immediately within a fraction of second. But the platelets were only 5,000. It was not possible to heal that ORN rupture during the ovulation, and it started bleeding and causing a hemoperitoneum and the severe abdominal pain. The diagnosis at this point, we got it as the Evans syndrome. We started a treatment being a 2.2 hemoglobin. We transfused a PCB with well cross-matched after the washing with saline to the RBC surface. We have started the intravenous immunoglobulin 1 gram per kg for 2 days. Then IV steroids we continued. I want to be maintain the endothelial stability. The TPO agonist weekly we started because we have to increase the platelet counts. We started the immunosuppressive therapy because I don't want to take any risk for further period of time after ending the steroid period of around 6 months. I don't want to be her in the next certain life-threatening situation. That's why I continued the immunosuppression, that is MMF. And we have given the required supportive care, including the antibiotics and blood transfusion. What was the response of this case with the treatment? HB started improving on day 3 of a IVIG. The HB, maximum HB before discharge, it went 11 gram %. The platelets were improved to the 1 lakh on the day 14 of a treatment with the IVIG and the TPO agonist with a steroid supplement. Repeat UAG are done. Serial UAG we did over a period of time. The gynecologist initially advised her it requires a immediate oophorectomy because the situation was a tense. But considering the platelet counts of 5,000, no gynecologist was ready to touch the patient, because ultimately if we do something, she will land up in some critical situation. So what we did, we just managed the Evans syndrome, and we did a serial EVG to look whether it worsens over a period of time or not. It has not worsened over a period of time. As platelets gone up, this wound started healing, the hemoperitoneum started resolving, and the cystic hemorrhage was on resolving trend at the end of UAG, and the ORN torsion itself resolved with the absorption of the blood from the cystic hemorrhagic ovary. So at the end of day, she is on the presently MMF only she is taking as an immunosuppression. What was the outcome? There was no blood transfusion since last 3 months. The most important to make the child happy, she had only one child, and the child was living at a house at the age of 3 years without parents. Itself is a very tough situation for the mother. The child was living to her grandmother. The child was happy after going mother to the home of a 14 days of hospitalization. At the end, the family was very happy. From 2.2 hemoglobin HB went to the 11 gram %. What is the take-home message with this lecture? Give the blood transfusions only when there is an indication. Lot of news we are hearing nowadays, from mismatch cross blood transfusion to the blood group exchange. The diagnosis of blood transfusion is always required. Why the patient is requiring blood transfusion, which itself gives the clue what to do the treatment and how to avoid the blood transfusion. Most of the blood transfusion disorders are treatable. If you treat the basic cause, the transfusion requirement will go down, and all disorders are treatable. The last but not least, disorders may be benign or the cancerous condition for the blood who are requiring the recurrent blood transfusion. But the only thing is that all are treatable. If you treat in proper way, we can give a better quality of life to the patient. So feel free to contact for any hematological malignancies or emergencies. My contact number is this, and I am very thankful to the Indacon Management Committee for inviting me here for this lecture. Is there any doubt? You can ask regarding the hematology for any type of query.
Thank you, sir, for that strong academic insight. and evidence-based case presentations.
Thank you.
Sir, be on the stage, please. I request Dr. Kalpana Panbude ma'am and Dr. Anuja Doshi ma'am to felicitate the sir. Now, now I request Dr. Ashish Kumar Banpurkar sir. He left. He's there. Welcome, sir. I request both of the lady doctor to felicitate the Banpurkar sir. Now, I invite Sanesh Gadre sir to accept the felicitation. Okay, he left the hall. त्यांच्या दोघींचं करायचं ना. Now I request Dr. Magar ma'am to felicitate the Dr. Kalpana Panbude and Anuja Doshi ma'am. Now, moving to next session. I would like to invite Dr. Yes, Dr. Madhvi Dadve Banpurkar ma'am. She's ready. Now I invite Dr. Suyesh Patil sir on stage.
Dr. Suyash Patil sir, he has completed his MBBS from MIMSR Latur, his MD from Kashibai Navli Hospital Pune, his diploma in critical care medicine from Symbiosis Pune, and he has done his interventional pulmonology at Yashoda Hospital Hyderabad. He is doing freelancing and working at Shwas Chest Clinic in Solapur, which is a dedicated chest center. We welcome you, sir.
For this session, I would like to invite Dr. Yuvraj Hakke sir to chair the session and Dr. Bijkuled sir. Okay, Dr. Sachin Torve sir, is here. काय करायचं? कदम सर, पुंडे सर, कदम सर. I requesting to Dr. Kadam sir to chair the session.
Okay. So, good afternoon all, and thank you, Dr. Shubda, for kind introduction. My
काहीतरी करायचं आहे ना.
नाही ह्याच्यानंतर ना ह्याच्यामध्ये मध्ये मला व्हिडिओ दाखवायचे थोरॅकोस्कोपीचे, तर त्यावेळेस हे मिनिमाइज करून डायरेक्ट येतंय का?
हां हां डायरेक्ट
हे मिनिमाइज
हे
करून
मिनिमाइज करा आणि तो व्हिडिओ प्ले करा.
व्हिडिओ प्ले केल्यावर डायरेक्ट हे होणार सेव्ह होणार. So, I will talk about today. I will talk about the medical thoracoscopy. It is untouched part in our area. So, before starting theoretically, I would like to present a small case regarding the medical thoracoscopy. So, this is a 46-year female, young female, resident of Solapur, housewife by occupation, recently diagnosed a hypertension, came with the dyspnea. Dyspnea is a progressive dyspnea with low grade fever since 3 days, generalized weakness and only dry cough. So she was clinically totally all well before the 10 days. So history is acutely history. Within 10 days she got the dyspnea, which is progressive fever, dyspnea and only dry cough. No any classic past history, just newly detected hypertension, started on telmisartan 40 mg OD, no any weight loss, appetite loss, no seasonal variation, no any familiar history. It's not moving. It's not moving. इथं मूव होत नाही. हां पुढंच हां
स्लाइड शो होत नाही ना.
मूवच होईना. पेनड्राईव्ह अजून एक पेनड्राईव्ह आहे.
त्यात पण आहे.
हो त्यात पण आहे.
तो कनेक्ट करा आधी. स्लाइड शो रन होत नाही. यांना देतो पण पेनड्राईव्ह
तुमच्या खिशात हातात पेन
नाही नाही हा नाही
ओपन करा आधी. ओपन करा.
सुयश पाटील
डिस्कनेक्ट करा सर.
कशात
सुयश पाटील हां CME हां फायनल केस 1
HDMI.
कॉफी करून घ्या. कॉफी चेंज करून घ्या. कॉफी करून घ्या. कॉफी करून घ्या. त्याची सेटिंग बी तुम्ही ऑन केलं ना. स्क्रीन गार्ड जो आहे
दोन्ही करायचं आहे. दोन्ही
दोन्ही
हां दोन्ही
आणि सर काय करा आदनं मधनं हात फक्त हलवत राहा. स्क्रीन लॉक होते ना. कॉपीपेक्षा डायरेक्ट ओपन केलं असतं चाललं असतं.
पहिल्याच चाललं माझ्याला कसं जमलं. पहिल्याला चाललं व्यवस्थित. डबल बॅकअप ठेवलेला मला माहित आधीच कुठं ना कुठं काय ना काय होतं. फायनल केस
स्लाइड शो.
मला फक्त एक जण थांबा ते व्हिडिओ लावायचा आहे मला त्यामुळे व्हिडिओ दाखवतो. So sorry for interruption. So moving on case, a 46-year female, young female with a very acute history, just 10 days fever, dyspnea, and dyspnea is progressive, dry cough, no any typical past history, family history, no weight loss, no appetite loss. So newly diagnosed hypertension, family, no any past family history. On examination, she is conscious oriented, slightly tachypneic, dyspneic. Her BP was 160/80. She was desaturated. We started on O2 supplement by face mask, and on 6 liters she maintaining 90% on 6 liter O2. On auscultation, there is decreased air entry on the right side. So hematological investigation, SAR pretty normal. Blood investigation, ECG, all zero. ABG was completely normal. So we did X-ray. So X-ray shows this. So there is completely right CP angle blunting, suggestive of query pleural effusion. So young female, young patient with very acute history, 10 days history. So we are suspecting for likely it is tubercular. So we did 2D echo as it is young female, and some kind of cardiomegaly also seen in the X-ray. So we did 2D echo. So 2D echo was completely normal. So we did UAG thorax to confirm the fluid. It suggests the right-sided moderate to severe pleural effusion on right side. So we did the diagnostic thoracentesis. The pleural fluid shows it is exudative, lymphocytic predominant. But the main glitch is the ADA. ADA is not positive or suspected for TB. So we did a thoracoscopy of this patient, and the all remaining pleural fluid examination for the bacterial examination, and CBNAT was clearly negative. So we did a CT thorax for this patient. We got the same consolidation with right-sided moderate effusion on CT thorax. So CT thorax shows right-sided moderate effusion with collapse consolidation of underlying lung. So we did a thoracoscopy of this patient. I will show the thoracoscopic image. That person. बाहेर एंड स्लाइड करायला पाहिजे ना इथं. पीपीटी कुठे आहे का? यात का? एंड स्लो हे करू ना. So we did thoracoscopy of this patient. We got multiple. Screen फक्त दाखवा ना. व्हिडिओ म्हणून थांबा सेपरेट व्हिडिओ आहे. केस थोरॅकोस्कोपी म्हणून व्हिडिओ त्यांना दाखवा फक्त 1 मिनिट. हे म्हणून दाखवा केस थोरॅकोस्कोपी. हां 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 ठीक आहे. हा केस बस थोरॅकोस्कोपी व्हिडिओ. नाही सिटी नाही पुढचा व्हिडिओ थोरॅकोस्कोपी. हां हां नाही खालचा ठीक आहे. फॉरवर्ड करा. सो वी डिड थोरॅकोस्कोपी ऑफ दिस पेशंट. शोज मल्टिपल nodules over the parietal pleura. We took a biopsy from there and sent for the histopath. ठीक है. The food forward करा थोड़ा सा वीडियो. We also got multiple septations, adhesions over the pleura. This is the septation. We removed all, so lung gets expanded clearly. ठीक है. So this is the immediate X-ray after the thoracoscopy. So lung gets completely cleared, all fluid gets drained out, and we got the complete molecular diagnosis. So the histopathology of the nodule suggestive of malignant mesothalassemia. We did IHC for this, and we got the metastatic adenocarcinoma. So
पीपीटी ओपन कर. हेच आहे ना.
आता मला डायरेक्ट मेन घ्या. आता जायला सोडा केस सोडा. थांबा 1 मिनिट. इथेच घ्या. इथूनच घ्या मी सांगतो. CMS open करा हाँ इथं medical thoracoscopy खाली घ्या हाँ केलं आता on कर नाही इथं इथं कंट्रोलच नाही ना काय तिथला व्हिडिओ सोडा आता इथं हे ह्याचं कनेक्शन द्या डायरेक्ट इथं पीपीटी आहे ना साडी बॅटरी रनिंग लोअर ह्याचं चार्जिंग संपलंय so we are starting from the main topic is medical thoracoscopy. Medical thoracoscopy is a window to a pleural space. What we do is we insert a scope in the chest pleural cavity and we visualize the inner pleura, visceral pleura, parietal pleura. We separate the adhesions, we clear out, drain out the all pleural fluid, we take a biopsy and we send it for the histopath. So it is a thoracoscopy is a window to the pleural space. By the definition, medical thoracoscopy, it is also called as a pleuroscopy, is a minimal invasive procedure that allows to access the pleural space using a combination of viewing and working the instrument. It is also allowed for the basic diagnostic, that is undiagnosed pleural effusion or pleural thickening, and therapeutic procedure like pleurodesis to perform safely. It is slightly different than VATS. VATS are doing by surgeon and medical thoracoscopy are doing by pulmonologist. In VATS we do bullectomy, lung pneumonectomy, but in medical thoracoscopy we did only a pleural biopsy, pleural chest tube insertion and pleurodesis. So what are the indications? We have some diagnostic and therapeutic indication for the medical thoracoscopy. First and most is pleural effusion of unknown origin. Any kind of pleural effusion, undiagnosed pleural effusion, we have a diagnostic yield of 93 to 100% with medical thoracoscopy. Second is to diagnose a suspicious tubercular effusion for suspecting malignancy with inconclusive cytology for evaluation of the chest trauma. Some therapeutic indications are for doing pleurodesis in malignant effusion, for recurrent pleural effusion, for recurrent pneumothorax, to do a pleurodesis. Second is to remove the adhesions in pleural. For loculated pleural effusion, it is mostly used. And third and most important is to perform a pleural toileting in fibrotic pleuropulmonary stage of empyema. So we use the instruments are a trocar with cannula wall, a single incision thoracoscope, a biopsy forceps, and a optical forceps to take a biopsy. So we have two thoracoscopy. One is rigid thoracoscopy and second is semi-rigid thoracoscopy. What anesthesia we use in thoracoscopy? It is a very minimal. We use only just local anesthesia or a conscious sedation. We use Midas Fenta for this thoracoscopy procedure. So position of the patient, we give the lateral decubitus position so that the rib space get increased. And what we do in thoracoscopy, we give the patient to the lateral decubitus position with arm space over the head. We give the local anesthesia, mostly 2% lidocaine over the space. A small we took the incision over the space. Before taking the incision, we confirm the pleural space and fluid under the thoracic cavity by using by doing the USG. We take a small incision, we dissect the muscle and insert a trocar over the chest. After taking inserting the trocar, we aspirate the all fluid, suck out all the fluid and create a artificial pneumo inside the chest cavity. After getting lung collapsed, we got the all visualization from the pleural space. We inspect the pleural space from apical to posterior, mostly posterior pleura, parietal pleura, we take a biopsy. So pleural biopsy, most pleural pathology in the posterior costal pleura, biopsy specimen from the parietal pleura over we take the biopsy from the parietal pleura over the lips. Ideally, a specimen should not be taken from the apex and anterior parietal pleura due to highly vascularization. So what we see in the tubercular pleural pathology, see the diagnostic yield for the closed biopsy is 70 to 19%. We need to take 6 or more bioscopy, pleuroscopy. So we got many times we got multiple nodular, that is sago nodules in the pleurus surface. So we took the biopsy and send it for the histopath. We also get multiple time of adhesions and thick septations over the pleura. So we separate that septations and clear the lungs will expand after the septation. So in malignancy, pleural fluid cytology is only positive 60 to 70% cases of pleural malignancy with marginal benefit when closed pleural biopsy is added. Patchy involvement of pleural cavity, involvement of the visceral pleura, lower hemithorax are morely seen in malignancy. So thoracoscopy is the recommended procedure in the patient with undiagnosed pleural effusion and negative pleural fluid cytology report who are highly suspected for the malignancy. The diagnostic yield is about 90 to 100% in the malignant effusion. Pleurodesis can be performed during the same procedure of the biopsy positive. So, if we got the diagnosis of any lung cancer, we got the recurrent malignant effusion. So in these cases, we do a thoracoscopy, we remove all the fluid and we did a talc pleurodesis procedure, and so that lungs get with so that recurrent effusion will not form. In case of spontaneous pneumothorax, persistent or recurrent pneumothorax, recurrent rate is about 20 to 30% after this first episode. So we did a thoracoscopy and did a talc procedure. In case of empyema, we got the very thick septations over there, and the bacterial load should be removed. Until and unless we remove the bacterial load and the pus, we are not getting cleared the chest cavity. So we did a thoracoscopy, we remove all the pus and cut down the septation in the thoracic cavity, and we get the pleurodesis done. So evaluation and management of blunt and penetrating trauma, any diaphragmatic injury, chest wall bleeding, traumatic pneumothorax, chylothorax, hemothorax, lung parenchymal laceration, we did a thoracoscopy. So we are moving toward the complications. So complication during the procedure, we got slightly bleeding, hypoxemia, cardiac arrhythmia, subcutaneous emphysema. We have some later complications, that local site infection, empyema, bronchopleural fissura, respiratory failure and neoplastic invasion in some cases. So prevention of complication, we postpone the thoracoscopy in several days if patient is coughing. Measure the blood gas and analysis, monitoring the cardiac status of the patient, pre-oxygenation before the thoracoscopy, and we avoid taking biopsy sample from the internal part of the fissure or mediastinum. So contraindication, we have some absolute contraindication, that absence or potential pleural space. If there is no pleural space, like if any patient has previously pleurodesis done, so it is absolutely contraindication for the thoracoscopy. And some relative contraindications like uncorrectable coagulopathy, multiple pleural adhesions, unstable cardiac respiratory status, or uncontrollable cough, inability to lie down is also a relative contraindications. So conclusion by pleuroscopy. So pleuroscopy is a very small diagnostic and therapeutic procedure. We did in a day care procedure type. We removed all pleural fluid. We got the molecular diagnostic of patient, and it will help to in very malignancy patient. So thank you. Any question?
Thank you, sir. I request Dr. Kadam, sir, to summarize the lecture.
Excellent presentation. May I ask you, sir, what is the scope in pediatric empyema?
We
Do you
can
do?
do a pediatric, we have a different pediatric thoracoscope, which I did not do a pediatric thoracoscopy, but we have scope in pediatric scope present. That is
Right.
for pediatric empyema.
Nowadays, bad empyema is rare because patient presents earlier, early detection and early tapping doesn't require this thing pleurodesis also.
Yes, yes, sir.
Thank
But
you.
what I get, sir, I have done almost 50 plus thoracoscopy in last 1.5 year in Solapur area. So mostly every pleural effusion is not a tubercular origin. Almost in between 15 patient, I got 22 malignancy due to thoracoscopy, which patient has already taken the AKT for 6 months, for the undiagnosed pleural effusion. Mostly that happens in due to empirical AKT. But I got all 22 to 23 malignancy in last 1 to 2 years.
Before doing the thoracoscopy, do you do only tapping
Yes,
for
sir,
diagnostic?
only tapping, sir. Yes, we did only tapping, and if
Not with the thoracoscope, with the needle only?
with needle only. Yes, sir. Yes, sir. To confirm.
Does it prevents the doing thoracoscopy? Because
Yes,
needle
yes, yes. Mostly, if we get the ADA value in suspected range, it is in lymphocytic, highly exudative, then it will be a my tubercular origin.
Right. Thank you.
Yes. Okay. Thank you, sir.
Yes. May I request Dr. Suresh Patil sir to come on the stage, and requesting Dr. Kadam sir and Hakke sir to felicitate the Suresh Patil sir. Now moving on to next lecture. I invite Dr. Madhvi kindly chair the session, sir, please continue. Dr. Madhvi Dadve Banpurkar ma'am. She is MBBS, MD, DNB, DRNB, nephrology. She is consultant nephrologist and transplant physician at all Ruby Hall clinics in Pune and in Vama, the kidney clinic Hadapsar. She is expertise in many more procedures in nephrology like renal biopsy and renal transplants. She is nephrologist and transplant physician practicing in the city of Pune, and she did her MBBS from MUHS and her post-graduation from the ZGS Medical College, Mumbai. She is managing both adult as well as pediatric cases with various forms of renal diseases. She has ample hands-on experience in performing various procedures like tunneled cuffed catheters, rear biopsies, and fistulograms. Ma'am, please deliver your lecture.
Good afternoon, everyone. Thank you, IMA Indapur, for giving me this opportunity. And my apologies to, as I'm coming between the lunch and you, so we'll start with it. So I will be presenting some updates in nephrology. So recently, a very common topic, chronic kidney disease. So they have launched a new guidelines, which are recent guidelines of 2024. They have updated estimated glomerular filtration rate measurement recommendations, which are now race neutral. Initially, it was different for the black race people and white race people. So now they have become race neutral equations. A single estimated GFR reading between 60 to 89 in the absence of other evidence of kidney damage like albuminuria may not necessarily indicate that it is a chronic kidney disease, as in old age population, their already renal function is less. SGLT2 inhibitors, which we call it as gliflozins and the finerenone, now firmly embedded in the treatment algorithms of the chronic kidney disease. Cause plus GFR category from G1 to G5 plus albuminuria category A1 to A3 is included for the diagnosis as well as prognostication of the disease. Heat map risk model has been introduced, which is green, yellow, orange and red for the progression of the risk. There, albumin creatine ratio remains the gold standard for the albuminuria assessment. RAS inhibitors, SGLT2 inhibitors forms the cornerstone dual therapy for proteinuric chronic kidney disease, and finerenone for type 2 diabetes and chronic kidney disease on maximum RAS inhibitors have been introduced. So GLP-1 RAS and RAs considered for the obesity CKD, obese CKDs with type 2 diabetes. So this is basically the heat map. It is divided into albuminuria and chronic CKD staging according to the EGFR. So A1, A2 and A3. A1 is mildly increased, so less than 30 mg per DL per bar gram of creatinine. A2 is moderately increased, 30 to 299 milligram per gram of creatinine, and severely increased is A3, which is more than 300 milligram per gram of creatinine. Accordingly, we have divided this CKD has been divided into G1, G2 and G3A, G3B and G4 and G5 according to the GFR categories. So if you see, the green part is basically the low risk groups. The yellow one is the moderately increased risk, and in the high risk and very high risk is the orange part, which is albuminuria of A2 and A3, that is moderately increased and severely increased, and the decreasing EGFR. So now I wanted to come to this very important topic, which is a pillared approach to treat chronic kidney disease and diabetes. So there are 4 pillars which are very important, that is use of RAS blockers, SGLT2 inhibitors, which are commonly known as gliflozins, non-steroidal MRAs, and GLP-1 receptor analogs. So how does they work? They basically, the outcome is slowing of the CKD progression. So RAS inhibitors, it causes decrease in the efferent arterial tone, which ultimately causes decrease in the glomerular filtration rate, hypertension and hyperfiltration. It also decreases endothelial dysfunction and cardiac remodeling. Similarly, SGLT2 inhibitors increase the afferent arterial tone and decreases the glomerular hypertension and improve the tubular glomerular feedback mechanism as well as hyperfiltration. They also decrease proteinuria, oxidative stress, and it has a beneficial effect of increasing anti-inflammatory and anti-fibrotic effects. Now, non-steroidal MRAs, these are the newer ones which are commonly known as finerenone. They come as in the names of Care India and Livelza. These decrease the inflammation as well as decreases the fibrosis, endothelial dysfunction, also causes the tissue remodeling and decreases the proteinuria. GLP-1 RA decrease the weight, decrease the dyslipidemia, decrease oxidative stress and decrease endothelial dysfunction. So now I would be talking about these drugs separately, and these are the main pillars, so I think everybody should know the names, the dosing and how they work. So SGLT2 inhibitors, basically the commonly available are dapagliflozin, empagliflozin and canagliflozin. So DAPA has been approved in the CKD who have a EGFR more than 25, which can be with or without diabetes, and it is also recommended in heart failure patients. And even there is a dip in the EGFR after starting the dapagliflozin. If it is less than 25, it has to be continued, not to be stopped. Empagliflozin is it comes in 10 mg OD dose, and it is recommended in the patients with the EGFR more than 20. It could be with or without diabetes. Canagliflozin also 100 mg OD dose, and mostly recommended in diabetic kidney disease with urinary ACR of more than 300. So what are the safeties and what are the whole criteria and monitoring? Because you may get patients who are already on dapagliflozin and they might land up to you. So in that scenarios where it has to be held, basically it is held when there are major surgeries and prolonged fasting is there. If there is a iodinated contrast used like in angiographies, severe illness or hospitalization is there. So we have a sick day protocol. We generally try to hold DAPA in case of elective surgeries in at least 3-4 days prior to it. Avoid using in type 1 DM because there is always a risk of diabetic ketoacidosis in type 1 DM patients. Avoid using in patients who have a prior history of diabetic ketoacidosis, who have active UTI, who have ADPKD, and EGFR less than 20 at the initiation. So what we are supposed to monitor when the patient is on dapagliflozin? Basically genital mycotic infections. Initial EGFR dip could be observed, but then we have to rule out other causes also, like any pre-renal AKI is there or any post-obstructive uropathy is there. So that has to be ruled out first. Patient might have euglycemic decay, so whenever the patient is ill, check for ketones. Volume depletion in the elderly patients. Whenever you are starting dapagliflozin in the elderly patients, you need to adjust diuretic doses in them. So there were two important landmark trials which were recently published. One was SMART-C consortium. It contained, there were 10 placebo-controlled RCTs. In this, 70,000 participants had participated into it, they had few were of diabetic, CKD, and heart failure, and they were grouped based upon the EGFR and the urinary ACR. What they found from this study is SGLT2 reduces CKD progression risk regardless of the baseline EGFR, albuminuria. It also supports that their routine used to improve the kidney outcomes across the spectrum of the renal function in those with type 2 diabetes, CKD, or heart failure. There was one more trial which have showed that within the studied participants there were clear absolute benefits of SGLT2 inhibitors on kidney, hospitalization, and mortality outcomes irrespective of the diabetic status as well as level of urinary ACR. So patient with albuminuria less than 200 also can be started on dapagliflozin, and he always need not to be diabetic. So these were some SGLT2 inhibitor landmark trials, which was Credence, DAPA-CKD, and EMPA-Kidney, which were very famous trials and everybody knows about it. But recently, SMART-C, that is, this trial was published in JAMA 2025, and they had shown that CKD progression can be slowed down regardless of the urinary ACR after using gliflozins. So other drug will be the finrenone. Non-steroidal MRA in a diabetic kidney disease. It is also a wonder drug. There are few trials which has been published, I think since last 3-4 years ago, and there are Fidelio DKD trial, Figaro DKD for the cardiovascular outcomes. So in that they have found that 18% CKD progression. There was a reduction in CKD progression in 18%, and a 13% reduction in the cardiovascular events, and 31% reduction in the urinary ACR at the 4th month was observed. And the discontinuation rate due to hyperkalemia was also less, that is 2.3%. So how is it different from the steroidal MRA, which is common as spironolactone? So this is a non-steroidal, so lesser side effects like no gynecomastia, no erectile dysfunction. It have high mineralocorticoid receptor selectivity, so equal cardiac as well as renal distribution is there. Have a short half-life, so therefore there is less chances of hyperkalemia. Even the due to less hyperkalemia, discontinuation rate is also less, which is just 2.3% versus 23% for the spironolactone. It is approved drug, can be used in EGFR more than 25 with urinary ACR more than 30 milligram per gram of creatinine plus type 2 diabetes who are already on maximal dose of RAS inhibitors. So how can you prescribe? The starting dose is 10 mg once a day in the patients whose EGFR is less than 60 and potassium is 4 to 4.8. You can up titrate after 4 weeks in the scenarios if the potassium is less than 4.8 and the EGFR is stable. Check potassium after starting the drugs at first week, 4th week and the 8th week, and then thereafter you will check it after 3 to 4 months. Hold if the potassium is more than 5.5. Restart at the lower doses when the potassium decreases to less than 5. Avoid using ketoconazole, which are the inhibitors, CYP3A4 inhibitors, because it is going to increase the drug levels and ultimately can lead to hyperkalemia also. So these were the clinical evidences, these were the trials. So another thing is the cardio-renal metabolic framework. Again, it includes all the 4 pillars, but they have added BP control and good diabetes, sugar control, and even along with that lifestyle modification. So this is again the same slide, when to initiate RAS inhibitors, when to initiate SGLT2 and MRAs. So now talk of the town, GLP-1 receptor agonist. I think these are the drugs which are used for even obesity, diabetes purposes and cosmetic purposes. So primarily it is used to treat type 2 diabetes and obesity. It mimics natural incretin hormone, glucagon-like peptide, which is released by the intestines after eating. Mechanism, it lowers the blood sugar, promotes the weight loss. The mechanism remains like it increases the insulin secretion, it decreases the glucagon, it causes the glucagon suppression, and it gives the early satiety, acts on the brain hypothalamus to give the feeling of the fullness and reduce the hunger. There's a slowed gastric emptying leading to slower rise in the blood sugar levels after the meals. So commonly available drugs are semaglutide, tirzepatide, dulaglutide, liraglutide and exenatide, which we have been using as semaglutide, which is Ozempic or Wegovy, majorly used for weight loss in obese individuals, and the dosing is also weekly and subcutaneously. Ribelsis was initially used as an oral drug, and it was majorly for diabetes. Tirzepatide is a recent launch, and it is coming under the name of Mounjaro, and Zepbound is again in the pipeline. So it is also weekly dosing dose, used subcutaneously and recommended for diabetes and obesity. Other drugs are used in various Asian countries. So what are the benefits? Not only beyond the blood sugar, it also causes the cardiovascular benefit. There are renal benefits and neuroprotection under study for potential benefits in the Alzheimer's and the Parkinson's disease. Side effects. So everybody is aware about the side effects of the this Ozempic, which is gastrointestinal side effects are very much prevalent in patients. They do complain about it. So nausea, vomiting, diarrhea, constipation are the most commonest side effects, but it can be tackled with the dose titration. Potential risk is patient can land up into pancreatitis, gallbladder disease, thyroid cell tumors, and therefore they are contraindicated who have a family history of medullary thyroid cancer or any family history or any personal history. There is a surgical warning to this drug. Whenever there is an elective surgery, due to delayed gastric emptying, patients are often advised to stop temporarily before the elective surgery to avoid the aspiration. So KDIGO has recently launched a new guideline on anemia also. So I'm not going deep into it, but I would like to talk about the HIF-PHI factors. HIF-PHIs, these are the newer drugs which are there. The anemia definitions remains the same, less than 13 gram per DL for males and 12 for females. So this HIF, I want to talk about this hypoxic sensing, the HIF system, what exactly it is and why they are more comfortable using these drugs. The body's sensing of tissue hypoxia and thereby recognition of anemia occurs by the HIF system. Central to this function are two proteins which are HIF alpha and HIF beta, and in the normoxic condition basically HIF does not get degraded. So this diagram actually tells you that in the normoxic condition, HIF alpha is not used, it remains in the cytoplasm, it undergoes acetylation and proteasomic degradation, while in hypoxic condition, this HIF gets transported to the nucleus, and here it combines with the HIF beta, and then after that transcription of the EPO gene occurs and thus helps in the erythropoiesis. So these are the common drugs available, which is HIF-PHI. HIF-PHI is basically hypoxia-inducible factor with prolyl hydroxylase inhibitor agents. So daprodustat, desidustat, roxadustat and vadadustat is available. So in India, desidustat is available, which comes as Oxemia or Ristat are the brands which are available, and these are to be given 3 times weekly. But this is not an alternative for ESA, it is a second line therapy for the anemia. EPO is the first line therapy. So how they are beneficial and what are the side effects of the drugs? So it is a basically ESA, that is a EPO. It is an exogenous EPO supplementation, and HIF-PHI it stabilizes, and it actually stimulates endogenous EPO secretion. ESAs are subcutaneous and IV injections, and the HIF-PHI are available as an oral tablet. HB response is rapid with ESAs, and HIF-PHI, there is a gradual response to it. Till date, ESA is always a first-line therapy, and HIF-PHI is a second-line therapy, and has to be considered in patients who have erythropoietin failure, response failure, or intolerance. What is the cardiovascular safety in this? So ESA, there is always a chance of thrombosis or hypertension or stroke if the patient's hemoglobin goes above 11.5. While in HIF-PHI, there is a higher major adverse cardiovascular events than ESAs, and there is a major risk of thrombosis. It is the ESAs are contraindicated. The absolute contraindication is active malignancy. But in HIF-PHI, it is contraindicated in children, transplant patients, in ADPKD patients, active cancers, pulmonary hypertension patients, and proliferative retinopathy and pregnancy also. So now coming towards the IgA nephropathy, this is a very commoner glomerular nephritis observed in the age of 30 to 40s. So I won't go into the pathogenesis of it, but newer drugs, newer guidelines have been updated in 2025, and now they are targeting UPCR they are targeting for complete remission, and target is less than 0.3 gram per gram ideally, but acceptable is less than 5 gram per gram, that is UACR less than 500 milligram. So dual therapy has been advised. Target IgA immune complex formation. So targeted budesonide has been launched. It has been like now 4 or 5 years. It has been there in the market. So first attack the IgA and IC formation, the cause, and then other CKD consequences has to be taken care of by using RAS inhibitors, SGLT2 and sparsentan. So these are the FDA approved drugs. But TR budesonide, which is again a steroid, it does not have any systemic side effects. It directly acts on the Peyer's patches, it directly acts on the colon, and reduce the formation of the IgA immune complex. Other drugs which are available are sparsentan, which comes under the name of Filspari, and it is not available in India, but it can be imported. Others are atrasentan and sibeprenlimab. Now coming towards the interesting part, that is what are the surgical and transplant advancements which have happened over the years. So everybody would have now come across the word xenotransplant. It is basically in the historic 2024, there was a milestone paper, there was a landmark trial in NEGM where a genetically edited pig kidney was successfully transplanted into a living human. Demonstrating immediate functionality. So within 23 hours, the kidney started functioning. Till 8th day, the creatinine was dropping. On the 8th day, again the patient has a cellular rejection, but it was treated, and on 52nd day, the patient died because of cardiovascular event. And now they have come up with FDA have approved multi-patient clinical trials for this technology in 2025. They have been enrolling patients, and they have 2 studies which will be coming up. Awake kidney transplantation. So Northern Western Medicine, which is in Chicago, performed the first awake kidney transplant in 2024 using a regional spinal anesthesia, allowing faster recovery and discharge under 24 hours. So they have this can be practiced in patients in a geriatric age group where general anesthesia is not possible, and there is a early recovery, and the patient even can see his own kidney getting placed. Other things is immunosuppressant elimination. That is, after transplant, patient has to be there on anti-rejection medications, immunosuppressant for lifelong. But now there are techniques where kidney, along with the stem cell transplants, if it is done, anti-rejection drugs can be stopped after 1 year of the transplant. Some diagnostics and technology. So artificial intelligence has taken over many things now. So AI algorithms like RETI-CKD now use retinal scans to predict future CKD risks more accurately than the traditional urine or the blood test. Deep learning models have come up to give accuracy of the renal biopsy interpretation to over 90%. There are some novel biomarkers are there. There are nephrocheck tests which measures TIM2 and BP7 and NGAL assays. They are increasing, and then they will be assessing the risk of acute kidney injury before creatinine level rises. So I would like to concentrate upon few drugs which you are going to come across in your day-to-day practice. You might get follow-ups of these patients also. So key takeaways is gliflozin, that is the SGLT2 inhibitors, are co-first line with RAS inhibitors for all CKD if EGFR is more than 20. SmartC 2025, they have shown the benefit that it is universal regardless of diabetes or albuminuria. Remove urinary ACR threshold for prescribing gliflozins. Finrenone adds cardiorenal protection in diabetic kidney disease beyond RAS inhibitors, SGLT2 inhibitors, and it forms the four-pillar approach of the standard of care for diabetic kidney disease. KDIGO 2026 anemia, they have introduced HIF-PHIs as a second-line therapy, and it has to be considered as second line, not to be used along with the ESAs. IgA nephropathy has again done a revolution. So there's a dual strategy with 4 new FDA-approved drugs. Proteinuria less than 0.3 gram per day for the complete remission. There is no routine systemic steroids for the Caucasian population. Thank you. Thank you for your patience listening.
Thank you, Dr. Madhvi. We have heard insightful data on such a complex topic.
Yes.
You made it simpler to understand us in hungry stage.
Yeah.
I requesting Dr. Sir to highlight on some points on the lecture. Okay, sir. Thank you.
Thank you so much.
Now we will move to have a lunch. We'll felicitate Dr. Madhvi ma'am. Requesting Dr. Kadam sir and Dr. Hakke sir to felicitate Madhvi ma'am. To felicitate our chairperson, may I invite Dr. Sachin Torbe sir and Dr. Arjun Narute sir. Nobody. Dr. Lakshman Sapkar sir, please felicitate our chairperson.
Sir. Let us have a look at IMA MNC panel. Just 1 minute video. होता है क्या? Lunch session will start soon.
Top of that, we will be discussing about the sleep. So I request everybody, learn here, but don't practice it here. So please be awake. Sleep is a topic nearer to the heart of many people. झोप एक हृदयाच्या जवळ असणारी गोष्ट. बरेच जण सांगतात की त्यांना झोपायला खूप आवडतं. दुसरी गोष्ट हे की आपण ज्यावेळेस बोलतो बऱ्याच वेळा की आपण बऱ्याच वेळा ऐकतो की काही जण म्हणतात आमचे हे तर गेले की लगेच झोपतात, त्यांना गाढ झोप लागते, घोरतात. दॅट इज मिसबिलीफ. मेनी पीपल थिंक दॅट स्नोरिंग इज इक्विव्हॅलंट टू गुड स्लीप. That is not correct. On the contrary, if a person is snoring, then there is possibility that he may be suffering from sleep disorders. And we know that the sleep, even though it is very important part of life, there is not much awareness about the sleep disorders. म्हणजे बऱ्याच जणांना हे पण माहिती नाही की स्लीप रिलेटेड डिसऑर्डर असतात. लोकांना ज्यावेळेस मी स्लीप बद्दल बोलतो त्यावेळेस झोपेचे पण आजार असतात, हाच क्वेश्चन असतो. तो बेसिकली स्लीप इज अन इम्पॉर्टंट पार्ट and we should take care of our sleep, and everybody has right to have healthy sleep. So understanding about the obstructive sleep apnea. So obstructive sleep apnea is a serious condition characterized by repeated airway obstructions during sleep, leading to various disrupted breathing patterns and significant health implication for affected individuals. When person snores and he don't have any sleep apnea, the problem is not that high. Only his spouse, or you can say bed partner, whoever is, she will not be able to sleep properly because of noise. But if a person is having sleep apnea along with snoring, then there may be various health issues patient may develop because of obstructive sleep apnea if he is not taking any proper treatment. So basically what happens, even though we are not aware of sleep disorders much, but surprisingly it was initially described in the literature 100 years ago. William Shakespeare described a character in his book Henry II, that John, the boy was very fat boy. He used to found napping everywhere. He used to get fast asleep and he used to snore like a horse. So typical OSA person. It was first described by Broadbent in 1877. Then there are various developments in the sleep. So what is obstructive sleep apnea? Apnea, we know, apnea means no breathing or no flow at all. Sleep, it is happening in sleeping. So in sleep, if there is no flow, that is sleep apnea. Sleep apnea is of two types. One is obstructive and another is central. Obstructive means there is obstruction in the upper airway. Because of that, patient will try to breathe. There will be chest efforts, abdominal efforts, but he will not be able to breathe at all. So that is obstructive sleep apnea. On the contrary, in central, there will be no flow and patient will not be able to take efforts. So obstructive sleep apnea is cessation of airflow for greater than 10 seconds with continued chest and abdominal efforts. So we can say more than 930 million adults are suffering from this. So you can see the magnitude, huge magnitude of this obstructive sleep apnea, but awareness, at least in India, is very less. Risk factors, overweight, obesity is the most important factor, because if there is one standard deviation in BMI, the increase of OSA, increased risk of OSA is fourfold. African, American, postmenopausal women, those who are having family history, alcohol use, smoking, large neck size, increased age, and males. Genetically, if you say gender-wise, males are more prone to have sleep apnea because of android fat deposition. We know that in male, fat deposition is on abdomen and neck, as compared to female. Female, the fat deposition is mainly on thighs and hips. So because of that, it is more common in males. Now coming to pathogenesis. Basically, in a simple word, obstructive sleep apnea means obstruction in the upper airway, and upper airway get collapse. So if there is deficient upper airway and the things which make it, keeps it patent, if there is decrease in neuromuscular compensation, there occurs the obstructive sleep apnea. So deficient airway anatomy, makes it more collapsible, then one can say why it is happening only in the sleep, not in when patient is awake. What happens now, when patient is awake, at that point there is increased neuromuscular compensation which prevent upper airway from collapse. So, but unfortunately during sleep that increased neuromuscular compensation is lost, and during sleep patient's upper airway collapses and he sleeps. So upper airway means if there is a small or narrow upper airway lumen, it may be because of small mandible or posterior displacement of mandible, or there is medial displacement of the rami of mandible. It will cause airway lumen small. Soft tissue, like we know that if macroglossia is there, large tongue is there, enlarged adenoid tonsils, it will affect the upper airway. Upper airway shape, if it is oval shape, then patients are more prone to have OSA. Upper airway length, long upper airway or nasal obstruction makes you more prone to have OSA. So what happens because of this, when there is obstruction, airflow is not there, patient is not breathing, saturation will go down. And this intermittent hypoxia will cause increased oxidative stress, inflammation, increased sympathetic activation, metabolic dysregulation, and endothelial cell dysfunction. So all these will make patient prone for cerebrovascular and cardiovascular adverse events. So those who are having obstructive sleep apnea and not taking treatment, they are more prone for pulmonary, cardiac, as well as cerebral vascular accident like stroke and heart failures. Now coming to diagnosis. Once you suspect that patient is having obstructive sleep apnea, patient may be having obstructive sleep apnea, you should take proper history, past history. There are some forms also, some questionnaires also which will tell you whether patient is more prone to have obstructive sleep apnea. And then to confirm, there is sleep test, that is polysomnography. So coming to history, nighttime symptoms, snoring. Snoring is the most important symptom, and most of the patients who snores, they are obese, they are more prone to have obstructive sleep apnea. Other is observed apneic episode, that is choking episode. What happens in obstructive sleep apnea? During sleep, tongue slowly falls back, and at particular point, it will totally block the airway. So there will be no flow at all. Saturation will go down, and brain will sense something is not correct. So what brain will do? It will have a neuromuscular spurt. The pharyngeal muscle will get contract, tongue will move forward, and again patient will resume the breathing. The choking episode is typical, means the spouse will tell, हे झोपत असतात, घोरतात घोरतात घोरतात, अचानक सगळं थांबतं आणि अचानकच जोरात श्वास घेऊन परत घोरणं चालू होतं. इट इज लाईक there will be pause, and so this is choking episode, and it is very pathognomonic of OSA. Restless sleep will be there because of all these things. Patient will be continuously tossing and turning in the bed. Diaphoresis, there will be sweating on mainly on the abdomen and upper chest or neck. It is because of this is obstructive event. So patient will try to breathe, but she will not be able to breathe. So there will be continuous abdomen and chest efforts will be there, and because of that there will be increased sweating, heartburn, noxuria, and dry mouth. Daytime symptoms, another important symptom is daytime sleepiness. Means if he sits for few minutes, then he will get asleep. So excessive daytime sleepiness, fatigue, there will be personality changes. Means recently patient will become more aggressive, irritable, or anxious, and morning headaches will be there. Whenever he wakes up, at that time he may not feel fresh. Many times patient will say that सकाळी उठल्यावर fresh वाटत नाही. That may be he needs evaluation for sleep apnea. Two important history you should ask: history of wisdom tooth removal. If patient has undergone wisdom teeth removal, it indicates that there may be deficient upper airway. And second is bruxism. Bruxism म्हणजे दात उडणे or involuntary movements of teeth. So what happens? Exact cause or relation we don't have, but the proposed hypothesis is that bruxism or teeth grinding may be a predictive mechanism against the repeated airway collapse. So those who are having wisdom teeth removal, history of wisdom teeth removal and bruxism, they should be evaluated for the suspected obstructive sleep apnea. This we have already seen. So one scale is there, Epworth sleepiness scale. This is to evaluate for the excessive daytime sleepiness. So in this scale, subject is asked to rate his probability of dozing in 8 various situations on the scale of 0 to 3. So ESS score vary between 0 to 24. If it is more than 10, then definitely patient is having excessive sleepiness and patient may have obstructive sleep apnea. Now, once you take history and you suspect that patient might be suffering from OSA, then the most important definitive test is sleep test, that is called as polysomnography. So polysomnography is done for diagnosis of OSA, for CPAP titration, also for assessment. Once we have diagnosed, you have started with the treatment, then whether he has improved with the treatment or not. For that also polysomnography is needed. Also it is needed for other sleep-related disorder diagnosis like parasomnias, narcolepsy, and nocturnal seizures. So this is very simple test. It doesn't require any pricking or blood sample. So there will be monitoring of sleep neurochannels with EEG, EOG, EMG. Monitoring of breathing means nasal and oral airflow will be measured. Thoracic and abdominal efforts will be measured. Pulse oximetry, saturation, and tracheal noise, it will be measured. There are 4 types of polysomnography or sleep study. Type 1 is the gold standard. It is performed in the lab. There will be a video recording also, and one person or one technician, sleep technician will be there throughout the study. Even though it is gold standard, but the problem it is very costly. And what happens, patient has to come to sleep lab and he has to sleep at the new environment. So sometimes patient will not be able to sleep, and if he is not sleeping, then there is no point in doing polysomnography. Type 2 is same, 12 channels are used, but it can be done at home also, so it is more preferred. What we commonly do is type 3. Here only cardiopulmonary, it is called as cardiopulmonary sleep study, but it is accepted. Type 2 and type 3 are accepted. Another is type 4, where only single channel or dual parameters are recorded, but it is not accepted at all. So many times we are using type 3, and if needed, then type 2. And rarely when you want to confirm the things, few things or rare disorders, then only type 1 is recommended. So this is a normal sleep study. What we have to see is third saturation. Here we can see, you are not able to see. Okay. So here this is the flow. This is thoracic and abdominal movements. For diagnosis of sleep apnea, these are important. So normally you can see there is a flow. Here abdominal and thoracic movements are present. For apnea, there should be decreased flow or absent flow. Here we can see flow is not there, so some problem is there. At the same time, when there is no flow, respiratory movements are there, thoracic and abdominal movements are there. So it is obstructive event, means flow is not there, patient is trying to breathe. The efforts are there, but he is not able to breathe. So it is called as obstructive sleep apnea. Another thing, here you can see that apnea is there, no flow, but at the same time, at that moment, there is no movements at all. So no flow is there and patient is not breathing at all. So it is apnea, but it is central sleep apnea. Here we can see it is mixed apnea. Initial part there is no flow and no efforts also. So initially it is central apnea event, but in later part we can see there are abdominal and thoracic and abdominal movements. So it is mixed. Initially it is central apnea and later on it is we can say obstructive apnea. There is another entity, hypoapnea, means for apnea there should be no flow, but in hypoapnea flow will be there but it will be reduced. Here we can see it is hypoapnea. Flow is there but it is reduced than actual. So for diagnosis, if polysomnography shows AHI, there is one entity which is very much important when you are reading a sleep report, apnea hypopnea index. If AHI is more than 15, then definitely patient is suffering from obstructive sleep apnea. But if AHI is more than 5 and patient is having symptom, then also patient is suffering from obstructive sleep apnea. Now, once you have diagnosed the treatment plan, there is general treatment or behavioral measures, medicines are there, some we can say we all know positive pressure ventilation is an important part, and sometimes some mechanical devices we can use, and if rarely if it is needed, then surgery is also helpful. So behavioral therapy, alcohol, one should avoid alcohol, one should avoid smoking. What happens? Smoking will increase inflammation, will injure and increase edema of the upper airway, and upper airway will be more prone to collapse. One should avoid sedatives, because if you are taking sedatives and you are suffering from obstructive sleep apnea, their hypoxic events will be prolonged. Cardiovascular risk factor reduction. Patient should get evaluated for hypertension, diabetes, hypercholesterolemia, and if with proper treatment, this cardiovascular risk will be reduced. Weight loss is the most important thing. You can have exercise, diet. If you need, then take help of the various drugs also. And if your BMI is very high, like more than 40, then you can opt for the bariatric surgery also. But if you reduce your weight, then your obstructive sleep apnea will, the severity will reduce very much. Positional therapy. When you sleep supine, what happens? Because of gravitation, tongue will fall back, and there are high chances that you will have obstructive events. But if you sleep lateral, then the chances of getting apneic spells are reduced. So initially, there was one practice when many therapies were not available. Then they used to sweep the tennis ball on your upper pajama, so that patient will not sleep supine and he will sleep laterally only. Coming to pharmacological treatment, oxygen, when your saturation is going down, then you have to take help of the oxygen. You have to maintain the saturation more than 90%. Other drugs have very much tried, like respiratory stimulant, REM suppressant, TNF-alpha inhibitors, but they are not having that much promising results. Wake promoting agent, it is not actually for treatment of OSA, but it will help reduce sleepiness. We are using that modafinil, that is Modalert. So you can use that as the adjuvant to reduce the excessive sleepiness. You can start with 200 milligram and you can increase the dose to 200 milligram twice. But important point is that if you want to give second dose, it should be given before 3 p.m. and not after 3 p.m. There are various appliances also which can, because what happens, because of less awareness, people are not ready to use BiPAP machine, and it's very difficult also unless you are properly explain about why it is needed, because you have to put something and sleep, and it will be continuously putting pressure on your face, so it is little cumbersome. So many because of discomfort, many people don't want it. If they are not willing for that and having mild, then we can use this oral appliances, mandibular advancement splint, where it will protrude your mandible, and tongue retaining devices. It will prevent tongue to fall back, and it will prevent obstructive events. The most important and many patients will require is positive airway pressure. There is CPAP and BiPAP. So this CPAP will act as pneumatic splint, which prevent collapse of the pharyngeal airway. CPAP increases airway volume and reduces the lateral pharyngeal wall thickness. Also CPAP reduces airway edema also, that results from chronic vibrations, and it reduces occlusion of the airway. So it is the most prominent treatment, and if you are having severe obstructive sleep apnea, you have to take help of CPAP machine. So when you decide that patient is having obstructive sleep apnea and you want to start him on CPAP therapy, most important is patient education. After that, you have to titrate the CPAP or positive pressure, whether he will be benefited with CPAP or BiPAP, and then you have to choose proper equipment. The most important hurdle in using CPAP for OSA is patient acceptance. And what happens if patient is not properly informed, then patient will not be using the machine daily. So explain the patient about what are the causes of OSA, what is the mechanism, what are the consequences of untreated OSA. Tell him about the CPAP therapy, how it will be beneficial, and tell him that for few days there may be some problem, but later on he will get adjusted and there will not be any discomfort with the CPAP. So titration can be done as full night or split night. It can be manual or auto titration also. In manual, what we do, we start with the 5 centimeters of water and then every 5 minutes we will increase by 1 centimeter till all apneas, hypopneas vanishes and snoring reduces. And auto titration means machine, you have to just apply the machine. Machine will titrate how much pressure patient will require. So there are two things in positive pressure ventilation. One is continuous positive airway ventilation, another is bi-level positive airway pressure. So CPAP, there will be continuous pressure. The best part is that it is cheaper than bi-level positive airway pressure, but the problem is there will be continuous pressure. So some patients will be finding it not comfortable to have continuous pressure. So there is BiPAP. In BiPAP, on inspiration there will be another pressure, and expiration pressure will be reduced so that he will be able to exhale properly. So with BiPAP comfort is good, but the problem is it is more costly if you compare it with the CPAP. So once you decided which therapy you want to add, CPAP or BiPAP, the another is you have to select the mask. There will be various nasal masks, full face mask or nasal pillows. Recommended is full face mask, but what happens, some patients have, we can say, they are not comfortable with the mask. So in those patients, we can use a small mask or nasal mask. Adverse effects are important because if patient have adverse effect, he will not be using mask at all. And these adverse effects are minor effects, like there will be marks on the face because of mask, there will be nasal discomfort, nasal congestion or dry nose. And if you properly select a mask size with silicone coating, then this can be taken care of. In CPAP, pressure is very much important. If you are using inadequate pressure, then the OSA will not be treated properly and there will be cardiac arrhythmias or various cerebrovascular complications. And if you are using excessive pressure, it will be very much discomfort for the patient. BiPAP we have already discussed. So it is needed when patient is requiring very high pressures in CPAP. It is more than 15 centimeter, then you have to use BiPAP, or patient is having COPD or CO2 retention, then CPAP will not be much helpful. In those patients, we have to prefer BiPAP. Surgical indications are required only in those patients where medical management fails, and when there is anatomical obstruction, at that point definitely you have to use surgery to relieve the obstruction. That's over. So if you suspect that patient is having obstructive sleep apnea, at that point there are pretests which will give you probability. There is Berlin definition, ASA definition, or you can say stop bank questionnaire. This questionnaire is very much popular. You can keep it in your OPD also. Ask 8 questions to the patient, whether he snores, feeling tired, or there are observed choking episodes, if he is having hypertension, his BMI is more than 35, age is more than 50, neck circumference if it is more than 40, or he is male. If this score is more than 3, then he may be suffering from obstructive sleep apnea. So definitely you should ask him for get evaluated for OSA. If it is not properly treated, we have already seen there may be pulmonary complication, heart failure, heart attacks, and metabolic disorders or cognitive impairment. So sleep is an important part of our life. Many times everybody has right to have proper, or you can say healthy sleep. Being a consultant or physician, our duty is we should evaluate a patient properly, we should diagnose those who are having sleep, and then we have to definitely treat them properly. Thank you very much.
Thank you, sir, for your excellent presentation. Now, may I request Dr. Shinde, sir, to summarize the session.
Thank you, sir. Now would like to call Dr. Srinivas Kulkarni, sir. Please come on the dais. Dr. Kulkarni, sir, is a medical oncologist, currently working as a consultant in the Department of Medical Oncology at Sahyadri Super Speciality Hospital, Hadapsar, Pune. He completed MBBS on ACPM Medical College, Dhule. Subsequently, he completed his DNB Internal Medicine from Jahangir Hospital, Pune. Later, he worked as a lecturer in Department of Intensive Care at Jahangir Hospital. Warm welcome, sir. Please deliver your lecture.
केलं होतं काहीतरी हो येस Good afternoon, everyone. I'm so sorry for the technical glitches, but now it has become a part and parcel of the conferences. Thank you so much for the kind introduction, and I would like to thank Indian Medical Association Indapur and office bearers for the kind invitation and to discuss something about what is happening in the field of cancer treatment. So, I always start my lecture with the thought, nothing in life is to be feared, but it is to be understood. फार महत्त्वाचं आहे, कारण आपण नेहमी म्हणतो की एखाद्याला कॅन्सर झाला की 50% मानसिक दृष्ट्या तिथेच पेशंट खचून जातो, पण काही गोष्टी समजून घ्यायच्या आहेत. आपण आजकाल जसे कॅन्सर ट्रीट करतो ते 20 वर्षापूर्वीचं 30 वर्षापूर्वीच्या ट्रीटमेंट्स राहिलेल्या नाहीयेत. नवनवीन ट्रीटमेंट ऑप्शन्स आलेले आहेत की ज्यांनी कॅन्सर फार चांगल्या प्रकारे ट्रीट होतो आणि तेवढंच नाही तर क्वालिटी ऑफ लाईफ सुद्धा खूप चांगल्या प्रकारे मेंटेन होते. लेट्स गो थ्रू द जर्नी वन बाय वन. सो आपण जर पाहिलं की जगभरामधले पहिले टॉप 10 कंट्रीज अफेक्टेड विथ कॅन्सर जर पाहिलं तर ऑस्ट्रेलिया सगळ्यात एक नंबरला येतो की ज्याच्यामध्ये इन्सिडन्स ऑफ कॅन्सर इज ऑलमोस्ट 460 पेशंट्स पर 1 लाख पॉप्युलेशन. सेकंड इज न्यूझीलंड, थर्ड इज डेन्मार्क, युनायटेड स्टेट्स ॲट 4th पोझिशन, हंगेरी ॲट 10th पोझिशन. ह्या पहिल्या 10 देशांमध्ये भारताचं नाव कुठेच नाहीये. इज इट अ थिंग टू बी व्हेरी हॅपी? ॲब्सोल्युटली नॉट. जर भारतामध्ये पर 1 लाख पॉप्युलेशन आपण जर नंबर काढला कॅन्सर इन्सिडन्सचा तर तो 97 आहे. तो 97 जरी खूप छोटा नंबर दिसत असला तरी ज्या वेगानं कॅन्सरच्या केसेस वाढत आहेत दॅट इज रिअली वरिसम. आपण हा ग्राफ पाहूयात. की 2018 साली 11.6 लाख न्यू कॅन्सर पेशंट डायग्नोज झाले, 2020 साली 13.2 लाख न्यू पेशंट्स डायग्नोज झाले आणि लास्ट इयर 15 लाख न्यू केसेस ऑफ कॅन्सर हॅव बीन डिटेक्टेड इन अ सिंगल इयर. So if you see from 2020 to 2025, there is a staggering 12% increase in the number of cancer patient. याचा अर्थ एकच आहे की कॅन्सर इज अ ग्रोइंग प्रॉब्लेम इन इंडिया. सो एक संस्था आहे दॅट इज कॉल्ड एज ग्लोबल कॅन्सर ऑब्झर्वेटरी. ती एक WHO ची संस्था आहे आणि त्याच्या ऑब्झर्वेशन नुसार भारतामध्ये 2022 साली मी मागच्या स्लाइड मध्ये जसं सांगितलं तुम्हाला की 14,13,000 नवीन पेशंट डायग्नोज झाले आणि नंबर ऑफ डेथ्स बिकॉज ऑफ कॅन्सर वॉज 9.16 lakhs. It's a huge number for a country like India. So if you see the top 5 cancers in Indian males, first cancer is lip and oral cavity, second cancer is lung cancer, third cancer is cancer of the esophagus, अन्ननलिकेचा cancer, colorectal malignancy that is आतड्याचा cancer आणि stomach जठराचा कर्करोग. Now if you see the top 5 cancers in Indian females, the most common cancer is breast cancer, second most common cancer is cancer of the cervix uteri, third common cancer is ovary, fourth common cancer is colorectal, lip and oral cavity, and the fifth cancer is actually colorectum was the fifth one. So if we see our knowledge or our understanding of a single cancer cell, and it was in 1975, we had only understanding of there is cytoplasm, there is nucleus, and that's all. पण तेच जर अंडरस्टँडिंग तुम्ही पाहिलं 2008 मध्ये, it has become a complex figure, and I couldn't put the figure from 2025 or 2026 because it is beyond the scope of this single slide. So I can say that there is a rapid transformation in the way we practice oncology compared to the 20 years ago. Sorry. So what are the various cancer treatments that we have today? One is systemic therapy, second is surgery, and third is radiation therapy. And in most of the cancer, all three treatment modalities are essential, because मी नेहमी सांगतो की या 3 modalities म्हणजे रिक्षाची चाक आहेत. एक जरी चाक काढून टाकलं तर रिक्षा पळणार आहे का आपली? सो नॉट ॲट ऑल. बरेच पेशंट असतात, सर आमची सर्जरी झालेली आहे, आम्हाला पुढे काही करायचं नाही. बट बऱ्याच वेळेला जेव्हा ट्यूमर स्टेज 2 स्टेज 3 च्या पुढे जातो तेव्हा तुम्हाला या तिन्ही मोडॅलिटीज सगळ्यात बरोबर घेऊन पुढे जावं लागतं. सो व्हॉट आर द सिस्टमिक थेरपीज इन द मॅनेजमेंट ऑफ अ कॅन्सर? फर्स्ट किमोथेरपी, की जी आपण ऐकत आलेलो आहे की कॅन्सरची ट्रीटमेंट म्हणजे किमोथेरपी, एक किमोथेरपी, पण तसं राहिलेलं नाहीये. सो अजून दुसऱ्या ट्रीटमेंट ऑप्शन्स काय आहेत आपल्यासमोर? इम्युनोथेरपी, टार्गेटेड थेरपी, ओरल टार्गेटेड थेरपीज, ADCs that is called as antibody drug conjugates, and CAR T cell therapies. आज मी तुमच्याबरोबर 4 केसेस डिस्कस करणार आहे. पहिली केस आहे लंग कॅन्सर, दुसरी केस आहे लिम्फोमा, तिसरी केस आहे कार्सिनोमा ब्रेस्ट, आणि चौथी केस आहे कार्सिनोमा ब्रेस्ट. की हाऊ वी आर ट्रीटिंग these advanced malignancies nowadays. It's not a conventional chemotherapy that we are using. So lung cancer. So आपल्याला माहिती की lung cancer is the leading cause of cancer related death in men and women. 85% लंगचे जे काही कॅन्सर्स असतात they are mainly because of cigarette smoking. And symptoms we all know: cough, chest discomfort, pain, weight loss, and less commonly hemoptysis. Diagnosis mainly by chest X-ray, CT scan, and it is confirmed by a biopsy. So आपल्याला रिस्क फॅक्टर्स माहिती आहेत लंग कॅन्सरचे: टोबॅको कन्झम्पशन, सेकंड हँड स्मोक, ऑक्युपेशनल एक्सपोजर, इन्क्रीजिंग एअर पोल्युशन, जेनेटिक ससेप्टेबिलिटी, आणि बाकीचे लाईफस्टाईल रिलेटेड फॅक्टर्स की डाएट असेल, अल्कोहोल कन्झम्पशन असेल, किंवा बाकीच्या गोष्टी असतील. सो जेव्हा आपण लंग कॅन्सर ट्रीटमेंटची गोष्ट करतो, इन 1970s तुमच्याकडे लंग कॅन्सर ट्रीट करण्यासाठी काहीच नव्हतं. सो देन केम अ कॉन्सेप्ट ऑफ किमोथेरपी दॅट इज कॉल्ड एज प्लॅटिनम बेस्ड किमोथेरपी. आणि त्या प्लॅटिनम बेस्ड किमोथेरपीनं स्टेज 4 लंग कॅन्सरच्या पेशंटचं आयुष्य 4 ते 6 महिन्यांपर्यंत गेलं. इन 1980s देर केम कॉन्सेप्ट ऑफ ड्युअल प्लॅटिनम थेरपीज, ज्याच्यामुळे तुमचं जी लाईफस्टाईल आहे किंवा जे लाईफ ड्युरेशन आहे ते 4 ते 6 महिन्यांवरून वाढून 6 ते 8 महिन्यांवरती गेलं. पण हे आपल्यासाठी कधीच सफिशियंट नाहीये की स्टेज 4 लंग कॅन्सर इज लिव्हिंग ओनली फॉर 6 months, 8 months. So there were inventions that went on happening and happening, and there came in 2004 an era of something called as targeted therapy. It is called as tyrosine kinase inhibitor. And these tyrosine kinase inhibitors are called as anti-EGFR therapies. हे का महत्त्वाचं आहे? कारण आपण सरसकट सगळे लंग कॅन्सर एकसारखे ट्रीट करत नाही. आपण म्हणतो ना एखाद्याची कुंडली पाहणं. Likewise, nowadays we are seeing the kundalies of a cancer. What does that mean? आपण DNA लेवलवरती जातो आणि कुठली जेनेटिक अल्टरेशन्स आहेत ते पाहतो आणि we treat those genetic alterations. Say for example, now I'll show you the example. Now this was basically an elderly gentleman with multiple comorbidities and permanent pacemaker implantation. He was diagnosed with a lung cancer with large left hilar mass. We can clearly see in the left hilar there is a large mass. Now because of multiple factors there were limitation in terms of treating him. We did a biopsy. We found to have adenocarcinoma of lung. We did something called as driver mutation analysis आणि त्याच्यामध्ये आम्हाला लक्षात आले की there is EGFR mutation. हे EGFR त्या पेशंटच्या ट्यूमरच्या DNA लेवलला असतं आणि today we have very efficient anti-EGFR therapies. We can clearly see that in a span of 2 to 3 months of treatment from left-sided image, it has significantly gone down. So it simply means without compromising the quality of life, without chemotherapy, we are targeting the cancers based on their nature. Another patient, we can clearly see on the left side, it is completely, shadowed. We can often label it as an ARDS or multiple cannonball opacities. But this is something, an advanced lung malignancy, which was treated with simple tablets, and we can clearly see marked improvement in the lung cancer patients. सो आपण नेहमी म्हणतो की ब्रेस्ट कॅन्सरसाठी आपल्याकडे स्क्रीनिंग मेथड्स आहेत, मॅमोग्राफी असते, सोनो मॅमोग्राफी असते. लंग कॅन्सरमध्ये भारतामध्ये कुठल्याही प्रकारच्या स्क्रीनिंग प्रोटोकॉल्स एस्टॅब्लिश्ड नाही आहेत. पण अमेरिकेच्या संशोधनानुसार काही स्पेसिफिक हाय रिस्क पॉप्युलेशन असते की ज्याच्यामध्ये जर तुम्ही स्क्रीनिंग केलं, स्क्रीनिंग विथ द हेल्प ऑफ समथिंग कॉल्ड एज LDCT. LDCT म्हणजे लो डोस सिटी स्कॅन्स. सो यू कॅन पिकअप मोर नंबर ऑफ पेशंट्स ॲज कम्पेअर्ड टू चेस्ट एक्सरे. हे कोणामध्ये करायचं की ज्या पेशंटचं वय 50 ते 80 आहे, ज्यांची स्मोकिंग हिस्ट्री 20 पॅक हिस्ट्री आहे. लो डोस सिटी स्कॅन इज प्रेफर्ड इन दोज पेशंट टू पिकअप द अर्ली डायग्नोसिस ऑफ लंग कॅन्सर. Now coming to the last portion of a lung cancer treatment, it's just not the tablets that we give. There's something called as immunotherapy. And these two gentlemen, on the left side, he's Tasuko Honjo, and on the right side, James P. Allison from US. Tasuko Honjo is from Japan, and these two gentlemen were awarded a Nobel Prize in the subject of medicine for a discovery of immunotherapy. Immunotherapy म्हणजे काय? It's basically anti-cancer treatment आहे एक प्रकारची की जी सलाईन मधनं दिली जाते. ती कशी काम करते? आपल्याला माहिती आहे की किमोथेरपी सरसकट सगळ्या पेशींना मारते, चांगल्या आणि कॅन्सरच्या सुद्धा. इम्युनोथेरपी काय करते? आपल्याला माहिती आहे की कॅन्सर सेल्स आर व्हेरी स्मार्ट सेल्स. दे रिमेन हिडन फ्रॉम द इम्युन सिस्टम ऑफ द बॉडी. दिस इम्युनोथेरपी मेक्स these cancer cells recognized by your body as foreign and specifically target them by enhancing your own immunity. So it not only avoids the side effects of a chemotherapy, but it also gives better results by maintaining the quality of life. So these are the various indications nowadays we are actually using immunotherapy in, and this list is ever increasing. Next slide. So coming to second case, lymphoma. So this gentleman, he was 32 years old, 34 years old. He came to me 2-3 months back. He is an IT professional and he came with some swelling in the axilla. He was being treated by some suspected axillary abscess for 3 to 4 months of duration, but it was not resolving. Subsequently, he started developing constitutional symptoms. Weight loss suru zala, fever, night sweats. So looking at the history of the patient, it was looking clinically like an lymphoma, but we need to clear it with the help of biopsy. आता याच्यामध्ये तुम्हाला एक ग्लिच सांगतो की why it is important to have some good oncopathologists with you. Now when this gentleman came to me, we did a biopsy. Initial biopsy suggestive of non-Hodgkin's lymphoma. There is one variant which is called as T-cell rich, histiocyte rich, non-Hodgkin's lymphoma. But मी जेव्हा ती स्लाइड एक सेकंड ओपिनियन साठी पाठवून दिली, that non-Hodgkin's lymphoma turned to be Hodgkin's lymphoma. So why this happened? Basically, there is a close connection between some histopathologies of lymphoma which has to be picked by an experienced eye. So we treated this patient of Hodgkin's lymphoma ऑन द बेसिस ऑफ नॉन हॉजकिन्स लिम्फोमा, कारण ह्या दोन प्रकारच्या एंटिटीज ज्या आहेत इथे, NLPHL म्हणतो आपण त्याला, नोड्युलर लिम्फोसाइट प्रिडॉमिनंट हॉजकिन्स लिम्फोमा, इट इज ट्रीटेड लाईक अ नॉन हॉजकिन्स लिम्फोमा. सो दिस पेशंट वॉज स्टार्टेड ऑन नॉन हॉजकिन्स लिम्फोमा प्रोटोकॉल. आपल्याला सगळ्याला माहिती असेल की कॉम्बिनेशन ऑफ आर्चॉप म्हणतो आपण त्याला, रिटुक्झिमॅब प्लस chemotherapy combination. So this patient was started on R-CHOP combination. He received 3 doses of chemotherapy with immunotherapy, and this was the result. You might feel that, you know, this picture has been edited, but this is not the truth. This is actually a reality, that these lymphomas literally melt with such kind of immunotherapy and targeted therapy. And this patient is doing relatively well after 6 cycles of R-CHOP. He's asymptomatic, and next immediate step that comes is basically radiation therapy for him. Now coming to the last 2 cases, first one is actually breast cancer. What are the signs and symptoms of breast cancer? Most breast lumps are cancerous. 80 to 85% breast lumps are non-cancerous. 15% breast lumps are cancerous. That doesn't mean that you are in 15%, I need not to worry. कारण तुम्हाला हे माहित नसतं की तुम्ही 85% मध्ये आहात की 15% मध्ये आहात. सो एनी सस्पिशियस ब्रेस्ट लंप हॅज टू बी इव्हॅल्युएटेड. So these are the various signs and symptoms of breast cancer: lump in the breast or in the underarm, thickening of the skin of the breast, any nipple discharge, change in the shape of the breast or the nipple areolar complex, or apart from bloody discharge, any other brownish discharge from the blood has to be investigated. So what are the steps of early diagnosis of a breast cancer? Breast self-examination and clinical examination by a doctor. So this is something age-old principle of diagnosing breast cancer, and it is called as triple assessment. Nothing has replaced it so far. History and physical examination, imaging and pathology findings. Core biopsy. Nowadays what happens now? We get lot of patients coming from the periphery. They undergo FNAC testing, and there is evidence of some atypical cells seen, and basically patient undergoes surgery or they have been referred to the higher centers. So I request all of you that whenever you are suspecting some kind of breast lump, biopsy has to be done. Biopsy is a compulsory modality because it not only establishes a diagnosis, but it also classifies breast cancer into one particular type. Because we need to understand these treatment options are varying based on the type of the breast cancer. There are 4 types of the breast cancer, 1, 2, 3, 4. Out of those, I have kept 2 cases actually for you, why it is important to understand. So this is one patient, XYZ, 60 years old, postmenopausal lady, comorbidities such as diabetes, hypertension, on regular treatment. She presented with large breast lump. Crooked biopsy of the breast lump revealed histopathological examination showing infiltrating ductal carcinoma. This is something which is very important for us to understand the type of breast cancer that we are dealing, because the treatment differs. In this patient, ER and PR were positive and HER2 was negative. Why it is important to understand? Because whenever any breast cancer diagnosis is established, we need to stage a disease and we need to see whether the patient is localized, locally advanced or metastatic. In this case, the patient was metastatic. We can clearly see this was basically a baseline scan, and we can clearly see that there was a breast mass and there was a diffuse mediastinal lymph nodal mass, lung nodules and diffuse pleural thickening. We can clearly see the pleural thickening here. And as I told you that this patient was ERPR positive and was started on targeted therapy with the help of tablets. This patient showed significant response, and we can clearly see that this is the scan report after 6 months of a treatment. This pleural thickening has also subsided. Believe me, this patient was diagnosed with stage 4 breast cancer in 2021. She is still regularly coming to the OPD. She is currently on tablets and asymptomatic. We haven't given a single chemotherapy so far in last 5 years for a stage 4 breast cancer, particularly this case. Now coming to the last case, why I am emphasizing on it is important to understand the type of breast cancer that we are handling. Initially we saw that that patient had ER and PR positivity and HER2 negativity. This is another patient who had HER2 positive disease, and this ER, PR and HER2, these are nothing but the antenna or the receptors which are present on the cancer cells. presence or the absence decides the type of the breast cancer. Here is a patient, 65 years old lady, diagnosed with CA breast, de novo metastatic disease. Again a stage 4 breast cancer. She was an HER2 positive advanced breast cancer. Believe me, around 30-35 years ago, the median survival of HER2 positive metastatic CA breast was not more than 6 months because there was no targeted therapy available. In 1998, for HER2 positive breast cancer, first targeted therapy came into the picture, that is called as trastuzumab. In my college days, it was a favorite question for the entrance examination in 1998 or so. But from that 1998 till 2026, the treatment of HER2 positive breast cancers is evolved so much, it has gone beyond imagination. Why I am saying so? Let's understand. So this was basically a lady which was diagnosed in late August 2023. She was HER2 positive metastatic breast cancer, and the treatment of choice used to be chemotherapy and targeted therapy in the form of trastuzumab. Then another agent came that was called as pertuzumab. Then another agent came that was called as TDM1. Then another agent came in the form of tablets that was called as lapatinib, and so on. So there are 6-7 anti-HER2 therapies that are currently available. Unfortunately, whenever we used to change the treatment, patient used to respond for a brisk time again to progress. We can see the timeline: August 2023, October 23, March 23, and probably this was in June 24 or so. So we gave multiple lines of treatment. Why I am putting these slides? Because there is something called as ADC. ADC is nothing but antibody drug conjugate. And this is another treatment modality used in treatment of cancer, especially HER2 positive breast cancers. And when the patient came to us after this, and we started using this something called as ADC, and we can clearly see, believe me, I am not exaggerating, this scan is the latest scan of the patient done 2 months back. So HER2 positive metastatic breast cancer patient doing so well with latest treatment advances in the form of antibody drug conjugates. I think this is something unbelievable. And being all primary healthcare providers, it is our duty to educate our patients. बऱ्याच वेळेला काय होतं, पेशंट आपल्याकडे येतो आणि आपल्याला फारसं ऑन्कोलॉजीबद्दल माहिती नसतं, मग आपण त्यांना सांगतो की तुम्ही या ठिकाणी जा, तुम्ही त्या ठिकाणी. इट इज व्हेरी इम्पॉर्टंट बेसिकली फॉर अस टू चॅनलाइज दिस पेशंट्स into proper direction so that they will take the treatment and utilize the latest advances in the medical oncology. So, and managing cancer patient is not a single person's job. It's a team effort. It's basically a multidisciplinary tumor board approach. Surgical oncologists, medical oncologists, and radiation oncologists has to work to get maximum result. And coming to the last slide of my talk, this is called as precision oncology. मी तुम्हाला सुरुवातीला म्हणलं होतं की आपण आजकाल सगळे कॅन्सर ॲज अ ब्लँकेट ट्रीटमेंट देत नाही. आपण एखाद्याची कुंडली पाहतो तशी कॅन्सरची कुंडली पाहिली जाते, and this is called as precision oncology. This simply means we treat a cancer based on its personal or individualized medicine. दोन ब्रेस्ट कॅन्सरचे पेशंट सुद्धा सारखे ट्रीट होत नाहीत बिकॉज देअर नेचर इज डिफरंट, देअर बायोलॉजिकल मेकअप इज डिफरंट. आपण म्हणतो ना स्वभावाला औषध नाही, लाईकवाईज आपल्याकडे औषध आहे, फक्त स्वभाव कळणं गरजेचं आहे. थँक्यू सो मच फॉर द पेशंट लिसनिंग. I will be happy to accept any questions either now or at the end of the program regarding oncology. Thank you so much.
Sir, Hello. Now may I request Dr. Srenik Shah sir to felicitate Kulkarni sir. Sir, where's our photo yet? And Kunji sir also.
Now I request Atul Kahate to speak on AI in medicine. Actually, अतुल काहते ची खरं तर इंट्रोडक्शन द्यायची म्हणजे खरं खूप मोठी इंट्रोडक्शन आहे अतुलची. त्याच्यासाठी एक लेक्चर करावं लागेल, परंतु बेसिकली थोडक्यामध्ये जर अतुलची ओळख करून द्यायची झाली तर ही इज अ सॉफ्टवेअर प्रोफेशनल अँड ट्रेनर. ही इज करंटली टीचिंग Agenic AI at Indacon and many other subjects at CDAC, which is a government institute. He worked in the currently he is teaching Agenic AI at Indacon and many other subjects at CDAC, which is a prestigious institute at Pune. He works in the IT industry, mainly in technical and hands-on roles for more than 25 years. And his training experience of about 25 years as visiting faculty, and he has authored 80 books and over 300 articles he has written. His basic education is in BSc Statistics and MBA in 1993 and 95. He has a special skills in Agenic AI, that is Open AI, Crew AI, AutoGen, deep learning, neural networks, NLP, programming like Java, Python, C, C++, microservices, Spring Boot, Flask. He has so many skills, so I will not go in that details. He is trainer at CDAC Pune, Edureka, from March 2022 till date. He has trained thousands of IT professionals and students on Agenic AI and a variety of subjects ranging from artificial intelligence, machine learning to development operations and cloud. Also conducted corporate trainings. He is a software professional at Sintel, American Express, Deutsche Bank, LTI, Oracle, REI Advisory from June 1995 to March 2022. Worked on many complex software projects and products in roles ranging from developer to head technology, worked in India, England, Germany, USA, Singapore. And he is a visiting faculty at Symbiosis International University, Pune from January 2001 to January 2022. He has taught many technical subjects for students of Master of Computer Application and Master of Business Administration. And he has authored many books on computer science, which are published by the prestigious publishers like McGraw-Hill and Pearson, on subjects such as cryptography and network security, web technologies, operating systems, DBM, C++, and also authored many non-fiction books on Marathi on subjects ranging from biographies to economics and finance. Many of these won several awards, and he is a regular contributor to leading Marathi newspapers. So this is in short introduction of Atul Kahate. परंतु जर दुसरी ओळख सांगायची म्हटलं तर आपल्यातल्या बऱ्याच जणांना अच्युत गोडबोले माहीत असतील तर अच्युत गोडबोले हे अतुलचे मामा आहेत. आणि दुसरी माझी जवळची ओळख सांगायची म्हटलं तर माझी आणि आर आर शिंदे आपले चेअरपर्सन आहेत, त्यांचा जो क्लासमेट आहे केदार काहते त्याचे ते भाऊ आहेत. आणि त्या प्रेमापोटी खरं तर खूप अडचणी असताना सुद्धा अतुल या लेक्चरसाठी आला, त्याबद्दल मी धन्यवाद मानतो आणि ओव्हर टू अतुल.
Hello. Okay, very good afternoon to all of you. मी थोडक्यात AI for doctors या विषयावर मला जे वाटतं ते सांगायचा प्रयत्न करीन. Of course, it's a big irony. I am not a doctor. I am the only person in my family who did not or could not become a doctor. And I am speaking to doctors on a completely different subject. But anyway, so what I have tried to do is to just give a glimpse of what kinds of tools are available for doctors. Secondly, I know there is some kind of fear in the minds of everyone as to whether AI will replace us, AI will do all our jobs. आणि या भीतीपोटी, right from software developers to doctors to engineers to lawyers, everyone is extremely worried. So how we can actually utilize AI to our advantage rather than fearing about it, अशा काही गोष्टींवर मी बोलायचा प्रयत्न करेन. So first tool I would recommend to all of you is a very simple free open tool called Notebook LM, which is from Google. आणि त्याचा थोडक्यात if you just want to have a quick look at this Notebook LM. So anybody can log into this Notebook LM, and then you can use this software. So all you have to do is to go to notebooklm.google.com. तर याचा फायदा काय आहे? So if you, for example, click on create new, this will allow you to create something like a personal workspace, which you can use to, for example, store all your files either related to a personal, let's say detail, secondly about a case. मी आता उदाहरणार्थ एखादी केस असेल आणि त्या केसशी संबंधित असलेली डॉक्युमेंट्स भराभर येत आहेत. लेट्स से डॉक्टर्स आर डायग्नोसिंग, कुठल्या डॉक्टरला वेळ नाही आहे, सो दॅट डॉक्टर हॅज मे बी व्हर्बली सेड समथिंग. यू माइट हॅव इमेजेस, लेट्स से स्कॅन्स वगैरे. हे सगळं एके ठिकाणी समजा आपल्याला ठेवायचं असेल, what you could do is to drop all those files here, or if you want to search something on the internet, हे सगळं आपल्याला एके ठिकाणी करता येतं. आणि वन्स यू डू इट, सो आता माझ्याकडे अर्थात अशा डायग्नोसिस वगैरेच्या फाईल्स नसल्यामुळे आय जस्ट मे बी upload one file which is let's say related to my area of work, but we will still see the advantage. So once I upload a particular document, आता इथे आपल्याला अशी भरपूर डॉक्युमेंट्स अपलोड करता येतात आणि त्याच्यानंतर this becomes a completely searchable database. It's not just documents, so you can upload images, you can do a lot of work here. आणि आता याच्यानंतर it has immediately understood what this document is all about. So it has read the document, it's telling us that this is some academic curriculum and teaching guidelines document. तर याच्या ठिकाणी समजा it was for example some diagnosis, patient history, whatever else you regularly use, ही सगळी माहिती इथे एका क्षणात येईल. आणि त्याच्यानंतर I can start querying this. So for example I can say give me a crisp summary in 3 bullet points. तर आता या डॉक्युमेंट मध्ये काय आहे, समजा there is a very busy senior doctor who has no time to go through all of this. So you can just say give me 3 bullet points. What are the key areas that I need to focus on? आता अशी समजा लेफ्ट साईडला आपल्याकडे एकच डॉक्युमेंट आहे, बट इमॅजिन दॅट वी हॅव से 100 डॉक्युमेंट्स, 10 इमेजेस, सम ऑडिओ फाइल्स, व्हिडिओ फाइल्स. इट विल स्कॅन थ्रू ऑल ऑफ दिस अँड इट विल गिव्ह अस अ व्हेरी क्रिस्प समरी. अशा प्रकारची कुठलीही माहिती तुम्ही यातनं मिळवू शकता. ऑल दीज डॉक्युमेंट्स विल बी प्रिझर्व्ड फॉर एव्हर. सो ॲट एनी पॉईंट ऑफ टाइम इफ यू नीड टू गो बॅक अँड रेफर टू दीज, दे आर देअर. त्याच्यानंतर some stunning things it can do. So for example, now you say I want an audio summary of this. So you don't have the time even to go through and read, but let's say while traveling or walking, as many people do, आपल्याला हे कानाला लावून फक्त ऐकायचं आहे what has happened, or let's say all the cases that are there for today, just upload all the files, get an audio summary and it will narrate for us. आता एक कधी कधी फेल होतं. आय विल ट्राय, सो आय विल जस्ट कीप इट फॉर ऑडिओ जनरेशन. अनदर वंडरफुल फीचर इज यू कॅन डू दिस इन एनी लँग्वेज ऑफ युअर चॉईस. म्हणजे फक्त इंग्लिशमध्येच केलं पाहिजे असं नाही. देन सपोज याच्यावर आपल्याला काहीतरी इंटरनल डिस्कशनसाठी वी वॉन्ट टू मेक अ स्मॉल प्रेझेंटेशन, जस्ट क्लिक हिअर, इट विल क्रिएट अ PPT. इफ लेट्स से यू वॉन्ट टू जस्ट हॅव अ माइंड मॅप, म्हणजे थोडक्यातचं सिक्वेन्स काय आहे, कुठून काय कसं फ्लो झालं आहे, सो इट विल क्रिएट अ माइंड मॅप. या 1-2 गोष्टी होतील त्या मी दाखवीन तुम्हाला. You can create reports, you can create flashcards. आता हे some of us may be teaching medicine somewhere, I'm sure. तर त्या ठिकाणी हे खूप उपयुक्त ठरतं. म्हणजे समजा आपल्याकडे खूप माहिती आपण काहीतरी गोळा केली आणि ती अपलोड केली आहे. यू कॅन क्विकली जनरेट फ्लॅश कार्ड्स. ओके, हे एक एक जनरेट झालं की वी विल सी. यू कॅन जनरेट क्विझेस, इन्फोग्राफिक्स, लॉट ऑफ थिंग्स अँड इवन अ व्हिडिओ बेस्ड एक्सप्लेनर. ओके, तर आपल्या ज्या गोष्टी आता तयार होतील त्या मी दाखवीन. सो इट इज जनरेटिंग फ्लॅश कार्ड्स. त्यांनी माइंड मॅप नावाची गोष्ट ऑलरेडी तयार केली आहे. सो सी व्हॉट इज द मेन टॉपिक, सब टॉपिक, त्यातनं आणखीन काय कॉम्प्लेक्सिटीज आहेत, त्यातनं मला आणखीन एखाद्या गोष्टीचं डिटेल पाहिजे. सो ऑल ऑफ दिस बिकम्स ऑटोमॅटेड अँड एक्स्ट्रीमली फास्ट अँड दिस इज कम्प्लिटली फ्री. आपल्याला एक खूप मोठ्या स्केलवर वापरायचं असेल तर वी कॅन गो फॉर अ पेड व्हर्जन. पण तसं नको असेल अँड वी आर युझिंग फॉर अवर डे टू डे वर्क, all of this becomes very simple and directly usable. Okay, so I would personally recommend that we take a look at this tool called Notebook LM from Google, and I think this will give us something wonderful. आता हे flashcards मगाशी मी म्हटलं होतं. So this is very useful for teaching. So it will generate, for example, questions, and then a quiz can be taken. It will show you the answers. And every time you do it, it will keep generating different questions, different answers. Okay, so it's extremely interesting, very powerful for teaching kinds of assignments. Audio generation झालं तर I will show you. That's really wonderful. It's actually a conversation between two people, AI generated voices, which will describe what is there in the document. So imagine two people discussing the case. Going through all the details in a very professional manner, almost as if there are two experts. Okay, so if it happens, I'll show you. In the meanwhile, I have just taken some different cases, based on my understanding of the challenges that doctors face. So first challenge could be writing very time-consuming reports. Many times, let's say we want की आपल्याकडे काहीतरी जनरल फाइंडिंग्स आहेत. लेट्स से देर इज अ रेडिओलॉजिस्ट हू सेज दॅट देर इज सम सिटी स्कॅन डन आणि त्याच्यामध्ये हे आता फाइंडिंग्स आलेले आहेत. पण हे सगळं रिपोर्टमध्ये लिहित बसण्याची आपल्याकडे एकतर तेवढा आपल्याकडे वेळ नसतो. दुसरं म्हणजे देर आर ऑब्वियसली अर्जंट केसेस पेंडिंग. लेट्स से देर इज अ क्यू ऑफ पेशंट्स. मग हे सगळं कोण करणार? सो दिस बिकम्स अ मे बी अ साईड सॉर्ट ऑफ effort on our side. Somehow we have to do it, but now today we have excellent simple tool such as ChatGPT where we can ask it to do it. So what we could simply do is just copy this. Okay, so I go to ChatGPT, I paste it, and I give a prompt where I say generate a structured radiology report with findings and impression. आणि याचा रिपोर्ट बघा. म्हणजे आय एम नॉट ऑब्वियसली आय डोंट नो एनी ऑफ दीज, बट all of you are experts here, but you will see based on my limited understanding that it looks very professional, almost like it's coming out from let's say a real expert or a doctor. So findings, impressions, recommendations. Then it also says going forward, do you want a patient friendly explanation? की आता पेशंटला समजावून सांगणं बरेचदा अडचणीचं होतं. सो आय विल से येस. की आता हे पेशंटला समजावून सांगायचं असेल तर व्हॉट डज द स्कॅन शो, व्हॉट कुड इट मीन. ओके, कॅल्शियम डिपॉझिट आहे वगैरे वगैरे. व्हॉट इज नॉर्मल, व्हॉट इज मे बी ॲबनॉर्मल, व्हॉट शुड यू डू नेक्स्ट. आता unfortunately the patient understands only Marathi, so I will say give in Marathi. आता हे सगळं करण्यासाठी आपण जी मेहनत घेत असतो, इमॅजिन This is happening in seconds. आणि you can say anything. For example, आता समजा मी म्हटलं की हे आहे हे मला नीट कळत नाहीये. अजून सोप्या भाषेत म्हणजे तुम्ही कुठल्याही लेवलला जाऊ शकता. म्हणजे हे एखाद्या एक्सपर्ट डॉक्टर म्हणजे जे सुरुवातीला मी म्हटलं की जी भीती वाटते AI विल रिप्लेस अस, ही यामुळे वाटते की हे जर का आता घर बसल्या कुठलाही माणूस करू शकत असेल तर तो आपल्याकडे कशाला येईल, अशी एक लोकांना भीती वाटते. तर मला वाटते हे असं होणार नाही. म्हणजे आय डोंट थिंक AI विल रिप्लेस एक्सपर्ट्स, ही भीती अनाठायी आहे. I think what will happen is that people who already are mediocre, म्हणजे जे खरोखर काही फार ग्रेट काम करत नाहीत, त्यांना ही भीती निश्चित आहे. आणि इट कुड बी इन एनी फील्ड. म्हणजे फॉर एक्झाम्पल that's what we see in software field also. People who are just software programmers, they are the first ones who are getting replaced. कित्येकदा असं झालेलं आहे की याच्याकडनं कोड लिहून घेतला लोकांनी, म्हणजे त्यांना हे काम दिलं की याच्याकडनं कोड लिहून घे, आणि तो कोड लिहून घेतल्यानंतर ज्यांनी तो कोड लिहून घेतला त्यांनाच काढून टाकलं, कारण त्यांना त्याच्या पलीकडे येतच नाही काही. म्हणजे AI कडनं फक्त अशा प्रकारची कामं करून घेणं एवढंच त्यांचं स्किल होतं. पण प्रत्येक फील्डमधले जे एक्सपर्ट्स असतील, आय थिंक AI ला घाबरण्यापेक्षा AIचा वापर करून हाऊ कॅन वी इन्क्रीज आवर प्रॉडक्टिव्हिटी, अशा दृष्टीने जे लोक AI कडे बघतील, देर इज नो लिमिट. म्हणजे व्हॉट AI कॅन डू, if you have not seen some such things before, you will be zapped. कुठल्याही क्षेत्रातली कुठलीही गोष्ट त्याला माहीत नाही असं नाहीये. म्हणजे आता हे आज मेडिसिन मला काही कळत नाही, पण मला यातलं बघून काही काही थोड्याशा गोष्टी कळू शकतात, असं आताचं चित्र झालंय. आणि यू गो टू लीगल ॲस्पेक्ट्स, यू गो टू इंजिनिअरिंग, यू गो टू सायन्स, यू गो टू आर्ट्स. आता मी समजा त्याला सांगितलं काय वाटेल ते करू शकतो हा. म्हणजे आता समजा मी त्याला सांगितलं मला रिपोर्ट पु ल देशपांडेच्या स्टाईलमध्ये लिहून दे, म्हणजे याला काय अंतच नाहीये. काय तो करू शकेल आणि काय नाही, आपल्याला वाटेल ते जगातलं तुम्ही जे म्हणाल ते क्षणात तुमच्या समोर हजर आहे. म्हणजे काही गोष्टींमध्ये मेंदूमध्ये सुद्धा विनोद शोधावा असं म्हटलं तर इथे आता आपल्याला दिसेल. इन अ मीन वे नोटबुक LM, आता हे मी तुम्हाला ऐकवतो. साऊंड येत नाही मला वाटतं इथे. ठीक आहे, हे झालं तर मी प्ले करतो. तोपर्यंत पुढच्या गोष्टी बघूया. दुसरी एक कटकट आता आपण ऍक्च्युली बघितली, पेशंट्सना रिपोर्ट्स एक्सप्लेन करा. आता उदाहरणार्थ काहीतरी MRI फाइंडिंग्स आहेत, हे आता पुन्हा मला काही कळत नाही, मी हे कुठल्या कुठल्या रिपोर्ट्स मधनं घेतलंय. तर आता हा ऑर्थोपेडिक सर्जन, लंबर स्पाइन मध्ये काहीतरी डिस्क बल्ज. सो एक्सप्लेन दिस टू अ पेशंट. ओके, पुन्हा तेच, व्हॉट इज अ डिस्क. आता हे आणखीन किती सोपं करायचं, म्हणजे आता माझ्यासारख्या माणसाला व्हॉट इज अ डिस्क. थिंक ऑफ डिस्क एज सॉफ्ट कुशन्स बिटवीन द बोन्स ऑफ युअर स्पाइन. एका क्षणात कुठल्याही पेशंटला कळेल. दे हेल्प इन ॲब्झॉर्बिंग शॉक, अलाउविंग मुवमेंट. डिस्क बल्ज म्हणजे काय, थिकल सॅक, आय डोंट नो व्हॉट इट मीन्स व्हॉट, आणि तुमच्या केसमध्ये नेमकं काय होत आहे. ओके, याचे सिम्पटम्स काय आहेत, हे सिरियस आहे का. आता समजा आपल्याला हे आवडलं नाही, हे आउटपुट काय एवढं चांगलं नाही, हे चालू आहे का.
Right, because nobody. So we are in 2026 right now.
Yeah, we are.
And we're building artificial intelligence that can, literally write its own software.
Right, autonomous orchestrators managing entire fleets of servers.
Exactly, without any human intervention at all. So, why is a premier tech institute forcing its most advanced students to spend 60 exhaustive hours mastering text commands from an operating system that was built back in 1991?
It sounds totally backwards, doesn't it?
It really does. Welcome back to another Deep Dive, everyone. Today we are...
हे काय आहे तर मी दिलेलं जे डॉक्युमेंट आहे ते डॉक्युमेंट वाचून AI जनरेटेड व्हॉइसचं ते डिस्कशन चालू आहे त्या डॉक्युमेंटच्या बद्दल. असं जगातलं कुठलंही डॉक्युमेंट तुम्ही दिलं तर ते समजून घेईल आणि त्या दोन माणसांमधलं डिस्कशन होईल.
looking at the absolute bedrock of our digital infrastructure.
The invisible stuff that makes everything actually run.
Right. We have this fascinating blueprint on the table today. It's the February 2026 Suggested Teaching Guidelines for Linux Programming and Cloud Computing, PGCP BDA.
From ACTS Poon.
Yes, exactly.
And it is honestly an incredibly revealing document. What we had here isn't just like a normal syllabus.
No.
No, it is a 60-hour intensive stress test for engineers. I mean, it's broken down into 28 hours of theory, 22...
Final deployment script version 4, actually final.ash.
Oh, we've all been there. It's terrible.
It really is.
But Git isn't just a backup system. It's a cryptographic ledger for code. The self-learning...
आता हे ऐकून कोणाला वाटेल की हे खरोखर दोन माणसांमधलं संभाषण नाहीये. म्हणजे आपण सगळ्या पेशंट हिस्ट्री केसेस वगैरेचं अपलोड केलेलं असेल त्या सगळ्याचं सार काढून ही दोन माणसं बोलतील. तुम्ही आणखीन एक डॉक्युमेंट टाकलं पुन्हा ते अपडेट करतील त्यांचं कॉन्व्हर्सेशन. हे असं सातत्याने तुम्ही करू शकता. म्हणजे याला पुन्हा काही अंतच नाहीये. हे किती वेळेला कराल आणि पुन्हा वर तुम्हाला हव्या त्या भाषेमध्ये हे करू शकता तुम्ही. समजा या सगळ्याची समरी पुन्हा तेच म्हणजे आता हे काढून आपल्याला ते पेशंटला द्यायचे काहीतरी हिस्ट्री तुम्ही ही ऑडिओ फाईल जनरेट झालेली ती ऑडिओ फाईल देऊ शकता रादर दॅन डिस्क्रायबिंग एनिथिंग. ओके. नेक्स्ट तिसरी गोष्ट डॉक्युमेंटेशन ओव्हरलोड. सगळ्या हॉस्पिटल्समध्ये हा प्रॉब्लेम होतो की खूप डॉक्युमेंटेशन असतं आणि ते करायला ऑब्वियसली डॉक्टरांना वेळ नसतो. हाताखाली माणसं असतील तरी किंवा डिक्टेशन वगैरे ते द्यायला लागतं काहीतरी इन्स्ट्रक्शन्स द्यावे लागतात. सो आता समजा एक साधी गोष्ट आहे पेशंट कंप्लेन्स ऑफ फीवर फॉर लास्ट 3 days कफ माइल्ड ब्रीथनेस ऑक्सिजन सॅच्युरेशन 94% नो कोमॉर्बिडिटीज. आता हे डॉक्टरांनी ह्या पटकन नोट्स दिल्यात पण हे पुन्हा कोणीतरी नीट फॉर्मॅट करायला पाहिजे. तर आता याच्या क्लिनिकल नोट्स नेम एज डेट fever for 3 days, these were the chief complaints. History of present illness, vitals, past history, provisional diagnosis, plan management, red flag signs. म्हणजे आता कृपा करून थांब असं म्हणायची वेळ येईपर्यंतचे डिटेल्स सगळे मिळतील. आपण समजा म्हटलंय खूप डिटेल्ड आहे, टू डिटेल्ड. म्हणजे माणसाला जेवढं समजावून सांगावं लागत नाही तेवढं एक शब्दात 2 शब्दात त्याला कळतं. तो म्हणतो ओके हिअर इज अ शॉर्ट अँड क्लीन व्हर्जन. आता आणखीन काय पाहिजे टाका. ओके. नेक्स्ट प्रॉब्लेम डिस्चार्ज समरीज. खूप पुन्हा ही माहिती आपल्याकडे थोडक्यात असते आणि ही माहिती खूप लांब लचक भरत बसण्या इतका वेळ नसतो. पण बरेचदा इन्शुरन्स कंपन्यांना ती लागते किंवा पेशंटच्या हिस्ट्रीसाठी ती लागते. आणि कदाचित मग आपल्याला वाटेल हे चॅट जीपीटी मधनंच सगळं होतंय का, तर चॅट जीपीटी नाही, आपल्याकडे गुगल जेमिनाय पण आहे. कधी वाटलं की हे चॅट जीपीटीचं आउटपुट जे येतंय ते तेवढं चांगलं नाहीये, तेच तुम्ही जेमिनायमध्ये टाकू शकता आणि दोन्हीचं कंपॅरिझन करू शकता. काही क्रिटिकल गोष्टी असतील त्या इथून व्यवस्थित आल्या नाहीत. आता डिस्चार्ज समरीचं काही आपण कंपॅरिझन करणार नाही, पण खरोखर काही क्रिटिकल गोष्टी असतील तर चॅट जीपीटीने काय दिलंय, गुगल जेमिनायने काय दिलंय आणि दोन्हीमध्ये काय कंपॅरिझन होऊ शकतं हे पण बघू शकता. नेक्स्ट, क्लिनिकल केस समरीज. आता 65-year-old male, chest pain for 2 hours, sweating, blood pressure is this, ECG shows ST elevation in anterior leads. Summarize key clinical points. आता हे नुसतं समरी नाही आहे, सो वी आर आस्किंग इट टू गो डीपर, म्हणजे ऑलमोस्ट ॲज इफ इट्स अ डॉक्टर, अँड ॲनालाइज दिस. Okay, I don't know whether it is correct or not, पण see, म्हणजे we can ask Gemini also, ki given this, right? म्हणजे खरोखरच सॉफ्टवेअर इंजिनियर्सनी BE कम्प्युटर सायन्स का केलं आणि डॉक्टरांनी आपण MBBS का केलं असा प्रश्न पडावा अशी परिस्थिती आहे आता. अनदर कॉमन थिंग, रायटिंग रेफरल लेटर्स, टाइम कन्झ्युमिंग टास्क. आपल्याला आता केस रेफर करायचे कार्डिओलॉजिस्टला, so patient with persistent knee pain, swelling, difficulty walking, no trauma history, and we want to refer this to, let's say, an orthopedic or any surgeon. More detailed. Okay. Next, information overload, constantly new information coming in. Explain new diabetes drug in simple terms. Okay, so explain atayka SGLT2, I don't know, inhibitors in very simple terms for a doctor who is not a specialist. मला माहित नाही बरोबर आहे का नाही, पण हे पुरे नाही असं म्हणून तो म्हणतो कंपॅरिझन विथ सम अदर थिंग्स, क्विक प्रिस्क्रायबिंग अल्गोरिदम. त्याला म्हटलं गिव्ह इन टेबल फॉर्म. One page prescribing flowchart. Okay. Next. Language barriers with patients. मगाशी बघितलं आपण, पण translate something to Hindi, Marathi. तुम्हाला हलका फुलका न्यूमोनिया झालेला आहे. औषधे वेळेवर घ्या, उपचार पूर्ण करा. साधारणपणे खालील औषधे दिली जातात. पॅरासिटामॉल, अँटीबायोटिक, खोकल्यासाठी. काळजी काय घ्यायची तेच पुन्हा हिंदीमध्ये. आपको हल्का निमोनिया, फेफड़ों का इन्फेक्शन है, दवाइयाँ नियमित रूप से ले, पूरा कोर्स करे. आमतौर पे दी जाने वाली दवाइयाँ ये हैं. आता तो म्हणतो इफ यू वॉन्ट आय कॅन मेक दिस इनटू अ प्रिंटेबल ओपीडी इन्स्ट्रक्शन स्लिप. म्हणजे डॉक्टर कसं काम करतात हे पण त्याला माहिती आहे. ॲड हॉस्पिटल लोगो ब्रँडिंग. ओके, त्याच्या सकट तो करून देईल. नेक्स्ट, रिपीटेटिव्ह पेशंट क्वेरीज. व्हॉट इज डायबिटीज वगैरे वगैरे. सो इट कॅन गिव्ह व्हेरी क्लीन एक्सप्लेनेशन. आय विल नॉट डिस्कस दिस. क्लिनिकल डिसिजन थिंकिंग सपोर्ट. आता हे दिस गोज मच बियॉन्ड द रेग्युलर वर्क. So possible causes for these symptoms: fever, headaches, body ache, platelet count low. List possible causes, not a diagnosis, and what tests to consider. Okay, so what are the possible causes? What tests to consider? Infection specific test, additional test. तर या सगळ्या एक्झाम्पल्स मधून आय होप वी रिअलाइज दी पॉवर ऑफ डुईंग ऑल दिस. आता याच्यामधली पुन्हा मेडिकल बिलिंग समरी आणखीनही काही एक्झाम्पल्स आहेत. इन्शुरन्स क्लेमसाठी काय करावं लागेल, ओपीडी प्रिस्क्रिप्शन फॉर्मॅटिंग, ओपीडी व्हिजिट समरी, अपॉइंटमेंट फॉलोअप मेसेज. म्हणजे इट्स नॉट जस्ट मेडिसिन किंवा हेल्थ केअर रिलेटेड. आणि आणखीन एक दोन एक्झाम्पल्स मला जी दाखवायची आहेत. सो आय जस्ट टेकन सम इमेजेस. फॉर एक्झाम्पल डॅमेज टू एन आय. आणि व्हॉट लेट्स से फॉर एक्झाम्पल चॅट GPT विल से अबाउट इट. Okay, the damage eye, it's a picture. So we upload this to ChatGPT and say, tell us what do you think are the reasons. So it says it has a well-defined bright red patch on the white part, sclera. So what are the most common causes? Suggest a subconjunctival hemorrhage. What are the common causes? Small broken blood vessel in the eye. What are the causes? Associated conditions. Less common causes. Other similar conditions. Clinical clues. And it's a small surface bleed in the eye, usually harmless, but check BP and medications. म्हणजे फक्त text नव्हे. If you give images, etc., it can do all kinds of analysis. Okay. Second, a pathology report. So we say analyze this pathology report. कधी कधी असं वाटतं आपण ते अपलोड करायच्या आतच उत्तर येतं का काय. So it's kidney function, what is normal, what is low, what are the key points, liver function, overall clinical impression, what to check clinically, what are the next steps. Okay. Another case is X-ray. Okay, so it says what is seen? Spine alignment, vertebral column appears centrally aligned, no obvious sclerosis or gross deviation. बाकी मला ते शब्दही वाचता येत नाहीत पण this may be associated with low back pain, stiffness, sometimes radiating pain. What is not seen? Good signs. No obvious fracture, no major deformity, no gross destructive lesion. तर हे ॲक्च्युली मी एकदा करून बघितलं होतं. तुम्हाला कदाचित माहीत असेल पुण्यामध्ये डॉक्टर आशिष रानडे म्हणून ऑर्थोपेडिक सर्जन आहे. तो माझा सोलापूरचा क्लासमेट आहे. तर तो ऑर्थोपेडिक म्हणजे डॉक्टरांना फ्रॅक्चर आहे का नाही, गरीब देशांमध्ये त्यांना ते सगळ्या खूप अवघड असतं शोधणं. तर त्यांनी मला सांगितलं की काहीतरी 2 हाडांमध्ये असा 15 डिग्रीजपेक्षा जास्त अँगल असेल तर याचा अर्थ फ्रॅक्चर आहे, अशी एक काहीतरी टेक्निक आहे. आणि ते AI करू शकेल का असं त्यांनी मला विचारलं. कारण त्यांनी खूप मेहनत करून ते काहीतरी मेथड डेव्हलप केली होती आणि तो केनयाला ते शिकवायला जाणार होता. नेमका आम्ही भेटलो. मग त्यांनी मी म्हटलं तुम्हाला इमेज देऊ शकशील का तशी. तर त्यांनी मला ती इमेज दिली आणि मी त्याच्यासमोरच AI वर टाकलं आणि पुढच्या 2 सेकंदात त्यांनी सांगितलं 2 मधला अँगल 17% आहे म्हणून फ्रॅक्चर आहे. तो म्हणला की हे सगळं करायला इतकं मी धडपडतो आणि इतकं म्हणजे माझा याच्यात वेळ जातो आणि म्हणजे ही वॉज थ्रिल्ड. तर अशाही काही ज्या गोष्टी असतात ज्यामध्ये आपला खूप वेळ जातो. आता मला हे मेडिकल सायन्समधलं काही कळत नसल्यामुळे मी ते कदाचित दाखवू शकत नाही, पण यू आर दी एक्सपर्ट्स. तर जिथे आपला खूप वेळ जातो अशा गोष्टी जरूर ट्राय करून बघा आणि इट ट्रिमेंडसली सेव्स टाईम. म्हणजे मी माझ्या वैयक्तिक अनुभवामधनं सांगू शकतो. मी मेडिसिनबद्दल जरी ऑथॉरिटेटिव्हली बोलू शकत नसेल तरी माझ्या स्वतःच्या कामामध्ये गेली 1 वर्ष मी हे सगळं म्हणजे आय कुड बी वन ऑफ द हायेस्ट युजर्स ऑफ ChatGPT त्यांनी मोजलं ते तर. आणि मला स्वतःला जाणवतं माझी प्रॉडक्टिव्हिटी इट हॅज इन्क्रीज ऑलमोस्ट 10 टाइम्स. इट इज नॉट अन एक्झॅजरेशन. म्हणजे गेल्या 10 वर्षांमध्ये मी जे काही काम करू शकलो असेल नसेल अक्षरशः त्याच्या 10पट काम मी गेल्या वर्षामध्ये करू शकलेलो आहे. याचं कारण रिपिटेटिव्ह ज्या सगळ्या गोष्टी आपण इतका वेळ घालवतो त्याच्यामध्ये, या सगळ्या गोष्टी ते क्षणात होत असतील तर त्याचा फायदा का नाही करून घ्यायचा. म्हणजे मला असं वाटतं की सम पीपल रेझिस्ट AI. म्हणजे याचे डिफरंट आयडिओलॉजीज आहेत. सम पीपल रेझिस्ट AI. दे से की नो वी डोंट वॉन्ट AI. सम पीपल से की AI इज नथिंग, AI ने काही होणार नाही, डोंट वरी. आणि सम पीपल आर व्हेरी स्केप्टिकल की AI विल डिस्ट्रॉय एव्हरीथिंग. तर मला असं वाटतं की समबडी हू लुक्स ॲट दिस पॉझिटिव्हली. Nobody can today stop AI. There is no question. म्हणजे lot of people say की AI समजा असं असेल डिस्ट्रक्टिव्ह आहे. Why doesn't the government stop it? Which government will stop it? And it's very obvious because if this is going to bring more and more money at much lower cost, which business will say we don't want AI? And if business is not going to stop it, why a government will stop it? It's a simple logic. So nobody can stop AI. Second, I don't think AI will replace humans. unless humans continue to become, as I said, more mediocre. म्हणजे त्याच्यात खूप छान वाक्य आहे, मी अलीकडे जे जिथे जिथे संधी मिळेल तिथे सांगतो. तर एक चार्ली मंगर म्हणून होऊन गेले. चार्ली मंगर वॉज द बिझनेस पार्टनर ऑफ वॉरन बफेट, द फेमस इन्व्हेस्टर. सो समबडी आस्क्ड चार्ली मंगर, तुम्ही कदाचित AI च्या संदर्भात मशीन लर्निंग नावाचा शब्द ऐकला असेल, म्हणजे मशीन्स लर्न. सो समबडी आस्क्ड चार्ली मंगर, तुम्हाला मशीन लर्निंग वगैरे बद्दल काय वाटतं? सो ही सेड, आय डोंट अंडरस्टँड ऑल ऑफ दिस, इट्स व्हेरी कॉम्प्लेक्स, बट आय अंडरस्टँड वन सिम्पल थिंग, machines are learning and humans are busy watching reels. यातनं मला वाटतं आपल्याला उत्तर मिळावं की माणसाची अधोगती AIच्या तुलनेमध्ये का चालू आहे. कारण इथे आपण बघतोय जे काम कदाचित त्या फील्डमधले 10, 50, 100 स्पेशलिस्ट करू शकत नाहीत, ते काम जर का इथे 1 सेकंदात होत असेल आणि यू आस्क रिपिटेटिव्हली, न कंटाळता 24/7 इट इज डुईंग and it is ever improving. असं असताना if we don't continue to evolve, obviously AI is going to just destroy us. पण somebody who uses it constructively, म्हणजे you should be in charge, म्हणजे I am in charge of AI, असा तुमचा viewpoint असेल, I don't think there is anything to fear. On the contrary, I would say even doctors who embrace this will rise so fast. There is no doubt about it. म्हणजे मला सरांनी म्हटलं होतं की देर इज वन फिअर इन द माइंड्स ऑफ पीपल, डॉक्टर्स दॅट इज, हु आर रेडिओलॉजिस्ट, पॅथॉलॉजिस्ट, म्हणजे जिथे फार तुम्हाला सर्जरीज वगैरे कराव्या लागत नाहीत, थिंग्स आर स्ट्रेट फॉरवर्ड. सो त्यांचं काय होणार अशी एक भीती लोकांच्या मनात आहे. आणि आय अंडरस्टँड इट, इट्स नॉट समथिंग विच आय विल से इज अनट्रू, बट इफ a pathologist or a radiologist today says that I don't fear it and I am in charge and I'll start using this, see the kind of improvements you will have in your day-to-day work, and the productivity increase and thereby cost reductions. It is massive, it is unimaginable. Unfortunately, I don't know why people don't see it. लोक फक्त हे ChatGPT गंमत वगैरे म्हणून वापरतात. But those who start using it seriously, I can guarantee you, within the next few months, you yourself will realize the kind of power it has, आणि तुमचं किती काम यामुळे सोपं होऊ शकतं. आणि overall, in terms of ultimately, we all also run a business. So from a business point of view also, how it will help you is, I will say, matchless, countless. Okay, so we can take n number of examples, but I hope this glimpse is good enough for us. तर काही प्रश्न असतील, 1-2 वेळ असेल तर आय विल ट्राय अँड आन्सर अँड आय विल स्टॉप. येस सर. ओके, सो देर इज समथिंग कॉल्ड ॲज प्रॉम्प्ट इंजिनिअरिंग, हे कदाचित तुम्ही ऐकलं असेल. तर त्याच्यामध्ये प्रॉम्प्ट्स कसे दिले पाहिजेत वगैरे शिकवलं जातं. म्हणजे आता एक गमतीचा भाग त्याच्यामध्ये असा आलाय की आता इथून पुढे माणसाचं काम काय असेल तर AIला प्रॉम्प्ट देणे असं म्हटलं जातं गमतीने. म्हणजे वी आर रिड्यूस टू गिव्हिंग प्रॉम्प्ट्स टू AI विल डू द वर्क. पण ऑन अ सिरियस नोट, ॲक्च्युली नाव दे हॅव बिकम सो ह्युमन फ्रेंडली दॅट इवन इफ वी डोंट अंडरस्टँड मच अबाउट प्रॉम्प्ट इंजिनिअरिंग अँड ऑल दॅट. आता तुम्ही बघितलं असेल, मी अक्षरशः म्हणजे आपण माणसाशी बोलतो, माणसाला पण कदाचित थोडं जास्त डिटेल सांगावं लागेल, इतक्या सहजपणे आपण त्यांना ते सांगू शकतो. सो व्हाईल वी कॅन सर्टनली थिंक अबाउट प्रॉम्प्ट इंजिनिअरिंग, म्हणजे त्याचे साधारण एक 15 नियम आहेत की प्रॉम्प्ट कसे असले पाहिजेत. म्हणजे काही उदाहरणं मी सांगू शकतो की उदाहरणार्थ आपण त्याला म्हटलं की मला अमुक अमुक काहीतरी डायग्नोसिस करून दे, हाऊ आय वॉन्ट इट, असं एक एक्झाम्पल आपण त्याला देऊ शकतो. हाऊ आय डोंट वॉन्ट इट असं एक्झाम्पल देऊ शकतो. तर म्हणजे त्याला ते पॉझिटिव्ह एक्झाम्पल, निगेटिव्ह एक्झाम्पल असं म्हणतात. किंवा त्याला आपल्याला पाहिजे की ते एक्झॅक्टली A4 पेजमध्ये बसेल, प्रिंट करायचं आहे. सो गिव्ह इन अ फॉर्मॅट विच विल ओनली हॅव A4 काइंड ऑफ साईज. अशा प्रिसाईज इन्स्ट्रक्शन्स आपण देऊ शकतो. आणि आपण जसजशा इन्स्ट्रक्शन्स देत जाऊ तसतसं त्याचं आउटपुट रिफाईन सुद्धा होत जातं. बट फॉर समवन हू इज जस्ट स्टार्टिंग, आय विल से जस्ट स्टार्ट ॲज अ व्हेरी कॅज्युअल कॉन्व्हर्सेशन, इट विल स्टील वर्क.
Hello. Any queries? Sir, I have tried prompt but not in medical field. I have tried in Dhurandhar Can you make image of me in Durandar style? That is prompt.
काय करू शकत नाही असं मला वाटत नाही. आणि या कंपन्यांचे जे सध्याचे मुख्य आहेत म्हणजे सॅम ऑल्टमन वगैरे जगातले टॉप लोक, त्यांची भाषणं तुम्ही ऐकली. सध्या आजच मी एक सॅम ऑल्टमनचा इंटरव्ह्यू ऐकत होतो. त्याचं आत्ताचं लेटेस्ट प्रेडिक्शन असं आहे की बाय 2028 आय विल बी सरप्राइज्ड इफ टॉप CEOs of the world, prime ministers, presidents of countries, if they are not using AI as their main sort of day-to-day worker, I will be surprised. म्हणजे अशी त्याची आता it's irreplaceable and it's bound to be there. Okay, so thank you for inviting me here and thank you for a patient listening.
शिंदे सर, समराईज. थँक्यू अतुल. आमची जी अपेक्षा होती त्या पद्धतीनं तू व्यवस्थितपणे सांगितलेल्या आहेत. आमच्या सगळ्याच खरं तर क्वेरीज त्यामध्ये फुलफिल झालेल्या आहेत. सो आय डोंट थिंक देर इज एनी क्वेरी वॉट एव्हर डाऊट वॉट एव्हर fear was in our mind that you have said that if you embrace it you will be the winner, but if you are mediocre or you shy away from it you will be defeated. So I think that is the take home message for this. I really thank you for accepting our invitation, and even if you were very, very busy with your CDAC commitment, but you tried to come here and given a very nice lecture. So I again thank you from I am Indacon. Thank you. I request Dr. Deshmukh sir to felicitate Atul Kahate.
Thank you very much. Now I request Dr. Patil sir to come on the dais.
नाही ते हे नाही स्लाइड चेंज.
Now may I request Dr. Shah sir to felicitate Dr. Shinde sir. Now may I request Dr. Shivajirao Khabal sir. Dr. Dada Mane. Past President I.M. Temburni to chair the session. Dr. Chemak Patil sir is consultant neurosurgeon at Sahyadri Super Specialty Hospital, sir.
Yes.
Okay.
चालू करू का प्रेझेंटेशन कसं काय की आता आलं होतं ना नाही हे लूज आहे का काही आहे ना आता काही करत नाही त्याला हातच लावत नाही तर थँक्यू व्हेरी मच फॉर इन्व्हाइटिंग मी मला वाटतं मी 2 वर्षापूर्वी आलो होतो इथे एकच मिनटं हॅलो हां हां एका कामात मी थोडासा अडकलेलो आहे मी फोन करतो तुम्हाला 15-20 मिनिटात ठीक मी 2-3 वर्षापूर्वी आलेलो इथे लेक्चर द्यायला आणि त्यानंतर 2 वर्षांनी परत येतोय एक गोष्ट तुम्हाला सांगायची म्हणजे का पुण्यामध्ये बरेचशा सोसायटीज असतात अमक्या ठिकाणची सोसायटी तमक्या ठिकाणची सोसायटी आणि कुठेतरी त्यांचं लक्ष अकॅडमिक्सकडून बाजूला आणि बाकीच्या गोष्टींकडे खूप जास्त असतं बाकीचे इव्हेंट्स आणि आतमधल्या सोसायटीमध्ये ग्रुपिझम अशा बऱ्याच गोष्टी असतात पण तुमची इंदापूर सोसायटी आय मस्ट कॉंग्रॅच्युलेट द ऑर्गनायझिंग प्रेसिडेंट सेक्रेटरी अँड एंटायर एक्झिक्युटिव्ह कमिटी मेंबर तुम्ही खूप ही जी पर्टिक्युलर तुमची कॉन्फरन्सची योजना आहे दरवर्षी की नवीन काय झालेलं आहे नवीन अपडेट्स काय आहे ते शिकायची तुमची इच्छा आहे ती डेफिनेटली चांगली आहे तर प्लीज कंटिन्यू दिस अकॅडमिक प्रोग्राम एव्हरी इयर सो विल कंटिन्यू विथ न्यूरोसर्जरी मला एक सांगा हे तुम्ही यूट्यूबवर काही दाखवत नाही आहे ना दाखवतोय का लाईव्ह चालू आहे का बरं ठीक आहे मग काही गोष्टी मला नाही दाखवत तर न्यूरोसर्जरी म्हणजे माझा एक मित्र आहे शैलेश अत्रे तो अस्सल पुण्याचा आहे पुण्यातली शक्यतो जी डॉक्टर आहेत ती बाहेरून आलेली आहेत काही डॉक्टर पुण्यातली आहेत आणि काही डॉक्टर बाहेरून आले शैलेश अत्रे म्हणजे पुण्यातला आहे आम्ही डिबेट करत असतो कधी कधी बसून शनिवारच्या दिवशी डिबेट्स करत असतो दादा हॉट डिबेटिंग टॉपिक आमचं हे आहे की ते इराण आणि अमेरिकेचं युद्ध आणि स्टॉक मार्केट खूप खाली गेलेलं आहे तर त्याच्यामध्ये काय होणार असं डिस्कशन असतं आमचं तो मला म्हणत असतो अरे तुम्ही न्यूरोसर्जन एआयचा टॉक आणि त्याच्यानंतर न्यूरोसर्जनला बोलवलंय तर तुम्हाला झोप नाही यावी याचा मी प्रयत्न करतो तेव्हा न्यूरोसर्जनवर प्रत्येकांना हेच वाटतं की ट्रॉमा आणि स्पाईन म्हणजे खोपडी एकतर स्ट्रोक झालेला असतो किंवा मध्ये रक्तस्राव झालेला असतो किंवा ऍक्सिडेंट झालेला असतो आणि खोपडी कोडतात रक्तस्राव त्याच्या व्यतिरिक्त मला थोडं पाणी पाहिजे त्याच्या व्यतिरिक्त न्यूरोसर्जरीमध्ये काय आहे कंटिन्युअस मेडिकल एज्युकेशन CME म्हणजे काय असतं तर थोडंसं एज्युकेशन झालं पाहिजे आपलं तर आज थोडंसं तुम्हाला सांगायचा प्रयत्न करतो की न्यूरोसर्जरीमध्ये रिसेंट ॲडव्हान्सेस म्हणजे नवीन नवीन गोष्टी काय झालेल्या आहेत तर थोडंसं आपण बोलूया ब्रेन आणि स्पाईन ट्युमर्स बद्दल ट्युमरचं ऑपरेशन आम्ही कसं करतो वॅस्क्युलर न्यूरोसर्जरी बद्दल थोडंसं बोलूया फंक्शनल न्यूरोसर्जरी म्हणजे काय असतं आणि पिडियाट्रिक न्यूरोसर्जरी एपिलेप्सी आणि पेरिफेरल नर्व्स आपण पुढच्या वर्षी शिकूया कारण तो एक टोटल डिफरंट टॉपिक आहे तर पुढे जाऊया हे थोडंसं स्टॅटिस्टिक्स आहे आता चालू करायच्या अगोदर ते माहिती आहे का जुन्या आपले जुने पुस्तक होते, त्या पुस्तकामध्ये धडा शिकल्यानंतर एक थोडासा एक सारांश असायचा, आपण काय शिकलो आणि असं. तर हे जे काही 3 लेक्चर झाले त्याच्यामधून मी थोडे थोडे प्रश्न तुम्हाला विचारणार आहे. जो कोणी माणूस बेस्ट उत्तर देईल त्याला सोसायटीतर्फे काहीतरी तुम्हाला प्राइज द्यावं लागणार. ठीक आहे. जर मी तुम्हाला विचारलं विच इज द मोस्ट कॉमन ट्युमर इन फिमेल्स इन इंडिया, कुठला असेल हो? सरांनी सांगितलेलं ब्रेस्ट कॅन्सर. ओके. विच इज द मोस्ट कॉमन ट्युमर्स अमॉंग्स मेल इन इंडिया? प्रोस्टेट कॅन्सर. सर गेले आता, नाही तर आपण चेक केलं असतं. बट इफ आय आस्क यू ओव्हरऑल विच इज द मोस्ट कॉमन ट्युमर इन इंडिया, ओव्हरऑल द मोस्ट कॉमन ट्युमर, नॉट सेक्स वाईज, ओव्हरऑल मोस्ट कॉमन ट्युमर इन इंडिया कुठला असेल? ओरल कॅन्सर. आपण पिक्चर बघायला जातो तर काय बघतो सगळ्यात पहिले? मुकेश अंबानी नाही, ते मुकेश, त्याला ओरल कॅन्सर झालेला असतो. तर आता जर आपण ब्रेन ट्युमर बद्दल जर बोललो तर ब्रेन ट्युमर मध्ये सगळ्यात मोस्ट कॉमन ट्युमर कुठला असेल हो? एनी गेस? मेनिंजिओमा. तर आमचे जे न्यूरोसर्जरीचे टीचर होते ना, त्यांना एक सवय होती, त्यांना कधीही आपण बोलायला लागलो ना तर ते बोलताना असे म्हणायचे की तू उत्तर दिलेलं बरोबर आहे, पण जो प्रश्न मी विचारलेला त्या प्रश्नाचं नाही, दुसऱ्या प्रश्नाचं उत्तर आहे. तर मेनिंजिओमा इज द मोस्ट कॉमन बेनाईन ट्युमर इन ब्रेन. अजून दुसरं कुठलं काही? ग्लायोमा इज द मोस्ट कॉमन प्रायमरी ट्युमर इन द ब्रेन. अजून काही? नॉट द मोस्ट कॉमन ट्युमर. मोस्ट कॉमन ट्युमर हा आहे काय? मेटास्टॅसिस. मेटास्टॅसिस म्हणजे काय असतं? कुठेतरी दुसरीकडे सुरू होतं आणि मग मेंदूला जातं. तर आता परत तेच प्रश्न आपण रिवाइज करू. जर मी तुम्हाला विचारलं की फिमेल्स मध्ये विच इज द मोस्ट कॉमन ट्युमर इन फिमेल्स विच मेटास्टाइजेस टू ब्रेन, तर कुठला असेल? ब्रेस्ट, बिकॉज दॅट इज द मोस्ट कॉमन. मेल्स मध्ये विच इज द मोस्ट कॉमन ट्युमर विच मेटास्टाइजेस टू ब्रेन? इट्स लंग. इट्स नॉट प्रोस्टेट, इट्स नॉट ओरल कॅव्हिटी, इट्स लंग. स्लोली लंग कॅन्सर इज बिकम मोर कॉमन. तर थोडंसं आपण बघूया ही पास्ट ऑफ द न्यूरोसर्जरी, म्हणजे पूर्वीच्या काळात जे सिनियर प्रॅक्टिशनर असतील, कदाचित तुमच्या काळात न्यूरोसर्जरी डिपार्टमेंट असून हॉस्पिटलमध्ये नव्हतं, जनरल सर्जरी डिपार्टमेंट असायचं आणि त्याच्यामध्येच क्रेनिओटॉमी व्हायच्या. कधी कधी जनरल सर्जरीच्या रेसिडेंट लोकांना पण क्रेनिओटॉमी करायचा चान्स मिळायचा, सिनियर प्रॅक्टिशनरला माहिती असेल. तर हा एक हार्वी कुशिंग नावाचा आमचा एक फादर ऑफ न्यूरोसर्जरी, म्हणजे पहिला अमेरिकेतला न्यूरोसर्जन आहे जो सर्जरी करतोय. आणि हे सगळे लोक वरती उभं राहतात, त्याचे फेलोज आहेत, बघतायत का सर्जरी कसं करतायत, मग ते त्यांच्या देशात जाणार आणि सर्जरी करणार. जर ब्रेन ट्युमर काढायचं म्हटलं ते असं काढायचे जसं काय एखादा गॉल ब्लॅडर काढतात, डिसेक्शन करत. ठीक आहे ना? हे इथं बघा असं. अच्छा, मेंदू आहे ना एकदम दह्यासारखा असतो. ठीक आहे ना? तर मी इमॅजिन करा की एक गाडगं आहे, त्याच्यावरती दही आहे आणि दह्यामध्ये आपण एक वरतून चेंडू टाकला टपक, आणि त्यांनी एक आकार घेतला, त्या मेंदूला पण एक असा थोडासा कर्व दिला. आता मी तुम्हाला सांगतोय की हा चेंडू काढायचा, पण दह्याचा आकार बिघडला नाही पाहिजे. आणि तुम्ही जर असं पूर्वीच्या पद्धतीने असा हात घातला आणि चेंडू काढला, काय होणार? सगळा पचका होऊन जाणार. मग हेच कारण होतं, आपण म्हणायचो अरे तुला मेंदूचा ट्युमर झाला म्हणजे तू यमाच्या पाया पडायला गेला, आला तर आला नाही तर असं व्हायचं. आता हळूहळू काय झालंय, हा कन्सेप्ट जो काय होता ते हाताने डिसेक्शन करायचा, तो फक्त आम्ही जनरल सर्जन लोकांना दिला. म्हटलं आम्हाला हे पटणार नाही, आम्हाला थोडंसं वेगळ्या प्रकारचं डिसेक्शन करावं लागेल, तरच मग व्यवस्थित आम्हाला काढता येईल. तर आता स्लोली आपण फ्युचरकडे चाललोय. तर हा मी आहे, लग्नाच्या अगोदर असा होतो मी, लग्नानंतर आता असं झालेलं आहे. हे मायक्रोस्कोप मध्ये बघून सर्जरी करतोय. म्हणजे मेंदूमध्ये खूप साऱ्या छोट्या छोट्या शिरा असतात, त्या ट्युमरच्या अवतीभोवती आहेत. ह्या शिरा तुम्हाला दिसल्या पाहिजे. या शिरा जर तुम्हाला दिसल्याच नाही तर मग तुम्ही बोटाने डिसेक्शन केलं तर शिर तुटणार. मग एक तर हात पॅरलिस होणार किंवा श्रवण हे जाणार, कपॅसिटी जाणार, वाचा जाणार, पाय जाणार, मेमरी जाणार, ह्या गोष्टी होणार. ह्या छोट्या छोट्या शिरा जर तुम्हाला बघायचं असेल तर हाय एंड मायक्रोस्कोप पाहिजे, त्याच्यामध्ये तुम्हाला त्या शिरा दिसल्या पाहिजे. अगदी तुम्ही 40x झूम पर्यंत जाऊ शकता आणि तुम्हाला अगदी छोट्या छोट्या शिरा पण मोठे दिसतात. एक उदाहरण तुम्हाला दाखवतो. हा 4 वर्षाचा मुलगा आहे ज्याला ट्युमर झालेलं आहे. दिसतंय का? हा मेंदू आहे. MRI समजून सांगतो. हा पूर्ण कवटी जी आहे ती काळ्या कलरची आहे, मेंदू आहे तो पांढऱ्या कलरचा. हा जो एवढा आहे तो पूर्ण ट्युमर आहे. आणि जर मेंदूला आपण 4 भागामध्ये कट केलं तर एक भाग फक्त ट्युमर असेल. आणि हा ट्युमर 4 वर्षाच्या मुलामध्ये मी असा हात टाकला किंवा बोट टाकलं असं काढून घेतलं तर एक साईडचा मेंदू तर गेलाच नाहीच मग, हो की नाही? आता याची सर्जरी जर करायची म्हटलं तर कशी करायची हे दाखवतो थोडंसं. तर 4 वर्षाचा मुलगा आहे, हा ट्युमर आहे आणि सर्जरी करतोय. आणि हे बघा, आता हे मायक्रोस्कोप मध्ये असं दिसतंय. जसं ड्युरा ओपन केलं, ड्युरा म्हणजे माहिती आहे ना, ड्युरा मॅटर, अरॅक्नॉइड मॅटर. तर ड्युरा मॅटर म्हणजे असा असतो, अरॅक्नॉइड आणि पाया हा मेंदूला एकदम चिकटलेला असतो. ठीक आहे? ड्युरा मॅटर ओपन केलं हे असं दिसतंय, पण कुठं मेंदू आहे आणि कुठं ट्युमर आहे हे दिसतच नाही. कारण काही ट्युमर असे असतात ते एकदम मिसळल्यासारखे, दुधात पाणी मिसळल्यासारखे असतात. आणि आपल्याला उघड्या डोळ्यांनी काय, मायक्रोस्कोप मध्ये पण काय, ते क्लिअरली डिस्टिंक्ट नाही होणार, दिसणार नाही. मग आम्ही एक गोष्ट ऑप्थॅल्मॉलॉजिस्ट कडून शिकलो. ऑप्थॅल्मॉलॉजिस्ट कोणी आहे की इथे ऑप्थॅल्मॉलॉजिस्ट नाही? हो, व्हेरी गुड. तर ही लोक ना रेटिनाच्या वेसल्स बघायचं म्हटलं तर एक स्कॅन करतात. कुठला स्कॅन असतो सर? फ्लोरोसन्स स्कॅन. हा, फ्लोरोसन्स रेटिनोग्राफी म्हणजे काय असतं? फ्लोरोसन्स माहिती आहे तुम्हाला? ते लहान बाळ झोपत नसलं तर आपण वरती चिटकवलेलं असतं तारे, चंद्र वगैरे सगळ्यांना त्याला दाखवतो, चंदमामा, ते तार. समजलं ना फ्लोरोसन्स म्हणजे काय? किंवा ते जुन्या काळामध्ये घड्याळाला लाईट नसायची पण ते घड्याळ तरी पण चमकायचं. तर फ्लोरोसन्स म्हणजे असा द्रव आहे, तो अंधारामध्ये जास्त चमकतो. तर हा फ्लोरोसन्स डाय जर आपण दिली तर शरीरामध्ये जिथे जिथे ट्यूमर टिश्यू असेल, ट्यूमर टिश्यू इज हायली मेटाबॉलिकली ऍक्टिव्ह, त्याचा ग्रोथ रेट खूप जास्त असतो. मग तो लगेच ही डाय घेतो आणि आपल्याला ती डाय मायक्रोस्कोप मध्ये त्या डायमुळे फक्त ट्यूमर असा ग्लेअर व्हायला, फक्त चमकताना दिसतो. आता मी ट्यूमर तो डाय देतो आणि फिल्टर चेंज करतो. ठीक आहे, आणि मग तुम्हाला दाखवतो काय होतं. ठीक आहे, सडनली चेंज झालं. हा ड्युरा आहे, हा ड्युरा रिफ्लेक्ट केला असा इथं. हा जो आहे हा नॉर्मल बिंदू आहे, हा एवढा जो आहे तो ट्यूमर आहे. मला क्लिअरली दिसतंय ही डिस्टिंक्शन बॉर्डर कुठे आहे. मला इथं बरोबर इथून इकडून सगळं ट्यूमर 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 काढून घ्यायचं. आता ते थोडंसं दाखवतो कसं ट्यूमर काढतो आणि ट्यूमर कसा पूर्ण निघून जातो. ठीक आहे ना. तर काही इन्स्ट्रुमेंट असतात आमच्या हातात, एक असिस्टंट लागतो चांगला. तर माझ्या सक्शन नावाच्या इन्स्ट्रुमेंटनी मी ट्यूमर पकडलाय, दिसला ना. आणि एक कॉटरी नावाची बायपोलर नावाचं इन्स्ट्रुमेंट असतं, त्यांनी बरोबर तो प्लेन ऑफ डिसेक्शन बरोबर शोधायचा की कुठं ब्रेन आहे आणि कुठं ट्यूमर आहे. आणि हळूहळू 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 ट्यूमर सगळा काढून घ्यायचा. हे बघा क्लिअरली दिसतं. डिसेक्ट करताना जर फ्लोरोसन्स दिसलं तर काढून टाका, हा पूर्ण ट्यूमर निघून गेला. दिसलं? आणि हे का शक्य झालं आता एक पोस्ट ऑफ स्कॅन पण दाखवतो. हा पोस्ट ऑफ स्कॅन आहे, पूर्ण ट्यूमर निघून गेला आणि मेंदूला काहीही धक्का लागला नाही. ठीक आहे. हा पेशंट, अरे मला माहिती नाही आता हे सरळ होईल का नाही. हो, तुम्हाला असं बघावं लागेल तुम्हाला. तर हा त्या 4 वर्षाच्या बाळाचा व्हिडिओ आहे. मी जेव्हा पण त्याला व्हिडिओ घ्यायला जायचो किंवा त्याच्याबरोबर बोलायला जायचो, त्याला माहित होतं ह्याच डॉक्टरने माझं ऑपरेशन केलं. तर मला बघितलं लगेच पळून जायचं. मग मी हा पाठीमागून व्हिडिओ घेतलेला. पीडियाट्रिक सुप्राटेंटोरियल एक्स्ट्राव्हेंट्रिक्युलर कॉर्टिकल एपेंडायमोमा, म्हणजे हे आम्हाला अशी वेगवेगळी नावं द्यायची सवय आहे. 4 वर्षाच्या मुलातला हे एक जर्नल आहे, त्याला इंडोनेशियन जर्नल ऑफ न्यूरोसर्जरी. पहिलं नाव आहे माझं चेमटे सचिन संभाजी. मी शक्यतो म्हणजे आपल्याकडे महाराष्ट्रातच ही कल्चर आहे, आपण बापाचं नाव लावतो, बाकीकडे जनरली बापाचं नाव लावत नाही. तर मला त्यांनी जर्नलनी परत हे विचारलं की संभाजी कोण आहे. आय सेड इट इज माय फादर. सो ही सेड यू वॉन्ट टू मेन्शन हिज नेम. आय सेड येस, आय वॉन्ट टू मेन्शन हिज नेम. तर चेमटे सचिन संभाजी इंडोनेशियन जर्नल ऑफ न्यूरोसर्जरी मध्ये 4 वर्षाच्या मुलातला लार्जेस्ट ट्यूमर रिमूव्ड इन द हिस्ट्री हा माझा पेपर आहे. आणि हे का शक्य झालं? कारण मायक्रोस्कोप आहे म्हणून. जर मायक्रोस्कोप नसेल तर हा मुलगा पॅरालिसिस होण्यापासून वाचू शकला नसता. हे तुम्ही विचारा मग सर हे मायक्रोस्कोप कितीचं आहे? तर आपल्याकडे सह्याद्री हॉस्पिटलमध्ये, आणि आता सह्याद्री ग्रुप ऑफ हॉस्पिटल्स आर एक्वायर्ड बाय मणिपाल हॉस्पिटल्स, यू नो दॅट. सो आय वॉज अर्लियर इन मणिपाल हॉस्पिटल, आणि आता मणिपाल हॉस्पिटलनी सह्याद्री हॉस्पिटल घेतल्यामुळे मी आता सह्याद्री हॉस्पिटलमध्ये पण आहे. म्हणजे पक्ष चेंज केल्यानंतर कदाचित ते उपमुख्यमंत्री कुठले आपले मागच्या वेळेस उपमुख्यमंत्री होते एकनाथ शिंदे, त्यांच्यासारखी गत झाली माझी. मी इकडून तिकडे गेलो आणि परत तो पक्ष त्यांनी घेतला, म्हणजे मला समजत नव्हतं मी कुठे आहे. बट एनिवे, नाव आय मीन सह्याद्री हॉस्पिटल प्लस मणिपाल हॉस्पिटल. आणि इथे आपल्याकडे कार्ल झाईज नावाचा मायक्रोस्कोप आहे, लेटेस्ट मायक्रोस्कोप. हा 2 करोड रुपयाचा मायक्रोस्कोप आहे. आता तुम्ही पुढचा प्रश्न विचारता, सर मग हे योजनेमध्ये होतं का? हे बघा, योजना वगैरे हा बिझनेस आहे ना, यांनी चालू केलेला एक 10-15 वर्षापूर्वी, आणि त्याच्यानंतर त्यांनी अपडेटच नाही केलं. आपली इकॉनॉमी वाढते ते लोकही सांगतात, मग डॉक्टरांची पण इकॉनॉमी वाढू द्या ना, हो की नाही? हा, सो जे काही पॅकेजेस आहेत ना ते खूप कमी पॅकेजेस आहेत. व्हेरी डिफिकल्ट टू डू सर्जरी. ब्रेन ट्यूमर सर्जरीचा पॅकेज हार्डली 70-80,000. इट्स नॉट पॉसिबल टू डू सर्जरी. ओटीचे अनास्थेशियाचे ड्रग्सच त्याच्यामध्ये संपून जातात. आणि दिस काइंड ऑफ इन्स्ट्रुमेंट इज बॉट मायक्रोस्कोप, तर त्याची रिकव्हरी किती होणारच शक्यच नाही असं. अच्छा, नेक्स्ट केस दाखवतो. आता मी जर तेच उदाहरण थोडंसं वेगळं करतो. जे गाडगं आहे, गाडग्यामध्ये दही आहे. आता वरतून चेंडू नाही आला, पहिले गाडगं आहे, नंतर चेंडू आला आणि वरतून दही आलं. आता मी तुम्हाला सांगतो का आता चेंडू काढायचा आहे, कसं काढणार? मग कुठून तरी दह्याला आपल्याला जागा करावं लागणार, एक बोळ बनवावं लागेल, त्या बोळीतून जाऊन काढून घ्यायचा. आणि जेवढी काही बोळ बनवली तिथं. पण हे आम्ही एकदा ईएनटी सर्जन, एनी ईएनटी सर्जन नो, एका ENT सर्जनला आम्ही सर्जरी करताना बघितलं, तो नाकातून सर्जरी करत होता आणि थोडासा अग्रेसिव्हली सर्जरी करता 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 तो बरोबर हा ट्युमर जिथे तिथे जाऊन पोहोचलेला. आणि मी बघितलं, म्हटलं अरे रे थांब थांब, तू रस्ता चुकलाय, पण ह्या रस्त्यात तू मला जाऊन पोहोचू शकतो का? तो म्हटलं हो काय प्रॉब्लेम नाही. मग तिथे जाऊन पोहोचलो आम्ही आणि ट्युमर आम्ही खालून काढून घेतला. म्हणजे गाडग्याला खालून बोळ करायची आणि ट्युमर चेंडू काढून घ्यायचा. समजलं? आता हे एक ॲनिमेशन मध्ये दाखवतो. हा एक ट्युमर आहे. कुठला ट्युमर असेल हो, समजू शकतं का? समजतंय ना? हा सर्जायकल सेक्शन म्हणजे साईडने बघतो आपण. हा इथे ट्युमर आहे. हा कोरोनल सेक्शन आहे. कुठला ट्युमर असेल? पिट्युटरी मॅक्रोएडेनोमा. नाव ऐकलंय का? विच इज द मोस्ट कॉमन. पिट्युटरी ग्लँड म्हणजे काय? मास्टर ग्लँड विच कंट्रोल्स ऑल द हॉर्मोन्स इन द बॉडी. आपले पाळी कधी येणार, आपली वाढ किती होणार, घाम किती येतो, आपली म्हणजे पूर्ण जे काही बॅलन्स आहे हॉर्मोनल, दॅट इज अ मास्टर ग्लँड. तिथून सगळे हॉर्मोनल कंट्रोल होतात. मग समजा एखादा हॉर्मोन जर जास्त बनायला लागला का, कारण त्या हॉर्मोनच्या पेशींची वाढ जास्त होते, त्या हॉर्मोनच्या पेशीचा कॅन्सर झालाय, तर मग त्या हॉर्मोनचं जास्त लक्षणं दिसायला लागतात. सो विच इज द मोस्ट कॉमन पिट्युटरी ग्लँड? एनीवन? मोस्ट कॉमन पिट्युटरी मॅक्रोएडेनोमा कुठला असतो? प्रोलॅक्टिनोमा. व्हेरी गुड. प्रोलॅक्टिनोमा जास्त आला की प्रोलॅक्टिन खूप जास्त होतं आणि बाई ते म्हणते सर 6 महिने झाले मला पिरियडच नाही आला आणि ब्रेस्टमधून अननेसेसरी सिक्रेशन यायला लागतं, मी खूप लठ्ठ झाले, कारण प्रोलॅक्टिन खूप जास्त आहे. ओके. विच इज द सेकंड मोस्ट कॉमन पिट्युटरी मॅक्रोएडेनोमा? जॉ असा फूट मोठा होऊन जातो, फ्रंटल बॉसिंग होऊन जातं, हात मोठे होतात, अंगठी येत नाही, चपलेची साईज वाढावी लागते, हाईट एकदम 7 फूट होऊन जाते आणि मग तो WWE मध्ये रेसलर म्हणून जातो. कोण असेल? acromegaly. But who is that wrestler? Anybody? Khali circle. So basically, but I tell you, there is a wrong answer. Most common pituitary macroadenoma is non-functional pituitary macroadenoma. If I ask you which is the most common functional pituitary macroadenoma, then it is prolactinoma. But most common it is non-functional. Non-functional म्हणजे तो कुठलाही द्रव बनत नाही. पण तो द्रव बनत नाही हो, पण बाकीच्या द्रव बनवणाऱ्या पेशींवर इतका प्रेशर टाकतो की कुठलाही द्रव बनत नाही आणि मग अशा पेशंटमध्ये हायपोपिट्युटॅरिझम किंवा पॅन पिट्युटॅरिझम होऊन जातं. ते एकदम स्तुल्ल होऊन जातात, त्यांची हालचालच होत नाही एकदम. असे पेशंट असतात. तर याची सर्जरीचं एक ॲनिमेशन दाखवतो आणि मग रिअल सर्जरी दाखवतो. हे ॲनिमेशन आहे. पिंक कलरची ती पिट्युटरी ग्लँड आहे. हा स्कोप चाललाय आतमध्ये, स्कोप आतमध्ये गेला, वरतून हे आवरण आहे अरॅक्नॉइड आणि ड्युरा, आवरणाला कट केलं. जनरली ह्या पिट्युटरी मॅक्रोएडेनोमा इतकं सॉफ्ट असतात का तिथं सक्शन घेऊन गेलं सक 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 ट्युमर निघून येतो. सक्शन अँड क्युरिटाच करता ना तुम्ही गायनेकोलॉजिस्ट, तर तसं सक्शन अँड क्युरिटाच सक्शन घेऊन गेलं तर एक सक 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 पूर्ण सक्शन होऊन जातं. ठीक आहे. नाव इफ आय आस्क यू, जर पूर्ण ट्युमर निघाल्यानंतर ही वरती ही जी एक तार दिसते, ही तार दिसते, कुठली तार असेल? दॅट इज अ नर्व. विच नर्व इज दॅट? Optic nerve, correct. So what is the most common presentation of non-functional pituitary macroadenoma? They don't come with hormones written here, na ki ha hormone कमी झालाय, तो hormone कमी झालाय. The most common presentation is blind, bitemporal myopia. कारण तो बरोबर ऑप्टिक कायझमाला प्रेस करतो. ऑप्टिक कायझमामध्ये ना हे साईडचं विजन असतं. पेशंट काय म्हणतो, सर मी गाडी चालवतो ना, मला हे साईडनी कोण जाते ते मला काही दिसत नाही, कारण ते ऑप्टिक नर्व. तर तुम्हाला समजलं, सर्जरी मी एंडोस्कोपनी केली आहे म्हणून मी पूर्ण ग्लँड काढल्यावर ऑप्टिक नर्व दिसली. जेव्हा ऑप्टिक नर्व दिसते, दॅट इज इंडिकेशन यू हॅव डन अ सक्सेसफुल सर्जरी. नाउ इमॅजिन वी डोंट हॅव अ टेक्नॉलॉजी ऑफ एंडोस्कोप, वी आर ऑपरेटिंग क्रेनिओटॉमी, म्हणजे वरतून ऑपरेट करतो. वरतून जेव्हा ऑपरेट करतो आणि येतो, सगळ्यात पहिले तुम्हाला काय दिसणार? ऑप्टिक नर्व. ट्युमर इज बियॉन्ड दॅट. सो व्हेरी हाय चान्स ऑफ ब्लाइंडनेस. तो पूर्वीच्या काळामध्ये जेव्हा पिट्युटरी मॅक्रोएडेनोमा मी ट्रान्सक्रेनियल म्हणजे खोपडी खोलून करायचो, त्यावेळी ब्लाइंडनेस वॉज इनएव्हिटेबल, पण आता ब्लाइंडनेस व्यवस्थित होऊ शकतो. ठीक आहे ना? ओके, व्हेरी गुड. हे सर्जरी करतोय आम्ही असं, आणि ही सर्जरी चाललेली आहे. तो मी आहे स्कोपमध्ये बघत बघत असं ऑपरेट करत असतो. हे असं आतमध्ये गेलो, ड्रिलिंग चालू असतं थोडंसं ENT सर्जनचं, आणि तिथं गेलो. आता हे बघा ड्युरा मॅटर आलं. आता ड्युरा मॅटर कट करतोय मी. ड्युरा मॅटर कट केला का ट्युमर इतका सॉफ्ट असतो, तो बाहेर यायला लागतो. पटकन बायोप्सी घ्यायची, नाही तर सक्शन घेऊन गेलं की पूर्ण सक होऊन जाऊ शकतो. तर थोडंसं डिसेक्ट करतोय असं. हे ॲनिमेशन दाखवलं म्हणून तुम्हाला समजेल, ॲनिमेशन दाखवलंच नसलं तर समजलं नसतं. सो दॅट इज अ ब्युटी ऑफ AI मुळे ॲनिमेशन आलं. आणि हे पूर्ण काढून टाकायचं. ऑप्टिक नर्व तेवढी सहजासहजी दिसत नाही, स्कोप एकदम आतमध्ये घेऊन जावा लागतो आणि मग दिसते. ठीक आहे ना? आणि नंतर सगळं बुजवून टाकायचं. सर्जरी झाली. तर हा आहे सर्जरीच्या पहिलेचा स्कॅन आणि हा सर्जरीच्या नंतरचा स्कॅन. पूर्ण ट्युमर निघून गेला, दिसतंय ना? तर ही बाई होती, प्रत्येक न्यूजपेपरमध्ये आलेलं एक
डोळ्याने थोडंसं विजन कमी दिसत होतं, तर मग डोळ्याची ट्रीटमेंट मी चालू केली.
37 इयर ओल्ड लेडी आणि तिला पूर्ण ब्लाइंडनेस झालेला. ब्लाइंडनेस झाला आणि ती नंतर मग ह्या डोळ्याच्या डॉक्टरकडे त्या डोळ्याच्या डॉक्टरकडे फिरत राहिली. त्यांनी औषध दिले, ड्रॉप दिले, सगळं दिलं. नंतर मग एका प्रॉपर ऑप्थॅल्मॉलॉजिस्टने सांगितलं की बाई तू एक काम कर, तू MRI कर, कदाचित तुझ्या डोळ्यात नाही, डोळ्याच्या पलीकडे जी तार आहे त्याच्यामध्ये प्रॉब्लेम असू शकतो. आणि मग स्कॅन केला आणि मग त्याच्यामध्ये पिट्युटरी मॅक्रोन आलं. मग त्यांनी माझ्याकडे पाठवलं, म्हटलं सर हे तुम्ही बघा. आणि हे केलं. जी बाई कम्प्लिटली ब्लाइंड होती तिचं आपण नाकातून ऑपरेशन केलं आणि एकदम व्यवस्थित झाली. ऑपरेशन केल्याच्या 10व्या दिवशी बघा ही बाई किती सुंदर दिसते. तसं इमॅजिन करा, हिला नाकातून नाही, आपल्याला वरतून सर्जरी करायची म्हटलं सगळे केस काढावे लागतात आणि मग आपण सर्जरी करायची. केस यायला 1.5-2 वर्ष लागतात. म्हणजे तिचं सोशल लाईफ काहीच नाही. ही म्हणते सर मी आता साखरपुड्याला जाऊन आले. हे का शक्य झालं? कारण एंडोस्कोप आहे म्हणून. तर फर्स्ट टेक्नॉलॉजिकल ॲडव्हान्स इज अ मायक्रोस्कोप, सेकंड टेक्नॉलॉजिकल ॲडव्हान्स इज अ एंडोस्कोप. विदाउट दॅट इट्स कॉन. सगळ्या न्यूजपेपरमध्ये आलेलं की सर्जरी केली, हा आंधळी बाई होती आणि बरी झाली. ठीक आहे ना. आता मी एक गोष्ट सांगतो. बँगलोरमध्ये आपण लोक खूप साधी बोळे होतो. ही जी साऊथ इंडियन लोक आहेत ही खूप स्मार्ट असतात. आपण सावध राहिलं पाहिजे. बँगलोरमध्ये एक केस झालेली. एका जनरल प्रॅक्टिशनकडे एक पेशंट आला आणि ट्युमर होता आणि त्यांनी अमुक हॉस्पिटलकडे रेफर केला, लोकल हॉस्पिटल, पुढे हाय स्पेशालिटी हॉस्पिटल नव्हतं. न्यूरोसर्जननी तो ट्युमर ऑपरेट केला. ऑपरेट केल्यानंतर पेशंटला थोडासा विकनेस झाला. कारण जिथं मोटर स्ट्रीप असते, मोटर स्ट्रीप म्हणजे मेंदूमध्ये प्रत्येक गोष्टीचं केंद्र असतं. समजा हाताचं जिथं केंद्र आहे त्याच्या शेजारीच ट्युमर होता आणि ट्युमर काढला, हाताच्या केंद्राला धक्का लागला आणि विकनेस झाला. आणि विकनेस झाल्यानंतर जरी त्या डॉक्टरने सांगितलं तर विकनेस वगैरे होऊ शकतो, त्यांनी ॲक्सेप्ट केलं. नंतर गेला. नंतर त्यांनी AI मध्ये ChatGPT सगळं टाकलं आणि ChatGPTने आन्सर दिलं, सर्जरी मायक्रोस्कोपिक, एंडोस्कोपी वगैरे सगळं. मग तो आला, डॉक्टरला विचारलं, का हो डॉक्टर माझी सर्जरी एंडोस्कोपिक झाली का मायक्रोस्कोपिक? डॉक्टर म्हणाले नाही काय नाही, एंडोस्कोपिक मायक्रोस्कोप काय नाही, आपल्याकडे तर साधं मायक्रोस्कोप वगैरे नाही आहे. जो ओपन केलं आणि ट्युमर काढून घेतला. मग लगेच तो म्हणाला ठीक आहे सर, नो प्रॉब्लेम. याची काही कागदपत्र आहेत का? म्हणे हा आहेत कागदपत्र घेतले त्यांनी आणि गेलं लॉयरला शोधलं. लॉयरला म्हणाल लॉयर साहेब केस करायची. जर करंट ॲडव्हान्समेंटमध्ये द बेस्ट ट्रीटमेंट ऑप्शन इज मायक्रोस्कोपिक सर्जरी अँड एंडोस्कोपिक सर्जरी, वाय वॉज इट नॉट ऑफर्ड टू मी? आणि त्यांनी केस फक्त न्यूरोसर्जनवर नाही केली, केस कुणावर केली? ज्या डॉक्टरनी रेफर केलं होतं त्याला पण, वाय यू डिड नॉट रेफर मी टू अ specialist or to a center where this particular facility was not available. So that is the beauty of this kind of conferences and CMEs. Current updates काय आहे आपल्याला माहिती पाहिजे. तर पुढच्या वेळेस तुमच्याकडे कधी पण जर पिट्युटरी मॅक्रोडोमाचा, जनरली गायनेकोलॉजिस्ट गेट ऑल दिस काइंड ऑफ पेशंट, सो यू मस्ट नो की बाबा एंडोस्कोपिक सर्जरी कुठे होतीये, कारण त्या बाईची बेस्ट ऑफ द बेस्ट ट्रीटमेंट झाली पाहिजे. ठीक आहे ना. आता मी काय सांगू, आणखी 2 केसेस सांगतो फक्त आणि मग संपवतो कारण बेलला वाजलेली आहे. एक गोष्ट आहे, ही पेशंट आहे, या पेशंटचं डायग्नोसिस तुम्ही काय मला सांगा. त्या पेशंटला एक समजा की 70-80 वर्षाचा म्हातारा आहे. गावाकडे आपण गेलं, काय ऐकू येतं तुम्हाला, गावाकडे आपण गेलं, फेटा घातलेला आहे, फेटा असा थोडासा हालत असतो, हात असा हालत असतो, चालायचं म्हटलं ना त्याला असं तुरु चालतं. पार्किन्सन झालं तर व्हॉट इज द ड्रग ऑफ चॉईस? सिंडोपा, टॅबलेट सिंडोपा, लिव्होडोपा कार्बिडोपा कॉम्बिनेशन, सिंडोपा प्लस 125 mg आपण लिहितो BD और TDS आणि हा पेशंट हळूहळू बरा. नंतर पेशंट म्हणतो सर थोडंसं आता परत मला हालायला लागलंय. मग आपण करतो TDS तर 4 वेळा करतो. सर अजूनही हलतंय, 4 वेळा तर आपण 5 वेळा करतो. नंतर अजून काही ड्रग ऍड करतो, आम्ही बेक्सोल ऍड करतो, आमंट्रीन ऍड करतो, फलाना ऍड करतो. म्हणतो सर आता असं झालंय ना की गोळ्या घेऊन पण काही फरक पडत नाही, मला माझ्या गुंड्या लावणं अवघड झालंय, पाणी पिणं, ग्लास घेणं अवघड झालंय, कपडे घालणं, आंघोळ करणं अवघड झालंय, हे आता खूपच अवघड झालंय, याच्यामध्ये काही करता येईल का? तर आम्ही शोध लावला. आम्ही प्रत्येकाला बघून काही ना काही शोध लावत असतो. तर जसं पेसमेकर टाकतात हृदयामध्ये, पेसमेकर का टाकतात? कारण SA नोडमध्ये फायरिंग कमी झालेली आहे. तर पेसमेकर काय करतं, तिथं इलेक्ट्रिसिटी लावलेली आहे आणि जर SA नोडची फायरिंग कमी झालं तर हे फायर करायला लागतं. तसं आम्ही म्हटलं, आम्ही शोध केला, कारण मेंदूमध्ये असं काही फायरिंगचं किंवा चलनाचं काही केंद्र आहे का? असं आम्ही शोधलं. सबस्टन्शिया गायरा म्हणून एक, सबस्टन्शिया नियाग्रा म्हणून एक सेंटर आहे, जिथं आपल्या हालचालीचं केंद्र आहे. आणि अशा पेशंटमध्ये डोपामिन कमी झाल्यामुळे तिथं हालचाल कमी होते. मग काय करायचं? एक तर पेशंटला डोपामिन द्या, आणि डोपामिन काय करतं, तिथं इलेक्ट्रिसिटी वाढवतं. पण नंतर असं झालंय का ते डोपाची टॅबलेट घेऊन पण इलेक्ट्रिसिटी नाही वाढत जावं लागेल. म्हणजे काय करावं लागेल? मग आकडा टाकावा लागेल. आकडा टाकणं म्हणजे समजतं का तुम्हाला? गावाकडची लोक आहेत ना, काय मी शहरात गेलो बरं का, बायको म्हणते आपण पुण्यामध्ये राहू, आणि माझं प्रोफेशन पण असं आहे की मायक्रोस्कोप एंडोस्कोप मला नगरमध्ये नाही मिळणार, मी मुलगा नगरचा. आणि पण ती मजा जी होती ना गावाकडची ती नाही राहिली. आकडा टाकायचं म्हणजे किती मस्त काम होतं. आपण जायचो तिथं आणि आकडा घेऊन जायचो, पडला की ते बल्ब लागायचा आणि टीव्ही बघत असायचो आपण काहीतरी श्रीकृष्ण वगैरे, आणि अचानक ते चित्र असं 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 हळू छोटं व्हायला लागलं. आपण जायचं, तांब्या घ्यायचं आणि पाणी टाकायचं. त्या आर्थिंग असायची ना, त्या आर्थिंग मध्ये पाणी कमी झालं तर किती मस्त. तर आकडा टाकायचं म्हणजे काय करायचं, इथं 2 होल करायचे आणि बरोबर सबस्टन्शियल नायग्रा जिथं आहे तिथं लीड टाकून सोडायचा, आणि त्या लीडला जसं पेसमेकर लावलेला असतो तसंच पेसमेकर लावायचं. या सर्जरी म्हणतात डीप ब्रेन स्टिम्युलेशन सर्जरी. म्हणजे नथिंग एल्स, dopamine was creating an electricity, but dopamine is not able to create the electricity after long time. Then we will create the electricity by directly putting the electrode there. Okay. आता ही एक पेशंट आहे जिचं सर्जरी झालेलं आहे आणि पेसमेकर लावलेला आहे. हे पेसमेकर मी बंद करतो आणि तुम्हाला दाखवतो इथे काय प्रॉब्लेम आहे. आता पेसमेकर आपण बंद करूया, मग तुम्हाला समजेल काय आहे. हे बघा, जसं पेसमेकर बंद केलं हाताकडे बघा काय होतं. दिसलं? हात हलायला लागला. ती ऍक्च्युली सर्जरी केल्यानंतर अजून मोकळी झालीये, पण ही खूप जास्त हात हलायचा तिचा, खूपच जास्त हात हलायचा, बोलता येत नव्हता, आवाज एकदम घोगरा होता. ठीक आहे, चालायचं म्हटलं तर खूपच हळू चालायची. आता सर्जरी केल्यानंतर थोडीशी मोकळी झाली, 4थ्या-5व्या दिवशी आहे. मी दाखवायसाठी फक्त ते डिव्हाइस बंद करतोय. असं काउंटिंग करायला सांगतो आम्ही, म्हणजे ते काही टेस्ट असतात आमच्या, काउंटिंग करताच येत नाही किंवा स्किपिंग होऊन जातं किंवा असं काउंटिंग करताच येत नाही. आणि आता आपण काय करूया, ते डिव्हाइस परत एकदा ऑन करू. जसं ऑन करू तेव्हा तुम्ही बघा काय होतं. हे बघा, आता ऑन करतोय. जसं डिव्हाइस ऑन होतंय तसं तिच्या हाताकडे बघा काय होतं. हे बघा, डिव्हाइस ऑन झालं, दिसलं? हात थांबायचे आणि चेहऱ्याकडे बघायचं. स्माइल, सोशल स्माइल इज द बेस्ट इंडिकेटर की सक्सेसफुल डीप ब्रेन स्टिम्युलेशन सर्जरी झाली. मास्क लाईक फेसिस इज वन ऑफ द प्रॉब्लेम. मला सांगा, कुठला मराठी कलाकार होता ज्याला पार्किन्सनचा प्रॉब्लेम होता? श्रीराम लागू. व्हेरी गुड. श्रीराम लागू. तुम्ही उत्तर देऊ नका आता. श्रीराम लागूचा सगळ्यात फेमस पिक्चर कुठला हो? आपल्या ते शाळेत बसलेली मुलं असतात ना, बसलेले असतात, आवडीचा प्रश्न आला ना की लोक मोठ्याने उत्तर देतात. पिंजरा पिक्चरचा आता लेटेस्ट न्यूज काय माहिती आहे का तुम्हाला? किती रील्स बघता तुम्ही? साधना नाही, त्या पिंजरा पिक्चरचं लेटेस्ट न्यूज हे आहे का पिंजरा पिक्चर मध्ये जी हिरोईन होती, कोण होती ती? संध्या आता रिसेंटली एक्सपायर झाली. कुठलं एक बेस्ट फेमस सॉन्ग ऑफ संध्या, सगळी शी वॉज अ लिजेंडरी डान्सर. संध्याचं फेमस सॉन्ग कुठलं होतं? तुम्ही शाळेमध्ये डान्स केला असेल. ते होळीचं सॉन्ग आहे ना, साईडनी असं आणि पाठीमागं असं. शी वॉज एक्सेप्शनल डान्सर. जर तुम्ही श्रीराम लागूचे नाटकं बघितले असतील जुने, म्हणजे तुम्ही पुण्याला जाऊन जर बघितले असतील किंवा आजकाल टीव्हीवर पण यायचे नंतर शेवटी ना त्याचं असं डोकं थोडं हालत होतं, हात पण थोडा हालत होता, पण आवाज माणसाचा चोख होता शेवटपर्यंत. हो की नाही? हा एक शेवटची केस दाखवतो आणि मग संपवतो. हा माणूस आहे, बोलतोय, हात इथे ठेवलेला आहे आणि अचानक बोलता बोलता आई आई ग असं करतो. काय झालं असेल हो? ट्रायजेमिनल न्यूरॅल्जिया. ट्रायजेमिनल न्यूरॅल्जिया म्हणजे काय असतं? ट्रायजेमिनल नर्व आहे. आणि मला जर थांबायचं असलं तुम्ही थांबायला सांगा, नाही तर मी असं किती वाजेपर्यंत पण बोलू शकतो. जस्ट 1-2 मिनिटं, एक शेवटची केस मग थांबा. ट्रायजेमिनल नर्व म्हणजे चेहऱ्याला कंट्रोल करणारी नर्व असते. ह्या नर्वला एकटं राहायला आवडतं. ह्या नर्वला आजूबाजूला कोणी नाही पाहिजे. एकलकोंडे लोक असतात ना तसं. आता मी नगरचा आहे, तर नगरला एक रोड आहे, त्या रोडला म्हणतात पाईपलाईन रोड. म्हणजे मुळा डॅम पासून जी सगळी पाईपलाईन सगळ्या नगरला जिथं पाणी जातं, तो मोठा एक पाईपलाईन आहे, मोठी. असं आम्ही लहान होतो त्यावेळेस तिथं जायचो, त्या पाईपावर बसायचो आणि जसं पाणी सुरू व्हायचं सकाळी 7 वाजता, तर लगेच ते असं समजायचं हा पाणी आलंय बरं का आता. का बरं? कंपन, हादरे बसायचे. अच्छा, 5-10 मिनिटं बसलं काही प्रॉब्लेम नाही व्हायचा. अर्धा तास 1 तास बसलं तर बुडाला मुंग्या यायच्या. का बरं? कंपन आहे म्हणून. आपल्या गावाकडे मोटार चालू होते, तुम्ही त्याच्यावर हात ठेवा बघा, लगेच कंपन देतं. तसाच हात अर्धा तास ठेवा, मुंग्या यायला लागतील. तर ट्रायजेमिनल न्यूरॅल्जिया म्हणजे नथिंग एल्स. जर ट्रायजेमिनल नर्वच्या वरती एखादी रक्तवाहिनी आली आणि त्याला चिघटली, रक्तवाहिनीमध्ये रक्त वाहतंय, कंपन येतं, हे कंपन जर त्याला ट्रान्समिट झालं तर त्याला पेन व्हायला लागतात. मग ट्रायजेमिनल नर्वसाठी आपण एक टॅबलेट देतो. व्हॉट इज द ड्रग ऑफ चॉईस फॉर ट्रायजेमिनल न्यूरॅल्जिया? Tegretol. What is the drug inside the Tegretol? Carbamazepine. What is the dose of carbamazepine? Yes, very good. आमची न्यूरोसर्जरी प्रोफेसर पण असेच, म्हणजे त्यांच्यामध्ये इगो असायचा काय, जोपर्यंत समोरचा थांबत नाही तेव्हा त्यांना थांबल्यावर त्यांना बरं वाटेल, हा अडकला का नाही आता, अरे कुठे ना कुठे तुम्ही अडकणार ना, तुम्ही सर आहे मी. एनिवे, तर टॅबलेट Tegretol, you can start with 150, you can give 200, or you can give nowadays carbamazepine XR or CR, continuous release, constant release, 300 mg, that you can give. ठीक आहे. कार्बामाझेपिन दिलं पेन कमी होते, कारण इट्स अ पेन मॉड्युलेटर. पण अशा पेशंटमध्ये कंटिन्युअस, जसं सिंडोपालमुळं होतं डीप पार्किन्सनमध्ये, की गोळी खाल्ली तरी पण हालचाल होते, तसंच याच्यामध्ये व्हायला लागतं. सर गोळी खाऊन पण आता काय होत नाही, वेदना होत आहेत, मग आपण गाबापेंटिन देतो किंवा लायोफेन देतो, तरी पण मग अशा पेशंटमध्ये सर्जरी करतो. सर्जरी करायची म्हणजे बेसिक सर्जरी असते. सर्जरीमध्ये आपण आतमध्ये जातो. ही जी दिसते ती ट्रायजेमिनल नर्व आहे, आणि ती मध्ये जी आहे ती रक्तवाहिनी. दिसली का तुम्हाला? हे एवढं मोठं आम्हाला मायक्रोस्कोपमध्ये दिसतं, एवढं क्लिअर. आतमध्ये ही नर्व 1 mm ची आहे, आणि इथं आपल्याला बघा एवढी मोठी दिसते, स्क्रीनवर तर खूप मोठी दिसते. ही जर दिसली आपल्याला तर आपण ही ऑपरेशन करणार आहे. जर दिसलीच नाही, उघड्या डोळ्याने दिसणारच नाही, मग कसं काय ऑपरेशन करणार? तर सर्जरी करायची म्हणजे काय करायचं, एक कापूस घ्यायचा आणि कापूस तिथे घेऊन जायचा. हे बघा, हा कापूस घेऊन गेलो तिथे, रक्तवाहिनी आणि तार याच्यामध्ये कापूस ठेवून द्यायचा. बस. आता मग तुम्ही मला म्हणताय की सर हे कापूस ठेवला, हा कापूस किती रुपयाचा आहे? जर डीप ब्रेन स्टिम्युलेशन सर्जरी केली, जर पेसमेकर सर्जरी केली हृदयाची, जर आपण गेलो दीनानाथ मंगेशकरला आणि पेसमेकर टाकलं, किती खर्च होईल? किती खर्च होईल? दीनानाथ मंगेशकर पेसमेकर सर्जरी केली तर एक जास्त 1.5-2 लाख. सह्याद्री हॉस्पिटलमध्ये केलं तर कदाचित थोडंसं, तिथं आहेत कोकणी PRO लोक, 1 लाखभर रुपये जास्त लागतील. पण जर डीप ब्रेन सर्जरी मेंदूची जर केली तर याला लागतात कमी कमी 10 ते 12 लाख रुपये. कारण जे डीप ब्रेन स्टिम्युलेशन जे पेसमेकर आहे ते आपल्याकडे बनत नाही, जर्मन कंपनी मेट्रॉनिक नावाची कंपनी बनवते, त्याच्यामुळे ते एवढं महाग आहे. आणि हे जी बॅटरी आहे ती बॅटरी फक्त 5 वर्षाची असते. 5 वर्षांनी परत फक्त इथं आपल्याला चिरा मारायचा, बॅटरी काढायची, दुसरी बॅटरी लावायची. माझ्याकडे एक पेशंट आला, तो म्हटलं सर ते तुम्ही मला व्हिडिओ दाखवलेला, त्याच्यामध्ये तुम्ही एक ते काहीतरी डिव्हाइस होतं, तुम्ही बॅटरी बंद करत होते, बॅटरी चालू करत होते, ते काय लफडं होतं? म्हटलं ते काही नाही, बाहेर एक डिव्हाइस असतं, आपण बॅटरी बंद करू शकतो, चालू करू शकतो. सर हे डिव्हाइस किती रुपयाचं आहे? म्हटले ते काही 20-25 हजार रुपयाचं. म्हटलं बस सर, मी तुम्हाला सांगतो ह्या डिव्हाइसची लाईफ 5 वर्षे नाही आहे, ह्या डिव्हाइसची लाईफ 10 वर्ष आहे. म्हटलं कसं रे? म्हणतो सर म्हातारा झोपला की डिव्हाइस बंद करायचं, म्हातारा उठला की डिव्हाइस चालू करायचं. म्हटलं वा. म्हटलं नगरचा का तू? म्हटलं हो. टॅलेंटवाले लोक आहेत आपण. एक केस दाखवतो फक्त, कारण याच्यामध्ये युट्यूबवर जरी आलं तरी काही प्रॉब्लेम नाही. 8 वर्षाची मुलगी आहे, डोक्यात कातर गेली. कातर कशी गेली हा प्रश्न मी कधीच विचारत नाही, ठीक आहे ना, बट ऑब्वियस आहे कातर गेली. ड्रिल करावं लागतं, म्हणजे जर कातर गेली असेल आणि ती निघत नसेल, आतमध्ये ती रक्तवाहिनीला किंवा मेंदूला चिकटलेली असू शकते, त्याच्या बाजूने पूर्ण असं 1 रुपयासारखं पूर्ण ड्रिल करायचं आणि अलगद कातर बाहेर आली पाहिजे आणि निघाली पाहिजे. बस. कातर निघाली, इथे दिसतंय का एका ठिकाणी तिथं भोग पडलेलं आणि आतमध्ये गेलेली कातर, तर तिथं ड्युरा मी थोडासा ओपन केला, आतमध्ये जिथे गेली होती तिथून रक्तस्राव होत होता, रक्तस्राव थांबवला आणि कातर निघून आली. ठीक आहे ना. आणि पेशंट अगदी व्यवस्थित वॉकिंग घरी गेली. न्यूजपेपरमध्ये पण आलेलं. आत्ता रिसेंटली एक कोयता गँगचा इन्सिडेंट झालेला, बघितलेला का तुम्ही? पुण्यामध्ये तो पेशंट माझ्याकडेच आलेला. आता तुमचं युट्यूब चालू आहे त्याच्यामुळे मी तो दाखवू शकत नाही. आय हॅव नॉट टेकन द कन्सेंट फ्रॉम द पेशंट. त्याच्यामध्ये ते त्याचं चेहरा वगैरे पण दिसतंय. तर नाही, तू युट्यूब बंद करू शकत असला तर मी दाखवतो. अच्छा, तू तो कॅमेरा इकडे करतो का तू माझ्यावर? ठीक आहे ठीक आहे, मग दाखवू शकतो. व्हेरी गुड. तर ही शेवटची एक केस दाखवतो आणि मग आपण थांबूया, कारण खूप हो. त्यांनी लगेच जुगाड शोधला, त्याला ते बघायची एकदम इच्छा नाही. नाही मला तर कोयतावाला बघायचंय सर, दाखवा. याला नाही रे, तू उलट केलं, त्यांना दिसत नाही. ते काय केलं तू? तिथं दिसतंय का? अच्छा दिसतंय का? आता याला फुल स्क्रीन बहुतेक, हे फुल स्क्रीन आहे का? नाही, एनिवे असले ब्रेन किंवा स्पाईनचे तर प्लीज तुम्ही मला रेफर करू शकता. एरवी पण कधी तुमच्याकडे पेशंट आला त्याचा स्कॅन मला पाठवा, लगेच फोन करून विचारा सर हे स्कॅन पाठवले सर्जरीचा लफडा आहे का नॉन सर्जरी, मी सांगेल मग हे कन्झर्वेटिव्ह मी आल्यावर मी बघेल, किंवा हे सर्जरी आहे, मग सर्जरी असेल सर पैसे किती लागतील, मी सांगेल किती पैसे लागतील आणि काय करता येईल. ठीक आहे, चालेल. थँक्यू व्हेरी मच फॉर द अपॉर्च्युनिटी. होप यू ऑल एन्जॉय.
Thank you, sir. Hello, check. Thank you, Chairman, sir. And now, next presentation is discussion on latest update in ortho. And faculties, my colleague at Dr. D.Y. Patil Medical College, Dr. Sachin Karkamkar. He is a MBBS MS consultant orthopedic surgeon, graduate from D.Y. Patil Medical College, Kolhapur, following which he did his PG MS Ortho from FMC, Pune University. He has served as unit head in YCM Hospital for 1.5 years, during which he gained a vast experience of managing complex and trauma cases. Because of his special interest in sports medicine, he's further updated his knowledge by doing fellowship at national and international centers since 2007. He has been working as consultant orthopedic, arthroscopic and arthroplastic surgeon in Hadapsar, Pune.
हॅलो ऑन कर ऑडिओ नाही लावलं तर हा ऑडिओ लागेल ऑडिओ हे चालू कर डिस्प्ले चालू कर. Right. So this is not my last slide. This is the first slide. Thank you for the opportunity, and I would like to thank you all for waiting in spite of having so much delay in your program. So like we have been doing the conferences from last 15 years or so. तर नॉर्मली कॉन्फरन्समध्ये काय बघितलं जातं की बरेच कॉम्प्लेक्स टॉपिक्स आपण डिस्कस करतो. डिस्प्लेत नाही आहे का? बरेच कॉम्प्लेक्स टॉपिक्स आपण डिस्कस करतो, कॉम्प्लेक्स प्रोसिजर्स आपण डिस्कस करतो, पण टेक होम मेसेजेस खूप कमी असतात. सो वी ऑल हॅपन टू बी इन अ रोल ऑफ चतुर, लाईक ऑफ अ 3 idiots. ॲक्च्युली वी हॅव टू बी इन अ रोल ऑफ रॅन्चो. इझी टॉपिक्स, सिम्पल टॉपिक्स अँड गुड टेक होम मेसेज. त्यामुळे माझ्या स्लाईडला टेक होम मेसेजची स्लाईड पण नाही आहे, बिकॉज ईच अँड एव्हरी स्लाईड विल हॅव सम टेक होम मेसेज फॉर यू. आयदर यू बी अ जनरल प्रॅक्टिशनर or a consultant or any other facility, you'll find something useful for you. So normally what we do when we see an orthopedic patient, there are couple of scientific what we can say pathologies which we deal with. तर या एक 25-30 गोष्टी आपल्याला जमल्या तर ऑलमोस्ट 90% ऑफ आपला ऑर्थोपेडिक प्रॅक्टिस आपली ओपीडी होऊन जाईल. तर या कॉमन गोष्टी ज्या आपण रोजच्या रोज बघतो जीपी प्रॅक्टिसमध्ये त्या आपण थोडक्यात डिस्कस करू एक स्लाइड्समध्ये. सेइंग सो, आय एम अ आर्थ्रोस्कोपिक सर्जन, आय एम अ जॉईंट रिप्लेसमेंट सर्जन. आम्ही रोबोटिक सर्जरी, आर्थ्रोस्कोपिक सर्जरी करतो. सध्या रोबोटिक सर्जरी वी आर एक्सटेंडिंग नॉट ओनली फॉर द नी बट ऑल्सो फॉर द हिप अँड शोल्डर. पण टुडे दिस इज नॉट द टॉपिक ऑफ अवर डिस्कशन. सर कुठलाही टॉपिक एक 30-40 मिनिटाच्या वरती आपलं हेजिटेशन होतं. आम्ही हे सगळे टॉपिक्स आपण सबडिवाइड करूया अँड देन वी विल सी. स्टार्टिंग ऑफ विथ बोन स्ट्रेंथ. सकाळी ऑस्टिओपोरोसिसचा एक चांगला टॉपिक झाला. थोडासा ब्रशअप करू त्या टॉपिकबद्दल.
तर ऑस्टिओपोरोसिस हे फक्त एल्डरी लोकांसाठी नाही आहे. आयडियली वी शुड लर्न अबाउट ऑस्टिओपोरोसिस इवन ॲट अ यंग एज. का बरं? कारण बोन ग्रोथ जेव्हा चालू होते तेव्हा ॲट द एज ऑफ 25-30 मेल्समध्ये बोन ग्रोथ ऑलमोस्ट स्लो होऊन जाते आणि फिमेल्समध्ये 35-40 पर्यंत आपण ही बोन ग्रोथ आपल्याला जाणवते. नंतर देन द बोन ग्रोथ स्टॉप्स. म्हणजे आपण आपली बोन स्ट्रेंथची बँक वी हॅव ओनली लिमिटेड टाइम पिरियड ऑफ 35 years or so to increase the bone. After that the bone will always degrade. In females it will be at a faster pace because of hormonal problems, and in male it will be comparatively slower. So female will lose the bone almost 3% every year, which is a very exponential value, and male fortunately only 0.3%. त्यामुळे जो काय आपल्याला बोन बँक आहे, बोन बँक यू कन्सिडर ॲज अ सेव्हिंग अकाउंट. यंग एजमध्ये, लहानपणापासून यंग एजमध्ये, वन्स यू स्टार्ट ऑफ डुईंग ऑल द फिजिकल ॲक्टिव्हिटीज, डायट, वी शुड क्रिएट अ सेव्हिंग अकाउंट विच वी कॅन यूज इट ड्युरिंग युअर पास्ट इयर्स म्हणू, किंवा आपण आपल्या पेन्शनसारखं आपण त्याला थोडं संबोधित करूया. तर बोन बँक चांगली डेव्हलप करायला पाहिजे टिल द एज ऑफ 35 years or so. का महत्त्वाचं? कारण ऑस्टिओपोरोसिस इज व्हेरी कॉमन आणि मॉर्टॅलिटी रेट्स आर खूप आहेत. म्हणजे एखाद्याला हिप फ्रॅक्चर झालं तर ओनली 30% ऑफ हिप फ्रॅक्चर पेशंट्स आर एबल टू गो बॅक टू देअर इनिशियल ॲक्टिव्हिटी. 30% विल डाय ऑन टेबल और ड्युरिंग फर्स्ट इयर ऑफ देअर पोस्ट ऑपरेटिव्ह पिरियड. तर मॉर्टॅलिटी रेट ऑफ हिप फ्रॅक्चर्स इज व्हेरी हाय. So hip fractures, most common reason is osteoporosis. Secondly, spine fractures जे होतात, which causes disability, bad posture, chronic backing, loss of productivity. These are also because of osteoporosis. These are very common in our Indian scenarios. So suppose a 55 years old female comes to your OPD and inquires about calcium. Calcium देणार की नाही? 55 years of age. Whether you will advise a calcium? Obviously, we will advise a calcium. But then we have so many options. Which calcium to be chosen? आता प्रत्येकाच्या घरात आपले आई वडील आहेत, आजी आजोबा आहेत, पण आपण युजली कॅल्शियमवर एवढं डिटेल स्टडी केलं जात नाही अनफॉर्च्युनेटली. ऑर्थोपेडिक सर्जन तर त्यातून थोडंसं अजून जरा मागेल, कारण दे आर मोर फोकस्ड ऑन सर्जिकल टेक्निक्स. त्यामुळे हा विषय थोडासा वाचला जात नाही, पण खूप कॉमन गोष्ट आहे. तर मोस्ट कॉमन कॅल्शियम दॅट वी यूज इज अ कॅल्शियम कार्बोनेट, सिट्रेट अँड सिट्रेट मॅलिएट. बट नाव रिसेंटली वी हॅव 2 more molecules, कॅल्शियम बिस्लायसिनेट आणि डायकॅल्शियम मॅलिएट. का महत्वाचं आहे? कारण एलिमेंटल कॅल्शियम कॅल्शियममधलं महत्वाचं आहे, बायोलॉजिकल अवेबिलिटी महत्वाची. सो यू सी इफ यू यूज कॅल्शियम कार्बोनेट, एलिमेंटल कॅल्शियम फक्त 40% आहे, ॲब्सॉर्प्शन 24 होतं. म्हणजे 100 मिलीग्रॅम 100 ग्रॅम कॅल्शियम खाल्ल्यावरती आपल्याला मिळतं फक्त 9.6 ग्रॅम. सेम इज देअर विथ अदर मॉलिक्युल्स. बट अदर कॅल्शियम लायसिनेट किंवा डायकॅल्शियम मॅलिएट बघितलं तर द ॲब्सॉर्प्शन इज मोर, अवेबिलिटी इज मोर, and hence more amount of calcium will be there available for your bone formation. So whenever you choose a calcium, don't choose because it is easily available, don't choose because it is available in your operation theater or in your pharmacy. You have to study that molecule, because this is a very common calcium, that very common medicine that we everybody happen to use, but don't focus much about that. तर हे 2 molecules आहेत ज्याबद्दल तुम्ही थोडा स्टडी केला पाहिजे, and then you can incorporate that in your practice. दुसरा कॉमन क्वेश्चन आहे, रिनल स्टोन्स आहेत, कॅल्शियम घेतलं पाहिजे का नाही? मेनी ऑफ द पेशंट विल आस्क किंवा स्टोन्स होतात का कॅल्शियममुळे? तर कॅल्शियममुळे स्टोन्स होणार नाहीत. आणि इन केस पेशंट हॅज सच अ हिस्ट्री, द बेस्ट कॅल्शियम टू बी यूज इज अ कॅल्शियम सिट्रेट. बिकॉज कॅल्शियम स्टोन कधी होतील? जर फ्री कॅल्शियम तुम्हाला ऑक्झलेट बरोबर किंवा फॉस्फेट बरोबर जर बाइंडिंगला अवेलेबल झाला तर तो स्टोन होईल. दिस कॅल्शियम सिट्रेट फॉर्म्स अ सोल्युबल मॉलिक्यूल. इट डझंट मेक द फ्री कॅल्शियम अवेलेबल टू फॉर्म द स्टोन. So if somebody is having a history of calcium stones, the best molecule available for calcium is calcium citrate. One step ahead, it will also helps to decrease the formation and dissolve the stones if they are already formed, because it increases the pH. So the choice of molecule for a renal patients is calcium citrate maleate. Vitamin D very common. CKD patient la cholecalciferol dila, inactive vitamin D, it will not be of use because her kidneys are not functioning. So in case you are giving calcium to a patient of a renal disease, CKD stage 3 or 4, तो always give them a active form of vitamin D. Inactive form चा फायदा होणार नाही. So involve a active form for that. Red flags काय आहेत? बराच वेळा आपण ॲज अ ऑर्थोपेडिक सर्जन पेन किलर देतो, अँटॅसिड देतो आणि मग कॅल्शियम देतो. तर हे कॅल्शियम जर कॅल्शियम कार्बोनेट असेल, and if you are giving an antacid with it, calcium carbonate requires acidic media, so that calcium will be of no use, because this is very common, painkillers, antacid and calcium. So in case you are using an antacid, always use a calcium citrate. If you are giving a anticonvulsant, iptoin deto apan, the iptoin and calcium, they will interact with one another. Both will decrease one another's efficiency. So you have to space them. Calcium sakali द्या, iptoin संध्याकाळी द्या. Spacing has to be done. Calcium मध्ये आता सध्या आपण वापरतोय 2 गोष्टी. Apart from calcium and vitamin D is magnesium, and vitamin K2. Magnesium काय करतं? Magnesium activates the vitamin D and it helps to absorption of a calcium. Magnesium is like a gatekeeper. It will not allow the calcium to go into the cells of kidney, liver, other visceral organs. त्यामुळे जे calcification soft tissue मध्ये होतं, calcification of soft tissues which happens, it may be even in the arteries giving to atherosclerosis. So calcium, adding a magnesium to a calcium tablet will help us to prevent this visceral organ deposition of the calcium. So it should also contain a magnesium. Vitamin K2, what does it does? Vitamin K2 काय करतं? तर जे calcium आपल्या blood vessels मध्ये आहे, it transports the calcium from blood vessels to the bone. तर gut मधून blood vessel मध्ये आणतो vitamin D, and vitamin K2 will take it from gut to the bone. So we need these 5 ingredients in your calcium tablet: calcium, vitamin D, magnesium and vitamin K2. That forms a good combination of a effective calcium which is good for absorption. Again, there is a lot of controversy regarding vitamin D3. Whenever you have a severe deficiency, intramuscular vitamin D is more cost effective, more consistent, sustained release, and it also helps to have a compliance of patient, because बरेच patient आपले vitamin D2 खूप कालांतरासाठी घेत नाहीत. They drop it in between. तर injections will assure that the compliance is maintained, and it is also cost effective. So severe deficiency managed with preferably injections, and जर moderate to mild deficiency असेल तर you can go for a once a week oral doses. Same patient आता 55 वर्षाची 60 वर्ष झाली, and then she comes and asks us whether only calcium is enough. तुम्ही calcium तर खूप छान दिली आहे, पण तीच calcium मी आयुष्यभर घ्यायची का? तर the answer is that we need to add something more than a calcium, which is a bisphosphonate molecule. तर अगदी सोप्या भाषेत, without going into the metabolism, if you want to explain what bisphosphonate does, तर एक पाण्याची टाकी इमॅजिन करा. पाण्याच्या टाकीमध्ये तुम्ही कॅल्शियम टाकताय, म्हणजे कॅल्शियम टॅबलेट खातोय, पण त्या टाकीचा जर नळ उघडा असेल तर काय होईल? पाणी सगळं खाली जाईल. So what bisphosphonate does, it stops the loss of calcium going from the bone. तर बोन मधून जे कॅल्शियम बाहेर पडतंय त्या कॅल्शियमला हॉल्ट करायचं काम बिस्फॉस्फोनेट करतं. तर पाणी भरतं आणि नळी बंद करतं. दॅट्स द रिझन की मॅक्सिमम अमाउंट ऑफ कॅल्शियम विल अक्युमुलेट इनटू युअर बोन्स. So add a bisphosphonate when the age is more than 60 or BMI is more than -2.5. Same patient maybe at the age of अजून 5 वर्ष bisphosphonate घेतले तर नंतर काय bisphosphonate cannot continue for more than 5 years. We have to stop because there are issues of side effects. खूप दिवस bisphosphonate तर atypical fractures होतात. तर these patients from bisphosphonate has to be shifted on to injectable molecule, denosumab, teriparatide. तर वेगळे कंपाउंड्स आपल्याला चेंज करावे लागतील. We'll have to go from oral to injections at the end of 5 years because safety data is available only for 5 years. तर सगळ्यात महत्त्वाची स्लाइड जी आहे आपल्याला तर ती म्हणजे ही जिरॅट्रिक पॉप्युलेशन मध्ये फॉल प्रिव्हेंट करणं खूप 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 महत्त्वाचं आहे. तर प्रत्येकाच्या घरात आपले स्वतःचे आई वडील आहेत, आजी आजोबा आहेत, तर प्रिव्हेंटिव्ह मेजर्स आर व्हेरी इम्पॉर्टंट बिकॉज इनव्हेरिएबली इन अ एल्डरली पेशंट फॉल झाला की फ्रॅक्चर्स आहेत. घरामध्ये प्रेफरेबली चप्पल, शूज, सॉक्स न घातलेले बरे बिकॉज प्रॉप्रिसेप्शन जी आपल्याला पायामध्ये नाही येतं दॅट हेल्प्स टू प्रिव्हेंट द फॉल. घरामध्ये जर कार्पेट्स वगैरे असतील त्याच्या बऱ्याच वेळा कार्पेट्स असे त्याचे फोल्ड झालेले असतात दॅट इन्क्रीज द रिस्क ऑफ द फॉल. 90% जे आजी आजोबा पडतात ते बाथरूममध्ये पडतात, रात्रीच्या वेळी पडतात. त्यामुळे बेडरूम ते वॉशरूम तो एरिया जो आहे तो बऱ्यापैकी एनलाइटन पाहिजे. देर शुड बी सफिशियंट सपोर्ट्स अवेलेबल टू प्रिव्हेंट द फ्रॅक्चर्स. त्याशिवाय घरामध्ये काही ऑब्जेक्ट्स, केबल्स असतील, काही वस्तू पडलेल्या असतील, ट्राय टू अवॉइड दोज ऑब्जेक्ट्स ऑन द फ्लोअर दॅट ऑल्सो प्रिव्हेंट्स द फॉल. स्टेअरकेस असेल तर रेलिंग पाहिजे. सो दीज आर व्हेरी स्मॉल थिंग्स बट दिस विल डेफिनेटली मेक अ इम्पॅक्ट इन प्रिव्हेन्शन. त्याशिवाय जर व्हिज्युअल प्रॉब्लेम्स असतील, ऑडिटरी प्रॉब्लेम्स असतील, दॅट प्रिव्हेंट्स देम फ्रॉम गेटिंग द सिग्नल्स. तर hearing loss है, vision problems है, do take care of these simple things before going for the high-fi things of calcium and vitamin D. Prevention is very important. सगळ्यात कॉमन प्रॉब्लेम नंतर फायब्रोमायल्जिया, अप्पर बॅकला पेन होतो बराच वेळा. इट इज युजली बिकॉज ऑफ द ट्रॅपिजियस. ट्रॅपिजियस नावाचा मसल जो असतो तो स्टिफ होतो अँड दिस विल रिस्पॉन्ड मोर टू द फिजिओ अँड टू द पेन किलर्स. तर याला म्हणतो आपण फायब्रोमायल्जिया. व्हेरी कॉमन सिम्पटम्स. बऱ्याच फिजिशियनला सुद्धा हा प्रॉब्लेम असतो कारण रिपीटेडली वाकून वाकून त्यांना स्टेथोस्कोप मधनं वागताना, बीपी घेताना प्रोलॉंग्स बेंडिंगमुळे हा फायब्रोमायल्जिया होतो. And what most important thing is that in spite of having a painkillers or a physiotherapy, many of them may not be better कारण it has a effect of stress and anxiety. त्यामुळे याला serotonin uptake inhibitors molecule चालू करावे लागतात. Second most common thing is tennis elbow. Tennis elbow very commonly seen in OPD. टेनिस एल्बो मध्ये जो कन्सेप्ट आपल्याला माहिती पाहिजे तो म्हणजे कोर अब्डॉमिनचा. जर एखाद्या पेशंटचा कोर मसल्स वीक असतील तर एक्सेसिव्ह फोर्स विल कम ऑन द शोल्डर ऑर ऑन द एल्बो. तर टेनिस एल्बोच्या पेशंटला फक्त एल्बोच्या एक्सरसाइजेस करून फरक पडणार नाही. एल्बो शिवाय कोर स्ट्रेंथनिंग करणं किंवा शोल्डर चांगलं करणं, बिकॉज एव्हरीथिंग इज इन अ कायनॅमॅटिक चेन. So the take home point for tennis elbow when you are seeing the patient in a OPD is not to focus only on elbow but to also on the other systems of the body. Pain along the thumb, decurrent stenosynovitis is very common. कणिक मळताना दुखतं, कपडे पिळताना दुखतं. जेव्हा ग्रिपिंगची कामं तुम्ही करता तेव्हा या टेंडॉनमुळे प्रॉब्लेम येतो. तर दिस टेंडॉन कॅन बी मॅनेज, इन्फ्लेमेशन कॅन बी मॅनेज बाय द फिजिओ अँड मेडिकेशन्स. सध्या हाय इंटेन्सिटी लेझर्स अवेलेबल आहेत. फिजिओथेरपी इज अ व्हेरी ॲडव्हान्स ब्रांच अँड अनफॉर्च्युनेटली वी आर अंडर युझिंग द फिजिओथेरपी. लेझर्स आहेत किंवा शॉकवेव्स आहेत, ह्याचा जर बरोबर उपयोग केला गेला तर फिजिओथेरपीने बऱ्यापैकी फरक पडू शकतो. टिंगलिंग नमनेस, रात्रीच्या वेळेस हाताला मुंग्या येणं, व्हेरी कॉमन थिंग. द डायग्नोसिस बिंग कार्पल टनेल सिंड्रोम. आता कार्पल टनेलमध्ये रात्रीचा मुंग्या येण्याचा प्रॉब्लेम कशामुळे होतो तर हाताची हालचाल. When the wrist is in neutral position, the pressure within the wrist is only 30 millimeter. But when it goes into dorsiflexion किंवा palmar flexion, ते pressure 110 किंवा 100च्या पलीकडे जातं. And that is the reason why these patients will be more symptomatic in the night, and the night splint will definitely help them. Simple measure of night splint stretches should be able to take care of your carpal tunnel syndrome. Trigger finger, typical again because of tendinitis, tendon से inflammation मुळे. What we do is a dynamic assessment. UEG करतात, stretches करतात, कधी कधी UEG guided injections पण आपण देऊ शकतो. This is also very common thing that we will find in your OPD basis. Knee pain. Every alternate patient above the age of 55 years will have a knee pain. Most common thing not to be done is not to go for staircase climbing. जमिनीवर उडबस करणं, जिना चढणं उतरणं जेवढं कमी करू तेवढं चांगलं. कारण आपण जेव्हा जिना चढ उतार करतो तेव्हा आपल्या गुडघ्यावरती आपल्या वजन 4 ते 5 पट वजन पडतं. जमिनीवरनं उठताना 8 पट वजन पडतं. तर सिंपल रिस्ट्रिक्शन्स किंवा जर जिना चढणं उतरणं कमी केलं किंवा लिफ्ट नसेल तरच चढ उतार केली किंवा जमिनीवर बसणं कमी केलं किंवा वर्षातनं घरी एकदाच पूजा तेव्हा बसा. These things will decrease the loading on the cartilage and it will improve the life of your joint. हातामध्ये काठी घेणं अगदी सिंपल गोष्ट आहे, पण बरेच आजी आजोबा घेत नाहीत. काठी घेतल्याने आपलं पूर्ण शरीराचं निम्म वजन काठीने जमिनीत जातं. तर एव्हरी टाइम यू टेक अ स्टिक, जर तुमचं वजन 70 किलो असेल तर काठीमुळे प्रत्येक स्टेप बरोबर प्रत्येक पावलावर 35 किलो वजन हे तुमच्या गुडघ्यावर कमी पडेल, विच इज गोइंग टू बी अ व्हेरी लार्ज. कारण आपण दिवसभरामध्ये जवळपास 3 ते 4 हजार पावलं चालतो. 3 ते 4 हजार पावलं मल्टिप्लाय बाय 35 किलोग्राम वेट. दिवसभरामध्ये तुम्ही समेशन करून बघितलं तर इट विल मेक अ व्हेरी गुड इम्पॅक्ट. तर काठी वापरणं सगळ्यात सोपा उपाय आहे. इट ऑल्सो इम्प्रूव्ज युअर बॅलन्स. So don't shy away from using a stick if you are having a significant pain in the knee. Knee supports तसे भरपूर आहेत, पण these are all seem to be like a decorations. Knee supportची तशी सायंटिफिकली विचाराल तर गरज नसते. आपल्या गुडघ्याच्या वरचेच नाही म्हणजे quadriceps muscles आणि hamstring muscle, these two muscles are like a God given belt. देवान दिलेला हा नॉर्मल पट्टा आहे. ज्यांचे quadriceps hamstring strong आहेत त्यांना बाहेरनं बेल्ट लावायची गरज पडणार नाही. So knee supports are more for the psychological effects. Don't spend much of your energy and literature or research on knee supports. Knee supports work only 5%. What really works for you is a exercise program and a physiotherapy. तर फिजिओथेरपी वरती भर द्यायला पाहिजे along with activity modifications. बरेच जण आता जेल लावतात, जेल स्प्रे आपण लावतो. तर जेल स्प्रे जे आहेत ते टोटली वेगळ्या प्रकारे करतात. दे वर्क बाय द फिलॉसॉफी ऑफ अ डिस्ट्रॅक्शन. व्हॉट दे डू, तुम्ही एखादं जेल किंवा एखादं मलम लावलं तरी जस्ट ऍक्ट एज अ काउंटर इरिटेंट फॉर द स्किन. तर स्किनला काउंटर इरिटेशन झाल्यामुळे मेंदूला ज्या वेदना गुडघ्यात येतात त्याचा विसर पडतो. सो इट जस्ट डिफ्लेक्ट्स युअर ब्लड, इट डिस्ट्रॅक्ट्स युअर ब्रेन, इट डज नॉट डायरेक्टली हेल्प टू इन्क्रीज द आर्थरायटिस प्रोफाईल ऑफ युअर नी. त्यामुळे जेल स्प्रे याचा पण इफेक्ट फार लिमिटेड आहे. टू बी यूज ओनली इन अ एल्डरली पेशंट. रात्री अपरात्री खूप दुखायला लागलं, ट्रॅव्हलिंगच्या दुखायला लागले तरच वापरा, अदरवाईज बी अवे फ्रॉम दॅट. देर आर डिफरंट इंजेक्शन्स अवेलेबल डिपेंडिंग ऑन द स्टेज. स्टेज 1-2 आर्थरायटिसमध्ये आपण हे इंजेक्शन्स वापरू शकतो. लेट स्टेज आर्थरायटिसमध्ये इंजेक्शनचा फारसा फायदा होत नाही. चॉईस ऑफ अ पेन किलर, पेन किलर्स खूप सातत्याने वापरले जातात, बट ऑलवेज सी द सेफ्टी प्रोफाईल. सगळ्यात safest among all is a paracetamol, followed by the Dynapar, then aceclofenac. So you should form the ladder form, gradually escalate from the safest molecule to the highest molecule. आणि सध्या सगळ्यात सेफेस्ट आहे डोलो, पण आता डोलो लोकांना दिली की त्याचा इफेक्टच होत नाही. यू सेम मॉलिक्यूल बट फ्रॉम अ डिफरंट कंपनी. डोलो क्रोसिन आर सो यूज टू की त्या प्लासिबो इफेक्टच निघून जातो त्याचा. So don't hesitate to use a paracetamol, but use a brand which is slightly unnoticeable to the patient so that it is safer as well as effective. TKR जे आहेत रिसेंटली आता आपण नी सर्जरीज नी रिप्लेसमेंट्स करतो, बऱ्याच वेळा ऐकतो. तर TKR जे आहे ते खूप लवकर पण करू नये, गुडघ्याचं ऑपरेशन खूप उशिरा पण करू नये. द राईट टाइम टू डू द TKR और नी रिप्लेसमेंट इज व्हेन द डेली ऍक्टिव्हिटीज आर इनिबिटेड. रोजच्या कामांमध्ये जर प्रॉब्लेम यायला लागला, रोजचे कामं स्वतःला जमत नसतील किंवा सारखं सारखं पेन किलर घ्यायची गरज पडली तरच नी रिप्लेसमेंटचा फायदा पडतो. सो डोंट पुश फॉर पेशंट्स फॉर द TKR इन अ व्हेरी अर्ली स्टेज. त्याचं TKR जे केलं जातं ते रोबोटिक टेक्नॉलॉजीने केलं जातं, विच इज मोर टाइम टेस्टेड, मोर ॲक्युरेट, आणि रिकव्हरी इफ यू सी इज व्हेरी फास्ट. पेशंट्स आर एबल टू वॉक, डू द स्टेअरकेस विदिन कपल ऑफ वीक्स ऑल्सो. द रिकव्हरी पेशंट आर ॲम्ब्युलेटरी, 1-2 दिवसामध्ये ते चालायला फिरायला लागतात. जे एक हेजिटेशन असतं की ऑपरेशन झालं की आपण खूप दिवस झोपून राहू, आपण कुणावर डिपेंडेंट राहू किंवा आपल्याला वॉशरूमसाठी प्रॉब्लेम येतील, तर इट इज नॉट सो. सेकंड थर्ड डे मोस्ट ऑफ द पेशंट्स आर आउट ऑफ द बेड अँड दे आर एबल टू गो बॅक अँड अटेंड देअर ओन ॲक्टिव्हिटीज. तर TKR ही आता फास्ट ट्रॅक सर्जरी झाली आहे. हेजिटेशन्स नसले पाहिजे TKR मध्ये, कारण रिहॅब चांगला झाला तर रिकव्हरी फार फास्ट होते. TKR मध्ये एक सातत्याने किंवा एक फोकस करून सांगायची गोष्ट म्हणजे अशी की ऑपरेशनचा रिझल्ट तेवढाच महत्त्वाचा जेवढा फिजिओथेरपीचा आहे. सो इफ यू हॅव अ गुड सर्जिकल प्रोसिजर फॉलोड बाय गुड फिजिओथेरपी देन द रिपोर्ट्स आर व्हेरी गुड. मोस्ट कॉमन प्रॉब्लेम ऑफ नी पेन इन यंग पेशंट इज कॉन्ड्रोमलेशिया. गुडघ्याच्या वाटीला पेन होणं, रिपीटेड स्क्वॅटिंग किंवा स्टेअरकेस क्लाइम्बिंगमुळे हे युजली होतं. सो दॅट ऑल्सो नीड्स अ फिजिओथेरपी. टिंगलिंग नमनेस ऑन द लॅटरल साइड इज युजली बिकॉज ऑफ न्यूराल्जिया, मेराल्जिया पॅरासिटिका आपण हे सिम्पटम्स म्हणतो. मसल क्रॅम्प्स, बरेच आजी आजोबा येतात, सांगतात की रात्री पोटऱ्या इतक्या जास्त दुखतात की त्याला ऑलमोस्ट असं काहीतरी कापड किंवा रुमाल बांधून झोपावं लागतं. द मसल क्रॅम्प्स आर व्हेरी कॉमन इन OPD प्रॅक्टिस. And the best way to manage that is with vitamin D, magnesium, carnitine and vitamin E. Carnitine is like a molecule which will give them strength to the muscles. Fatty tissues la glucose मध्ये convert करायचं काम carnitine करतं. So if you have combination of these things in your medication, then the muscle fatigueness or muscle cramp will be taken care of. Heel pain, plantar fasciitis, सकाळी उठल्या उठल्या पहिलं पाऊल ठेवलं की दुखतं. That is very typical of plantar fasciitis. रात्रभर पायाची हालचाल झाली नाही, tissue stiff zala, then gives a very typical pain of first step in the morning. Even this will improve with good amount of physiotherapy. Great toe pain, very typical of uric acid. तर पायाच्या अंगठ्यामध्ये युरिक ऍसिडचा प्रॉब्लेम फार कॉमनली होतो. द रिझन बिंग पायाच्या अंगठ्याचं जे सांधा आहे, दॅट इज द जॉइंट दॅट इज हॅव्हिंग द लोएस्ट टेम्परेचर इन द बॉडी. So uric acid has an affinity to go into those joints and deposit where the temperature is low. That is the reason this is a favorite joint for the uric acid. Then comes the shoulder problems. The movements can be reduced because of rotator cuff. And this rotator cuff can be managed again with a physiotherapy. Different types of rotator cuff tears. So in a nutshell, if you take into consideration these couple of OPD things in your practice, most of the orthopedic issues will be settled down. So thank you very much for patient listening. I'm sorry I had been too fast because already I'm late for the program. So I won't take much of a time. Any queries if there, I'll be happy to answer.
Thank you very much, sir. Sir has an emergency patient, so sir has to rush early. May I request our President Anil Shirke sir to felicitate Dr. Sachin Karmakar. Sir is a batchmate of Anil Shirke sir. Thank you. The next lecture will be by Dr. Sunil Subhash Narute. He has done MBBS, DTCD, DNB Pulmonary Medicine, currently working as a consultant chest physician at Shras Clinic, Akluz. He is a director internship at Aklai ICU and Multispecialty Hospital, Akluz. So please welcome Sunil Subhash Narute. His topic is TB, what is new in treatment?
First of all, I am thankful to Dr. Anil Shirke sir and entire organizing committee for giving me this opportunity. आता मला असं वाटतं की AI न्यूरोसर्जरी एवढे सगळे झाल्यानंतर टॉपिक TB म्हणले की सगळ्यांना वाटत असला कुठला टॉपिक ठेवलाय. But I think still TB is important because it is leading cause of death in our country in infectious diseases category. झालं ना? काय झालं? दुसऱ्या लॅपटॉपमध्ये घेते काय मग? तो मगाचा लॅपटॉप त्यात नाही मगाचा लॅपटॉप आता काय बोलणार? व्हिडिओ नाही येत नाही व्हिडिओ नाही येत. माझा लॅपटॉप बनायचा का? लावला. पूर्ण होत नाही. So let us continue. So TB is, why is TB important? Because TB is still leading killer in infectious diseases category. For shorter period, COVID-19 actually surpassed TB, but still now TB is the leading cause of death. And approximately 10.6 million people fall ill with TB annually. And mortality is roughly 1.3 to 1.5 million deaths per year. So it is quite significant number. And majority of patients are young patients, they are working class patients, so that's why TB is important. आता ही जर स्लाइड बघितली तुम्ही तर ह्याच्यामध्ये आपण आता म्हणतोय इंडिया 4th लार्जेस्ट इकॉनॉमी झाली आहे, तरी वी आर फर्स्ट इन ऑल कंट्रीज in number of cases. So we have almost like highest absolute number of cases of pulmonary TB in our country. So what is global share? India accounts for 25% of world's TB cases and 28% of global TB deaths. And incident trends, in 2015 it was 237 per lakh population, and in 24-25 it is 187 per lakh population. Definitely it is decreased, but still it is quite a significant higher incident trend. And mortality is around 21 per lakh in 24-25. and it accounts for 32% of world's multi-drug resistant tuberculosis cases. So it is very high number, and we have to really be worried for that. And in 2024-25, India diagnosed approximately 64,000 MDR-TB cases. So before going to treatment part, we will first see the diagnosis part of TB, and a lot has changed in diagnosis of pulmonary TB. So traditionally we use sputum microscopy. So it is primary tool for diagnosis of TB. So it is essential for identifying infectious cases. It is used to monitor patients' response to treatment. It is rapid, inexpensive, and requires minimal specialized equipments. Sputum microscopy म्हणजे जे आपण simple ZN staining जे करतो ती test. So what are the limitations of microscopy? It requires at least 5,000 to 10,000 bacilli per ml of sputum to be positive. It cannot distinguish between Mycobacterium tuberculosis and non-tuberculous mycobacteria. It cannot tell if bacilli are alive or dead, and it cannot detect if strain is multi-drug resistant or not. So now new technique for taking swabs is tongue swab technique, specifically in pediatric population in which we cannot take sputum samples, and many times gastric lavage is actually it is difficult procedure to do in pediatric patients. So we can do tongue swab in these patients, and these swabs are processed with molecular tests like GeneXpert Ultra. So molecular tests actually have changed the diagnosis of diagnosis scenario of tuberculosis, and the molecular tests target the DNA of Mycobacterium tuberculosis, providing much higher sensitivity and identifying drug resistance simultaneously. So it has advantage of detection and also diagnosing resistance at the same time. And we get results within 1 to 2 hours. It has high sensitivity even in possibacillary cases, such as in children and HIV positive patients, and in many other patients also. So it can detect as low as 100 bacilli per ml, and it can also detect resistance, which is important in MDR cases. So most important test is GeneXpert MTB-RIP. माझ्या सगळ्यांनी ही टेस्ट लक्षात ठेवणं गरजेचं आहे, आणि each and every case of pulmonary TB we should do this test. आणि हे काही फक्त pulmonary TB साठी नाही, जे एक्स्ट्रा pulmonary TB चे पण जे पेशंट्स आहेत, जे lymph node TB आहेत, जे तुमचे abdominal cox चे पेशंट आहेत, ज्याच्यामध्ये सर्जन्स बायोप्सी घेतात, आणि बाकीचे जे CNS tuberculosis आहेत, मिलियरी tuberculosis चे पेशंट आहेत, तर सगळ्यांमध्ये you should do GeneXpert. So what this test do? It actually diagnose Mycobacterium tuberculosis, and at the same time it gives whether it is patient is rifampicin resistant or not. And in pulmonary it has great sensitivity, like in smear positive it has almost 90 to 97% of sensitivity, and in smear negative it is 60 to 80% of sensitivity. म्हणजे पेशंट जरी स्पुटम AB निगेटिव्ह असतील तर 60 to 80% पेशंट्स मध्ये आपण GeneXpert ने डायग्नोसिस करू शकतो. And it has specificity of around 98 to 99%. And for rifampicin resistance detection, it is more than 94% of sensitivity and more than 98% of specificity. So why rifampicin resistance is important? Because rifampicin resistance is surrogate marker of MDR tuberculosis. And if patient is rifampicin resistance, that means patient is MDR TB case. And its turnaround time is only 60 to 90 minutes. So only in 1 hour to 1.5 hours you get result. So this is the game changer test. Like you get diagnosis, and at the same time you get like whether patient is resistant to rifampicin or not. Then second test is expert MTB XDR. Once patient is positive with this test, we have to do this test. This is follow-on test, and it detects resistance to isoniazid, fluoroquinolones, ethionamide, and second line injectables. So again, if you have to subcategorize patients into MDR TB, pre-XDR TB, XDR TB, this test is really important. And it can differentiate between low level and high level resistance to isoniazid and fluoroquinolones, allowing for more precise dosing. म्हणजे काही पेशंट्स मध्ये जर तुम्ही लो डोस आयसोनियाझिड देत असाल आणि लो डोस मॉक्सिफ्लॉक्स देत असाल तर ते पेशंट्स बऱ्याच वेळा हाय डोसला पण सेन्सिटिव्ह असतात, तर ते आपल्याला ह्या टेस्ट मध्ये एकदम ॲक्युरेटली कळणार आहे. Then again, third test is line probe assay. So I will not go into technical part. We get result within 1 to 2 days, and in this test you will get first line LPA and second line LPA. In first line LPA, you will get resistance to isoniazid and rifampicin, and in second line, you will get resistance to fluoroquinolones and second line injectables. And it confirms like whether patient is MDR-TB, pre-XDR-TB, and you also get result in 1 to 2 hours. Only disadvantage with this test is it requires a specialized laboratory and trained personnel. But in Gene Expert and Expert XDR, you can do this test with simple setups, and your normal technicians also can do this type of tests. The third most important test is TB MGIT culture. So in each patient, you have to send molecular test plus culture, because culture is the gold standard test, and you can do DST, which can confirm the results of molecular tests. So you get results within most of the cases, you will get result within 1 to 2 weeks, and compared to previously used solid media, in which results we are getting in 3 to 8 weeks. So average turnaround time is 1 to 2 weeks. So coming to our today's main talk on treatment of tuberculosis, and what are the recent advances in tuberculosis treatment. So this is our standard treatment, 6 months regimen, 2 HRZD plus 4 HRE. I think everyone knows that. And now this shorter 4-month regimen is granted for drug-sensitive tuberculosis. It consists of 2 months of isoniazid, rifampicin, pyrazinamide, and ethambutol, followed by 2 months of isoniazid, rifampicin, and moxiflox. So now treatment is, duration is decreased to 4 months of treatment. Most important thing I want to convey today is TB treatment is not equal to AKT4. म्हणजे TBचा पेशंट पॉझिटिव्ह आलाय म्हणजे त्याला AKT4 द्या असं नाही. You have to actually patient give treatment basis on the basis of the weight of the patient, because if patient is of 90 kg and you are giving AKT4, so definitely you are giving underdosing, and chances of treatment failures are very high. So dose of isoniazid is 5 mg per kg, maximum is 300 mg. Rifampicin is 10 mg per kg, maximum dose is 600 mg. For pyrazinamide, it is 25 mg per kg, and maximum dose is 2 gram. And for ethambutol, 15 mg per kg, maximum dose is 1600 mg. So please give doses according to the weight of patient. So these are the definitions of drug-resistant tuberculosis. For MDR, either in everything, every category, rifampicin resistance is must. In MDR, it may be rifampicin resistance with or without INH resistance. In pre-XDR TB, rifampicin plus or minus isoniazid plus fluoroquinolones. And in XDR TB, rifampicin plus or minus INH plus fluoroquinolones plus 1 group A drug, which may be, which can be bedaquiline or linezolid. So this is the latest WHO classification of anti-TB drugs. Now it is categorized into group A, group B, and group C. In group B, it is Leoflox or Moxiflox, bedaquiline, and linezolid. In group B, it is clofazimine, cycloserine, ethambutol, delaminid, and pyrazinamide. Clofazimine and cycloserine. In group C, it is ethambutol, delaminid, pyrazinamide, imipenem celestine, amikacin, ethionamide, and PAS. So how one should approach the cases of drug-resistant tuberculosis? So in each case, you have to do Gene Expert. In government setups also it is available. In every SDH, district hospitals, medical college, this test is available. It may have different names like TrueNat, CBNat, but please do this test in each and every patient. So once you diagnose drug-resistant tuberculosis, then start pre-treatment evaluation and send sample for expert XDR or line probe assay. You can do any test depending on whether patient is put like smear positive or not. Like if patient is 1+ or more than 1+ positive, then you can do LPA. And in Gene Expert, even 1+ is also sufficient. And culture is important in each and every patient. And depending on like these reports and final drug resistance pattern, severity of TB, previous exposure to ATT drugs, and whether patient is pregnant, whether there is pregnancy or not, you have to give shorter regimen, longer regimen, and recently launched ultra short Bipal-EM regimen. So Bipal-EM regimen now for even MDR TB cases, 6 months treatment is available. Previously it was almost 2 years. Gradually it was decreased to 18 months. and now then 9 months, and now it is finally 6 months of treatment. So it consists of bedaquiline, pretomanid, linezolid, and moxifloxacin. Now it is gold standard treatment for drug-resistant tuberculosis. And in India also, government of India and the WHO have officially rolled this out to replace older 9 to 20 months of regimens. So its duration is reduced from 20 months to 6 months. Efficacy, it has success rate of more than 89% in selected patients, and pill burden is drastically reduced to 920 total pills compared to 5,000 total pills. So inclusion criteria for this regimen is age more than 14 years, pulmonary MDR, rifampicin resistant tuberculosis or non-severe extrapulmonary TB, and less than 1 month of previous exposure to bedaquiline or linezolid. And exclusion criteria is pregnancy or breastfeeding patients, severe extrapulmonary TB like CNS TB, skeleton bone TB, and disseminated TB. So these are the doses of Bipalium regimen. Then we have longer duration DRTB regimen. So in that, at least 5 effective drugs should be included. From group A, all 3 drugs should be included. From group B, both the 2 drugs are included, like clofazimine and cycloserine. And in group C, we have delaminid, amikacin, and other options. And these are the add-on drugs. If a patient is suppose pre-XDR-TB and he is resistant to fluoroquinolones also, then we can replace fluoroquinolones with delaminid. And if patient is not tolerating any other drug, then we can replace it with amikacin. So we have intensive phase of at least 5 drugs for 6 months and continuation phase of at least 4 drugs for the remaining 12 to 14 months. And total duration is 18 to 20 months. So shortly we will discuss 2 cases. First case is 30-year male. He is software engineer at Pune, came with history of dry cough, fever, weight loss since 1 month. And on investigation, his X-ray showed right upper zone inhomogeneous opacities with cavity. His sputum AB came negative. HRCT chest showed centrilobular nodules with tree bud in whole right upper lobe with cavitation in anterior segment. So what should we do next? आपण ह्या पेशंटला फक्त क्लिनिकल हिस्ट्री आणि चेस्ट एक्सरे फाइंडिंग ज्या क्लासिकल आहेत टीबी साठी त्या बेसिसवरती आपण एकेटी सुरू करायला पाहिजे का आपण काय वेगळं करायला पाहिजे? So we did something different. Actually it is protocol only. So we did video bronchoscopy, and as patient was not expecting that much sputum, we did bronchoscopy with bronchoalveolar lavage from right upper lobe, and his BAL AB smear came 1+. But see the gene expert report. His gene expert showed MTB detected and rifampicin resistance also detected. So he was first time TB case, like primary TB case. He had never TB in past. So BAL TB MJT culture came positive after 1 week. Then these are the reports. So you can see, like in first report, his gene expert showed detection and rifampicin resistance. And this is the expert XDR report. You can see Mycobacterium tuberculosis detected, isoniazid resistance, which was low resistance, and ethionomide resistant. All other drugs were sensitive. So he was started on shorter oral regimen, and he was cured after 11 months of treatment. आपण जर समजा ह्याच्या ह्या टेस्ट केल्याच नसत्या तर तो दुसरी ट्रीटमेंट नॉर्मल ट्रीटमेंट घेत राहिला असता आणि नंतर एक्सटेन्सिव्ह डिसीज झाल्यानंतर त्याला खूप सारे पोस्ट टीबी सिक्वेली राहिले असते जरी नंतर त्यांनी ही ट्रीटमेंट प्रॉपरली घेतली असते तरी. So it is, now we will discuss case 2, 21-year female pharmacy student on the first line, AKT since 50 days, came with complaints of high-grade fever, cough, and mild hemoptysis, weight loss. On investigation, chest X-ray showed right mid-zone consolidation with cavity near right hilar area. HRCT chest showed consolidation with large cavity in superior segment of the right lower lobe. Sputum AB was negative. म्हणजे ही बाहेर तिला AKT सुरू केली होती. कारण तिला स्पुटम जास्त येतच नव्हतं आणि तिला त्याच बेसिसवरती त्यांनी एकेटी सुरू केली होती आणि पेशंट वॉज नॉट गेटिंग इम्प्रूव्ड. सी इज जस्ट 21-year-old female. So we did bronchoscopy with BAL from superior segment of the right lower lobe. So in BAL, AB smear was positive, and TB gene expert MTB detected with rifampicin resistance also detected. So this is her report of gene expert. And we did line probe assay in this patient. So you can see, she has rifampicin resistance, she has isoniazid resistance, and also she has fluoroquinolone resistance. So she was basically pre-XDR TB case. So she was started on longer duration of treatment. Her fluoroquinolone part was replaced with delaminid, and after 18 months of treatment, she was declared cured, and she is now doing MBA. आता एक लक्षात घ्या की ह्या जर केसेस एवढे यंग पेशंट्स आहेत आणि असं काही नाही की नाऊ टीबी इज ऑफ पुअर पेशंट्स पुअर पीपल्स डिसीज, तर आपल्याकडे आता जे चांगल्या सोसायटीमधले लोक आहेत त्यांच्यामध्ये सुद्धा ह्या टीबीच्या केसेस सापडतात. अँड टू इन्व्हेस्टिगेट each and every case properly is really important. We can't afford to miss single case of drug resistant tuberculosis. So take home message, TB is the world's leading infectious killer. Early diagnosis and treatment is important to prevent morbidity, mortality and community spread of disease. Do gene expert MTB and TB MJT culture in all patients to rule out drug resistant TB. Give weight based treatment to all patients. Good nutrition, counseling of patients is must along with drug treatment. Thank you.
Thank you. Thank you, Dr. Narote sir, for such a elaborative presentation on tuberculosis management, investigation, everything. Now I would like to felicitate Dr. Narote sir. Dr. Rushikesh Garde will felicitate Dr. Narote sir. I request Dr. Sagar Doshi sir to felicitate our chairperson, past President Temburni, Dr. Dada Saheb Mane.
हे लावा लागेल हे तर लावून तरी काय म्हणतात बघ तर नुसतं विचार बघ काय म्हणतात. अरे लवकर चालू करायचं लेक्चर लावतील द्यायला लावायला काय अडचण नसते. Now it's the final session of this conference, and now I request Dr. Vikas Mahatme sir to come on the dais. Sir, Dr. Vikas Mahatme needs actually no introduction, though he is from Vidarbha. We all people from Maharashtra and Western Maharashtra know him very well. He is a former member of Rajya Sabha, former president of AIIMS Nagpur. He is a Padma Shri awardee, an eye surgeon of international repute, known for his significant contribution to the community eye care, has himself performed 1.2 lakhs of surgeries. He is awarded DLIT by ITM University. He is the executive chair at GCPR, that is Global Council of Political Renewal. He has developed a special technique, that is Woodcutter's nucleus cracking technique for phacoemulsification and tattooing pigment for cosmetic corneal tattooing. He has a contribution to the research. He has received highest national award for research in ophthalmology and got Colonel Rangachari National Award and gold medal. He is a founder of and medical director of Mahatme Eye Bank, Eye Hospital Nagpur, and Mahatme Eye Hospital at Bombay and Amravati, has a branch in Pune also. Mahatme Eye Bank, Eye Hospital is a recognized postgraduate teaching institute for DNB and DOMS, international fellowships training center for Government of India eye surgeons. The institute also runs skill-based ophthalmic technician course for rural youth and thus empowering them economically and skill-wise. The course is affiliated to the Nagpur University. He is the chair of the Executive Council at GCPR and he is also a social worker and reformer. He has designed weighted indexing system for caste-based reservation to the right people. He runs Institute of Science of Happiness for thinking skills, emotional and psychological health of the community, ultimately for happy, meaningful life. He works for the rights of his community. He leads the Shepherd community of India and works for the rights of the nomadic people. He has suggested alcohol control policy to save the people from the addiction, working from the ethical politics and electoral reforms. He believes in simple, different and better innovative processes and working currently on Ekas mission, Sarvanna pension, that is pension for all. So this is in short introduction of the sir, and on our request, sir has traveled all along from Nagpur. So I welcome Dr. Vikas Mahatme sir, and his topic for today's lecture is Man Behind Machine. Sir, over to you.
Thank you, Dr. Avinash Panbude. And he has introduced me, I think, very well. I shall like to invite you for every function so that you will be introducing me. It's such a good thing. Every aspect was covered. Thank you for that. Friends, it's real that I have come from a long distance. But it's for me I have come here. I shall let you know. Because the topic which I was supposed to give here was Man Behind the Machine. And when I came here, when I came here, I realized that there are only 4 ophthalmologists here. And then I thought I should change the topic because ophthalmology will be too much microscopic here. So it's better. I actually prepared slides, videos and everything for nearly more than 1 hour yesterday. And then here when I came, I decided I should shift the topic to something else. And I realized that there are many challenges which ophthalmologists are facing from other fraternity members. What are those? Let us see. If you see from the birth of a child, from the birth of a child, if watering is there, I'm not talking about pediatrician, they know it very well. If the parents complain that watering is there from the newborn child, most of the doctors will say, watering is okay, you don't have to worry. No, it's a serious problem when watering is there in first 7 days, because in first 7 days, lacrimal glands do not secrete water. So if it is there, it indicates that some infection is definitely there. And most of the time, if infection is there, all of us usually will like to give advice or put the drops which are higher antibiotics, but they are not tolerated by the babies, and so we usually start with tobramycin. And if watering is there, that has to be referred to the ophthalmologist. Then comes, the parents say that sometimes you see some different color of the eye of the baby. Usually it is neglected by most of the fraternity members, but if it is there, it talks about something is there. It can be cataract, it can be retinoblastoma, it can be many things. So it's a very serious and urgent problem, should be consulted. Ophthalmologist must be consulted. Then comes, suppose squinting of the eye is there in first 3, 4, 5, 6, 7 years. All the doctors will say, okay, it corrects automatically most of the time, so please do not worry. No, it's a serious problem and it has to be checked up by ophthalmologist only, because of many diseases which will be missed by general practitioners, specialties, as well as we being relatives. This often they will ask you that, okay, right squinting is there. ते म्हणतात की ह्याच्या बहिणीला पण असंच होतं पण ते ठीक झालं, त्याच्या भावाला तसं होतं पण ते ठीक झालं. तसं नको आहे. You have to consult ophthalmologist. Injuries, injury to the eye and black eye. Just you should test the vision of that black eye. That is very important. I have seen many patients that when the black eye is there, there is a total ptosis. So nobody takes the vision. And if the vision is not recorded, what happens? After 7 or 15 days, the patient realizes that he cannot see with that eye at all. No PL also. No perception of light. I've seen many patients. What happens whenever there is injury to the brow? This is the bone. The optic nerve passes through the optic foramen as a bony canal. It has no space around it. The optic nerve has no space around it. So what happens? Whenever injury to the bone, that bone, whatever you say, that stress on the bone, thrust on the bone will go up to the optic nerve and it will damage the optic nerve also. And if it is edematous, it becomes edematous. Still the pressure rises. And that pressure rise doesn't allow the blood supply to the optic nerve. So ultimately, there is a vision loss. So it has to be detected at the earliest. So whenever there is a black eye, always check for vision. That is very important. Thirdly, one more thing I shall like to tell you is about the glasses. From the age of 9 years to 17 years, earlier in the girls, because the puberty is early in the girls, there is a high probability that these students will develop myopia. And in myopia, the vision is poor for distance. In Gadicharoli, we have done a survey. Nearly 18 point some percent students need glass in the age group of say 9 to 17. And these students, the parents say, पहिले ना हा हुशार होता पण आजकाल याचा अभ्यासात लक्षच नाही राहत. आता तो मागे पडायला लागलेला आहे आणि त्याला काही अभ्यास आजकाल आवडत नाही, त्याचा इंटरेस्ट अभ्यासातला निघून गेला. आपल्यालाही वाटतं की वी ऑल्सो फील ओके these are the changes which are there usually, and it may be the what happens is that those who have myopia, even of -1 diopter, they will have around 660 vision without glasses. They will not be able to see what is there on the blackboard. And if they cannot see what is there in the blackboard, they cannot understand what the teacher is saying. If they cannot understand, it cannot be that still he or she will be able to concentrate on the topic. What is not visible, how can she concentrate on that topic? And once the concentration is lost, interest in that study is lost. I told you that in Gadicharoli we have done survey. Once I went for a Vipassana center, on the day one day everybody gathers together, and one of the friend actually which I met after a long time, he said, I told him that we are doing survey in Gadicharoli because he was a social science student. not social science studies he undertook. So then I asked, I told him that we have done survey and we have provided glasses to 2,000 students in Gadchiroli. And I was telling him proudly. And the tears came out of his eyes. उसका त्याचं रडणंच सुरू झालं एकदम. तर मला वाटलं खूपच इमोशनल आहे हा. Then he told me that when he was in 6th standard, he was not able to see what was there on the blackboard. He repeatedly told his parents that I am not able to see what is there on the blackboard and I need glasses. Parents said, यांनी आजकाल एखादी मूवी पाहिली असेल, ते हिरो हिरोईन्स घालतात चष्मे, याला पण चष्मा आवडतो म्हणून हा चष्मा पाहिजे करतोय. They didn't approve glasses at all. And the consultation was not there for the to the ophthalmologist. They don't they didn't went to ophthalmologist also. आता ophthalmologist कडे गेले नाही. What was the biggest hurdle he told me was the money. They didn't have the money. So ultimately when he said that I'm not going to go to school at all unless and until you give me glasses, then parents said okay. They went to the zamindar there. He said throughout the day he and his father were sitting there and waiting for the zamindar. In the evening zamindar came and he gave 40 rupees. And with that 40 rupees, he said that I purchased the glasses from the optical shop, and because of that one spectacle, I could complete my studies. And it has changed my life. So, Dr. Mahatme, you have not only provided 2,000 spectacles, you have touched and changed the lives of 2,000 persons. So that is the impact. And this is also very essential, we should understand this. Now it's not that they are not wearing the glasses. The whole perspective of life changes. Then comes what I shall tell you about is the presbyopia. Nobody likes this word presbyopia when they cross the age of 40. आपल्या मराठीत आपण म्हणतो 40, 40चा चष्मा. आता 40चा चष्मा लावायचा तर असं होतं शक्यतोवर सगळेजण टाळतात. Nobody wants to put on the glasses. And previously it was bifocal, so it becomes very clearly visible that you are above 40. So nobody wants that. But few people will say that I don't need glasses. I am 55, but I never use glasses. Are there anybody? कोणी आहे का ज्यांनी आजपर्यंत चष्मा कधी न लावता सगळं काही दिसत आहे त्यांना? नाही असतात असे. देर आर. तुम्ही डॉक्टर नगरकर ना? नवरंगे, सॉरी मी नाव थोडंसं चुकवलं. डॉक्टर नवरंगे. हा. What's your name? Tamil है. What is your age? Because you look young. 40. ठीक है. I'm talking about above 40, say 50, 55. The difference he is not using. Then he can say dogmatically that okay, I am putting gomutra in my eyes and so I don't need glasses or something like this, anything like this. But I tell you there are 4 reasons why you will not need glasses even if you are at 50, more than 50 or 55, for neither for near nor for distance. One most important is that your one eye is myopic and the other eye is normal for distance. So when both eyes together, you can read as well as you can see the distance. Second is, if you have a cylinder around -1 at 90 degrees, then you do like this habitually, like this, and for distance also very clear, and for near also it will be very clear, because of the cylinder gets corrected once you reduce the palpebral aperture. So cylinder at 90 degrees minus. Thirdly, when the pupil is very small, the depth of focus is very high. So you can see this as well as this. So when the pupil is very small, then also. This is not possible for the foreigners because with blue iris, the pupil is always larger. Fourthly, if the job is not that demanding, say for distance, even if you have 6'9", 6'12" vision, it is okay. You can identify the people and everything. And everything is possible. And for near also, you can see the mobile, etc. because the, written work, handwritten work is nearly more than N24 and 36. So you can read without glasses also. So if your job is not demanding, and if you have cylinder at 90 degrees minus, if you have myopia in one eye, and if your pupil is small, if these 4 reasons are there, you will not require. But the challenge in society is totally different. I shall tell you one more thing and then come to this point again. After the age of 40, or you can say 55, 60, there is one additional problem or additional advantage many times, is that my father, he said to my elder brother, अरे तू जवळच्यासाठी चष्मा लावतो, मी पण 15 वर्ष वापरला 40 नंतर. Is there anybody who cannot understand Marathi? Everybody can understand Marathi, though it's okay. Because when the stories are there, it's better I can express myself, and we can also feel the difference if it is in Marathi or mother tongue. Okay, so he said to my elder brother, from the age of 40 till 55, 58, he was around 58, I was using glasses for near, presbyopic glasses. That time it was bifocal. So I was using glasses. But I started Shirshasana, and I don't need now glasses for near. I don't need glasses. And he used to able to read everything, even finer prints also, very easily without glasses. You also start doing Shirshasana, and that will be possible for you. Just tell me the time, as well as after this there will be one more lecture. Huh? Inaugural function. There will be different speech, no? Yeah. Okay. So now the challenge is, he was not able to read from 40 to 58. After 58, now he is able to see the things without glasses. Read fine prints also without glasses. Why is it so? Yes, correct. तालियां बजाएं उनके लिए, cataract बताया. Really, it's a good thing. It's because of the nuclear cataract which develops in many patients, especially in Indian eyes. There is another type, is a cortical cataract. In that there will not be myopia. But here, because of sclerosis, there will be myopia. This is termed as second sight. In scientific books, it will be termed as second sight. But the challenge in society is totally different. Everybody will say Shirshasana, everybody will say auto urine therapy, जो एक प्राइम मिनिस्टर थे उनका भी था, auto urine therapy था, Morarji Desai, yes, auto urine therapy, and many other things you can give credit to that. This is because of just nuclear sclerosis. Then, if you check them, they will have 612, 618 vision for distance, but now their problem is they are not there for the distance because they don't have to read something which is written at a distant place. small letters, of course. Secondly, they have to identify people. That is possible with 618 vision also. That we should understand. And actually, they are starting with the nuclear cataract. You must have seen many people, even I know my grandmother's mother, grandmother or whatever is that. Panji, barabar. You feel that science doesn't know. Many things science doesn't know, but we admit that science doesn't know this. That is the most important thing. Many things science doesn't know, but we know answers for this all. So I shall tell you why this happens. Because we think that, okay, this second sight and everything, we do not know much. Similar question happens when I tell you one more story about this glasses. I come back to glasses. Once I saw a patient and prescribed the glass number to her. She said, you are prescribing me my glasses, but give me medicine which you have given previously to my elder sister. And after putting those drops, her number is not increasing. After putting those drops, her number is not increasing. So give me that drop so that my number will also not increase. So I was getting credit for nothing. I didn't do anything. This is science, so I am telling you the truth. Otherwise, I could take the credit also. The thing, what is that stopped her myopia increasing? Not increasing? Myopia not increasing because of my drop or something else is there. It is 90% when it is a simple myopia, with astigmatism also. But if it is simple myopia, after the age of growth period is over, the number stabilizes. When the growth period is over, that puberty, suddenly the number will increase. I tell everybody, when your height increases, your number also increases because the axial length of the globe also increases. So when height increases, number increases. When the increase in the height gets settled, then number also nearly becomes settled. 0.1 millimeter axial length. If it is 23 millimeters, 0 number is required. If it is 23.1 from cornea to fovea, if the distance is, say, most of the time I am telling, there are many, average I am telling you. 23 millimeter if it is there, this axial length, you will not need glasses. If it is 23.1, you will require -3 number, -3.1. If the height is, say, 5 feet 2 inches of a girl, we don't say that she is a diseased girl. We say that is the variation. She can be a 5.2 and somebody else can be 5.7. That is variation. But if the variation in axial length is of 0.1 millimeter, we will say, tila te chashma hai, nahi, chashma wali nahi pahiye. So, that is the what is in our perception is most important. What is inside our head? How we look at it. That is very important. And then, most probably what happened in that case, I gave her drop when her puberty was nearly over. So, parents and everybody thought, Dr. Mahatme बहुत बड़े ophthalmologist है, त्यांनी दिलेल्या औषधाने तर माझा नंबर थांबला. तिथेच जायला पाहिजे. So this is what is the perception and what is the science. And we have to differentiate between the two, and we have to tell to the parents, to the people, what is science and why it is important. Just I shall tell you one thing. One is this is a science of probability also. That many times you see that we say, I told one of the patients that you have mature cataract and you should get operated, otherwise it will get ruptured or anything, and complications will happen and you may not gain the vision. तुला जास्त पिकलेला आहे मोतीबिंदू आणि हा मोतीबिंदू जर एखाद वेळेस फुटला किंवा जास्त झाला तर काचबिंदू होऊन डोळा जाण्याची शक्यता असते. त्याच्यामुळे ऑपरेशन लवकर केलं पाहिजे. That patient came after 1 year and said, तुम्ही मला म्हणाले होते पण मला 1 वर्ष झालं पण अजूनही काहीच नाही झालं. मी ना ते आयुर्वेदिक औषध टाकलं किंवा ते होमिओपॅथीचं औषध टाकलं, आता काहीच नाही झालं. There are medicines, Cineraria maritima, it converts white cataract into brownish cataract. So that helps really, because research I have done, means in our institution was only done. But everybody should understand it is a science of probability. I shall tell you a real story. My nephew Vikram, he got admission in engineering college. So his father gave him a motorcycle because he was insisting, मला motorcycle पाहिजे, मला engineering college ला जायसाठी motorcycle पाहिजे. He gave him. जसं आता youngsters चालवतात तसं तो खूप fast चालवायचा. So I told him, you should drive it slowly, slowly. Every time when I met him, I told him that you came very fast. It is not good. You should drive slowly. 3-4 वेळा तर ऐकून घेतलं त्यांनी. चौथ्यांदा म्हणाला, काका तू म्हणतो नेहमी नेहमी हळू चालव, हळू चालव, हळू चालव. म्हटलं हो, हळूच चालवायला पाहिजे, आपल्या सेफ्टीसाठी आवश्यक आहे. तो म्हणाला, तुला माहिती आहे का ते आगाशे काका? मी म्हटलं हो. ते कितीच्या स्पीडनी चालवतात? मी म्हटलं ते 40च्या वरही जात नाही कधी. त्यांचा तू हे घ्यायला पाहिजे, त्यांच्यापासून शिकायला पाहिजे. ते 40च्या वरती कधीच चालवत नाही. इज इट ऑडिबल? येस. ओके. 40च्या वरती कधीच चालवत नाही. तो म्हणाला, तुला माहिती आहे का त्यांचा ॲक्सिडेंट झाला आणि ते स्वर्गवासी पण झाले. आणि मी मागच्या 3 वर्षापासून चालवतोय, फास्ट चालवतोय, आजपर्यंत एकही ॲक्सिडेंट नाही. आता त्याला काय सांगू? फास्ट चालव, हळू चालव, का तुला वाटते ते कर, माझं डोकं नको खाऊ. And that is the science of probability. If 100 vehicles from this place to Mumbai, 100 motorcycles go from this place to Mumbai by 120 speed, then 120 speed, then suppose 7 accidents occur. If you go by speed of say 80, 2 accidents will happen. But accidents will not happen, will not be true. म्हणजे accidents होण्याची शक्यता कमी करतो. हे खूप महत्वाचं आहे. Everybody must understand, whatever we are doing is to reduce the probability of diseases. It is not 100% that this, you do this and there will not be any disease. We reduce the probability. आणि ही प्रॉबॅबिलिटी कमी करण्यासाठी सगळे प्रयत्न आहे. जसं ते म्हणतात डॉक्टर महात्मे तुम्ही ते काय नेहमी बिस्लेरी पाणी पिता तरी ते तुमचं पोट बिघडलं होतं. काही नाही, जे प्यायचं ते प्या, जे व्हायचं ते होणार आहे. जे व्हायचं ते होणार आहे नाही असं नाही आहे. कारण आहे त्याचा प्रॉब्लेम, शक्यता कमी मरतो, खात्री नाही. मुलाला आपण म्हटलं असं असे कॉन्सेप्टमुळे खूप मेजर प्रॉब्लेम सोसायटीत आहे. मुलगा म्हणतो की अभ्यास त्यांनी इतका केला की त्याला वाटते 90% मार्क मिळणार आणि मग त्याला मिळतात 85. ही कॅनॉट ॲक्सेप्ट दॅट. मी इतका अभ्यास केला, माझ्यापेक्षा कमी त्यांनी अभ्यास केला आणि त्याला तर 90च्या वरती मिळून गेले, मला 90च्या कमी मिळाले. He will search for a talav. Very bad. It's a probability science. And it is not that you have failed. You have failed. तुम्हाला त्यावेळेस परीक्षेत अपेक्षित यश आलं नाही. तुम्ही त्यावेळेसल्या त्या पेपरमध्ये जे एक्झामिनर होते त्यांना जो प्रश्नाचं उत्तर अपेक्षित होतं ते तुम्ही दिलेलं नाही. त्याच्यामुळे तुम्हाला त्याच्यात कमी मार्क मिळाले. तुम्ही फेल झालेले नाही आहात, त्या परीक्षेतल्या त्या पेपरमध्ये तुम्हाला मार्क कमी मिळाले. मी फेल झालो असं म्हणतात सगळेजण. तू फेलच नाही होऊ शकत. आयुष्यात इट्स ऑल लर्निंग एक्सपिरियन्स. शिकण्याचा अनुभव आला मला, बस, दॅट्स ऑल. दॅट वॉज अन ऑपॉर्च्युनिटी टू लर्न. आय हॅव नॉट फेल्ड. नोबडी फेल्स. मला एक जण दाखवा तशा पद्धतीने जर डेफिनेशन केली तर असं एकही नाही आहे इथे की जो कधी फेल, म्हणजे मी असंच नाही म्हणत, परीक्षाच नाही, सगळ्या आयुष्यात कधीच कोणत्याच अटेम्प्टमध्ये कुठेच कधीच फेल नाही झालं, असं तर झालंच नाही. सो दॅट इज व्हॉट इज सायन्स ऑफ प्रॉबॅबिलिटी. अँड वी मस्ट टीच एव्हरीबडी अबाउट दिस प्रॉबॅबिलिटी सायन्स. अँड देन ओनली वी विल बी एबल टू फेस, वी विल बी एबल टू हॅव अ हेल्दी लाईफ. दुसरं एक आहे की एक्सपिरियन्स आणि एव्हिडन्स. जसं मी सांगितलं की माझ्या वडिलांनी म्हटलं की शीर्षासन केलं आणि माझा नंबर गेला. त्यांचं ऑब्झर्वेशन बरोबर आहे. पण मी सांगतो याचं एक उदाहरण सांगतो. एक सायंटिस्ट होता. ही वॉज ऑफ इंटरनॅशनल रेप्यूट अँड देन ही डन वन एक्सपेरिमेंट. He did one experiment. What was that? He brought one frog, done pithing, and then after that, not pithing, after that he put it on the table and said, jump. Frog jumped. Frog ne छलांग लगा दी. Then what happened? त्या सायंटिस्टनी काय केलं, त्याचा एक पाय कापला. and said jump. बेडकानी पुन्हा छलांग लावली. आणि दुसरा पाय कापला, जम्प. त्याने पुन्हा उडी मारली. आणि तिसरा पाय कापला, जम्प. त्यांनी पुन्हा उडी मारली. आणि चौथा पाय कापला, म्हणाला जम्प. काहीच नाही झालं. मग त्या म्हणाला कुदो, तरी काय नाही झालं. उडी मार, तरी काय नाही झालं. मग त्यांनी हे सगळे ऑब्झर्वेशन्स लिहिले, छान प्रकारे क्लासिफाय करून व्यवस्थित लिहिले की कसा एक्सपेरिमेंट केला. आणि मग इन्फरन्स लिहिला शेवटी, कन्क्लुजन इन्फरन्स. देन तुम्ही जेव्हा बेडकाचे पाय कापता तेव्हा त्याला ऐकू येत नाही. His observations were accurate. His inference was inaccurate. My father's observations were accurate that he started doing Shirshasana and his glasses, he didn't need glasses for near. All the observations are accurate. But that was the reason was inaccurate. मी तुम्हाला असं वाटेल की हे फक्त वडिलांचं, पण मी सांगतो 1 कोटी जनतेपेक्षा जास्त जनता या एका कारणाने गेलेली आहे. आणि तुम्हाला आठवत असेल जे इथे सिनियर्स आहे की 1992 जेव्हा, ठीक आहे, गणपती भगवान दूध पितात, गुरुवार होता तो दिवस, म्हणून 1 कोटीपेक्षा जास्त जनतेने 1 कोटीपेक्षा जास्त जनतेने त्यावेळेस देवाला दूध पाजलं आणि मुख्यमंत्र्यांनी पण पाजलं. मी कोणाच्या विरोधात नाही, मी कदाचित त्यांच्या पार्टीच्या जवळच्या पार्टीतला माणूस खरं पाहिलं असता, पण मी सायंटिस्ट पण आहे ना, म्हणजे मी सायन्सवर विश्वास ठेवणार आहे. and that is the priority. तर माझं असं म्हणणं आहे की हे सगळं बरोबर आहे, त्यांचं ऑब्झर्वेशन बरोबर होतं पण चुकलं नव्हतं, हे लक्षात घ्या. देअर ऑब्झर्वेशन वॉज करेक्ट की जर मूर्तीजवळ अशा रीतीने टिल्ट केलं तर ते दूध खाली जातं. ऑब्झर्वेशन वॉज करेक्ट. इन्फरन्स की तो त्याच्या मागे काहीतरी ईश्वरीय शक्ती आहे, त्याऐवजी एकच सायंटिस्ट, 1 कोटीच्या वरती जनता आणि एकच सायंटिस्ट. तिथे लोकशाही नसते. पुष्कळांना काय वाटते 1 कोटी जे म्हणतात तेच खरं असणार, एक माणूस म्हणतो ते थोडी खरं राहू शकतं. दॅट इज ट्रू इन लोकशाही, दॅट इज नॉट ट्रू इन सायन्स. एकच माणूस म्हणाला की ते सिंपल कॅपिलरी ऍक्शन आहे, केशाकर्षण आहे, की त्याच्यामुळे हे असं होत आहे. आणि ते त्याच्याच सोबत नाही होणार आहे. कुठली कुत्रा तुम्हाला आवडत नाही, कुत्र्याची मूर्ती घेऊन त्याच्याजवळ असं धरा तरी होईल. And that is what is important. That experience and evidence are two different things. Experience doesn't mean that what you have observed and the conclusion because of that is correct. No. What is the difference between experience and what is evidence? Evidence सांगतो. समजा जर मला म्हणायचं आहे की या औषधाने ताप कमी होतो, तर हे कोणीच विश्वास ठेवणार नाही, फक्त म्हणतील की हा तुमचं हे एक्सपिरियन्स आहे, चांगली गोष्ट आहे, आपण एक स्टडी करू. कारण त्याला स्टडी का करू, कशाला, मी सांगतो ना, मला जेव्हा झालं तेव्हा त्याच्यानी ताप कमी झाला. मी माझ्या बहिणींना सांगितलं, त्यांच्या घरी त्यांनी दिलं, त्यांचेही ताप कमी झाले. 50च्या वरती अनुभव आहे. डायबिटीसमध्ये तर खूप जणांचा अनुभव, मला तिथे पार्लमेंटमध्ये त्यांनी म्हटलं की वी हॅव एक्सपिरियन्स ऑफ मोर दॅन 50,000 पीपल. मग मी त्यांना सांगितलं 1 कोटी लोकांचा अनुभवही होता, त्याच्यामुळे तसं नाही होऊ शकत. तर त्यांनी म्हटलं की ताप कमी होतोय. कारण मला माहिती आहे, तुम्हालाही माहिती आहे, जर आपल्याला सर्दी झाली तर आपल्याला माहिती आहे की आपण जर औषध नाही घेतलं ना तर 7 दिवस लागतात ठीक व्हायला, आणि औषध जर घेतलं ना तर एका आठवड्यातच ठीक होऊन जाते. तर त्याच्यामुळे आपल्याला हे माहीत असल्यामुळे आपण अशी स्टडी करायची की हे औषध हे पिवळ्या रंगाचं आहे, हे गोळ्याच्या टॅबलेट फॉर्ममध्ये देता येतं, ते हेच कडू पण नाही चवीला, त्याची एक टॅबलेट बनवू आणि किती दिलं तर तो सांगतो एवढं दिलं तर होतं. ठीक आहे, ते आहे साधारण 50 मिलीग्रॅम. तर आपण एक टॅबलेट 50 मिलीग्रॅमची तयार करू, येलो रंगाची होते त्या याची, ती 1000 टॅबलेट्स किंवा 10,000 टॅबलेट्स घेऊ आणि तशाच 10,000 टॅबलेट त्याच रंगाच्या, त्याच साईजच्या, तशाच सारख्याच दिसणाऱ्या 10,000 दुसऱ्या टॅबलेट्स राहतील ज्याच्यात काहीही औषध नाही, ज्याच्यात काहीच औषध नाही, प्लॅसिबो म्हणजे चॉक खडूचा आणि रंग पिवळा. हे जेव्हा देऊ आणि हे कोणाला कोणची गोळी मिळाली हे कोणालाच माहिती नाही, फक्त त्याच्यावर कोडिंग राहील आणि ते कोडिंग डिकोड केल्या जाईल स्टडी नंतर. हे सगळ्या लोकांना जेव्हा 10,000 गोळ्या देण्यात येतील तेव्हा जर असं लक्षात आलं की खरंच ज्याच्यात 50 mg टॅबलेट औषध आहे त्यांनी 60% लोकांचा ताप कमी झाला आणि प्लासिबो, दुसऱ्याला आपण प्लासिबो म्हणतो, इफ वी से दॅट प्लासिबो हॅज ऑल्सो reduced by 55% and this has reduced the temperature in 60% of people. तर ते काही स्टॅटिस्टिकली सिग्निफिकंट नाही आणि त्याच्यामुळे हे औषध खरोखर ना. त्या औषधाने समजा 90% लोकांचा ताप गेला आणि प्लासिबोनी 60% लोकांचा गेला, तर म्हणून नाही नाही ते वापरलं पाहिजे, खूप चांगलं नवीन ड्रग आलेला आहे. So experience has a value till you get provoked to do study. Experience has a value if though there are no studies and you have studied that subject for years together and you know that that is not harmful. म्हणजे आता डोळा पुसल्याने स्वच्छ केल्याने शक्यता अशी आहे, लॉजिकली आपण म्हणतो की बा इन्फेक्शनच्या वेळेस डोळा पुसा, पण तसं काही खूप रिसर्च नसेल त्या विषयाचा, तरी पण डॉक्टर म्हणून राहिले म्हणून आपण करू. तर दॅट इज द एक्सपिरियन्स अँड दॅट इज द एव्हिडन्स. Unless and until we doctors understand this, it is very difficult for a layman to understand all this. हे आपण समजून घेतलं पाहिजे, अतिशय महत्वाचं आहे की दोन, इट इज अ सायन्स ऑफ प्रोबॅबिलिटी अँड एक्सपिरियन्स अँड कन्क्लुजन्स आर डिफरंट. एक्सपिरियन्स अँड एव्हिडन्स, वी आर प्रिफरिंग एव्हिडन्स. वी आर फॉर एव्हिडन्स. तर हे सगळं झालेलं आहे. दुसरं मी सांगतो की त्याच्यानंतरच्या याच्यात एक ग्लॉकोमा, इवन मी सांगतो आता तुम्हालाच विचारतो, मला सांगा की किती लोकांनी मागच्या 3 वर्षात 3 वेळा डोळे चेकअप केले आणि दे आर अबव 50. तसं तर अबव 40 विचारायला पाहिजे आयडियली, पण मी सांगतो की ठीक आहे 10 वर्षाचं तुम्हाला मुभा दिली. अबव 50 3 वर्षात, 3 वर्ष तास, बर्थडेला किंवा 26 जानेवारीला किंवा 15 ऑगस्टला. अरे वा, जोरदार टाळ्या वाजवा. मॅडम पण आहे, काय नाव आहे मॅडम? डॉक्टर अज्योतिकर, जोरदार टाळ्या वाजवा. डॉक्टर आरणकर यांना खरंच आपण 2-3 ठिकाणी घेऊन गेलं पाहिजे की खरं नाही. इट्स व्हेरी टफ. आय शॅल आस्क दिस इन Ophthalmologists Association, and I tell you that 50% of the ophthalmologists not checked their own IOP. आणि 10 डॉक्टरांना 10 लोकांना सांगितलं असेल की तुम्ही तुमचं चेकअप करायला पाहिजे. तुम्हाला तर माहित आहे, दिवसभर दारू पिऊ नको म्हणून सांगतो आपण, आणि मग संध्याकाळी काय करतो ते पाहत. त्याच्यामुळे इट्स डिफरंट. पेशंट इज डिफरंट अँड डॉक्टर इज सम सुपर ह्युमन बिईंग. त्याच्यामुळे आणि त्याला सगळं कळतं, त्याच्यामुळे त्यांनी नाही केलं तरी चालतं चेकअप. सो दॅट इज व्हॉट इज इम्पॉर्टंट, दॅट वी हॅव टू हॅव गेट चेकड अप फॉर अवर सेल्स ॲट लिस्ट अँड देन टेल इट टू द. देन कम्स द फ्लॅशेस ऑफ लाईट. फ्लॅशेस ऑफ लाईट इग्नोर करू नका इफ इट इज देअर. रेटिनल एक्झामिनेशन इज अ मस्ट. आणि फ्लोटर्स सडनली वाढले तर चिंता करू नका, पण चेकअप करून घ्या, कारण फ्लोटर्स पुष्कळांना असू शकतात. शेवटचं एक सांगतो, मी इतके कॉर्नियल अल्सर पेशंट्स पाहिले, मॅडम प्रधान आहेत, उमा प्रधान मॅडम इथे, त्यांनी पण पाहिले असतील. दॅट पेशंट वॉज इन ICU or patient as an old age patient, he cannot completely close the lids together. So palpebral aperture is open even during sleep. Or in ICU they cannot blink, so it remains open. Then there is a desiccation, dryness. Dryness leads to epithelial defect. Epithelial defect, exposure to organisms will ultimately lead to ulcer. Ulcer will lead to loss of vision and many other problems also. This I have seen many times in my own relatives also. So please see to that if the palpebral aperture of your relative in ICU is open, ask them to put ointment, no drops. Ointment. With ointment you cover the cornea completely. That is very important. It should remain covered at least 3 times or 4 times a day you put that ointment. Any ointment will do, but usually chloramphenicol is a disposable one, So you put and throw it away. That is a good option. But you can put any ointment. It's just a protective cover. So that is what I wanted to tell you. I think I have taken much more time than you have allotted me, and I am very much thankful that Dr. Panbude, you have invited me. And या इथे I am very much thankful. Dr. Uday आहे ते पुण्याला आले, मला घ्यायला आले, इथपर्यंत होते घरी वगैरे सगळं हॉस्पिटल पाहिलं. त्यांचं खूप चांगलं हॉस्पिटलही आहे. जोरदार टाळ्या वाजव पनबुडे आणि त्यांच्यासाठी. आणखी एक महत्त्वाचं आहे डॉक्टर भारती, त्याही माझ्या इथेच होत्या. त्यांचा पण त्याच्यामुळे भेट झाली आणि इथल्या सगळ्यांनी तुम्ही शांतपणे ऐकून घेतलं त्याच्याबद्दल फार फार धन्यवाद. थँक्यू व्हेरी मच. आणि मला पुन्हा एक वेळेस सहन करायचं आहे तुम्हाला, तर पुन्हा एक वेळ येणार आहे. थँक्स अ लॉट. I hope I have changed the topic so you are not got disturbed.
Thank you, sir, for giving a very nice insights on the various aspects of the ophthalmology. Those seemingly very simple topics like cataract, corneal ulcers, presbyopia, but still how they hold importance in dealing with as a medical person to them. So I thank Dr. Vikas Mahatme sir again for giving us nice lecture on this. Now the next session is of inaugural function of the conference. So I request all the dignitaries and delegates to be seated in the hall till the preparations are over.
माजी अध्यक्ष IMA छत्रपती संभाजीनगर 26 एप्रिल 2026 रोजी होऊ घातलेल्या महाराष्ट्र मेडिकल काउन्सिलच्या निवडणुकांसाठी IMA MMC पॅनलतर्फे मी एक उमेदवार म्हणून उभे आहे. महाराष्ट्र मेडिकल काउन्सिल ही ॲलोपॅथिक डॉक्टरांची नोंदणी, नियम आणि देखरेख करणारी एक अधिकृत शासकीय संस्था आहे. आमच्या पॅनलतर्फे डॉक्टर अनिल पाचनेकर, डॉक्टर अनिल पाटील, डॉक्टर मंगेश गुलवडे, डॉक्टर संजय देशपांडे, डॉक्टर संजय कदम, डॉक्टर अनिल पाटील, डॉक्टर संतोष कदम आणि डॉक्टर सुनील इंगळे, मी स्वतः डॉक्टर उज्ज्वला कराड दैफळ असे अनुभवी समर्पित IMAचे 9 उमेदवार उभे आहेत. आम्ही डॉक्टरांच्यासाठी मजबूत प्रभावी प्रतिनिधित्व करण्यासाठी कटिबद्ध आहोत. आपल्या सर्वांना नम्र विनंती करते की आम्हाला जास्तीत जास्त मताधिक्याने निवडून द्या. जय हिंद, जय राष्ट्र.
The chief guest, the guest of honor, the president of the event, and IMA members. Please step out of the hall. Step out of the hall as we have a special procession for them. Entry procession. Special entry procession for them. ऑर्गनाइज करायचं म्हणजे मला जरा झाली माझी तत्व चालू होईल. मला वाटलं तिकडे बसून करायचं. आता कसं सांगणार त्यांना, तिथे बाहेर सगळे फोटो काढत आहेत. त्यांची अजून तिकडे तयारी चालली आहे. पहिल्यापासून स्टार्ट करायचं, फक्त गुड इव्हनिंग बोलून बोला.
Good evening, everyone. We are gathered here for the inauguration ceremony of Indacon 2026. I request our chief guest, Dr. Mahatme sir, our guest of honor, Dr. Uma Pradhan ma'am, the president of our today's event, Dr. Naurange sir, and all our IMA members to kindly step out of the hall as we have a special entry procession planned for them.
चालू करायचं एवढेच अरे सगळे गेले बाहेर.
I request all other delegates to be seated in the hall. We will be beginning the procession soon. Good evening, distinguished delegates, esteemed faculty, and dear friends. आजचा हा दिवस आपल्या सर्वांसाठी अत्यंत विशेष आहे. IMA इंदापूर ब्रांच आयोजित इंडाकॉन 2026 या शैक्षणिक परिषदेच्या उद्घाटन समारंभासाठी आपण सर्वजण इथे एकत्रित आलेलो आहोत. This year, our theme is inspired by a moment that united 1.4 billion hearts, India's T20 World Cup victory. This month, our nation celebrated a moment of immense pride as the Indian cricket team lifted the T20 championship trophy. The stadiums were filled with cheers, the country celebrated with joy, and we witnessed what teamwork, dedication, and passion can achieve.
तुम्हाला सगळ्यांना प्रश्न पडला असेल की वैद्यकीय परिषदेत
सुनो गौर से दुनिया वालों, बुरी नजर ना हम पे डालो. सुनो गौर से दुनिया वालों, बुरी नजर ना हम पे डालो. चाहे जितना जोर लगा लो, सबसे आगे होंगे हिंदुस्तानी. सुनो गौर से दुनिया वालों, बुरी नजर ना हम पे डालो. चाहे जितना जोर लगा लो, सबसे आगे होंगे हिंदुस्तानी. हमने कहा है, तुम भी कहो. हमने कहा है जो तुम भी कहो.
आओ हम मिलजुल के बोले अब तो यारा, अपना जहां है सबसे प्यारा. आओ हम मिलजुल के बोले अब तो यारा, अपना जहां है सबसे प्यारा.
हमने कहा है जो
आजचा हा दिवस आपल्या सर्वांसाठी अत्यंत विशेष आहे. IMA इंदापूर ब्रांच आयोजित इंडाकॉन 2026 या शैक्षणिक परिषदेच्या उद्घाटन समारंभासाठी आपण सर्वजण इथे एकत्रित आलेलो आहोत. This year, our theme is inspired by a moment that united 1.4 billion hearts, India's T20 World Cup victory. This month, our nation celebrated a moment of immense pride as the Indian cricket team lifted the T20 championship trophy. The stadiums were filled with cheers, the country celebrated joy, and we witnessed what teamwork and dedication, passion can achieve.
इथे बसलेल्या सगळ्यांना हा प्रश्न नक्कीच पडला असेल की वैद्यकीय परिषदेत क्रिकेट कशासाठी.
तुम्ही जर बारकाईने पाहिलं तर निळ्या रंगाचा कोट घातलेला क्रिकेटपटू आणि निळ्या रंगाचे स्क्रब्स घातलेले डॉक्टर हे दोघे तुमच्या कल्पनेपेक्षाही अधिक सारखे असतात. क्रिकेटच्या मैदानात असो किंवा हॉस्पिटलच्या ICU मध्ये शेवटच्या ओव्हरमध्ये घेतलेला अचूक निर्णय विजय मिळवूनच देतो. जसा भारतीय संघाने जिद्दीने वर्ल्ड कप उंचवला तशीच जिद्द आणि सेवावृत्ती आपण डॉक्टर म्हणून जपतो. It is about power play of innovation and the team spirit of the people involved. Today, we aren't just doctors, we are Team India, ready to bowl out disease and hit excellence out of the park.
Before we move forward, allow us to introduce, I am Dr. Shubhada Chavan, and joining me is my brilliant colleague, Dr. Nupur Kadam. We both carry the spirit of Pune in our hearts, but our daily match is played here in Indapur, where we are practicing as obstetrics and gynecologists. As OBGYNs, we are used to deliveries under pressure, though we involve a lot more crying and a less more commentary. We are thrilled to be your host for Indacon 2026, ensuring this conference runs smoothly. Today, we are gathered here to celebrate our champions who may not play in stadiums, but who step into clinics, wards, and operation theaters every day with same commitment and passion. Cricket is not just a sport for India. It is a symbol of teamwork, strategy, resilience, and excellence. And interestingly, these are the very same qualities that define the medical profession. जसे क्रिकेट टीम मध्ये बॅट्समॅन, बॉलर्स, फिल्डर्स अँड कॅप्टन्स असतात, त्याचप्रमाणे आपल्या मेडिसिन टीम मध्ये फिजिशियन्स, सर्जन्स, ॲनेस्थेटिस्ट, नर्सेस अँड टेक्निशियन्स मिळून एक टीम तयार होते, जे एक साथ जिद्दीने काम करत असतात. इन T20 फायनल, the last 2 overs decide the fate of trophy. For us, T20 च्या अंतिम सामन्यात शेवटचे 2 ओव्हर जसे मॅच जिंकणार की हरणार हे ठरवतात, त्याचप्रमाणे आपल्यासाठी ER म्हणजेच इमर्जन्सी रूम मधील गोल्डन आर एका जीवाचे भविष्य ठरवत असतात. त्या ठिकाणी धैर्य, स्थिर मन आणि अंडर प्रेशर शांत राहण्याची क्षमता आवश्यक असते. Dr. Nupur, what do you think? Who works under more pressure, a cricketer or a doctor?
I think a doctor. कारण एखाद्या क्रिकेटपटूची जर चूक झाली तर तो आउट होऊन पॅव्हेलियन मध्ये परत जातो, पण आपली जर चूक झाली तर मग पेशंटचे नातेवाईक आपल्यालाच ग्राउंडवर घेतात. आणि IPL मध्ये स्ट्रॅटेजिक टाइम आउट असतो, मात्र आपल्या इमर्जन्सी मध्ये आपल्याला श्वास घ्यायला देखील वेळ नसतो.
बरोबर.
Cricket champions bring glory to the nation, but doctors bring something even more precious: health, hope, and happiness. So today, inspired by the recent cricket victory, the theme of this inauguration celebrates champions on the field and in healthcare. With this spirit of teamwork, excellence, and victory, I warmly welcome you all to the inauguration ceremony of Indacon 2026. Let the innings of knowledge begin. आता वेळ झाली आहे आपल्या टीमचे डायसवर स्वागत करण्याची. मी सर्व उपस्थितांना विनंती करते की टाळ्यांच्या जोरजोरात गजरात त्यांना आपण डायसवर इन्व्हाइट करूयात. आपले
I request all our champions for the lamp lightning. क्रिकेटमध्ये पहिला चेंडू टाकला की सामन्याची सुरुवात होते, त्याचप्रमाणे आज या दीप प्रज्वलनाने इंडाकॉन 2026 ची ज्ञान यात्रा सुरू करूयात.
मराठी
I request the dignitaries to take their seat on the dais. Our chief guest for today, Dr. Vikas Mahatme sir. Our guest of honor, Dr. Uma Pradhan ma'am. President of today's event, Dr. Jayant Naurange sir. And our IMA members, Dr. Ram Arankar sir, Dr. Anil Shirke sir, Dr. Avinash Panbude sir, Dr. Kalpana Khade ma'am, and Dr. Sudhir Tambile sir. I request Dr. Hari Umare sir to kindly join us on the dais.
Before we move ahead, it is a beautiful tradition in our culture to begin every auspicious event by seeking divine blessings. In the field of medicine, we look up to Dhanvantari, the divine physician, who is believed to be the source of health, healing, and knowledge. I request
Dr. Kalpana Panbude madam, Dr. Bharti Kurudkar madam, and Dr. Jyoti Narute madam to come forward for Dhanvantari Stavan.
नमामि धन्वन्तरिमादिदेवम् सुरासुरैवन्दितपादपद्मम् लोके जरारुक् भयमृत्युनाशनम् दातारमीशं विविधौषधीनाम् शङ्खं चक्रं जलौकां दधतमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविलसन् मौलिमम्भोजनेत्रं कालाम्बोदोज्ज्वलाङ्गम् कटितटविलसत् चारुपीताम्बराढ्यम् वन्दे धन्वन्तरिं तं निखिलगदवन प्रौढदावाग्निलीलम् प्रौढदावाग्निलीलम् प्रौढदावाग्निलीलम्.
Thank you for that beautiful prayer. May the blessings guide us in our noble mission of healing and serving humanity with compassion and dedication.
रुग्ण सेवा हीच ईश्वर सेवा. आपल्या कर्तव्याची पुन्हा एकदा आठवण करून देण्यासाठी आपण सर्वजण IMA प्रार्थना आणि IMA फ्लॅग मानवंदना देऊयात. I request you all to repeat after me. May everybody be happy.
May everybody be happy.
May every one of us see to it.
May every one of us see to it
that nobody suffers from any pain or sorrow.
Any pain or sorrow.
I do not ask for crown.
I do not ask for crown.
Nor I wish to be in heaven or reborn.
Nor I wish to be in heaven or reborn.
I only want to alleviate the suffering.
I only want to alleviate the suffering
of those people who are burning in fire of sorrow.
burning in fire of sorrow.
I will recite the flag salutation. Please do not repeat after me. We, the members of the Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind. I hope everyone in the audience is enjoying the cricket theme.
Yes, of course. Doctors do love cricket. It's probably the only match we get to watch between our busy OPDs. Just as the trophy recognizes champions' hard work, it is our honor to felicitate our guests who have hit success in the field of medicine. I request our IMA patron, Dr. Ram Arankar sir, to felicitate our chief guest, Dr. Vikas Mahatme sir. I request our Indacon organizing chairman, Dr. Avinash Panbade sir, to felicitate the president of today's event, Dr. Navrange sir. I request Dr. Kalpana Khade ma'am, the ex-IMA president, winner of national and state best IMA branch, and Dr. Arankar ma'am to felicitate our guest of honor, Dr. Uma Pradhan ma'am. Now I request our IMA president, Dr. Anil Shirke sir, to felicitate Dr. Umare sir. I now request our IMA secretary, Dr. Sudhir Tambile sir, to felicitate our IMA patron, Dr. Ram Arankar sir. I now request Dr. Anil Shirke sir to felicitate Dr. Ravindra Kute sir, past president of Maharashtra State IMA. I now request Dr. Anil Shirke sir to felicitate Dr. Raju Varyani sir, past president of IMA Pune. I request Dr. Anil Shirke sir to felicitate Dr. Samir Mulani sir, Secretary of NEMA, Indapur. I request Dr. Anil Shirke sir to felicitate Dr. Suryakant Bansode sir, President of Homeopathy Association, Indapur. मी डॉक्टर पानबुडे सरांना विनंती करते की त्यांनी कार्यक्रमाची प्रास्ताविक करावी.
Good evening, and at the very outset, I welcome all the dignitaries and the delegates and our close associates. The chief guest of today's inaugural ceremony, an ex-Rajya Sabha MP, Padma Shri awardee, Dr. Vikas Mahatme sir, who is a senior ophthalmologist from Nagpur, the president of today's function and senior pediatrician, Dr. Jayant Naurange sir, senior ophthalmologist from Solapur, Dr. Mrs. Uma Pradhan, madam, who happens to be my teacher at VM Medical College, Solapur. During my undergraduation, she was my teacher, but I pursued medicine, so she can't remember me. Our patron, Dr. Ram Arankar, under whose patronage from last 4 years we are continuously organizing these conferences. Dr. Hari Umale, a senior ophthalmologist from Nagpur, who is a close colleague of Dr. Mahatme sir, and on our request, who has traveled all along from Nagpur to visit Indapur. Our president, dynamic president I can say, who has an opportunity to serve this branch from last 2 to 3 years, Dr. Anil Shirke, ex-president, and another vibrant, dynamic president, first woman president of our IMA Indapur, Dr. Mrs. Kalpana Khade madam, still more active secretary, without whose support this conference might not have seen the day of light, Dr. Sudhir Tambele sir, ex-IMAMS president, Dr. Kute sir, Dr. Raju Variani sir, and all my colleagues. Indapur and Indapur Taluka itself is a historical place, sir. It is nestled on the banks of eastern flowing rivers, the great rivers of Maharashtra, that is Bhima and Nira. The historical aspect of Indapur is, it has a blessing of Veerasri Sardar Maloji Raje Bhosle, who was the grandfather of our Chhatrapati Shivaji Maharaj, who laid his life in the battle of Indapur during his fight with Ali Adil Shah of Bijapur, because this area was under the siege of Adil Shah of Bijapur. Also, this was a Jahagir of Sardar Shahaji Raje, father of Chhatrapati Shivaji Maharaj, one of the Jahagirs, that is Indapur, Supa, Chakan and Pune, where the Jahagirs of Shahaji Raje, and one of them is the Indapur. So, little bit this is the historic aspect, and as this is nestled on the banks of Bhima and Nira. Also, some anecdotal reports say that the Moropant Trimbak Pingle, who was the first Prime Minister or Peshwa of Ashtapradhan Mandal of Chhatrapati Shivaji Maharaj, was also from Indapur. And the great poetess and the lyricist, Shantabai Shelke, was born in Indapur, and she has her primary learning at Indapur also. So this place and this taluka is having a lot of historical aspect, geographically situated between these two rivers. We have a pilgrimage center, sir, that is Nira Narsinghpur, situated at the confluence of Nira and Bhima, which is a family deity, ancestral deity of our popular Chief Minister Devendraji Fadnavis sir, who has contributed a lot for the development of Nira Narsinghpur. Also, we have a world-renowned bird sanctuary at Kumbhargaon, where you can see the migratory birds like flamingo and a plethora of birds who visit this place every year. And fortunately, this is the season when you can see the flamingos near the big one in Kumbhargaon and all surrounding area. As far as the Indapur IMA branch is concerned, so initially in 1978, it was founded by our patron and the then senior doctors from our Indapur, that is Dr. M.A. Hegde, Dr. M.M. Hegde, Dr. M.A. Pense sir, Dr. Arankar sir, Dr. B.B. Mali sir, and all others with a meager number of 12 members. But now our member strength has gone up to 100 plus with all active members in the branch working together to make any event very successful. From last 4 years, sir, though it is a small branch from small town, but it is not small in the fame or its work, because our branch is always on the forefront of all cultural activities, social activities, any medical camps, and it is well known all over Maharashtra, and we have a good reputation in the IMAMS as well as the IMA headquarters national level. As I have already told you that from last 4 years, we are continuously, consistently, and successfully, we are arranging such a conference that is Indacon 2, Indacon 3, Indacon 1, MedFest. So these all conferences were arranged very enthusiastically, successfully, with a great acclaim from all the doctors from the Maharashtra. So when we say it is a small branch, but the work of our branch is very much. Just 2 years back, a flagship program of the IMA National, which was arranged, that is the Aao Gav Chale. That is, patients are coming to us, but it is the need of the time that we have to go to the society. We owe something to the society. We have to do something for the society. So the national chairman, Ketan Bhai, promulgated this scheme. You have to start a Aao Gav Chale program. So we adopted a small village around 800 to 1000 population, that is Pandarwadi, which is hardly 5 to 6 kilometers from the Indapur. We adopted it under the able leadership of Dr. Mrs. Kalpana Khade. Throughout the year, we have arranged lot many programs, maybe academic programs for students of Pandarwadi, medical camps, awareness programs. So the natives of the Pandarwadi, they were so pleased that they donated us 10 gunthas of piece of land free of cost to the Indapur branch, which was a great success and great acclaim by the people of Indapur Taluka. So the credit all goes to the office bearers of our IMA branch, Dr. Kalpana Madam, Dr. Pratibha Unve Madam, and the patron, Dr. Ram Arankar sir. From last 2 years, our very active and vibrant president, Dr. Anil Shirke, who is continuously in the field of social works, organizing through the IMA branch with the help of all our office bearers and our all members of IMA Indapur. And sir, this is the only branch, small branch in Maharashtra, which has its own building, own conference hall. This is the only branch, small branch, I can say taluka level branch, who is arranging consistently and regularly, because many branches arrange the conferences one time or second time and they leave it, because to arrange a conference, so as you are sir already in the politics and social work, so you know very well to how to gather the people, how to organize any function, but still we are continuously, regularly we are arranging with a great success and great acclaim from all over Maharashtra. So, and every time we are arranging this conference on a hybrid mode, that is physical conference as well as the online conference also. And every time the registrations are too high, sir. They are beyond our expectation, because this year also we have more than 700 registrations, sir, till date. And still the doctors from Maharashtra are inquiring whether we can register still, because they are seeing this, our conference online. And the quality of the conference, the content of the conference, the subjects, various subjects, not only medical subjects, but we are arranging some non-academic subjects also. The very burning issue for doctors is the POXO and the medical legal subjects. For this, we call the medical legal experts from the various fields. Last year, we arranged a panel discussion on the medical legal aspects, and we called the special DG of the NIA, Delhi, Mr. Atul Chandra Kulkarni, Dr. Lale, who is the Director of the Health Services. So, experts from various fields we call up here. We have panel discussions on various topics. Also, we have topics like artificial intelligence in the medicine, because we are very much worried whether the AI will replace us. But our experts have told that if you embrace the artificial intelligence, it will not replace. But if you shy away from it, then, or if you behave mediocrely, then definitely you are going to be outdated and you will be replaced. So, sir, we continuously arrange so many programs, and every time the support of our delegates is huge. Because without our delegates, without their support, without acclaim, we can't arrange such programs. So, such a big event is only possible due to the dignitaries, the experts. They come over our call, our request, and the delegates who come here and support us. So this is all about, sir, our conference, and I thank all the dignitaries. Vikas Mahatme sir has traveled all along from Nagpur by train, because I think it's a travel of more than 10 to 12 hours also. Out of his busy schedule from medical practice, from his social work, from his politics, still at one request of ours, sir has traveled along also with Dr. Hari Umale. Dr. Uma Pradhan, she is closely associated with our branch. Actually, she was supposed to visit our branch last year, but due to some personal reasons, some unavoidable reasons, she couldn't make it. But she promised us that this time she will definitely come, and she has fulfilled her promise. So, I thank all the dignitaries, all the office bearers, and not the least, all the delegates who have come over here and supported us. So, from the heart of mine and the Indapur IMA, I thank and congratulate all, and I conclude my 2 words. Thank you.
Thank you, sir, for the detailed introduction. I request our IMA patron, Dr. Ram Arankar, sir, to address the audience with his wise and insightful words.
Very good evening. As per the tradition, I am supposed to speak in English. But since I can speak English and Marathi equally bad, I will prefer Marathi. तर आजच्या ह्या समारंभाला प्रमुख पाहुणे म्हणून लाभलेले डॉक्टर महात्मे, डॉक्टर नवरंगे, डॉक्टर मिसेस उमा प्रधान, आणखीन आमचे खास आलेले श्रीरामपूरहून डॉक्टर कुटे, याशिवाय जी मंडळी आवर्जून या कार्यक्रमाला आलेली आहेत, डॉक्टर वरियानी आहेत, आणखीन काही ब्रँचेसचे प्रेसिडेंट सेक्रेटरी आहेत या ठिकाणी, हे सगळे मंडळी वास्तविक आत्ता आपल्याला डॉक्टर बानगुडेंनी एकंदर या ब्रँचबद्दल संपूर्ण माहिती दिलेली आहे. त्याच्यामुळे मी थोडासा विषय चेंज करतो. ब्रँचच्या माहितीपेक्षा सुद्धा आजचा जो बर्निंग विषय आहे त्या विषयावरती मी थोडंसं आपल्याशी बोलणार आहे, फार वेळ न घेता. आपल्याला अवगत असेलच, गेली 10 वर्ष इंडियन मेडिकल असोसिएशन महाराष्ट्र राज्याचे प्रतिनिधी 9 प्रतिनिधी हे महाराष्ट्र मेडिकल काउन्सिलवरती निवडून गेलेले होते आणि ते 9 वर्ष सतत 10 वर्ष सतत कारभार करत होते. ह्या काळामध्ये आपण काय केलं नेमकं असं जर तुम्ही मला विचारलं तर सगळ्यात पहिली महत्त्वाची गोष्ट म्हणजे क्रेडिट आवर्स जे होते ते ऑनलाईन आपण केले, रजिस्ट्रेशन ऑनलाईन केलं. त्याच्यानंतर अत्यंत महत्त्वाची गोष्ट म्हणजे 70 पर्यंत जी मर्यादा होती ती आपण 65 वरती आणली. आणि असं एकही व्यक्ती मला आढळली नाही गेल्या 10 वर्षामध्ये की त्यांच्या कामाकरता त्यांना IMA तिथे जाऊन MMC मध्ये जाऊन काम करून घ्यावं लागलं किंवा काही पैसे द्यावे लागले किंवा काही इतर गोष्टी कराव्या लागल्या. असं अजिबात घडलेलं नाही. कालच आमचे डॉक्टर पेंडसे आहेत, त्यांच्या मुलीचा मला फोन आला होता की अवसर असं असं झालेलं आहे आणि मला महाराष्ट्राचं ह्याच्याकडून गुड कॅरेक्टर सर्टिफिकेट पाहिजे म्हणून. आमचे तिथं उत्तरे आत्ता बसलेले आहेत नेमके, त्यांना फोन केला, ते म्हणले मी उद्या सकाळी पाठवतो. दिस इज द वर्क व्हॉट वी आर डुईंग. आता हे सगळं करत असताना आता नेमक्या आपल्या तोंडावरती MMCच्या निवडणुका आलेल्या आहेत आणि या निवडणुका करता जे मंडळी सिलेक्ट करायची, जे उमेदवार सिलेक्ट करायचे, हे काम महाराष्ट्र स्टेटकडे होतं. पण एक साधी गोष्ट आहे, कुठल्याही गोष्टी करता आपण उमेदवार सिलेक्ट करताना विशेषतः महाराष्ट्र मेडिकल काउन्सिल सारख्या एखाद्या अतिशय महत्त्वाच्या ठिकाणी की जी संस्था गेली 12 वर्ष सरकारशी भांडते, अनेक वर्षापासून चाललेला आपला खटला होता की डॉक्टरांना तुम्ही कंझ्युमर प्रोटेक्शन मध्ये आणू नका. आत्ता कोर्टाने त्याच्यावरती निर्णय दिलाय की डॉक्टर्स हे कंझ्युमर मध्ये येत नाहीत. हे जे काम आपण करतोय हे काम करायला त्या माणसांनी वेळ द्यावा लागतो. त्या माणसाला नॉलेज पाहिजे, त्याला एफिशियन्सी पाहिजे, त्याला डेडिकेशन पाहिजे, त्याला एकंदरीतच वातावरण असं पाहिजे की तो माणूस धडाड्याने आपले प्रश्न तिथं मांडू शकला पाहिजे आणि सोडू शकला पाहिजे. हे सगळं आपल्या आतापर्यंत लोकांनी केलेलं असताना सध्याची जी बॉडी आहे या बॉडीने काय केलंय, इंटरव्ह्यूला जे लोक बोलवले त्यांना ऐन वेळेला सांगितलं तुमचा इंटरव्ह्यू आहे. सिलेक्शन कमिटीला जे लोक बोलवले त्या सिलेक्शन कमिटीमध्ये एकही पास्ट प्रेसिडेंट नाही, सिनियर मेंबर नाही किंवा सेंट्रल वर्किंग कमिटीचे मेंबर नाही. अशी सगळी परिस्थिती आणून ॲज इफ देअर इज अ मॅच फिक्सिंग असं असल्यासारखं त्यांनी ऐन वेळेला 9 लोकांची नावं डिक्लेअर करून टाकली. तुम्हाला आश्चर्य वाटेल, डॉक्टर कुटेसारखी व्यक्ती की जी प्रत्येक ब्रँचला महाराष्ट्रातल्या 4 वेळा जाऊन आलेली आहे, की ज्यांचं योगदान प्रचंड आहे, त्यांना वगळलं. म्हणजे मला आश्चर्य वाटतं की यांना करायचं तर काय. याचा अर्थ किंवा याचा वास असा येतो की कुणीतरी त्यांना पाठीमागून डिवचतंय, काहीतरी प्रलोभन देतंय आणि त्याच्यामुळे हे सगळं चाललेलं आहे. त्याच्यामुळे 15 तारखेला गेल्या पाठीमागचे सगळे 5 प्रेसिडेंट्स जे उमेदवार आहेत, हे सगळे मेंबर ज्यांनी ज्यांनी काम केलेले आहे ते सिनियर लीडर्स ऑफ द महाराष्ट्र, सेंट्रल वर्किंग कमिटीचे मेंबर, ह्या सगळ्यांची एक मीटिंग झाली आणि आपण 9 लोकांचा एक स्वतंत्र पॅनेल तयार केलेला आहे की जे पॅनेल तुम्ही नुसती नावं जरी बघितली तरी तुम्हाला लक्षात येईल की अरे ही दिस इज अ व्हेरी कॉम्पिटंट पर्सन. त्याच्यामुळं आता आपल्या समोर सध्या निवडणूक आहे. या निवडणुकीमध्ये आपल्याला पुण्याला जाऊन, जिल्ह्याच्या ठिकाणी जाऊन 26 एप्रिलला सगळ्यांनी मिळून सर्व उमेदवारांना मतदान करणं गरजेचं आहे. कारण असं आहे, त्यातलं 18 उमेदवार असतात, 9 त्यातले गव्हर्नमेंट नॉमिनेटेड असतात, 9 इलेक्शन मधून आलेले असतात. यातला एक पडला की आपला चेअरमन होणार नाही, की जो गेले 10 वर्ष आपला चेअरमन होता, डॉक्टर उत्तरे चेअरमन, आणि ही इज वेल नोन, वेल वर्स विथ एव्हरीथिंग. प्रचंड कार्य त्यांनी केलेलं आहे. अशा वेळेला आता आपण मागे न हटता हिरिरीने जिथं जिथं आपले मित्र आहेत, ज्या ज्या ठिकाणी आपल्याला माहिती आहे की बाबा या ठिकाणी काहीतरी होण्याची शक्यता आहे, त्या सगळ्या ठिकाणी आपण लोकांना सांगून आम्ही जे नवीन पॅनल निवडले ते आम्ही आता दाखवू आहे, हे दाखवू आम्ही तुम्हाला इथं पॅनल कुठला आहे ते, आणि त्या पॅनलला आपण सगळ्यांनी मतदान करणं गरजेचं आहे. या निमित्ताने हे सगळी मंडळी जी आपल्याकडे आली त्यांचे मी मनपूर्वक आभार मानतो, कारण ही उगीच भाषण करण्याची वेळ नाही. थँक्यू.
Thank you, sir. Audience, I have a question for you. If doctors were a part of cricket team, which department would be the captain?
Any answers from the audience?
Any answers?
Anyone from the dais? Yes, sir.
Yes.
Absolutely right. Because they quietly control the whole situation. So the Just like in cricket, where every over brings new excitement, our program moves forward with another interesting segment. It is my pleasure to introduce our guest of honor for today's event, Dr. Uma Pradhan ma'am. Dr. Uma Pradhan ma'am is a highly experienced senior ophthalmologist from Solapur with over 45 years of clinical practice and the founder of modern NABH accredited eye hospital. She has served as an associate professor of ophthalmology at Dr. VM Medical College, Solapur, where she contributed extensively to undergraduate and postgraduate teaching. Her areas of expertise include pediatric ophthalmology, phacoemulsification, and refractive surgery. She is a distinguished academician and award-winning researcher, having received multiple honors, including the Best Academician Award and the prestigious Service Above Self recognition by the Rotary International. She has also been awarded with the Solapur Bhushan Award in 2014 and Best Paper Presentation for 5 times. Ma'am, please, I request you to kindly address the audience.
नमस्कार. व्यासपीठावरील सर्व मान्यवर, डॉक्टर महात्मे, डॉक्टर नवरंगे, डॉक्टर कुटे आणि बाकी इतर सर्व मान्यवर, IMA इंदापूरच्या सर्व कार्यकारिणी सदस्या, मला मेनली हे ठीक आहे, मेनली लेडीज जास्त दिसत आहेत आणि त्यांनी इतकं वंडरफुल मनापासून काम केलेलं आहे, आणि व्यासपीठासमोरचे मान्यवर. इट्स बिट ऑफ अ सरप्राईज फॉर मी टुडे, कारण मला असं वाटलं होतं की मला भाषण केल्याशिवायच फेलिसिटेशनचं बक्षीस मिळणार आहे, पण मी पण तुम्हाला एक सरप्राईज देणार आहे की मी भाषण अगदी 3 ते 4 मिनटं करणार आहे. तर मला काही गोष्टी खरं तर कम्युनिकेट करायच्या असेल ना, आपल्या मनामध्ये कितीतरी असतं, पण मला एक 2-3 गोष्टी सांगाव्याशा वाटतात की आय एम व्हेरी प्राऊड फॉर 3 थिंग्स गॉड हॅज गिवन. आय एम बॉर्न ॲज अ फिमेल, कारण मला असं वाटतं की फिमेल्स आर ऑलवेज व्हेरी कंपॅशनेट, हार्ड वर्किंग आणि डेडिकेटेड. This part of the audience may not agree with it, but that's the thing I really, मला मनापासून तसं वाटतं. Second thing is, as a profession I got medicine. I became a doctor. कारण त्यावेळेला सोलापूरमध्ये एक मेडिकल कॉलेज आणि डिप्लोमा इंजिनिअरिंग सोडून दुसरं काहीच नव्हतं. दिस वॉज अबाउट 50 years ago, more than 50 years ago. आणि त्यावेळेलाच गव्हर्नमेंटचं मेडिकल कॉलेज झालं, तर त्याच्यामुळे विदाऊट डोनेशन इट वॉज पॉसिबल to get an admission. And third thing is, as a super specialty or specialty, I did ophthalmology, and I'm an ophthalmologist practicing for last 40 years. I taught in medical college for almost 15 years. तर मला ऑप्थॅल्मॉलॉजिस्ट झाल्याचा खूप खरं म्हणजे मी जेव्हा ऑप्थॅल्मॉलॉजी घेतलं ना तेव्हा आय वॉज बिट स्केप्टिकल अबाउट इट. पण आता मला मागे वळून पाहताना असं वाटतं की इट्स अ ग्रेट थिंग. कारण 40 वर्ष आता मला प्रॅक्टिस करून झाली. तर 40 इयर्स ॲगो ऑप्थॅल्मॉलॉजी वॉज नॉट अन इम्पॉर्टंट ब्रांच. पण काही कारणांमुळे मी ऑप्थॅल्मॉलॉजी घेतलं. अँड ॲट दॅट टाईम आय स्टार्टेड माय प्रॅक्टिस. I took a loan of 1,30,000 with 2 years holiday period, and that time only ophthalmoscope, refractionचा सेट आणि ऑपरेटिंग मायक्रोस्कोप सुद्धा त्यावेळेला नव्हता. पण आय वॉज द फर्स्ट वन टू यूज इट इन सोलापूर. एवढंच होतं. पण त्याच्यानंतर गेले 40 वर्ष ऑप्थॅल्मॉलॉजीमध्ये इतका ट्रेमेंडस इतका प्रोग्रेस झालेला आहे टेक्नॉलॉजीमध्ये in all fields, surgical as well as therapeutic, everything. Cataract surgery steps, complete cataract surgery I must have changed at least for 5 times, and small little steps in innumerable times. Then lasers came in ophthalmology, various kinds of laser to treat retina, to do glaucoma surgery, then various cornea for refractive surgery, myopia treatment, that is LASIK. नंतर कॅटरॅक्टमध्ये आता जी सर्जरी करतात ती that it's within 5 minutes, 5 to 10 minutes without any anesthesia. There are several types of lenses that have come in that can give you good vision without even glasses, and so much and so forth. आणि तिसरी गोष्ट त्यामुळे आम्हाला दॅट वॉज अ लर्निंग पिरियड फॉर अस अँड इट वॉज अ चॅलेंज फॉर अस. असं नाही की आता मुलं जी आले त्यांना ऑडिओ व्हिज्युअल आहे, ट्रेनिंग सेंटर्स आहेत, फेलोशिप्स आहेत. इट वॉजंट दॅट काइंड ऑफ अ ट्रेनिंग अवेलेबल फॉर अस. सो दॅट लर्निंग कर्व वॉज व्हेरी हार्ड, अँड बट स्टील इट वॉज चॅलेंजिंग अँड दॅट मेड इट इंटरेस्टिंग ॲज वेल. आणि तिसरी गोष्ट म्हणजे आपल्याला सांगावीशी वाटते की आम्ही जे आयकॅम्प्स खूप घेतले तर त्याच्यामध्ये माझे आफ्रिकेतले जे अनुभव होते ते मला ॲज अ डॉक्टर अँड ॲज अ ह्युमन बिईंग त्यांनी मला इतकं शिकवलं की प्रत्येक माणूस आपल्याकडे येणारा प्रत्येक पेशंट वेगवेगळ्या आर्थिक स्तरातून, वेगवेगळ्या अडचणीतून, आपापली ओझी घरातले प्रॉब्लेम्स, इतर प्रॉब्लेम्स, म्हणजे ऑप्थॅल्मॉलॉजीसाठी नाही, सर्वच ब्रांचेसना आहेत, ते सर्व घेऊन आलेलं असतात आणि आपण फक्त त्यांच्याकडे पेशंट म्हणून बघतो. तर तसं न करता आपण ॲज अ ह्युमन बिईंग अँड ॲज अ पेशंट म्हणून जर आपण वी कॅन कम्युनिकेट, वी कॅन डेव्हलप अ बॉन्ड विथ देम, आणि दे आर रेडी टू ॲक्सेप्ट एव्हरीथिंग व्हॉट एव्हर वी आर इन अ पोझिशन टू गिव्ह देम ऑर टेल देम. तर आफ्रिकेतल्या मी तुम्हाला 2-3 गोष्टी सांगते आणि जास्त काही मी बोलणार नाही, कारण डॉक्टर महात्मे आणि बऱ्याच जणांना अजून तुम्हाला ऐकण्याची इच्छा असणार आहे. तर आफ्रिकेमध्ये आम्ही 1997 मध्ये प्रथम गेलो युगांडाला. तर आफ्रिकेमध्ये अशी कंडिशन आहे की तिथे आपल्याकडे कशी गव्हर्नमेंट हॉस्पिटल्स किंवा चॅरिटेबल हॉस्पिटल्स आहेत जिथे आपल्याकडे पैसे नसले तरी आपण काहीतरी बेसिक ट्रीटमेंट घेऊ शकतो. तर तिथे तशी काहीच फॅसिलिटी नसते. एक प्रायव्हेट प्रॅक्टिशनर्स असतात जे साऊथ आफ्रिकेला जाऊन, लंडनला जाऊन, दोज हू कॅन अफोर्ड, त्यांच्याकडे म्हणजे वेल्दी पेशंट्स जाऊ शकतात. आणि मिशनरीजची काही हॉस्पिटल्स असतात पण ती सुरुवात करून देतात, मशीन्स वगैरे सगळं, पण पुढे मेंटेनन्सला वगैरे काही, त्याच्यामुळे बरीचशी मिशनरी हॉस्पिटल्स ख्रिश्चनांची बंद असतात. सो इफ यू डोंट हॅव मनी यू आर ऑन द स्ट्रीट, अशी पोझिशन असते. त्याच्यामुळे आम्ही जे रोटरीतर्फे तिथे कॅम्प्स केले, अगणित कॅम्प्स केले, म्हणजे जवळजवळ माय हजबंड वॉज अ चेअरमन ऑफ दिस इंटरकॉन्टिनेंटल मेडिकेअर प्रोजेक्ट. तर ही हॅज गॉन देअर फॉर ऑप्टीन नंबर ऑफ टाइम्स. मी 17 वेळेला आफ्रिकन कंट्रीजमध्ये गेलेले आहे. तर 1997 मध्ये आणि मग लास्ट मी शेवटचा आम्ही सेम टीम घेऊन, फक्त 1-2 काही फरक असेल, परत 2017 मध्ये युगांडालाच आम्ही कंपालाला आणि आणखीन 2-3 ठिकाणी कॅम्प घेतले. तर त्यावेळेला तुम्हाला एकच इंटरेस्टिंग गोष्ट की इतका फरक होता तिथे की एव्हरीथिंग वॉज चायनीज. ऑल बिल्डिंग्स, रस्ते, हॉटेल्स, इवन पार्लमेंट बिल्डिंग, चायनीज प्रेझेन्स वॉज सो प्रॉमिनंट. आणि त्याच्या आधी सगळं तुम्हाला माहिती आहे आफ्रिकेमध्ये गुजराती लोक असायचे. तर अशा रीतीने तो एक फक्त नोटीस केलेली गोष्ट होती. पण आफ्रिकेला एक 2-3 पेशंट्सच्या मी तुम्हाला पेशंटची गोष्ट सांगते की त्यांच्याकडे अगदी अजिबात काही नसायचं. म्हणजे आम्हाला मेडिसिन्स, आयपॅड्स, इन्स्ट्रुमेंट्स, एव्हरीथिंग वी यूज टू कॅरी. इतकं सामान असायचं की त्याच्यासाठी आम्ही एअर इथिओपियाशी कॉन्टॅक्ट केला तर पहिल्यापासून कॉन्ट्रॅक्ट केलं होतं आणि त्याच्यामुळे त्यांनी आम्हाला बऱ्याच फॅसिलिटी देऊन सगळं सामान. टिल देन these African countries used to look up to the European countries. आणि तुम्हाला माहिती आहे की युरोपियन किंवा वेस्टर्न कंट्रीजमध्ये किती महाग असतात सगळ्या गोष्टी, इन्स्ट्रुमेंट्स काय, लेन्सेस काय काय. तर आम्हाला ते सगळं घेऊन जायला लागायचं. आणि पेशंट्स इतके गरीब पण तरी देखील ती जी कृतज्ञतेची भावना असते ना. तर मला आठवते की एका बाईने मला ऑपरेशन झाल्यावर सो हॅपी की तिने तो छोटासा त्यांचा पंखा असतो ना तो दिला होता आणून की डॉक्टर जे काय असेल ते वगैरे तुम्ही खूप मदत केली. एका बाईने तिच्याकडे 2च बकरी होत्या. त्या बकरीचं दूध काढून 10 दिवस साठवून त्याचं तूप काढून असं मिचकट कुचकट बाटलीमध्ये तूप आणून दिलेलं होतं. आम्ही कंपालाला ऑपरेशन करून जेव्हा एअरपोर्टवर गेलो तर एअरपोर्टवर म्हणजे ऑपरेशन संपून 2-3 दिवशीच गेलो होतो. तर एअरपोर्टवर तिथल्या रोटेरियनचा फोन आला की अहो तुमचा पेशंट एक खूप वेड्यासारखं करायला लागलेला आहे. तर काय झालं होतं की दॅट ओल्ड वुमन हॅड नॉट सीन हर, शी वॉज कॅटरॅक्ट ब्लाइंड विच वॉज रिव्हर्सिबल. आणि शी हॅड नॉट सीन हर ग्रँडचिल्ड्रन फॉर 10 years. आणि 10 वर्षांनी तिने आपल्या फॅमिलीतल्या सगळ्या मेंबर्सना पाहिलं आणि ती आनंदाने वेडी झाली. आणि तिच्या कम्युनिटीतल्या माणसांनी ते मांत्रिक तांत्रिक वगैरे बोलवले आणि असं मग ती सेटल झाली वगैरे. तर अशा खूप गोष्टी आम्हाला त्या आफ्रिकेतल्या ह्यांनी शिकवल्या. मला असं वाटतं सांगू तेवढ्या कमीच असतील. तर त्याच्यामुळे मी इथेच तर मी त्या ऑप्थॅल्मॉलॉजिस्ट त्यावेळेला कसं की OB-GYN, सर्जन, प्लास्टिक सर्जन वगैरे. पण मी ह्याच्यासाठी घेतला तर ऑप्थॅल्मॉलॉजी की त्याच्यात 3 वर्ष कंटिन्युअस रेसिडेन्सी मला मिळत होती. अँड आय रिक्वायर्ड दॅट पेड जॉब दॅट टाईम. तर म्हणून मी ऑप्थॅल्मॉलॉजी घेतलं तर पण त्याचा मला आता खूप आनंद होतो की ऑप्थॅल्मॉलॉजी घेतलं. आणि वॉट एव्हर वॉज पॉसिबल फ्रॉम माय साईड आय हॅव ट्राईड टू गिव्ह इट टू द सोसायटी. आणि पेशंटसुद्धा खूप आपल्याला म्हणजे तुम्हाला माहिती आहे किती आनंद देतात ते की एखादा पेशंट येऊन नुसता तुम्हाला थँक्यू डॉक्टर खूप छान झालं बरं का वगैरे. तर तो आनंद असतो तो वेगळा असतो ना हातून आलेला. इट्स नॉट अबाउट द मनी दॅट वी गेट फ्रॉम द पेशंट. तर एवढं सांगून मी थँक्यू.
Thank you, ma'am, for sharing your inspiring story with us. I now request Dr. Kalpana Khade, ma'am, Dr. Arankar, ma'am, and Dr. Geeta Margar, ma'am, to present a token of appreciation to our speaker.
तर ती नैतिक लोकनीतीसाठी आहे. मग त्याच्यामुळे यू विल नॉट सी एनी ब्रेकिंग न्यूज फ्रॉम माय साइड अँड मेनी ऑफ यू मे नॉट बी अवेअर दॅट आय वॉज अ member of parliament for 6 years. So that is the difference. When it is naitik lokniti, you people are not aware about that person. Usually that happens. I am also I also face the same thing. And the most important question is we never talk about ethics. Do you agree that the trust of the patient on the doctors is day by day reducing? हे ॲग्री करता की नाही करत? जे नाही ॲग्री करत त्यांनी हातवरती करावे. म्हणजे आय शॅल लाईक टू अंडरस्टँड व्हॉट इज दी गुड थिंग अबाउट इट, बिकॉज देन वी शुड फॉरगेट अबाउट इट. Everybody knows about it, that ethics or the trust on the doctors is reducing. If that is there, आता समजा मला माझा मुलगा म्हणाला की I want to appear for NEET exam and I want to be amongst first 10,000 and 25 lakh students are appearing, you are aware. आणि तेव्हा जर असा फिरत असेल फक्त इकडे तिकडे किंवा आणखी खूप अभ्यास करत असेल पण मेडिकलच्या रिलेटेड नसून दुसरा करत असेल, तर व्हॉट यू विल फील? त्यांनी काय करायला पाहिजे? त्यांनी समजा युनिव्हर्सबद्दल वाचलं, त्यांनी ही मस्ट हॅव रीड अबाउट एव्हरीथिंग, अर्थ, युनिव्हर्स अँड एव्हरीथिंग. तर तुम्ही काय म्हणाल? अरे नीटची परीक्षा आहे, त्या विषयांचा अभ्यास कर म्हणाल का नाही म्हणाल? म्हणाल. दॅट इज देअर. If I want to be a good ophthalmology and surgeon, good surgeon, I become MBBS, I then become MS ophthalmologist and then do a fellowship or something. So I at least work hard for nearly 10 years. Everybody of you have done that. Apapल्या branch मध्ये. For 10 years. But we want that the trust of the patient should increase on the doctors. विश्वासार्हता डॉक्टरांची वाढली पाहिजे. But we will not do anything for it and still it should happen. म्हणजे माझा मुलगा जो नीटसाठी करतोय ना, तसं आपण सगळे करतोय, including me. We do not want to talk about, we do not want to discuss, we do not want to have a strategy, we do not work for it continuously. If it is the biggest problem, I feel it's a very big problem because that creates many hurdles for us also. So we have to think about how this can go away. Just I shall tell you one example. What can be done? What can be done? त्याच्या आधी एक स्टोरी सांगतो. We arranged so many camps in Gadchiroli, there in deep forest. We had a camp, and during that camp, one of the camp I saw the mango tree, and being summer, I tried to go on the top of the vehicle and catch hold of the 2 or 3 mangoes. तर तिथून एक मुलगा, यंग मुलगा धावत आला. I thought the mango tree must be his own tree and so that's why he is coming there. म्हटलं नाही नाही, या इथे कच्चे आम लागले होते म्हणून मी तोडले. हे कोणाचं झाड आहे? तो म्हणाला हे गावाचं झाड आहे. and only I think 18 houses were there and 18 houses they call it as toli. That village was of 18 houses only. Then I discussed with him. Of course, interpreter was there because his tribal language I was not able to understand. त्याला जस्ट विचारलं, इतक्या दूर तुम्ही राहता, या इथे हेल्थ सर्व्हिसेस म्हणजे तुला जर आजार झाला तर तुम्ही काय करता? डॉक्टरकडे कुठे जाता? तो म्हणाला आमच्या इथे एक वैद्य आहे, त्याच्याकडे जातो. मग मी म्हटलं की तो वैद्य तुला ट्रीटमेंटचे किती पैसे घेतो? तर तो म्हणाला नाही नाही, काय पैसे वगैरे नाही. मला वाटलं पैसे नसेल घेत. नाही, आम्ही त्याला धान्य देतो म्हणे. पैसे नाही घेत ते, आम्ही त्याला धान्य देतो. तरी मी खूप क्युरियस झालो की समजा तुला लूज मोशन्स आहे, हगवण आहे, तर त्यावेळेस तू त्याला किती धान्य देशील त्या वैद्याला? थोडा नाही नाही, ज्या वेळेस मला लूज मोशन किंवा माझ्या घरातला कोणाला आजार होईल त्यावेळेस त्या महिन्यात आमच्या घरातून त्याला काहीही धान्य जाणार नाही, बाकीच्यांच्या घरातून जाईल. म्हणजे कसं आहे, डॉक्टरचं काम काय आहे? तर सगळ्यात पहिलं आजार होऊ नये म्हणून ट्रीटमेंट. आजार होऊ नये म्हणून डॉक्टरचं काम हे नाही आहे की आजार झाल्यावर ट्रीट करायचं. बेसिक कन्सेप्ट खूप महत्वाचा आहे. आज मी आजारी पडलो तर पूर्ण इंडस्ट्रीला फायदा आहे. मी आजारी पडलो किंवा आमचं कुठेही कोणी आजारी पडलं तर डॉक्टरला तर फायदा आहेच, कारण तुम्ही म्हणाल की एकही पेशंट नाही तर ते क्लिनिक हॉस्पिटल कसं चालणार, बरोबरही आहे, मी म्हणत नाही. दुसरं, इन्स्ट्रुमेंट्सवाले कंपन्यांना फायदा आहे, मेडिसिन शॉपवाल्यांना फायदा आहे. म्हणजे एव्हरीथिंग रिव्हॉल्व्स अराउंड डिझिजेस. जर तुम्हाला आजार झाला तर तुम्हाला डॉक्टर्सांना आणि सगळ्या हेल्थ इंडस्ट्रीमध्ये सगळ्यांना फायदा आहे. याचा ग्रेट डिसएडव्हान्टेजेस काय आहे तर कोणीच प्रिव्हेंटिव्ह मेडिसिनकडे जात नाही. नो बडी वॉन्ट्स टू थिंक अबाउट प्रिव्हेंटिव्ह मेडिसिन. यू विल फील की हां ठीक आहे जायला पाहिजे वगैरे, पण तुमच्या हेल्थवर सगळ्यात महत्त्वाचं लाईफमध्ये काय आहे, जीवनात सगळ्यात महत्त्वाचं काय तर आपलं जीवन महत्त्वाचं आहे, बस. दॅट इज द मोस्ट इम्पॉर्टंट. लाईफ इज द मोस्ट इम्पॉर्टंट थिंग. एव्हरी डॉक्टर विल डेफिनेटली से येस टू दॅट. आता मला सांगा, ॲडल्ट व्हॅक्सिनेशन म्हणजे अबव्ह 18चं व्हॅक्सिनेशन आहे, किती जणांनी या इथे व्हॅक्सिनेशन घेतलेलं आहे? ॲडल्ट व्हॅक्सिनेशन. पिडियाट्रिक तर तुम्ही दिलेलं असेल हजारो मुलांनी, सध्या पण घेतलेलं आहे, पण ॲडल्ट व्हॅक्सिनेशन किती जणांनी घेतलं? बरं, तुम्ही तुमच्या फॅमिलीमध्ये न्यूमोनियानी डेथ झालेली पाहिली आहे का? तुमच्या फॅमिली किंवा अराउंड कोणाची? नाही. मेनिंगोकोकल मेनिंजायटिसनी डेथ झालेली पाहिली आहे का? हिपॅटायटिस सी झालेलं पाहिलं आहे का? हिपॅटायटिस बी झालेलं पाहिलं आहे का? फ्लू झालेला पाहिला आहे का? म्हणजे फ्लू म्हणजे व्हायरल पाहिला का नाही पाहिला? पाहिला. इन्फ्लुएन्झा, फ्लू, कोविड, कोरोना, हिपॅटायटिस सी, बी, टायफॉइड झालेलं पाहिलंय का? येस. या सगळ्यांना वॅक्सिनेशन आहे. इज देअर कॅन्सर विच हॅज अ वॅक्सिनेशन? येस आहे वरती. हां, HPV. इथे तुम्ही तुमच्या घरातल्या मुलींना किंवा आता इव्हन ॲडल्टला पण आहेत, 25 वर्षापर्यंत पण आहे, कारण मग मी जेव्हा बोलतो तर कोणीतरी म्हणते नाही नाही यांना माहिती नाही, ॲडल्ट्सला नसते. आता ॲडल्ट्सला पण आहे, तर त्याच्यातल्या इव्हन माणसांना पण असू शकतो तो. ते पण एक कन्सेप्ट आहे, मिसकन्सेप्ट. तर किती जणांनी ते कॅन्सर सारखी बिमारी होऊ नये म्हणून एकच इंजेक्शन घ्यायचं आहे, पण किती जणांनी, डॉक्टर हे सगळे डॉक्टर्स आहे बरं, घेतलाय? म्हणजे आपण जेव्हा या सिस्टम मध्ये बसतो ना तेव्हा हे लक्षात घ्या की आपण आपलं आरोग्य सुद्धा त्याच सिस्टम मध्ये बसवलेलं आहे, स्वतःच सुद्धा. म्हणजे प्रिव्हेंटिव्ह मेडिसिनचा इतका म्हणजे त्याच्याकडे लक्ष नाही देऊन राहिलो की आपण आपल्या हेल्थला, आपण हेल्दी राहण्यासाठी, आपल्याला आजार होऊ नये याच्यासाठी इवन व्हॅक्सिन घेत नाही. जर आज नवरंगे सरांनी म्हटलं की मुलांना व्हॅक्सिनेशन मला वाचलेलं आहे, मला पाठ आहे, पण मी काही कोणाला देत नाही आणि कोणी काही देऊ नये, तर तुम्ही म्हणाला बापरे का डॉक्टर आहे. पण हे ॲडल्ट व्हॅक्सिनेशनमध्ये तसंच करून राहिलो ना आपण. असं काही आहे का की ॲडल्ट झाल्यावर डेथ नाही होऊ शकत या आजारांमधून? कोविडनी कितीतरी लोक मेले, साध्या कोविडनी. इन्फ्लुएन्झा किंवा फ्लू जो आहे ना त्यांनी सुद्धा जातात, नंतर कॉम्प्लिकेशननी गेलो म्हणतो आपण, पण दॅट इज दी प्रायमरी कॉज टू स्टार्ट विथ. हा प्रॉब्लेम मेजर आहे. आणि त्याच्या याच्यातच मी तसंच हे जे फायनान्शियल कम्युनिटी मेडिसिनचा जसा प्रश्न आहे ना, प्रिव्हेंटिव्ह मेडिसिन, त्याच्याकडे आपण लक्ष देत नाही, ते याच्यामुळे, आणि आपल्याला लक्ष द्यायला पाहिजे. तसंच ते एक गोष्ट अशी पण आहे एथिक्स, ज्याच्याकडे आपण लक्ष नाही देऊन राहिलो. आता हे लक्ष देताना मी सांगतो की काय काय करता पण येऊ शकते. तुम्ही म्हणाल डॉक्टर महात्मे हा एथिक्स शिकवलं पाहिजे याचं तसं बोलता, फक्त बोलून गेले चांगलं नाही झालं, नाही, ॲक्शन प्लॅन असू शकतो याचा. आणि समजा आता मी सांगतो इथे लार्ज कॉर्पोरेट हॉस्पिटल्स आहे, मला माहीत नाही इथे आहेत की नाही, पण मुंबई पुणे, तुम्हाला तर पुणे तुमचा जिल्हाचा आहे त्याच्यामुळे काय प्रश्न असतो. मुंबई पुण्यात आहे, सगळीकडे नागपूरमध्ये आहे, मोठ्या शहरांमध्ये आता जवळपास सगळीकडे आहे. ज्युनियर डॉक्टर्स इतके इन्व्हेस्टमेंट करू शकत नाही. करू शकतात का? एवढं येऊ शक्य नाही. मग ते हे कॉर्पोरेट हॉस्पिटल जॉईन करतात. मग कॉर्पोरेट हॉस्पिटल जॉईन केल्याबरोबर तो काय म्हणतो, ठीक आहे तुम्हाला जॉईन करतो, इतका इतका पगार मिळेल. त्याला वाटतं वा खूप छान आहे. मग तो म्हणतो पण तुम्ही जर एवढे टार्गेट फायनान्शियल टार्गेटचे एवढे पैसे आणले तर मग तुम्ही जर 1 लाख आणले तर तुम्हाला 30,000 रुपये आणखी मिळतील. आणि 1-2 महिने तो आणत नाही आणि त्याला वाटतं जे आहे ते सांगितलं पाहिजे इन्व्हेस्टिगेशन्स असं. मग तो पुन्हा भेटतो, तुमचा रेव्हेन्यू खूप कमी होतो, आम्हाला दुसरा डॉक्टर घ्यावा लागेल. मग तुम्ही ठरवा तुम्हाला राहायचं असेल इथे तर ठीक आहे, नाही तर आम्ही दुसरा डॉक्टर घेऊ. कारण आता नवीन डॉक्टर्स इतके येऊन राहिलेले आहे, कारण वी हॅव इन्क्रीज द मेडिकल सीट्स, आता खूप येऊन राहिले आहे. मग तो त्यांनी म्हटल्याबरोबर त्याचा सर्वायवलचा प्रश्न येतो. त्याचा सर्वायवलचा प्रश्न आल्याबरोबर तो काय करतो, इन्व्हेस्टिगेशन्स लिहिणं चालू करून देतो. तर इन्व्हेस्टिगेशन्स लिहिल्याबरोबर मग डॉक्टरवरचा विश्वास त्या लोकांचा उडायला लागतो की इन्व्हेस्टिगेशन त्यांनी सांगितलं, दुसरा म्हणतो काही आवश्यक नाही, हे असं केलं तरी चालेल. आता मेजर प्रॉब्लेम कुठून सुरुवात झाला, फायनान्शियल टार्गेट. हे टार्गेट देऊ नये याच्यासाठी आपण प्रेशर तर निर्माण करू शकतो आणि लोकांचं प्रेम तुमच्याबद्दल वाढेल. मी सांगतो का, IMA म्हटलं की वी विल नॉट अलाउ दोज कंपनीज हू आर गिव्हिंग फायनान्शियल टार्गेट्स. फायनान्शियल टार्गेट्स आणि डॉक्टरचा काही संबंध नाही. इट शुड नॉट. पत्रकार लोक तुम्हाला डोक्यावर घेतील, तुमच्या सोसायटीला डोक्यावर घेतील. हो, these people are aware and these people want that this money should not get involved in the doctor's business. त्याच्यानंतर पेशंटला पण बरं वाटेल, पत्रकार पण डोक्यावर घेतील. आणि दुसरं असं आहे की तुम्हाला वाटेल हे शक्य नाही होत कारण ते कॉर्पोरेट मोठे असतात. बिलकुल नाही. मी सांगतो, आत्ता आमच्या इथे एक मोठी कंपनी, इंटरनॅशनल कंपनी आहे, नाव विसरलो मी, इंटरनॅशनल कंपनी. ते इलेक्ट्रिसिटीचे काही कॉम्पोनंट्स बनवतात, इलेक्ट्रिकल याचे. तर ते कॉम्पोनंट्स बनवतात, तर ते पहिले ज्याच्याकडून छोटे मोठे काही गोष्टी विकत घेतात त्याच्यासाठी लागणाऱ्या, त्यांच्याकडून लिहून घेतात की तुमच्याकडे चाइल्ड लेबर नाही आहे अँड यू विल नॉट डू दोज अनफेअर प्रॅक्टिसेस, की चाइल्ड लेबरकडून काम करून मग ते आम्हाला दिलेलं आहे तरच आम्ही विकत घेऊ. सो दिस पॅटर्न कॅन बी देअर. म्हणजे असं नाही की आपण मी जे म्हणतो ते अशक्य आहे. वी विल हॅव टू से दॅट यू विल, नो बडी इन इंडिया विल बी एबल टू गिव्ह फायनान्शियल टार्गेट टू अ डॉक्टर. IMA ला काय वाईट म्हणणार आहे, कोण वाईट म्हणणार आहे, कोणीच नाही वाईट म्हणू शकत. आणि एथिकल त्याला सुद्धा प्रॉब्लेम नाही येणार, आपलेच ज्युनियर्स आहे. पुष्कळ जण मी सांगेल की मी कट प्रॅक्टिस करत नाही. अरे पण मी कट प्रॅक्टिस करत नाही कारण माझा आता इतक्या वर्षाच्या अनुभवानंतर कोणाला कट प्रॅक्टिसची काय आवश्यकताच नाही ना. त्याला काही मी मोठा झालो त्यांनी असं बिलकुलच नाही. उलट मी माझ्या ज्युनियर्सला कसं एन्व्हायरमेंट देऊन राहिलो ज्याच्यामुळे त्यांना कट प्रॅक्टिस करावीच लागत नाही. हा महत्वाचा भाग आहे. त्यांना करावी का लागते, दे हॅव द स्किल्स, दे हॅव द नॉलेज, बट दे कॅनॉट युटिलाइज इट. मग अपॉर्च्युनिटीज क्रिएट करा. अपॉर्च्युनिटीज सिनियर्सच करू शकतात आणि अपॉर्च्युनिटीज क्रिएट करायला आता तर अजून चांगलं आहे. सिनियर्सकडे वेळ नाही आहे तर कोण करेल, हे ज्युनियर्स करतील. आपल्या हॉस्पिटलमधले जे MJPGY किंवा काही अशा ज्या केसेस आहेत त्यांच्या सुपरविजनमध्ये करतात. बट दे विल गेट द अपॉर्च्युनिटी टू युटिलाइज देअर स्किल्स. IMA नाही पण आपणही स्वतः प्रत्येक जण रिस्पॉन्सिबल आहे. आणि मला असं वाटतं की हे घेतलंच पाहिजे आपण हाती. तरच असे काही वेबसाईट आहे का आपल्या इथे की यू पोस्ट युअर आयडियाज हाऊ टू इन्क्रीज दिस ट्रस्ट ऑफ द पेशंट ऑन डॉक्टर्स. असं वेबसाईट सुद्धा नाही तयार करत आपण, त्याला काही पैसे नाही लागत. आणि यंगस्टर्स हॅव मेनी आयडियाज. आय टेल यू, दे विल टेल यू. आउट ऑफ दॅट few will be implemented. हे खूप महत्वाचं आहे. डोंट टेक इट लाईटली. खूप जण मग काय करतात मी ते सांगतो. हा ओळखीचा पेशंट म्हणतो मला ना सुट्टी घ्यायची आहे, तुम्ही मला एखादा आजार लिहून असं करा 7 दिवसाची सुट्टी द्या लिहून. आता तुम्हाला वाटते जाऊ दे ना लिहून देतो. लिहून दिल्याबरोबर तो काय करतो, हा त्या डॉक्टरांचं काय काही पण खरं नाही, आम्ही सांगितलं त्यांना पैसे दिले त्यांनी लिहून दिलंच, म्हणजे विश्वास उडाला. इन्शुरन्स कंपन्या आहेत, इन्शुरन्स कंपन्याचं मी म्हटलं त्याला की तुम्ही खूपच कमी पैसे देता, because these people are highly intelligent in finance. You cannot compete with them as far as finance is concerned. या तशाच या मोठ्या मोठ्या कंपन्या, आमच्या इथे ऑप्थमचं सांगतो मी, इथे आता डॉक्टर भारती आहे, डॉक्टर उदय पण आहे, बाकीची पण ऑप्थल्मॉलॉजिस्ट असते. एक इक्विपमेंट घेतलं तर त्यांनी त्याच्यात असं केलं आहे की कॅसेट लावायची फेकूच्या वेळेस. मग ती कॅसेट म्हणजे तुम्ही जर पेशंटकडून 10,000 घेत असाल तर कॅसेटचे मला पैसे मिळायला पाहिजे, कारण ती बदल. लेझर जर करत असेल त्याच्यात एक असतं ते इन्सर्ट करावं लागतं, ते प्लास्टिकचं एकदा 20 रुपयाचं नसेल, ते इन्सर्ट केलं तरच तुम्हाला तो दुसरा पेशंट ऑपरेट करता येतो, नाही ते नाही करता येत. म्हणजे काय, त्याच्याकडून ते 5-6 हजाराचं खरेदी करा. म्हणजे पर पेशंट तुम्ही जर पैसे कमवा नका कमवू, पण आम्हाला पर पेशंट पैसे पाहिजे, फक्त मशीनचे पैसे नाही पाहिजे, पर पेशंट. फायनान्स ते मॉडेल तसं तयार केलं जातं. यांच्या समोर आपण फायनान्समध्ये त्यांच्या समोर नाही जाऊ शकणार, हे लक्षात घ्या. या इन्शुरन्स कंपन्यांचं पण तसंच आहे. दे आर व्हेरी हायली इंटेलिजंट ॲज फार ॲज मनी इज कन्सर्न. ते काय करतात, पहिलं 6,000 देतो म्हणतात, मग 3,000 देतो म्हणतात कॅटरॅक्टचे, अशी कमी कमी करत जातात. आणि देन यू डोंट हॅव अ चॉईस, कारण पेशंट म्हणतो माझं इन्शुअर्ड आहे, तुम्ही करा, तुमचं नाव होतं तिथे. आता त्याच्यात तो काय म्हणतो रिप्रेझेंटेटिव्ह येऊन, तुम्ही असं करा ना, त्याच्यात व्हिजिट पर व्हिजिटचे 400 रुपये आहे, तुम्ही एकच व्हिजिट लिहिलं तर तुम्ही 4 व्हिजिट लिहून टाका ना, 400 1600 येतात, ते लिहा तुम्ही. आता त्या डॉक्टरने लिहिलं समजा 4, तर काहीच नाही, इन्शुरन्स पैसे देतं, हे देतं, त्या पेशंटकडे जातं. पेशंट वाचतो, हां डॉक्टर महात्मे, अरे तिथे एकच वेळ आले होते, 4 वेळा लिहिलं त्यांनी, पण ते तर एकच वेळ आले होते. माझ्याशी काही बोलत नाही, कोणाशीच काही बोलत नाही. घरातल्या लोकांना सांगतो, आजूबाजूच्या लोकांना सांगतो, आणि मनात काय आहे त्याच्या, डॉक्टर महात्मे करप्ट प्रॅक्टिसेस करतात. म्हणजे झालं इन्शुरन्सचं, त्यांनी तुम्हाला आयडिया दिली, तुमचा ट्रस्ट कमी झाला ना विनाकारण. यू हॅव टू ऍक्ट ऑन दिस, वी विल नॉट डू दिस. नाही ते सर्टिफिकेट नाही, हे नाही, काहीच नाही, कारण दॅट इज कॉझिंग अ प्रॉब्लेम. वी हॅव टू चेंज अवर सेल्स. हे लक्षात घ्या, ऑन द बेसिस ऑफ परसेप्शन ट्रस्ट इज देअर. असं काहीच नाही, तुम्ही 4 लोक, तुम्ही पण स्वतः, मी एखाद्या माणसाने दुसऱ्या माणसाला 4 वेळा फसवलं आणि ते मला पाहिलं तरी तो माणूस चांगला आहे त्याच्यावर मी विश्वास ठेवला असं म्हटलं तर मी म्हणेन मी नाही ठेवतो, त्याला ते फसवलं त्यांनी. तसंच हे आहे, तुम्ही इन्शुरन्स कंपनीला फसवलं हे लक्षात ठेवलं त्यांनी, आणि आपण फसायचं नाही असं ठरवलेलं आहे. सो वी सर्व ऑन द बेसिस ऑफ ट्रस्ट, फेथ, एथिक्स. आणि आम्हाला मेडिकल कॉलेजमध्ये डामा करतात, डिस्चार्ज अगेन्स्ट मेडिकल ॲडवाईस. वी यूज टू बी हॅपी. आणि आत्ताही मी माझ्या फेलोजला वगैरे विचारतो, ते म्हणतात आम्ही करतो ते डामा, डिस्चार्ज अगेन्स्ट मेडिकल ॲडवाईस, आणि त्याच्यामुळे सुट्टी होऊन जाते आपली, डोकेदुखी कमी होते. आता हे डामा केल्यावर तो पेशंट मात्र सगळीकडे सांगतो ना की इथे सर्व्हिस चांगली नाही मिळत आहे. म्हणजे आपण विनाकारण ट्रस्ट घालवलेला आहे, त्याला काउन्सिलिंगची खूप आवश्यकता आहे. आणि हा ट्रस्ट जो आहे, हे ट्रस्ट डेफिसिटबद्दल काम करायची गोष्ट आहे आणि सूचना घ्यायची गोष्ट आहे. आणि मी IMAचा मेंबर आहे म्हणून माझं पण काम आहे, मी असं नाही म्हणत की मी त्याच्यातून सुटलेलो आहे आणि मी राज्यसभेचा खासदार म्हणून तिथूनही सुटलोय, तर नाही, माझी जबाबदारी उलटी जास्त आहे. त्याच्यामुळे या सगळ्या गोष्टीत आपण घेतलं पाहिजे. आणि या याच्यातलं दुसरी एक गोष्ट सांगतो की हे ट्रस्टबद्दल झालं, नंतर तुम्हाला मी प्रिव्हेंटिव्ह मेडिसिनही सांगितलं. तसंच एक आणखी गोष्ट सांगतोय की जी खूप महत्त्वाची मला वाटते, जो पूर्णपणे मॉडर्न मेडिसिन विसरलेला आहे. तो एक भाग आहे. मी इंटर्नशिप करत होतो तिरोड्यामध्ये. During the internship, there was a cholera epidemic in one of the villages. In cholera epidemic, we went there, we gave intravenous fluids, and in that village around out of 123, 60 people suffered from cholera, and fortunately we could treat everybody came out of it. Nobody died or nothing happened bad to them. तर आता ते सर्वाइव्ह झाले आणि we were very proud. We sent the stool for examination. That was in remote village, and it came out to be cholera vibri, and we were very proud that we could come to conclusion that cholera vibri was the organism for that cholera epidemic in that small village of 123 people. In that village there was only one well, and that well water was utilized by everybody in that village. So after that I took a meeting with all the people, and then I told them that okay, you have to, तुम्ही या विहिरीतून पाणी प्याले आणि तुमच्या गावात एकच विहीर आहे, त्याच्यातलं तुम्ही पाणी प्याले, आणि मी पहिल्यांदा ॲक्च्युली येऊन गेलो होतो, ब्लिचिंग पावडर टाका म्हटलं होतं, टाकायला गेलो होतो, तर तुम्ही मला अडवलं आणि ब्लिचिंग पावडरनी बेकार चव लागते, ते घाणेरडं दिसतं, त्याच्यामुळे आम्ही ब्लिचिंग पावडर टाकू देत नाही म्हटलं आणि टाकू नव्हतं दिलं. ते टाकू दिलं असतं तर हा विब्रियो कॉलरी आजार तुम्हाला झाला नसता आणि तुम्हाला पुढे जो प्रॉब्लेम येतो तो झाला नसता. तर मी म्हटलं त्यांना असं सांगितलं, आणि याच्या पुढे पाणी शुद्ध करून प्यायला पाहिजे. एक तर ब्लिचिंग पावडर टाका, उकळून प्या, काहीतरी करा. त्याच्यातला एक यंग मुलगा होता आणि तो त्या गावचा उपसरपंच पण होता, सगळे मिळून जे होते उपसरपंच पण होता. तर त्याचं नाव एकराम. तो एकराम म्हणाला मला एक प्रश्न विचारायचा आहे. तर मला असं खूप छान वाटलं आतून की बा माझं समजलेलं आहे ना, आणि त्याच्यामुळे आता त्यांच्या मनात प्रश्न पण आहे, तर ते प्रश्न विचारतोय. त्यांनी प्रश्न विचारला. त्यांनी म्हटलं की आमच्या गावात एकच विहीर आहे, आम्ही 123 लोक आहोत, आम्ही सगळेजण 123 लोक याच विहिरीतून पाणी पितो, पण या 60च लोकांना कॉलरा का झाला, उरलेल्या 63 लोकांना का नाही झाला? का नाही झाला? का नाही झाला? आम्ही सर्व आजार का होतो याच्यावर पूर्णपणे लक्ष केंद्रित करतोय. आम्ही हेल्दी का राहतो, आम्ही स्वस्थ कसं राहतो याच्यावर नाही. आयुर्वेदमध्ये स्वस्थ वृत्त आहे ना, स्वस्थ वृत्त ते महत्वाचं आहे. सॅल्युटॉलॉजी, मॉडर्न मेडिसिनमध्ये त्याला सॅल्युटॉलॉजी आहे. त्याच्यामुळे आपल्याला हे खूप महत्वाचं आहे की आपण स्वस्थ का राहतो याच्याकडे पण लक्ष देणं, त्याचा स्टडी करणं, त्याच्यावर रिसर्च करणं हे कम्युनिटीच्या दृष्टीने खूप आवश्यक आहे. आणि मला खात्री आहे की या इथे सर्वजण मिळून या प्रश्नांवर सुद्धा आपण सगळे मिळून काम करू आणि एक दिशा बदलवणारं काम होईल या IMAचं. IMAने आत्तापर्यंत बऱ्याच गोष्टी चांगल्या केलेल्या आहे इंदापूर IMAने, आणि मला खात्री आहे की या विषयांवर पण त्याच्यामुळे एक बदल सुरुवात होईल. तसंच जसं आत्ता त्यांनी सांगितलं डॉक्टरांनी की आता आपण डॉक्टर्स त्या कन्झ्युमर फोरम म्हणजे कन्झ्युमर प्रोटेक्शन ॲक्ट खाली येत नाही. तर माझा असं आपण जोरदार टाळ्या वाजवून अभिनंदन करूया ज्यांनी ते काम केलेलं आहे त्यांच्यासाठी, कारण खूपच महत्त्वाचा आहे तो निर्णय. माझी अशी इच्छा आहे की तुम्ही तो मलाही पाठवा आणि इथे वेबसाईटवर टाकला तरी असेल तर ते सांगा, म्हणजे मग मी पाहून घेईल, कारण मला त्याची कल्पना नव्हती. पण खूप मोठं काम झालेलं आहे. तसंच हे पण एक पथदर्शी काम होईल आपल्या IMAतर्फे. आणि या इथे आता कल्पना काळे मॅडम आहे, बाकीचे भारती आहे, बाकीचे सगळे आहेत. तुम्ही मला या इथे बोलावलं, तुम्ही सगळ्या मंडळींनी मला बोलावलं, माझे विचार शेअर करण्याची संधी दिली. मी नेहमी हा प्रश्न विचारतो की वासरू गाईचं दूध पितं तेव्हा आनंद कोणाला जास्त होतो, गाईला का वासराला? गाईला. देण्याचा आनंद जास्त आहे. आणि मला तुम्ही सगळ्यांनी संधी दिली की माझे विचार मी शेअर करावे, याच्यासाठी मनापासून तुमचे धन्यवाद. आय एम ए चिरायू हो इंदापूरचे. थँक्यू.
Thank you, sir, for your encouraging words. Your thoughts will certainly motivate all of us to continue striving for excellence. I request Dr. Panbide sir and Shirke sir to give vote of appreciation to Dr. Mahatme sir.
करतो आणि खूप आनंद व्यक्त करतो की या IMA इंदापूरच्या खूप छान कंडक्ट करतायत. खूप अभिनंदन तुमचं. तर खूप उशीर झालेला आहे. मी नाही, पण पेशंटची पण वृत्ती बदलली आहे. मला असं वाटतं की कन्झ्युमर ऍक्ट जो माझ्या मते अजूनही आहे त्याच्याबद्दल उहापोह अत्यंत आवश्यक आहे असं मी आता प्रत्येक डायसमधून सांगत असतो. आणि ते सिंपल आहे, आपल्याला कळायला अगदी सोपं आहे. हे सगळीकडनं कुठनं डिस्ट्रस्ट आला? नो डाऊट मनी इज वन पार्ट, नो डाऊट कॉर्पोरेटायझेशन इज वन पार्ट, कन्झ्युमर ऍक्ट इज वन ऑफ द कल्प्रिट्स. त्याच्या जोडीला ही जी सगळी सर्च इंजिन्स आहेत ना, गुगल, याहू, रेडिफ, ही सगळी सर्च इंजिन्स जी आहेत त्याच्यामुळे चांगली गोष्ट आहे की इन्फॉर्मेशन एक्सप्लोजन झालेलं आहे. आपल्याला एक वाक्य लिहायला पाहिजे आणि आपल्याला मॅथमॅटिक्समधलं एक चिन्ह आठवत असेल, इक्वल टू म्हणजे आपण दोन आडव्या रेखा, त्याला क्रॉस केलं की नॉट इक्वल टू, दोन रेखा समांतर आणि क्रॉस नॉट इक्वल टू. इन्फॉर्मेशन इज नॉट इक्वल टू एज्युकेशन. Information, education, two together are not equal to knowledge. This in turn is not equivalent to experience, and this in turn is not equivalent to evidence. या सगळ्याचा जो परिपाक आहे तो म्हणजे तो डॉक्टर आहे, ज्याला आपण प्रुडंट डॉक्टर असं म्हणूया. दोज हू आर प्रॅक्टिसिंग, मला वाटतं सरकारने सुद्धा लावणं आवश्यक आहे की इन्फॉर्मेशन इज नॉट इक्विलंट टू नॉलेज अँड एज्युकेशन, विच इज नॉट इन टर्न इक्विलंट टू एक्सपिरियन्स अँड एव्हिडन्स, अँड डेफिनेटली नॉट इक्विलंट टू विजडम. आपले प्रश्न सुटतील. लोकांना सुद्धा समजून द्यायला पाहिजे की ट्रस्ट वाढवायचा तो कसा वाढवायचा. आता सरांनी मगाशी उल्लेख केला तसं थोडासा उल्लेख करतो, कारण त्या प्रक्रियेशी मी थोड्या प्रमाणात खारीचा वाटा उचलत असतो. ते म्हणजे MMC इलेक्शन्स. यंदाचे घोटाळे काय झाले ते सोडून द्या, आपल्याला कोणाला मतदान करायचं ते बाहेर लिहिलेलं आहे. आपल्याला रवींद्र कोटे पण आपले ते उभे आहेत. मला असं वाटतं की त्यांचं सिलेक्शन इकडे किंवा तिकडे कुठेतरी व्हायला पाहिजे होतं. होईल अशी मला अपेक्षा आहे, आजही होईल, कारण शेवटी विड्रॉलची डेट व्हायची आहे. कारण हे पॅनल सर मगाशी थोडं बोलताना एक वाक्य राहिलं ते मी ऍड करतो फक्त, की 9च्या नको यायला का पाहिजेत एखाद्या पॅनलचे. याचं कारण त्या पर्टिक्युलर बॉडीमध्ये विच इज अ गव्हर्नमेंट बॉडी, महाराष्ट्र मेडिकल कॉलेज, सरांनी सांगितलं 18 लोक आहेत, 9 गव्हर्नमेंट अपॉइंटेड आहेत. म्हणजे तिथे तुम्हाला काही एंट्रीज नाही आणि 9 लोक हे सिलेक्टेड, 9 इलेक्टेड 9 सिलेक्टेड, आणि ते 9च्या 9 सिलेक्टेड जे असतील ते एकाच बाजूने मतदान करण्यात, पण इलेक्टेड आहेत त्यांना स्वतःचं मतदान आहे. आणि तुमचा जर चेअरमन नसेल तर 0 व्हॅल्यू आहे उरलेल्या 8 लोक. क्वेश्चन ऑफ MMC, कारण सुप्रीम कोर्टाचा निर्णय असा आहे की तुम्हाला ॲलोपॅथिक परमिशन देतो प्रोव्हाइडेड यू आर ऑन द स्टेट मेडिकल काउन्सिल्स रजिस्टर. तिथे आपण ते अडवून धरलेलं आहे. ज्या क्षणी तुमचे 9चे 8 होतील सगळं मुसळ केरत आहे. तेव्हा व्हिजिलंट राहा, योग्य व्यक्तींना निवडून द्या, IMA पॅनलला, IMA मेंबर्स पॅनलला निवडून द्या, आणि तो एक्सक्लुझिव्ह असलं पाहिजे. एक जरी कमी झालं हे सगळं मुसळ केरात गेलं म्हणून समजा. हा झाला थोडासा पॉलिटिकल आणि एथिकल इश्यू. IMA इंदापूरबद्दल मला खूप जिव्हाळा आहे. IMA इंदापूर हे पुणे जिल्ह्यातलं एंडचं तालुका आहे, कारण बॉर्डरिंग आपलं सोलापूर आहे. तर अगदी जिव्हाळ्याचे संबंध तर आहेतच. आणि आता मगाशी हिस्ट्री पाणबुडे सरांनी खूप छान सांगितली जी मला पूर्ण माहिती नव्हती. तर मला असं वाटतं की इंदापूर ही जागृत अशी डॉक्टरांची संस्था आहे. आणि दरवर्षी सर महात्मे सरांना सांगायला मला आवडेल की एथिक्सवरती ही ब्रँच दरवर्षी एक कम्प्लीट सेमिनार घेत असते. तेव्हा एथिक्स आपण विसरलो तर मेडिकल लिगल केसेस नंतर येतात. तेव्हा प्रिव्हेन्शन ऑफ मेडिकल लिगल इश्यूजमध्ये टू मेंटेन एथिक्स इज द मोस्ट इम्पॉर्टंट थिंग ॲज अ प्रिव्हेंटिव्ह ॲस्पेक्ट. ती तुमची वॅक्सिन आहे, तेच तुमचं न्यूट्रिशन आहे, तोच तुमचा एक्झरसाइज आहे. यू फॉलो दॅट, you will be out of the clutches of anything which is so-called nonsense. With these words, I conclude my talk. We are already very late, and once again I would say my parent branch. असं तुमचे टॉपिक्स इतके सुंदर होते. शेवटची 3 लेक्चर्स मी ऐकली. मला असं वाटलं की कालपासून मी यायला पाहिजे होतं. समथिंग आय हॅव मिस्ड. इतके चांगले टॉपिक्स आहेत. थँक्यू व्हेरी मच फॉर कॉलिंग मी.
Thank you, sir. I would like Dr. Arankar sir to give token of appreciation.
माझी पिशवी पिशवी नाही एकच नाही कडतरी आहे ना त्याची दूध द्या किंवा द्या ना. या इकडे देतो बरोबर ते. हॅलो, मला एक विशेष गोष्ट या ठिकाणी सांगायची आहे. गेली जवळजवळ 3-4 वर्ष आपण या ठिकाणी कॉन्फरन्स घेतोय आणि 3-4 वर्ष सातत्याने काही मंडळी आपल्याला मदत करतात. मला आश्चर्य वाटलं डॉक्टर अनिल राजे निंबाळकरांचं. झालं असं की गेल्या वर्षी जेव्हा आपली कॉन्फरन्स होती त्यावेळेला माझ्याही काही लक्षात नव्हतं, पण त्यांचा अचानक फोन आला मला सकाळी उठल्याबरोबर, का सर तुम्ही आमच्यावर रागावलंय का? म्हटलं रागावलं का, काय कारण आहे रागवायचं? म्हटलं तर तुम्ही आता इतकी वर्षाची मैत्री आपली. नाही म्हटलं तुमच्याकडे कॉन्फरन्स आहे, तुम्ही आम्हाला काही सांगितलंच नाही. सॉरी बरं का म्हटलं, बरोबर आहे, मी तुम्हाला सांगायला पाहिजे होतं, पण कसं काय विसरलो कुणाला माहिती. बरं म्हणले, मग आता काय करताय म्हटलं, तुम्ही किती रजिस्ट्रेशन आणून देताय? नाही म्हटलं मी उद्या सकाळी 51 रजिस्ट्रेशन घेऊन येतो. आणि लिटरली 51 रजिस्ट्रेशन घेऊन ते आले. त्याच्यानंतरची कालच्या ह्या आजच्या कॉन्फरन्सची गोष्ट अशी की त्यांचा फोन आला मला की सर तुम्ही मला निरोप दिलेला मिळालेला आहे, माझे वडील वारलेत, 2 दिवसात मी तरी सुद्धा प्रयत्न करून पाठवतो काहीतरी. काल त्यांचे 30 रजिस्ट्रेशन आले. आय रिअली वंडर की अशी माणसं प्रेम करणारी, माझ्यावर म्हणण्यापेक्षा IMA वरती प्रेम करणारी, हे वैशिष्ट्य आहे यांचं. आणि एक ह्याला किती प्रेझेंट दिलं तर ते कमीच पडणार आहे. मी एक छोटंसं त्यांना या निमित्ताने सत्कार त्यांचा करतो. त्यांनी स्टेजवरती यावं. तो हा काढा तो मोठा रे.
हे माझ्या सगळ्या मेंबरचं माझ्यावरच्या प्रेमाचं प्रतीक आहे. मी कुणी नाही आहे, माझे मेंबर आहेत माझ्याबरोबर म्हणून मी आहे.
पण मेंबर्स बरोबर ठेवणं हे सुद्धा कौशल्य आहे, हे विसरून चालणार नाही. दुसऱ्यांना दुसरा आणखीन एक सत्कार आम्ही करतोय. डॉक्टर मंडक नळी हे सुद्धा नेहमी आपल्या प्रोग्रामला असतात. मी ज्या वेळेला लोणंदराला गेलो होतो त्यावेळेला त्यांनी ज्या पद्धतीने माझं स्वागत केलं, RNTCPच्या कार्यक्रमाकरता मी गेलो होतो, खरोखरच धन्यवाद. या अध्यक्ष. डॉक्टर मंडक नळी. अरे हा, डॉक्टर मोहिते प्लीज. ठीक आहे, डॉक्टर पवार प्लीज. कारण हळूहळू 2-2 मिनिटांनी उशीर होतोय ना. डॉक्टर मोहिते. या डॉक्टर बोईटे. दुसऱ्या अकलूज ब्रांचचा सत्कार करायचा होता, पण ते ऑलरेडी बिझी आहेत असं कळलं आम्हाला.
I now request our IMA President, Dr. Anil Shirke sir.
महाराष्ट्र मेडिकल काउन्सिलच्या पॅनेलचा व्हिडिओ आपल्याला 1-2 मिनिटं आहे.
प्ले करत आहोत तो सर्वांनी
शांततेत. आपण IMA मेडिकल काउन्सिलचा एक व्हिडिओ प्ले करत आहोत. तो सर्वांनी 1-2 मिनिटं शांत बसून बघावे. आत्ता उभे असलेले उमेदवार. I request our IMA President, Dr. Anil Shirke sir, to give the vote of thanks.
मी पुष्कळ डॉक्टरांना हे जे मेंबर्स उभे आहेत त्याच्याबद्दल काय ओळखत नसेल, पण मंगेश गुलवाडे डॉक्टर आमचे चंद्रपूरचे, त्यांना मात्र चांगलं ओळखतो आणि ते चांगले मेंबर आहे. तर तुम्हाला पुन्हा तेच आवाहन करतोय.
Respected dignitaries on the dais, our beloved patron, Dr. Ramarankar sir, distinguished delegates, esteemed members of IME Indapur and also neighboring branch, invited guests, media personnel, ladies and gentlemen. As we conclude this magnificent inaugural ceremony of Indacon 2026, I rise with a deep sense of gratitude and humility to propose the vote of thanks. First and foremost, I extend our heartfelt gratitude to the Almighty for blessing us with this wonderful evening and for success of this grand beginning. We are deeply honored to have with us chief guest Padma Shri Dr. Vikas Mahatme sir. Your presence has elevated the stature of this ceremony. Your exemplary work in the field of ophthalm and your contributions to society as a former MP and founder of Mahatme Eye Bank are truly inspiring. Thank you for taking time from your busy schedule to grace this occasion. I extend our sincere gratitude to our President, Dr. Jain Naurange sir, for presiding over this function. Sir, your guidance and leadership in IMA-MS Legal Committee are commendable, and we are grateful for your unwavering support. We are also privileged to have our distinguished guest of honor, Dr. Uma Pradhan ma'am. Your expertise in your respective fields is an inspiration to the medical fraternity. Thank you for being a part of this celebration and for encouraging us with your kind words. I would like to express my special thanks to our patron, Dr. Ram Arankar sir, for his constant motivation and for setting a benchmark of excellence for our branch. I am deeply grateful to my organizing chairman, Dr. Avinash Panbude sir, and organizing co-chairman, Dr. Kalpana Khade ma'am. Your vision, tireless efforts, and leadership have been the pillars of this conference. It is an honor to work alongside you. I extend warm vote of thanks to all our distinguished speakers, faculty members, and delegates. Your presence and participation are what make Indacon a platform for learning and growth. A special thanks to media for your extensive coverage. Finally, the conference would not have been possible without the support of our sponsors, exhibitors, and well-wishers. Your generous support has been instrumental in helping us achieve our vision. I also extend my gratitude to the administrative and support staff who have worked behind the scenes. As we celebrate compassion in action, local care, global standards, I thank you, each and every one of you, for being here today. If I have inadvertently missed anyone's name, please accept my sincere apologies. It is a lapse of memory, not of gratitude. Now I invite everyone to join us for a banquet and orchestra at Shivanya Lawns. Thank you all once. Thank you all once again. Jai Hind, Jai IMA, Jai Maharashtra. Now, felicitation. Felicitation. Now may I request today's superb anchoring performance, our new generation, Dr. Shubhada ma'am and Dr. Nupur ma'am. जनगणमन तयार ठेवा. नाही तिथं लागणार आहे ते. हा करून टाक.
I request everyone to stand up for our national anthem.
Bye.